आज
लाइव है कॉल करता हूँ मैं।
हाँ ठीक है ठीक है।
starting in 4 minutes, sir. Good morning, everyone, and welcome back to the World Conference on COVID and Critical Care 2021. Let us now begin with the scientific program scheduled for today. For the plenary sessions, the chairpersons for our plenary sessions are Dr. M.C. Mishra, Director of Liver and Biliary Sciences Institute, Dr. Prashant Nasa, Head Critical Care Medicine, NMC Specialty Hospital, Dubai, Dr. J.V. Peter, Director and Professor, Critical Care Medicine, CMC Vellore, Dr. Hussein Al Rahma, Consultant Emergency Medicine, Head of Critical Care and Emergency Medicine, Associate Professor of Medicine and Senior Examiner, Dubai Medical College for Women, Dr. Deeptimala Agarwal, Senior Consultant and Intensivist, and Head Intensive Care Unit, Shanti Ved Institute of Medical Sciences, Agra. And now give the session to our chairperson. Thank you.
गुड मॉर्निंग, नमस्कार सभी पार्टिसिपेंट्स को और डॉक्टर गुलेरिया का स्वागत है। पहला इनॉग्रल सेशन आज डॉक्टर रणदीप गुलेरिया ले रहे हैं। डॉक्टर रणदीप गुलेरिया किसी इंट्रोडक्शन के मोहताज नहीं है, वो हाउस होल्ड नेम बन चुके हैं पिछले 2 वर्षों में। भारत का ऐसा कोई गांव, ऐसा कोई शहर नहीं बचा है जिसमें डॉक्टर गुलेरिया को लोग नहीं पहचानते। कोविड से जूझ रहे हैं पिछले 2 साल से, उसके सेंटर में है। और डिपार्टमेंट ऑफ पल्मोनरी मेडिसिन जब अखिल भारतीय आयुर्विज्ञान संस्थान में बना था तो उन्होंने उसका नेतृत्व बहुत सक्षम तरीके से किया पिछले 20 वर्षों में। और अब वो ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेस को नेतृत्व प्रदान कर रहे हैं पिछले लगभग 5 वर्षों से। और कोविड के दौरान उनका जो रोल रहा है बहुत अहम रहा है, चाहे वो कोविड ट्रीटमेंट से हो, प्रोटोकॉल से हो, ग्रैंड राउंड जो उनके नेतृत्व में अखिल भारतीय आयुर्विज्ञान संस्थान ने किए कोविड के दौरान। सभी को पूरे भारत में और अंतर्राष्ट्रीय स्तर पर भी अखिल भारतीय आयुर्विज्ञान संस्थान की जो ख्याति है वो बहुत सबको पता है। और बहुत एक अच्छे इंसान है और बहुत अच्छे क्लिनिशियंस हैं, उनकी बहुत डिमांड है। हर एक जिसको कोई भी रेस्पिरेटरी प्रॉब्लम होती है वो डॉक्टर गुलेरिया की तरफ देखते हैं। और आज हम सब ये जानेंगे कि उनका क्या मत है को थर्ड वेव को लेके। क्या थर्ड वेव की अभी भी कोई आशंका है तो कितनी है, किस प्रकार है, और उससे बचने के लिए क्या करना चाहिए। So we would request Professor Randeep Guleria to give us some insight into what he thinks based upon his extensive experience in COVID pandemic over last 2 years, close to 2 years. And so we will then go forward to prevent this third wave, if any, it has to come. Also, we compliment him, congratulate him for leading the Covaxin trial at All India Institute of Medical Sciences. And we just completed 100 crores of doses, which is a huge achievement for our nation. Our Prime Minister, Government of India, all the state governments, lakhs of healthcare workers all across India. And above all, every citizen of this country who came forward to get this dose. And now we are moving forward. We cannot just be complacent on the pandemic. We are in a very good situation, at least in North India, Northeast India. Southern states are still struggling a little bit. And today's figures are still down to 15,000 or so, mainly from Kerala and some other southern states. So we hope that coming times would give us more vaccines, more insight into COVID treatment, if any. So let's hear Dr. Professor Randeep Guleria on all these issues. Thank you, Randeep.
Good morning. Thank you, sir, for your kind words. And I'd like to start by thanking the organizers of this World Conference on COVID and Critical Care for inviting me to give this talk. It's indeed a pleasure to be here. I shall be talking on COVID-19 and the third wave, the fear of the unknown. This is something that is probably one of the hottest topics nowadays, where everyone is worried, are we going to see another surge like we saw the first or the second wave? I hope my slides are visible.
Yes.
So I'm going to really talk on the current scenario as far as COVID-19 is concerned. How can the third wave be prevented? And what are the preparedness that we've been doing in the last few weeks or months as for the third wave? So current scenario, and will there be a third wave? So COVID-19 is the biggest pandemic of a lifetime. I don't think that we can really have any doubt on that we haven't seen anything like this in our lifetime and possibly in the last 100 years. Started off as an acute respiratory syndrome with coronavirus in December 2019. It seems a long time ago, but it's not that long. More than 242 million people worldwide have been infected, and we have close to 5 million deaths just because of this one small virus. And India has suffered two devastating waves of the pandemic. We've all gone through the second wave, which was really uh, devastating, and many of our colleagues lost their lives. And therefore, there is this big apprehension that are we going to have a third wave? If you look at the burden of disease currently, in terms of cases, India has the second highest number of cases at around 3.41 crore, and the third highest number of documented deaths around 4.52 lakhs. And although these numbers seem large, if you were to look at it in cases or deaths per million, then they are much lower down, and we are in a much better position than many countries, even in the developed world. If you look at the timelines, we started off in January 2020 when we had the first case in India, which was basically reported from three medical students who returned to Kerala from China. We had a first lockdown in March 2022, the first peak in September. The vaccine was launched in January of this year, and we had a second wave in March and May. And on the 21st of October, we crossed the 1 billion mark as far as vaccine was concerned. So we've had two waves, and as you can see, the second wave has been devastating with the huge surge in the number of cases. What has really caused this devastation is not only the large number of cases, but the rate of rise as far as the number of cases is concerned. And as we can see now, we are at the tail end of the second wave, although things are still not over. There are certain states in the south which are still reporting cases, and therefore the pandemic or the tail of the second wave is still there. Now, if we go back 100 years, and this will give us some idea, then the flu pandemic, which was what people call the mother of our pandemics, had also three waves. And the issue here was that the first wave, after the first wave, people thought that the pandemic was over. And if you read the history, you'll realize that at that point in time, people started having parties, they started having get-togethers, and this led to the huge surge, which was the second wave. Subsequently, they did have a third wave also, but things are different now because this is the pre-antibiotic era, the pre-vaccine era. And at that point in time, there were no antibiotics, no vaccines. The only measure that they had was non-pharmacological methods to really control this pandemic. Despite the fact that during that time, there was no air travel, this pandemic quickly traveled across the world and spread to all countries in the world. If you look at data from India, and this is data at that point in time from what was at that time British India, again, you would see that the mortality due to the pandemic in India was almost 7 to 10 million. So 7 to 10 million people died in 1918. And at that time, the population of India was only 389 million. So a large number of people died during that point as far as India is concerned because of this Spanish flu or the pandemic in 1918. More people died in this pandemic than during that World War. This is the picture from that time, and this could be today. This is a gymnasium, but we could have a COVID care center very similar to what we are seeing in this picture. Same things were there. Public gatherings and places were closed. People wore masks, and there was a nationwide cascade shortage because of mounting deaths. And about in 2018, I had written an editorial about this flu pandemic and that after 100 years, we are still vulnerable and we need to really prepare ourselves for future pandemics, because at that point in time, there was a lot of signals with outbreaks from SARS, bird flu, the H1N1 pandemic, that we are looking at a pandemic in the very near future. So what were the causes of the second wave, which was the devastating wave? Relaxation of COVID-19 precautions, that was one. There was opening of schools, theaters, gyms, public gatherings. Laxity from public, people felt that the pandemic had ended, and this was exactly what happened in 1918 also. Large indoor gatherings without masks. And I think also the arrival of the mutant strain, especially the alpha variant to begin with, followed by the delta variant, which was both were more and more infectious, which led to the rapid surge in the number of cases. But it's also important to remember that India is a very large country and we have different waves. If you look at what happened in Delhi in September last year in September, Delhi actually had 4 small waves rather than one large wave as the country saw. And also there is temporal discordance. We've seen that in our country, in most parts, the wave is over as far as the second wave is concerned. But in Kerala, the cases did continue to rise even when, as far as the nation was concerned, the cases had come down. So there are going to be regional differences which could depend on containment measures. It could depend on various other factors, which could be travel, climate, population density. And this needs to be kept in mind when we talk of a third wave, because the wave may not be at a national level, it may be at a regional level. What could be the causes of the third wave? One, of course, is waning immunity, which was in previously exposed individuals, and this could happen in people who have been infected or people who have been vaccinated. Remember, healthcare workers who took the vaccine in January have now, it's been almost 9 to 10 months since they took the vaccine dose. Emergence of new viral variants that are capable of immune escape mechanism is another factor, and viral variants which are more transmissible and therefore cause more rapid spread. And there is some data that some of the variants of interest which are emerging may be more transmissible, and that's why we're seeing a surge in the number of cases being reported from countries like Russia and from China itself. And of course, release of lockdown for fresh opportunities for transmission. And this is another concern because of the festive season, that we will have people crowding in markets, in gatherings, and this can also lead to increased surge in the number of cases. So when we look at variants, we have two things: variants of interest and variants of concern. Now, COVID-19 is an RNA virus and it will mutate. This is a natural tendency for this virus. And the more the virus multiplies, the more copies it makes, the more chances that these copies will have mistakes, which leads to development of new mutations, and therefore the variants occur. But most of these mutations are inconsequential, and they are just variants of interest. It's been calculated the virus may mutate twice every month, but most of these mutations really don't cause much problem. But there are some mutations which become variants of concern because the virus can become more transmissible because of this. It can become more virulent. It can develop an immune escape mechanism and thereby cause more infection. And to some extent, some variants of concern may evolve that they evade the current RT-PCR testing that we have, and that also becomes a variant of concern. Now, there have been a lot of modeling of how a third wave could look like. This is one which was from IIT Kanpur, which looked at various prediction models, trying to see how things would happen depending on various mechanisms. So if there was a virus, if the virus had mutated, they had predicted that a huge surge of cases would happen. If everything was back to normal and the virus had not mutated, then they said things would increase, and that was predicted somewhere around this time, the October, November. And if we had interventions, then a smaller wave would be there somewhere around November or closer to December. There's also a prediction model which was done by ICMR, and they looked at their theory was that the immune-mediated mechanism are unlikely to drive a severe third wave on their own. And they said for a third wave, you will have to have a very high R naught. For that means the virus will have to become much more transmissible to really cause a third wave. The possible mechanism, they said, for the third wave could be a new variant that is more transmissible and at the same time capable of immune escape mechanism. That is what one is really concerned about, because that could lead to a third wave. Luckily, currently, the data that we have with the Delta Plus and the new variants which are being reported, they don't seem to be more transmissible or having significant immune escape mechanism. And that's why it seems the vaccine are still holding out. Now, we have had the variants of concern. We all know about them: the alpha variant, the beta variant, the gamma, and the delta variants, which are basically based on mutations which have happened at key sites in the spike protein, which have led to higher transmissibility, some variants causing significant degree of immune escape mechanism. And this is something that has always been a cause of concern. So coming to how can the third wave be prevented? One issue is that we must protect our community from the third wave, and that is by enforcing COVID appropriate behavior, which should continue till the pandemic is over. And this is something that we have to keep on enforcing. Vaccination is the other very strong pillar that we have, and that's why it's a great moment that we've crossed the 1 billion mark. But it should be upgraded, and we must be able to keep this pace so that more and more people are protected. Genomic surveillance, which the government is doing, we has to continue very aggressively, because if you pick up the variant early, then you can intervene early and prevent the spread of this variant to other areas, or know about it and be able to take timely action. And wherever there are hotspots or increasing number of cases, limited lockdown must be implemented so that a surge in a small area doesn't become a huge wave across the country. Now, will this work? And again, if you go back to the lessons from the influenza pandemic, what it really showed there that in America, those states which had stricter policies were able to come back in a much better manner. They had lower mortality, and the increase in manufacturing employment also occurred much more earlier. So it clearly showed that physical distancing, mask, and limited lockdowns were the cornerstone of pandemic response. If we combine vaccine with this, I think then we should be in a good position. So a lot of people have argued that do masks and physical distancing really work, or is it just something that we're talking about? And this is a paper published last year in the Lancet, which was basically a systemic review and a meta-analysis, which looked at 172 observational studies across 16 countries, looked at healthcare and non-healthcare workers. And what it found was that it looked at MERS, it looked at SARS, and looked at COVID-19. And it found the transmission of the virus was lower with physical distancing of 1 meter or more compared with a distance of less than 1 meter. And this was seen in almost all of the studies. It also showed that face masks use could result in a large reduction in the risk of infection. Similarly, there was a greater reduction with N95 or similar respirator compared to disposable surgical masks. Eye protection was associated with less infection, and therefore this is still something that we need to do. Also, to prevent the third wave, vaccination is very important. This has been touted as the most effective public health measures to end the pandemic, and we have more than 2.2 billion people that have been vaccinated worldwide. This has led to widespread optimism that this is the beginning of the end. But there are certain questions which we have as far as vaccine is concerned. Are they truly safe and effective? Will they prevent disease transmission? How long will the benefit last? And will vaccine work against the new strains? And this is important when we start talking of the third wave. Now, vaccines are very useful and they do really give a good immune response. This is the first time that for one virus, there are over 60 candidate vaccines in human trial and over 118 preclinical trial. Never before has this happened. And we still have more and more research going on. There are now research going on to see whether we can develop a bivalent vaccine, which would also cover for the new variants. So there are studies going on to see whether now the next generation vaccines should be developed, which will cover also for the beta and the delta variant, because they are the ones which are likely to be more infectious, and whether we should have a booster dose which covers for that, or this would be required in the subsequent months. But it's important to remember that vaccines don't prevent infection that much. They do prevent infection, but not that much. That's not their main strength. And therefore, one can still get mild COVID infection, and you may still be asymptomatic or have mild infection. But they prevent illness, or they prevent severe disease. So they prevent hospital admissions, prevent ICU admissions, and prevent death. And that is what one has observed, that vaccines are holding out as far as this is concerned. They do some extent also help to break the chain of transmission. We have now a large number of vaccines in India, and India should be proud. We have Covishield, Covaxin, Sputnik V has also been approved, and Johnson & Johnson single-dose vaccine is also approved in our country. And the ZyCoV-D, which is a plasma DNA vaccine, the first DNA vaccine in our country, which has actually been manufactured, researched, developed, and manufactured in India, has also been approved. This is a 3-dose vaccine. And therefore, we have a very robust vaccine platform as far as India is concerned. And along with that, we have other vaccines. We have the Novavax, which is being made by Serum Institute of India, the recombinant protein antigen-based vaccine by Biological E, which would also be very useful. An mRNA vaccine, which can be kept at 2 to 8 degrees centigrade, is also being made by Genovia, and we're hoping that this would be out by the end of the year. And Bharat Biotech is also doing trials on a nasal vaccine. So we have a large number of vaccines in trial, and hopefully they should be adding to our armamentarium. Data suggests these vaccines are useful. This is data from Bharat Biotech, which suggests that there is 65% efficacy against the Delta variant, 93% efficacy against severe COVID-19 disease, reducing hospitalization, and around 63% efficacy against asymptomatic transmission. We have crossed the 1 billion mark, as has already been said, and almost 70 crore Indians have received the first dose, and around 30 crore Indians have received both doses of the vaccine. A lot of concern has been there that are vaccines effective, especially with the new variants. This is data from the Public Health England, which looked at the AstraZeneca vaccine and showed it was 60% effective against symptomatic disease against the Delta variant, and had good efficacy as far as severe disease was concerned. Similarly, as far as the Covaxin is concerned, the data which came out from ICMR and National Institute of Virology also suggested that this was effective against the Delta variant, and therefore that seems to be holding out as far as our observation is concerned. This is a paper that we had published, which is preprint, which looked at the efficacy of vaccination in preventing severe illness and death from our patients who were admitted and hospitalized. And case fatality was significantly lower in fully vaccinated, this was around 5%, than unvaccinated, which was 22.8%, and partially vaccinated. There were lower odds of developing hypoxia, critical illness, or death in those who were completely vaccinated. And we have also now done a study where we looked at our healthcare workers and looked at those healthcare workers who got Covaxin, and again shown that the efficacy of Covaxin was very good in terms of preventing severe illness and death. There is data from the world also which suggests that vaccine have helped as far as subsequent waves are concerned. This is data from UK, where if you look at the second wave, which is shown in this red enclosure, when there was an increased surge in the number of cases, it was associated in an increased number of deaths, as is seen in the black line. But now when they're seeing a surge in number of cases, UK is seeing increasing number of cases. They're seeing almost 35,000 cases a day. But this increase in number of cases is not going hand in hand with increased hospitalization of deaths. So the third wave in UK is seeing a lower mortality despite high number of cases. And this is being attributed to the fact that more people have been vaccinated there and they are prevented against severe disease. So what this really says is that the current vaccinations seem to be helping us as far as the new variants are concerned and protecting us against the Delta variant. And this will help in not having severe hospitalization and death as far as subsequent waves are concerned. India has put in the INSAGOG in place, which is the consortium for doing genome sequencing. It started off with 10 labs, and now there are almost 30 labs across the country which are doing genome sequencing. And it picked up the variant B1617, which subsequently was identified. The Delta variant was part of this lineage, the B16172, which WHO also declared a variant of concern. So what are our preparedness for the third wave? Of course, one important preparedness has to be focusing on hand hygiene, mask, and social distancing, which we have to keep on pushing forward as far as preventing the third wave is concerned. We've been involved in a lot of training, and this is one part that we're doing, which is part of the Empowerwood Group 3, that we are training and capacity building for COVID care in case there is a third wave, and aims in the institutes of excellence, medical colleges, and private organizations have been involved in this, in developing various modules. There are a number of modules for frontline worker, Ayush workers, for nurses, for pediatricians, for adults, which are looking at how we could manage properly cases in case there's a surge. Along with this, there's been a lot of capacity building. So these are the modules which are there. There are 7 modules which have been developed and 7 thematic groups have now completed this, and we've done a lot of training as far as this is concerned. This is also using a blended learning model where there is simulation also, so that people are trained and are comfortable in managing these patients. So skill training is also part of this mechanism. The government also has been active, in the India COVID-19 Emergency Response and Healthcare Health System Preparedness Package, the ERCP, was approved of around 23 crore rupees. And this was basically for central sector and centrally sponsored schemes. A lot of activity has been involved in this. It is basically to increase the number of beds. The NCDC has been given funds to do more aggressive genome sequencing. Hospital management information system is being upgraded in various district hospitals across the country. Teleconsultation has become more aggressive in terms of the e-Sanjeevani, And a lot of such activities have started, including creating beds for pediatric patients, because there was this fear that this may have, the third wave may cause more infection in children, and that has also been factored in. And funding also for the liquid oxygen storage tanks and the medical gas pipeline systems has also been incorporated in this. There's also resource distribution, which is something very important, and that has also been done because there was some shortage experienced in the previous waves. So proper resource distribution is also part of that. And there's also a great lot of detailed planning as far as this resource distribution is concerned. Focus is also there on meeting the special needs for some people who are more likely than others to contract the pandemic because of chronic illness. So one focus is to aggressively vaccinate them and provide information so that they can stay protected. As the pandemic evolves, we have to change and evolve and develop strategies, and this is something that we need to do. And I think this is very important if we need to prevent the third wave. So what I would like to say that the third wave is not inevitable if we really take the measures that I've mentioned. And I think the two most important pillars are COVID appropriate behavior and aggressive vaccination, along with very good surveillance. We would be able to prevent a third wave. The emergence of a more transmissible variant with immune escape along with lifting of restriction may result in the third wave, and that is why very aggressive surveillance is required. Key elements to prevent the third wave include COVID-appropriate behavior, limited lockdowns, vaccination, and enhanced genomic surveillance. And there has been adequate planning and training and resource allocation to deal with any wave which may happen. Thank you very much. And I would just like to end by quoting Mahatma Gandhi that the future depends on what you do today. And therefore, if you prepare today, I'm sure we will not have a third wave. Thank you.
Thank you very much, Professor Andeep Guleria, for giving exhaustive outline of your hard work with passion, what you have been doing for last almost 18 months, we can say. And you are at the center focus when it comes to COVID and current pandemic. I would begin with the question. There was some talk of Lambda variant in Chile and other Latin American countries. It also, some cases were reported from UK. We haven't seen in India any case of Lambda variant because it also is supposed to be very infectious. And that was responsible for surge in these Chile and other Latin American countries.
So that's true. There is a lot of aggressive genome sequencing going on, even for travelers who are coming, and that's why all travelers who come from areas where cases are high are actually undergoing an RT-PCR testing, and if it's positive, it goes for genome sequencing. Current data that we have suggests that what is actually more prevalent is the Delta and the Delta plus. And the AY lineage is much more common in our country. We are not seeing much cases of Lambda or of the mu variant. And among AY lineage, also AY4 and AY12 are the ones which are being seen, but they are not being associated with increased number of cases. So currently we are seeing variants of interest. They have not become variants of concern because they have not been shown to be associated with higher mortality or increasing number of cases in that area. But having said that, I think we need to be very vigilant because we know that the alpha variant came from UK to our country and led to this surge. And therefore, one of the most important factors is to have aggressive testing and genome sequencing to pick up any variant which develops and develop strategies to deal with that. Currently, what the INSAGOG is reporting is predominantly lineages which are from the Delta plus.
The same applies for Kerala. Surge is ongoing since July and is still continuing with that, the both Delta plus and AY4 and 12.
Yes, so in Kerala, there has been a lot of aggressive genome sequencing being done because one of the theories was that is there a new variant which has emerged in Kerala which is causing this increase? But currently, whatever data they've been able to collect and they focused on a lot of sampling from that area suggests that it is related to the Delta lineage only and not related to a new variant which may have emerged in that area.
in Kerala, they have also noticed that about what they are saying, 28% or 42% breakthrough infections happening in Kerala. Is that true? After people have received vaccination?
Yes, so in Kerala, in certain areas, breakthrough infection is being reported and it is significant. That has been seen that they are having breakthrough infections. But what is also interesting is that in these breakthrough infections, when they followed up these patients, most of them, or I think almost all of them, none of them really developed severe infection. So like I said, you may have infection which may called a mild illness, but it will not cause severe disease. The utility of the vaccine is actually to prevent severe disease. And that's why there is a little bit of a controversy here, because the Kerala government is actually not that much concerned about the breakthrough infection, and it is actually, well, looking at a little different theory of allowing the infection to spread a little bit, because they feel that they're having mild cases rather than severe cases, and this may lead to better immunity in the long run. So if you look at Kerala, there is not a lot of strict lockdowns being imposed to prevent the or a lot of contact tracing being done, because the government there is of the opinion that we may allow the infection to spread a little bit, because whatever breakthrough infections that we're seeing are very mild, and they will actually in a natural way act as a booster to whatever previous immunity that you've had. So this is the same theory which was being used by the Scandinavian countries, where they have totally lifted any lockdown and allowing some degree of infection to happen, with the theory that if you have predominantly mild infection, it is something which may actually enhance the immunity in the population.
Another question which a lot of people are asking today about the booster. As you mentioned that the medical professionals started getting vaccine right from January 16, 2021, and they completed their vaccination, at least half of them by March. So should they help at least the frontline workers, healthcare workers, be considered for another dose now? And if yes, then which vaccine is better for that? And also, what is the status of vaccine for children? When we can expect that to happen?
So regarding the booster dose, I think we need more data. There are two parts of this. One is the when it should be given. I don't think we have enough data based on the antibody titer to say that the booster should be given based on antibody titer. In the long run, I think the booster will be decided on duration of your last dose. Should it be 1 year after your previous, as we do for influenza? The influenza vaccine is an annual vaccine which is taken after 1 year. We don't do our antibody testing to see do we have influenza antibodies and then should we take the vaccine or not. So I think that will evolve over a period of time. Currently, whatever data we have, and I've shown that, suggests that the current vaccines are holding out for severe disease even in those who took the vaccine in December. Because in UK, the vaccine rollout started in December itself. And they're seeing these new cases now in September, and the cases are there, but mortality is low. So as of now, the vaccine seems to be holding out, but no one really knows how long it will hold out and when we will require a booster dose. I'm sure we will require one. Second issue is that we need to be sure that if we have limited doses, then the first important thing would be to give at least one dose to everyone who needs it, rather than giving 3 doses to someone when we're not sure whether it's required. If we need to give a booster at some point in time, it will again have to be prioritized to those whose immunity is low, possibly the elderly, because they would have a higher chance of having more severe infection and waning immunity. Which vaccine should we give? It's a big question, because there are data which shows that if you do a mix and match, your immune response is better. The recent study which came out also showed that if you mixed even in your prime and boost for the dose, if you had the AstraZeneca followed by the mRNA vaccine, you had a better immune response as compared to both the doses of the AstraZeneca. So are we going to have a mix and match for the booster? studies are being done, but I don't think I have an answer right now. As far as the children vaccination is concerned, both the Zycov-D and Bharat Biotech have been approved for children. The regulatory approval is there. There is a lot of work going on to develop strategies, and I think the focus will be first to vaccinate children who have a higher risk of having severe disease, because we do know that children predominantly have mild disease. So those children who have comorbidities, who are on immunosuppressive drugs, probably would be vaccinated first, and the same mechanism as has been done for adults would be used. After that, it will be opened up, I think, for all children. It should happen soon because the approval has happened and it just needs to be rolled out and the mechanism needs to be worked out.
Thank you. My last question, what can we strategize that those who got infection in the second wave be given only one dose of vaccine, and we can focus on those who did not get any infection whatsoever, because we have completed right now, I think 30%, you said, both doses to 30% eligible population. 100 crores doses we have given, but 70% one dose. So will that be a optimal strategy?
So this is one strategy which was even thought in the past, that if you have already had if you already had infection, then that should be like the first dose, and then you just take one shot, and that will give you enough protection. And there is data which supports that. But we need to be sure, because a large number, and there was a theory in the beginning that before giving the vaccine, let's do antibody testing, because we know that 70 to 80% of people have mild infection and may not be actually tested also. So that theory was that you do antibody testing. Those who have antibodies don't give the vaccine or give only one shot. But logistically, it becomes difficult. And therefore, from the logistic point of view, it was decided to give both the shots. But if you have a shortage of vaccine, one could actually limit one dose to those who have already had the infection, because that itself would be sufficient in my mind.
Thank you very much, Dr. Narendra Rungta. Would you like to ask something?
Thank you, Dr. Guleria. Your great presentation today indicates why people are after you to have your opinion on everything related to COVID. And you have clarified a lot of issues. And I'm sure the delegates here have been greatly benefited by your wisdom on COVID. And coming times, I think this country and the medical professionals will need your guidance more and more. Thank you so much for being with us.
Thank you. Thank you for inviting me.
Thank you very much, Randeep, for giving us insight into what's going on and what future lies for all of us. And you have given a lot of hope, positivity, and also people must continue with public health measures, be that mask, be that distancing, be that hygiene. There is no replacement. And I also add, since you are a respiratory expert, that even if for COVID you don't want to use mask, use for pollution, which is now winters have set in North India and pollution is at its peak, and that also would be beneficial, a collateral benefit of continue with COVID appropriate behavior. So thank you so much indeed. First thing in the morning, it's a wonderful insight into the whole pandemic thus far.
Dr. Prashant Nasa, you can introduce the next speaker, please.
Thank you, Dr. Deepti. Professor Daniel Becker doesn't need much of an introduction. He is well-known faculty and well-known, researcher in intensive care medicine. He is professor of intensive care and head of the department at the Chirac Hospital, Brussels. He is a very well-known researcher, was past president of European Society of Intensive Care Medicine. He has more than 300 papers to his credit and various book chapters. Well known for his famous FANIS study, which was first prospective observational cohort study done in Europe. I invite Professor Baker to take over the dais.
Hello, my name is Daniel Becker. It's my pleasure to discuss with you the issue of maintaining hemodynamic stability in COVID-19 ICU patients. We often face these kind of patients, white lungs, major alterations in PF ratio, and we need to have the best respiratory management as possible. However, we have to remember that COVID is not just a lung disease. Lung disease is important, but we should not forget about the other organs. And indeed, we have several reasons to worry about hemodynamics. We have on one hand, severe RDS and use of mechanical ventilation, often with very advanced conditions, and this may favor the development of acute cardiopulmonale. Also, we have endothelial dysfunction, leading to capillary leak, and hence hypovolemia. We have the inflammatory process, which indeed will impair vascular tone and may induce cardiac dysfunction. And at the end, we also may have thrombosis and especially pulmonary embolism that may lead to acute cardiopulmonale. All these factors make that we have also to worry about hemodynamics, to measure, meaning estimate the hemodynamics by different monitoring devices, and of course to treat these alterations. So the first aspect is what is the best hemodynamic tool in these COVID critical patients? We should apply in this area a stepwise approach, just as in other regular patients. And for this, we suggest indeed to begin with an echocardiography, just to indeed identify which are the main alterations we face in these patients. We often have arterial lines, of course, for blood gas analysis, but also we can evaluate the CVP and other measurements with central venous oxygen saturation. With this, we will begin, of course, with having a good idea of to what is already occurring in these patients. But we should also, of course, look at several indices of tissue perfusion, because crucial question when we will measure the hemodynamics of this patient is whether or not tissue perfusion is adequate in these patients. And for this, we have several indices from SVO2 to lactate, of course, capillary fill time, and some other factors. We should not neglect the clinical signs of tissue perfusion, especially the capillary fill time. And especially, I say, because we have to remember this very important trial from our South American colleagues demonstrated that peripheral perfusion guided resuscitation is at least as good as lactate guided resuscitation. But of course, it's probably better to combine all these factors. What about SVO2? SVO2 should not be neglected because indeed it is a very good indice of the adequacy of oxygen delivery compared to oxygen consumption. And in COVID, we have, of course, the hypoxemia that will play a role as well as the impaired cardiac output perhaps. And so SVO2 is an early detector of this imbalance. Among the factors in shock associated with poor outcome, SVO2 is often there. And SVO2 also is impaired in septic shock and occurs in 1/5, 1/3 of our patients with septic shock. But admittedly, SVO2 is usually high in COVID patients for several reasons, but perhaps microvascular shunting, microcirculatory alterations, all these factors may play a role there. So what is exactly the target value of SVO2 in COVID patients? Admittedly, we do not know at this stage, even after 18 months of taking care of these patients. Elevated blood lactate is also an important marker. And in septic shock especially, we see that indeed there is a very strong correlation between elevated lactate levels and mortality. And often, initially, lactate levels are associated with tissue hypoxia, while at later stages, other factors, and especially inflammation, may play a role there. Again, in COVID patients, we do not know exactly when we find elevated lactate levels, whether these represent tissue hypoxia on one hand or represent the lung production of lactate in the inflammatory states. So we do not know exactly. So when nevertheless we will find these abnormalities in capillary fill time, lactate levels, or even venous arterial CO2 differences, when these are abnormal, what should I do at the bedside? And this begins to be much more tricky, much more complex. Because clinical evaluation is a trigger, but not a substitute to hemodynamic evaluation for several reasons. The first one is that there is a very poor correlation with cardiac output. Second, we have no information on the cause of tissue hypoperfusion and hence no information on the therapy to apply to these patients. So echocardiography is very important to try to separate the different type of shock that we may face. And all of these can be found in COVID patient. We may face hypovolemia, as we mentioned. We may face obstructive shock due to pulmonary embolism or right ventricular dysfunction. We may have cardiac shock due to left heart impairment. And of course, distributive shock due to decrease in vascular tone. So all these factors may contribute. So then performing ultrasound echocardiography is very important because very rapidly we may have access to separation into these different diagnoses. Well, the question will be, is it so rapid in COVID? Probably not, because indeed it's a little bit more complicated to protect the device, to protect the sonographer. But once done, it's very rapid indeed to have the diagnosis. And this is why we recommended in shock to use echocardiography to really rapidly assess these patients. And indeed, in very different consensus conferences, it is indeed recommended to use echocardiography to detect what is the cause of shock. So if the patient rapidly improves, we would expect and reevaluate. And this is what we propose in that consensus conference from the ESICM. Admittedly, there is some place there for a continuous non-invasive cardiac output monitoring tool for alarming entrance. And especially in COVID, with the isolation and the difficulties to enter the room to make new assessments, this is really something where you love to have some additional measurements to warn you that something is ongoing in this patient. So when there is no improvement, or in complex cases when we have additional alterations, it's often good to have some more complex measurements. And for these, the measurement of the extravascular water or endoscopic volume with transparameter thermodilution is really very desired, or in more complex patients, even the pulmonary artery catheter with the PA catheter. And actually, in many of our severe COVID patients, we inserted the transparameter thermodilution. In some of these, we inserted the PA catheter, and I will explain you why we select one or the other one. So why do we select one or the other one? Well, mostly it is based on the fact that we observed some right ventricular dysfunction. Indeed, because when we have right ventricular impairment, we suggest to use a PA catheter. When we have no right ventricular dysfunction, then we may select indeed the transparameter thermodilution. So we have to select between the two, and again, echocardiography is really very useful in these conditions. Then, of course, we have to discuss how to treat these patients. And the volume replacement in patients with COVID-19 is really a very difficult issue. Because on one hand, we have to realize that there may be causes of hypovolemia in these patients because there are blood losses, especially initially when these patients present with diarrhea. And of course, also just due to the capillary leak, the increase in permeability will indeed lead to these fluid losses. But there is also blood flow redistribution and venous dilations that occur just due to the decrease in vascular tone. All these factors play a role in generating some hypovolemia. So yes, giving volume to this patient is probably at some point desired. But we have to be very careful because on one hand, we have the indication for fluids, but also the risk associated with fluids, especially in these patients with already increased extravascular water. So we will keep for these patients some general principle, meaning that we will try to keep, whenever possible, these patients dry. And we will have some cautious administration of fluids in a situation where a hypovolemic component is associated with impaired tissue perfusion. So this is very general, but it is very important to keep in mind because indeed, each time we need to pay attention to the benefits and the risk associated with fluid, but also the benefit and the risk associated with fluid deprivation in these patients. And generating acute kidney dysfunction is really not the good alternative either. So we need to balance between a little bit excess of water or an excess in water deprivation and organ dysfunction. So my approach in these patients with COVID-19 is always to ask myself, what are the potential benefits of fluids in this specific patient? What are the risks of fluids? Of course, this will depend mostly on situation. The risks are not identical in a patient who is breathing spontaneously under high flow oxygen therapy and very close to intubation, and a patient under mechanical ventilation where indeed the risks are a little bit more limited. And what are also the risks of the alternative therapies? And alternative therapies meaning nothing or some other therapies to increase cardiac output. And then, of course, I will try to predict whenever possible. I say whenever possible because it's not always easy. Again, in the patient under high flow oxygen therapy is not as easy as in the patient under mechanical ventilation, of course. And especially evaluate the response to fluid. Because indeed, when we give fluids, it's important to know whether the patient responded and tolerated these fluids or not, because we will ask ourselves in some next future the same identical question. And if the patient was not responding or not tolerating, it will be useless to give fluids there. And so each time we should evaluate the effects of fluids. Management of hypertension is also something important. And indeed, we can go with the general guidelines of giving norepinephrine as the first vasopressor. And this indeed was in the COVID-19 recommendation also, even though based mostly on data on sepsis, of course. And these data on sepsis are mostly this kind of data where patients were randomized for norepinephrine versus something else, and where norepinephrine was obviously associated with the best outcome in cardiac shock, but also in septic shock and hypovolemic shock perhaps. And in meta-analysis of septic shock patients, norepinephrine was better compared to dopamine. And perhaps more important, when there was some shortage of norepinephrine, there was an increase in the risk of death in the units that were submitted to this shortage. And so the norepinephrine is always associated with a very robust signal of an improved outcome compared to other vasopressors. Same magnitude for most of the comparators. Then the question is what to do when we have some persisting hypertension. And the previous guidelines suggested to consider perhaps epinephrine. The new guidelines are even worse, considering that indeed epinephrine, yes, should be used in some of these patients. Why? Well, perhaps just because we have epinephrine available. Okay, but so remember why you use epinephrine. And you use epinephrine because you would like to improve blood pressure. But why do you improve blood pressure with epinephrine? Because it is acting on alpha receptors. Yes, but norepinephrine also. So you substitute or you add an alpha receptor to another alpha receptor. And what else do you expect than just the effect of just increasing norepinephrine? Well, nothing. You expect just nothing. Nothing else, but perhaps some adverse effects because you will stimulate very markedly beta-adrenergic receptors with high dose of epinephrine. And indeed, when these were compared, we had these kind of signals. An increased heart rate with epinephrine. Well, no, never so good to have tachycardia, I admit. An increase in lactate levels. And also when we look at the mortality, we say, oh, yes, there is no difference in mortality. Okay, but the primary outcome was a 28 days mortality. And then we can see that there was a very significant trend here. But of course, study unpowered. So we end up by conclusion saying, no difference in mortality because we were not able to prove it. Okay, but the signal there is quite frightening, isn't it? And then, of course, we have to think at what is the pharmacology for using other agents. Well, we'll stimulate other receptors, but the machinery below is exactly the same, exactly identical. Remember this. So when we have substitution for norepinephrine, we will have exactly the same machinery that will be implicated downstream. So differences between the different agents arise due to receptor sensitivity. And this is a marked importance, of course. And also disposition in the vascular system, as well as stimulation of other receptors. And this begins to be important because these other receptors may be detrimental or beneficial, of course, in some conditions. So about vasopressin, indeed, we have these data initially showing that it was at least as good as norepinephrine. And there was even a signal that there could be an improved outcome with low-dose vasopressors, not in high dose. Okay. So in low dose could be beneficial. But then other trials failed to confirm this. And then meta-analysis of mortality, absolutely no difference in mortality. Interesting. But then there was indeed for tachycardia or arrhythmias, less arrhythmias with vasopressin, and also less requirements for renal replacement therapy. So these are subtypes of patients that may benefit from vasopressin rather or in addition to norepinephrine. Remember, no difference in outcomes. This means that at the end, there is a price to pay on other factors by definition. Which one? Well, perhaps vasoconstriction, splanchnic constriction, but not sufficiently significant to be disclosed by these trials. Vasopressin can be an alternative. Well, not in favor for the surviving sepsis campaign. Based on what? Based on that trial that showed, well, equivalent effects on blood pressure, on lactate, and no difference in survival rate in that trial. There was also another trial very interesting, comparing vasopressin and epinephrine in septic shock. And in that trial, crude hospital mortality, 44% vasopressin, 50% in epinephrine group. Not significant, okay, but very interesting signal at the end here. And in subgroup analysis, it was shown that indeed this trend was always found in the same direction. Other agents may be angiotensin. Angiotensin is shown here to be associated with a trend, at least in some improvement in outcome, but of course not significant. The trial was a phase 2 trial that indeed just compared the hemodynamic effect of angiotensin. And in that trial, the fact that there was a little bit more thrombotic events, peripheral ischemia with angiotensin. So we need to be cautious with this. Again, this aspect here, and perhaps also something interesting, more fungal infection with angiotensin. So what about COVID there? Well, we can look at these kind of papers showing that indeed angiotensin, it may not be very good because indeed the stimulation of this angiotensin may indeed favor the infection by the COVID. Well, yes, but our patients are already infected, of course, and replication of virus is not really the major issue. And this was discovered by the lack of efficacy of most of the antiviral effects. And then what about the angiotensin in hypotensive patients? Well, in hypotensive patients, there is some changes in the enzymes so that indeed at some point giving exogenous angiotensin may perhaps block the entry of the virus into the cells and may also have some other effects downstream. Interesting when we look in series giving angiotensin or norepinephrine in these kind of patients and with COVID, well, you can control the mean arterial pressure, you decrease the other vasopressor requirements, and you have some moderate or no effect on blood gas and creatinine, perhaps improved with angiotensin compared to controls. Compared to other factors, well, the dimers also decreased in these patients compared to the other one. So maybe something else there on beneficial effect. Here, the Italians looked at the impact on blood gas, and they observed an improvement in PF ratio in these patients. So this signal is quite interesting, but of course need to be validated in more advanced data. And at the end, we also should look at the heart because, again, what could be occurring to the heart, thrombotic events, myocardial infarction, but also myocarditis, pericarditis, myocardial depression, just as in sepsis, and of course, acute pulmonale. Focal inflammation necrosis occurs in these patients, so sometimes we have myocarditis that can be disclosed in this patient. Pleural pericarditis is also frequent, very mild as is in this patient, but more advanced like in this other patient. And of course, even more advanced here in this patient also. What is exactly the place for echo in COVID-19? Again, not always easy because we need to protect ourselves and the device, but nevertheless, it's quite useful because you can sometimes see some alterations in level of function with minor effect or moderate effect on the ejection flow here. Here are some more severe alterations, global, left heart, right heart, and paradoxically, less effect on the stroke volume. This is what's better preserved here. And here, even more severe, especially for the right side here. And you can see that the stroke volume was even more preserved in that patient. So variable alterations, predominant left ventricular dysfunction, but also global dysfunction, predominant right ventricular dysfunction in some other patients, and very variable impact on cardiac output. And this was found repeatedly by several investigators here in large-scale data where you find exactly the same alteration on the left side, alteration on the right side, pericardial effusion, biventricular failure. And so indeed, what is probably relevant for this patient is a right ventricular dysfunction, because indeed we can see that patients with right ventricular dysfunction really have a poor outcome compared to patients without right ventricular dysfunction in there. And for the left heart, remember that we need to compare what is the output impact, because indeed some patients have here unimpaired cardiac function but preserved cardiac output, and we should not give ARP agents to these patients. Only give ARP agents here to the patient with combined low cardiac output associated with impaired cardiac function. So at the end, for the echo in COVID, we have similar pattern as in usual sepsis. And this cannot be predicted from clinical features biomarkers. We have also to remember the pericardial effusion is frequent in these patients, and the thrombotic events may also affect the heart. And with this, I thank you for your attention.
Thank you, Professor Baker. I think it was a very excellent presentation and very informative as always. So before I invite questions from the delegates, I take this privilege to have a question from you. So we understand that critically ill COVID patients, most of the time we initially start a non-invasive, respiratory support to these patients. And many of the time, as you have rightly, told in your presentation too, that they are fluid deficits, either because of gastroenteritis or because of their respiratory part, because of tachypnea and other things. So how do you assess fluid assessment in these patients? Any sort of hemodynamic monitoring you recommend, or specific fluid strategy?
I think he's left on, not looking online.
Okay, so Professor Baker.
I think Professor Baker is not live. So we move on to our next talk.
Yeah.
I'll take this opportunity to introduce Dr. Praveen Amin, Head of the Department of Critical Care Medicine at Bombay Hospital, Institute of Medical Sciences, Breach Candy. Sir is the founder and one of the senior most past president of ISCCM. We'll be speaking on explosion of COVID-19, the mystery.
Good morning, everybody. At the outset, I'd like to thank Dr. Narendra Rungta, my dear friend, and the organizers, all the organizers of this wonderful conference for inviting me for this plenary session. Over the last 2 years, we've been through an explosion of COVID-19, and this has affected all our lives. More than nearly 4.9 million people have died across the world. So this has left us quite devastated, and we've never seen a pandemic as devastating as this one. So we need to understand what is the mystery behind this COVID-19? How did this come about? What are the origin? So actually, instead of what is called an explosion, I think I would refer to this as the origin of the COVID-19. And is there a mystery behind this? And as we unfold, you will see that there are some events which have occurred in the last year and a half, which has made the world aware that there is something more than what we have been told. If we look at the virology of coronavirus, it was isolated in 1966, but it was an ancient virus. It's been around for centuries. To name the coronavirus based on the the radiation of the sun, and as you can see here, it gives you a radiance like the corona, like the sun. Hence the name. Now, if you look at the family Coronavirinae, there are basically classified into 4 genera. The genera is alpha, beta, gamma, and delta. Alpha and beta coronaviruses usually are seen among bats and rodents as the primary hosts, and the gamma and delta, the birds, are the natural host. Jumping hosts from these natural hosts is not uncommon with the coronavirus, and we have actually experienced this with the SARS-1 and the MERS virus, which was the most devastating of the lot. And as we can see here, from the COVID, it moved to the civet cat. In the SARS-1, the camel was the intermediate host. The intermediate host for the SARS-2 is not known. So in SARS-1, it moved from the civet to humans, and in the MERS, it moved from the camel to humans, and then it spread from human to human. So this is something which is very typical, that the virus actually moves on to an intermediate host, and then goes on to the humans to get affected, and then it spreads from human to human. And you must know that this is the largest host that any virus would thrive on in terms of spreading from host, because humans are around everywhere in the world. So the beta coronavirus genre is divided into Sarbecore viruses, which is what we are predominantly going to be looking at. And there are other groups of viruses, and all of them have certain features which we will try and understand what they can do. Now, there are 7 coronaviruses that infect humans. Like I said, the SARS, MERS, and the SARS-CoV-2 are the ones which cause the severe form in terms of ARDS and respiratory symptoms. The other 4 are actually cause milder colds, common colds. So as you can see here, the HCoV 04C43 was found in the mid-90s. It moved from the rodents to cattle, and then to humans. But when they trace it back, when they look at it, we talk about it later, that it may have actually been present for centuries. Likewise, the HCoV 2229E was detected in the mid-1960s. It moved from bats to alpacas or cameloids, camel relatives. And of course, the NL63 from the bat to an unidentified host was identified in 2004, and HKU1 from rats to an unidentified host to human. These 4 really cause very mild corona illnesses. Now, if you see in this timeline, which is nicely published in the Nature Reviews, if you look at the NL63, which causes the common cold, the alpha coronavirus, it may have affected humans way back in 1200. And if you look at the OC43 in 1890, so these are ones which have caused cold. There are other coronaviruses which have caused diarrhea in calves and animals. And of course, the MERS, the most severe one in 2012, and the SARS SARS-CoV-1, which was in 2000. So they have been around for many, many years. Now, if you look at the timeline, as I showed you here, the alpha coronavirus NN63, the time it moved to humans was somewhere in 1940. So it took about 300, 350, 200, 300 years for some of these viruses to migrate from bats to alpaca to humans. So the time frame, as you can see in the 229E, took about 250 years. First probably present in the 18th century. So from the bats to the alpaca to human, it took a pretty long time for it to adapt itself from the bat to the alpaca, and from there to move to the human. So it's a time consuming, when the mutation takes place, it's time consuming from it to move from the primary host, the natural host, to the intermediate host, and then finally to man. And this is typically seen in most of these coronaviruses. They take time from them to move from the primary natural host to the human beings. Now let's look at the ones which we really know pretty well about. And this is the SARS-CoV-1, where actually it moved from bats to civets, which are cats. There were 5 mutations before it, and every mutation that takes place, it leaves a stamp behind. So every time a virus mutates, there are telltale signs, there are signs which are left behind in their genome, which tells you that they move from bats to civets. Likewise, from civets, when it moved to humans, there were 14 mutations from the civet cat to move to human. And when it first moved to human, it was very weak. And then subsequently, there were 4 more mutations. And that's when the SARS-CoV became very virulent. And that's when we got that last pandemic. Fortunately, the mutations then that took place kind of killed it and disappeared from the earth. So it was there for a few years and then it disappeared. Likewise, MERS too has had its time process of which it moved from the bat to the camel and then to humans. Now, the first cases of SARS-CoV-2, we were told by the Chinese that this was in the Yunnan market in Wuhan, where it came from some wheat. Nearly 1/3 of the 174 earliest known cases were linked to the Yunnan market. The patient 0, who was identified as patient 0, never went to the Hunan market. He shopped in a supermarket across the river. So that brought out some kind of a message that did this actually take place? Was Hunan the actual primary area where the virus moved from animals to humans? Did it ever move from animals to humans? So in May 2020, the Chinese CDC said that first we assumed that the seafood market was where the virus originated, but probably that was the area where a lot of people met, and that's where the virus spread. Maybe it was there, and they said the novel virus probably existed before that. So this brought us to a lot of thinkers who thought that maybe there is something to it, because then this is a cosmopolitan city. Why did the COVID a bat virus come in a city where there is no bats? So then people thought about it. In this city, coincidentally, the largest viral institute, which is called the Wuhan Institute of Virology, is about 7 miles away from the Wuhan seafood market. So they were doing experiments on virus. The scientists had collaborated with multiple international virus hunters. They had published in academic journals about various viruses. They had received thousands of dollars of grants from the US. And the Wuhan Institute of Virology frequently partnered with the Wuhan Center for Disease Control and Prevention. And this was a new institute which was started, and this was recently moved to the Hunan market area. So let's look at the Wuhan Institute of Virology. The Wuhan Institute of Virology, the lead corona research is called Shi Dingli. She was first to identify that the horseshoe bat was responsible and was the natural reservoir for SARS-CoV-1. And this actually in 2002 killed 774 patients and sickening nearly 8,000 patients globally. And she then had this distinction of doing considerable research in virology. And she became known in China as the Bat Woman because she would fearlessly go into various caves to explore for bats and collect samples, their feces and blood samples from bats, and bring it back to the Wuhan Institute of Virology, where she performed high-profile experiments on these pathogens. And some of these experiments would mount to what is called as gain of function, and this has generated a lot of controversy among various virologists across the world. So there was a lot of people who said, did this virus come out from the lab? Was there a leakage from this lab? Even some people went to the extent of saying, because this was governed by the military, was this a bioweapon? None of which has yet to be proven, that either is this a lab leak or is this a bioweapon. But there are many questions which are unanswered, and still till date, we still see answers in this direction. So there are a group of scientists across the world who are in support of the Wuhan Institute of Virology, and such a group got together and published in the Lancet, saying that those people who say that there is a lab leak are conspiracy theorists. And among this was, if you look at this, there was a phrase which came, which is called as Eco Health Alliance. The president of the Eco Health Alliance actually got all these virologists together to write in this letter, and there was sufficient emails to show that he instigated to write this letter to state that all people who spoke about a lab leak were conspiracy theorists. So when we looked at, and if you look at the in this article, the president did not even mention that there was a conflict of interest because he was funding this through the NIH. He was giving considerable funds. So if he had provided funds to this institute and he wrote out such a letter, which went across as a very strong letter to a lot of people, and a lot of people then stopped asking questions about the lab leak because of very prominent people involved. So this raises a big question about the conflict of interest. The EcoHealth Alliance, through the NIH of the USA and NIID, actually provided funds for the Eco Alliance, which they let out to various institutes across the world. And a large amount of funds did go to the Wuhan Institute of Virology. And some of these members, as you can see, 2 authors are members of the board of directors of Eco Health Alliance. 1 author was the group's executive vice president. And of course, another was a science and policy. So most of them, when it was found that of the 27, except 1, probably had some relationship with the Wuhan Institute of Virology in terms of grants, in terms of... So there seemed to be some questions asked when later on people came to know about it. A month later, another very senior virologist went about giving explanation in Nature about how the SARS-CoV took place and said this is impossible for it to be a lab leak. He gave all reasons of why the COVID was a virulent organism, but he did not give any proof to suggest there was a natural spillover, which was provided in this article. And of course, there was no proof to say there was a lab leak. So the argument was that since the SARS-1 and the MERS happened to move from a bad to intermediate host, most likely this has to be a natural host. So that was the realms of speculation as per this author. And so they went about, subsequently they came out with another article in July where they went about, instead of now saying conspiracy theory, they said this is unsubstantial allegations. Again, the same group of people got together, same authors went about, saying that the virus has evolved through nature and has never produced any evidence to show that. And this would mean cutting professional links with the Chinese, who in the meantime were very aggressive and were in fact not providing adequate information to the World Health Organization and to a number of questions which were asked to the Chinese in terms of what has happened in the Wuhan Institute of Health. A word about the EcoHealth. And EcoHealth is somebody, the president of the EcoHealth, just about on 9th of December, before the pandemic was announced, he then gave long details about what the Wuhan Institute of Virology was capable of doing. They were capable of reprogramming the spike protein, generating chimeric this thing, and infecting humanized mice. These humanized mice are mice which have got in the trachea, genomic variation, ACE inhibitor 2 receptors. So it makes it susceptible to the SARS virus. So these were the experiments which were done, and he came out in this interview very clearly saying that this was capability of the Wuhan Institute of Virology. And subsequently, after the epidemic that came out, he retracted his step and said that there was no such experiments carried out. And we now have found 6 to 7 years of doing this over 100 new SARS-related coronaviruses. So this was the kind of work which was being done in humanized cell, making a virus more potent by making genomic changes in the spike protein and incorporating. These were clearly evidence of clear and present danger. So subsequently to this, because the message or the rumor about lab leaks started increasing, including messages from politicians, various scientists who questioned this. Is this a possibility? The WHO commissioned, they created a group of people to go and visit the place. The Chinese, when the WHO recommended 3 Americans, they completely rejected them and selected, scientists of their preference. So clearly, of which the president of the EcoHealth was in fact also a part of that group. And in fact, the WHO head, who subsequently, when he came out of that interview, they were for 4 weeks in the Wuhan Institute of Virology, but they were allowed only 3 hours in the Wuhan Institute of Virology, and they were not shown any database or anything of that kind. So there were problems that they had limited access to anything that was, and whatever was asked for was never provided. So they just had a 3-hour visit, and they said that the laboratory origin was extremely unlikely. There were only 13 of them and 60 scientists from the Chinese group. So they were quite overwhelmed by the Chinese. The head of the 13-member group, who was a part of the WHO virology group, an expert by himself, later on in August gave an interview that the Chinese official pressurized him to include this phrase of extremely unlikely in his report. So the WHO director, after looking at this report, said this requires further investigation. And on the 12th of October, the WHO announced a new team. But to this, the Chinese have completely refused to cooperate and said they will not participate in this investigation. There was another transit. Again, as I said, the president of the EcoHealth was the only American chosen by the Chinese. So again, somebody who the Chinese preferred to anybody else in the US. Likewise, there was another Lancet group, task force group. Again, this was formed by the president of EcoHealth. His name keeps cropping up, where he was generating people to spread the message that the lab leak was impossible, was unlikely, and it was a conspiracy theory. And of course, recently, the chairman of this group, who was the director of sustainable development at the Columbia University and the chairman of this COVID-19 group, dissolved this group, saying that I just don't want a task force that is so clearly involved with one of the main issues of this whole search of the origin, which was the Wuhan Institute of Virology. So the members of the Lancet task force too had some connection with the group. Likewise, there was a contrary view where they actually replied to both the letters, clearly saying that you have not provided us any solid reference to say that it was a natural spillover, and neither the host pathway from bats to human has been delineated. And of course, looking at the geographical distance from where the bats originated was in a distant southern part of China called Yunnan. It was about 1,600 miles. Bats don't fly that distance, and there are no bats in that area. So this overwhelming evidence of either a zoonotic or a research-related origin is lacking. The jury is still out there. We do not think that the scientists would promote unity. This question, because the previous in the letter they said we must promote unity, and this business of promoting unity to say that this is a conspiracy theory is not right. You should go on scientific facts. That's what this letter says. This is very damning, and this was something probably which made the previous president of the US state that there was something wrong with the Wuhan Institute of Virology. This is the US State Department fact sheet where they did some investigation. They said the US government has reasons to believe that several researchers inside the Wuhan Institute of Virology became sick in the autumn of 2019 with symptoms which were consistent with COVID. And when this question was raised to the Wuhan Institute researcher, she said we had zero infection among the Wuhan Institute of Virology. Never substantiated with serology report of any of kind. Accidental infections in lab has caused number of previous infections in China. This is a known fact. The Communist Party of China has prevented independent journalists, investigators, and global health authorities from interviewing researchers at the Wuhan Institute of Virology, including those who were ill in the fall of 2019. So this is what happens with an authoritarian government. And of course, there are cases of citizen reporters who have disappeared, doctors who have disappeared. We have no idea what has happened to them. They are still missing. Research at the Wuhan Institute really looks at, there was this research which was called as RAT-G13, the bat coronavirus, which was identified in Wuhan Institute of Virology, which was published in 2020, sometime last year. And it has 96.2% similarity to the SARS-CoV virus. So the Center for International Research, after the 2003 SARS outbreak, has been studied on animals, including mice, bats, and pangolins. The Wuhan Institute has published a number of research on gain-of-function research to engineer what is called a chimeric virus. The Wuhan has not been transparent or consistent about its record of studying viruses, most similar to the COVID-19 virus, which is RAT-G3. And this was, this virus was supposed to have been isolated in Yunnan province 2013, where several miners died. Of course, in their publication, they did not mention that this originated from the laboratory, from the caves in Yunnan. This was, I will show you later on, due to some investigations by a group of internet sleuths who actually found out this happened. And of course, as the Wuhan Institute has engaged in classified research, which include laboratory animal experiments on behalf of the Chinese military since 2017. This is the fact sheet which is done by the US State Department. And this was what probably the previous president was quoting when he said it was a leak from this thing. And considerable political issue which really emerged from that. We won't get into the politics of that. So in the Wuhan Institute database, in 12th of September, well before the 22,000 coronaviruses which they had in the database disappeared and has not come back online since. So the same day, the security was beefed up. They had issued a tender to replace an air conditioning. This is probably when the leak may have occurred. A month later, this is when the institute went into a communication blackout. There was no cellular activity in the compound. So it was a complete blackout in this area. So there is a belief that this is probably when the leak may have taken place. And there was some of the workers who got sick. And there are a lot of smoke everywhere. There's really no smoking gun, but there's a lot of smoke coming out multiple windows. Telling you there were a number of things which tell you there is a possibility of a lab leak. History of lab leaks, there are numerous histories across. In England, the smallpox vaccine, where 80 cases happened, 3 deaths. SARS-3 in China itself, across China, Singapore, Taiwan showed leakages, and people were affected by severe SARS in these groups. H1N1, the Venezuelan equine encephalitis, the anthrax leaks in Russian lab. So history of lab leaks is clearly there. Lab accidents are not rare. In the US too, in 2020, there were 134 reported cases and 68 people at 25 registered centers. So even in places with well-maintained labs, there are lab leaks which take place. So why is this? If you look at the labs, there are different categories of BSL-4 is where you wear like a spacesuit, and then BSL-3. These are where you use BSL-4 is for Ebola, smallpox viruses, whereas BSL-3 is for avian influenza plague. BSL-2 is for minor where simplex, where common cold viruses, and BSL-1. And if you look at what Xi Jinping has published, most of our work on coronaviruses was done in BSL-2, which is like just wearing a gown and gloves, which is what a dentist would wear. So this is the kind of work they did, extensive work with coronaviruses with not high degree of safety. And of course, the US fact sheet also said there was a problem in 2018 with the BSL-4 labs. it's not that gain of function report is bad. Now, if you look at the SARS-CoV-2 spike protein, which was incorporated into the adenovirus, and that's how the AstraZeneca virus vaccine came out. So there is some benefit of gain of function, and it can be seen in the Ebola virus, the Mar virus, and the LSV viruses, which have actually shown vaccines can be got out from these viruses. So what happened was this particular rat G3 was published in the Nature by Shi Jing Li, and she said that this was the closest virus to this thing, and it was collected from the Yunnan province. A group called Drastic, which is a decentralized radical autonomous service team, a collection of internet activists. They are 34 members active on Twitter. What they did was they looked into research work in Chinese on this, and then they found out, the one Indian actually published that actually this rat G3 was close to another virus which was called as 4991, and this was exactly the same virus. This was the virus which they picked up from the Yunnan mines. So instead of saying that this was, and she then made a correction, instead of saying that this was a correction, this probably is clearly a really bad scientific data telling you that you said first that this was, in fact, a different virus. You renamed it. Actually, you had this virus from 2013 when the miners got sick. There were miners who got sick, and then they said this was not viral infection. They all had features which were similar to the SARS-1, and 3 of them died. 6 of them, they said they treated with antifungal. 1 actually got better without antifungal. And they attributed this to this thing. And they found out, at that time, they found this virus called RA4991. And this 4991, later on, they renamed, and we don't know why they renamed it. So why this lab leak theory? There are multiple issues which tell you that there are, this Wuhan showed limited genetic diversity. There's a single source which is involved. And looking at the uniform structure of the genomes, it looks very, very well made for humans. So that gives you this. And the eco-health system, what they did was in 2018, they did what is called as the Diffuse Project. They provided to Drastic, which is the Defense Advanced Research Products Agency in the US in 2018, exactly what gain of function is, where they did a furin cleavage site into the SARS-like COVID coronavirus. And this was rejected by the defense system as something bad. So I'm going to quickly wind up here saying that the genomic structures, you need to have a backbone from which it is done. So what is done is this furin cleavage site. And this is something which tells you that this may be manipulated. So there is the spike protein. The spike protein attaches itself to the ACE inhibitor. And there are 2 components, S1 and S2. Between this, there is a furin cleavage site, which actually cuts off S1 once it attaches. Then the S2 will deliver the virus inside. This happens to the AC2 virus. This is not seen in any beta coronavirus. So this has never been seen. And this is something which tells you that this may be something that you're concerned. And the people who say that, there should be telltale signs. Nowadays, they've improved the technique so much that there is no signature left behind when you do these alterations in these viruses. This is typically how it is, the arginine, proline, arginine, alanine. So these are, how it is seen between spike 1, spike 2, then PRRA. This is the proline, arginine. This is the furin cleavage site where the furin attaches and breaks, cuts off S1 and then transmit. And if you look at it, it has got the arginine, CGG, which is never seen in any, this is typically made for humans. So it looks like that this genome is which is never seen, has never been demonstrated in SARS virus, is demonstrated in SARS-CoV-2. And of course, there's a receptor binding protein domain, which is also affected. And in September, just recently, they have actually detected another virus, coronavirus, which is 96.8% genome identity to the SARS-CoV virus. And this is found in North Laos. And this is in the bat flying distance of from Laos to Yunnan district. So it cannot fly up to 1600. So this bat, which is actually responsible for this, in September, there was very unlikely because bats go into hibernation. When it came in September 2019, bats had already gone into hibernation. So all these telltale signs are telling you that there are a possibility of a laboratory leak. And this Nikolai Petrovsky has actually gone about saying that this virus, can affect humans. It is made for humans, but it does not infect bats. It does not infect any other animal that he tested. So these are something which are of concern. And so if you look at the plausible of natural emergence, because they say SARS-1 and MERS moved from an intermediate host to humans, but they tested 90,000 animals in the wet market. None of them had this virus. And the hospital, there is no evidence from hospital surveillance records of the epidemic gathering strength. And this is a single strength showing that probably this epidemic, which suddenly came completely adapted to humans. Who takes responsibility? The Chinese virologists, the Chinese authorities, worldwide community who have not actually thought about what was being done and whether this gain of function research is something which is very harmful, needs to look at it. So in conclusion, I'd like to say all theories are possible that the wild bat moved, it may have moved directly to the humans, or it may have moved through an intermediate host, or it may have moved in the laboratory by genetic engineering, by the cell culture, or humanized mice to human because of an accident. So the quick question that we ask is, why did SARS-CoV break out in Wuhan? Why was there only one spillover, which then tells you that this is more likely to be a lab leak? Why was the first isolated SARS-CoV so well adapted to humans? How did SARS-CoV acquire a furin cleavage site in the spike protein, which has never been seen in any of its relatives? Why there is no intermediate host? Why in February 2020, the Wuhan Institute gave the genome rat G13 a new name when it was already existent in 2013? The rat G13 was found at a site suspected of coronavirus outbreak at the Mujiangbai, which the Chinese never disclosed to the World Health Organization. Thank you very much for a patient hearing.
Thank you, Dr. Praveen Amin. It was indeed a very interesting, it was like a mystery unfolding as the story was going on. And
I don't think
I felt like
I don't think I've ever spoken so fast. This is the advantage of recording, where you can fast forward your speak to cut down the time that I probably overshot. So a new technique of fast forwarding your talk, making you speak faster than you actually speak.
Thank you so much, sir. Thank you. With this, I'll request Dr. MC Mishra to introduce our next speaker.
Can I have a question from Dr.
Sure, sir. Sure.
And
Praveen?
I also.
Praveen,
Yeah.
you're there?
Yeah, I'm here.
You have blasted a dynamite, Praveen. And
Well, there are numerous questions out there.
Right.
Truly,
And
if you look at it, there are a lot of smoke coming out of the windows, and too much time has passed, and I think the Chinese may have already, cleared their tracks of what was possibly
the CGG factor that you have brought out to the fore is real crux to the whole issue, which probably triggers the debate whether this was specifically made for human beings. And exactly what that you have blasted and brought to the fore.
The furin cleavage site is something that is not seen in any coronaviruses. Now, we're not saying that it cannot happen. Conventionally, when viruses mutate, two viruses of beta coronavirus invades a cell and they exchange, their genomes. But this furin cleavage site is not seen in any beta coronavirus, which is makes it terribly infective to humans, because when the S1 component of the spike protein attaches itself to the ACE2 receptors, it needs to be cut off from the this thing for the S2 to attach itself to deliver the RNA genome, the virus genome into the cell. So this is the big mystery, and I think, and not only that, you see, the EcoHealth president had presented this to the DARPA, which DARPA is the defense authority in the US, in 2018, that they were able to do this for beta coronavirus. And the defense system in the US said this is too dangerous, and they rejected it. And then subsequently we're not saying that there is any telltale sign. The reason that in September 18, when the Chinese database disappeared from this thing, when the leak took place, we don't know what other viruses are there in the Chinese database. So that's something that we are concerned. So we have an authoritarian government which may have covered its track, and I'm not sure.
Praveen, my question is a little more vital. Looking at this small possibility of this virus coming from somewhere for human issues, that clearly indicates that we should be prepared for yet another calamity not too long after this. And our preparations, in fact, the whole world should be prepared for any possible epidemic or a pandemic like this in coming times. And our preparations in terms of vaccine preparation, preventions, and behavior pattern of society should be alerted for future to keep the growth of humanity on. That's my larger question.
Yeah.
You are right, Dr. Rungta. This is basically complicity of the WHO also with China from the beginning of this pandemic. So there has been no doubt this Ethiopian chief of WHO, all the time he was siding with China, not telling the world to stop flights from China. They knew everything. Now there is more evidence that they were buying these kits to test the RT-PCR equipment right from May 2019. So the data is much more than what meets the eye. And they have been dealing with this. And from China, you can never get any information. And WHO's complicity actually, and President Trump did the right thing to pull out from WHO on that, because WHO also kept the world in dark about this lab leak, whether it was deliberate. The only moot point is whether it's for deliberate or it was accidental. I think that is the only question which can never be answered, whether it was deliberate or, because even Fauci said that they told them not to do gain of function research, but they went ahead and they did that. So, and you know, a lot of physicians disappeared who wanted to actually come out and bell the cat, and they were just made to disappear. So there is a whole lot of now indirect evidence. And recently on this WION, there is a journalist, Palki Upadhyay. She actually gave all this, that why so much equipment was being purchased by China, and their labs basically building up the capacity well in advance, and they came out with vaccine ahead of everybody else. How? Why? So I think there are a whole lot of questions. There is no doubt that it was a lab-made virus. Our scientists from Delhi University and IIT Delhi said it 2020 February, this thing, and the Fauci actually discarded those observations when they said this is not a natural virus. So I think there is a whole lot of the smoke is not without fire. So and a lot of defense people believe that it is a bio-war, and it is bio-war. There is no doubt that they are sitting pretty because they are authoritarian regime. They can control everybody, they can jail everybody, they can kill everybody who got infected. So I think there is a whole lot of explaining China has to do, to whom we don't know. That's why there is a mistrust. Their vaccines are not working the way other vaccines are working. So the whole lot of explaining they have to do, but they will not explain. We know that might is right in this whole world. And even USA could not put enough pressure on them to come out clean on this and at least accept their mistake. And they will never do that. So I think, as you rightly said, we have to be more alert, more cautious on bio-war in future. And one can see now, one can gauge the magnitude, what this bio-war can do to the whole world. They just made the world stop from all accounts. No travel, no movement, nothing. World was at a standstill for 18 months. So I think that is something which we all have to keep in mind. And China is a rogue country, there is no doubt. That's why there is no one today with them. Australia, Germany, everybody asks for compensation from them. At least some pinpricks can be given. If not, solutions will not come. Damage has already been done. But at least they'll be then not do this in future, this kind of a harm to the whole global community.
Thank you, sir. Thank you so much. Dr. Dipti, over to you.
So the next speaker is none other than Professor Shiv Sareen. And actually, Dr. Sareen, if he's there, he would be listening. Dr. Rungta, your coordinators made me director of ILBS in the morning.
Yes, sir. I apologize to you.
Did you notice that? I
yes,
was happy.
Sir. I had apologized.
No, I didn't mind. I didn't mind being director of ILBS. Of course, Dr. Sareen is the founder of that. He's the architect of that Institute of Liver and Biliary Sciences, a close friend, a long-time friend from AIMS onwards, when he was at GB Pant, and then established this institution, which has become, and it has its own name, not only in India, but even at international level. And this is most sought for now institution for liver and biliary diseases under his leadership. And he is now the vice chancellor of that deemed university, or that's a university in our own right. And he has received Padam Shri, Padam Bhushan, Shanti Sarup Bhatnagar Award. And I think to say about him would be to show Diya in front of Suraj. So we would request Dr. Sareen to share some of his thoughts on COVID in patients with particularly liver disease. Shiv, please, we are all waiting to hear you.
Good morning. I bring greetings from the Institute of Liver and Biliary Sciences, New Delhi, a deemed to be liver university. I would like to profusely congratulate and thank Dr. Rungta for having organized this very big global meeting on COVID. I do hope all of us will learn, and it's a privilege to speak to my colleagues and friends across the world. I have no disclosures, except that our students are very bright. COVID and liver is a very interesting area. Many of you have ignored actually liver, and my job is to tell you, don't do that. COVID-19, a very well now understood by all biology and medicine people. A virus which has spike proteins, membrane proteins, glycoproteins, and nucleocapsid. And these have very well described structures now against which antibodies and different tests have come up. So COVID can affect a healthy liver or can affect a liver which has underlying chronic liver disease. The way COVID causes problems in the liver are because severe inflammatory response. Patient has moderate to severe COVID, has hypoxia, hypoxemia, and sepsis. It affects the liver as well. Then you give several drugs. They can cause liver injury. Every drug nearly is metabolized in the liver. Then there are microthrombi in the hepatic sinusoids. The diameter is only 12 to 15 micron. SARS-CoV-2, can it directly damage liver hepatocytes? Not clear, but yes, cholangiocytes it can. And there can be many other factors involved. So let's see, the virus has come into the lungs. From lungs, there is a cytopathic damage, the macrophages are there, hypoxia, venous congestion. Immune cells, they all will go finally by blood to the liver where there is a sinusoid. Now this sinusoid has these exposed CD8, CD4, NK cells lying in the liver. So whenever the next lot of cells or bacteria or viruses come, you have what is known as a bystander hepatitis. So the cells come from here, they stay here. Next time, let's say for influenza, let's say it is for COVID, the virus or its products or the cytokines, when they come next time to the liver, they cause injury. So one of the major mechanisms is a bystander hepatitis. You have high liver enzymes, you have increasing bilirubin. It occurs more if there is underlying chronic liver disease. Of course, there is some direct cell injury to several cells other than hepatocytes. So the liver damage in these patients is a result of many things. You have a high D dimer, you have coagulation disorders, you get cytokine storms, and these can add to the whole problem. Then there is a dysregulated hepatic liver lipid metabolism. They are dyslipidemic, and I'll come to it again. Then the fecal shedding continues for a long time, especially in those who are obese, diabetic, or immune compromised. So let's look at what happens to a healthy liver. Now, these are all studies which have occurred in healthy liver patients. Acute liver injury is seen in nearly 1/3 to half of the patients. But severe acute liver injury can also occur in a fair proportion of patients. So remember, high AST, ALT, bilirubin, SAP, gamma GT are not unexpected. This is to show you of the about 1800 patients in non-severe versus severe COVID. The SGOT or SGPT can be high in as many as 70% of the patients. You can have actually in many patients albumin levels which can go down in severe COVID, and bilirubin levels can also go up in these patients. So remember, liver injury is not uncommon. This actually occurs more in those who have diabetes and obesity. So remember, these patients can present to a physician like acute hepatitis. Oh, SGOT is 800, SGPT is 1500. What do you think of it? Well, if the levels are more than 400, my first reaction is that test for other viruses, because COVID can reactivate hepatitis B, HSV, herpes simplex, EBV, and other viruses. And we have to exclude hepatitis A and E. Please remember that general population in India has about 3% chronic liver disease, obesity related, diabetes related. So look for chronic liver disease. Look, severe drug-induced liver injury, either the medicines given for COVID or otherwise. So review them. Do CPK and rule out myositis, do LDH and INR. Stop hepatotoxic medications, correct hypoxia, hypotension, and on case-to-case basis, you have to do a liver biopsy, especially if chronic liver disease is considered. Let's now go into those who already have known chronic liver disease. So this could be fatty liver, non-alcoholic fatty liver disease, alcohol, or other diseases. So these are large studies from multi-center, multi-institution studies, where those who had liver disease or those who have fatty liver disease, both of them had a higher incidence of complications. However, relation with death was not there, but increased severity was seen in those who had high BMI, diabetes, COPD, and others. In this retrospective study, anybody who has a FIB4, which is a simple index of AST, platelet, and this is calculated with the assessment. If FIB4 is 2.67, means you have significant fibrosis. So general population, those who have a high FIB4 have increased mortality. Patients who have got underlying chronic liver disease express more ACE2 and TMPRSS2. Both are the COVID-19 receptor proteins. Let's look at this very important study. We say in COVID, you have a high comorbidity problem. Those who are above 60 or males or high BMI or comorbidities, they have higher risk of progressive disease. But one single thing, that is NAFLD, is equal to all. You know, 6.4 is odds ratio. If somebody has underlying fatty liver disease, this is worse than even your age and others. And this has been ignored by most societies and most countries. So remember it. In your emergency, if an obese with fatty liver disease comes with COVID, he is a high risk. Alcohol, nearly 2 times more risk of mortality. Unfortunately, during COVID, alcohol consumption increased, not realizing they have heard me or the policymakers, maybe they would have done better. Because alcohol also decreases your immunity. These are some of the studies. Alcoholic liver disease is an independent risk factor for death, 1.79 compared to 1. In North American study, it has gone up to 2.4 times. So if you have friends or patients who have alcoholic liver disease, then remember, care for them, look after them with priority. It is interesting to see data on hepatitis B and C. Hepatitis B can be flared by corona. And these infections, unfortunately, have not been recognized. But what is also not recognized is the role of tenofovir. Tenofovir is an antiviral given for hepatitis B. This drug is as effective as your remdesivir. It stops replication of SARS-CoV-2 by terminating RNA-dependent RNA polymerase of coronavirus. So tenofovir actually can protect your patients. So two things. One, those who never had hepatitis B treated have hepatitis B but no treatment. In them, it can be flared up. Those who are on treatment for hepatitis B by tenofovir are protected. Hepatitis C, similarly, those who were on sofosbuvir, it inhibits SARS-CoV-2 RNA-dependent RNA polymerase and better than remdesivir. So both B and C patients on treatment are safe. Drug-induced liver injury in COVID is very common, especially if you are giving lopinavir, ritonavir combinations. Remdesivir also can cause drug injury. So you can't give it to a patient who already has severe liver disease. Don't do that. And 1 in 3, 1 in 4 can have problems. Now, somebody has pre-existing liver disease. So this was a major study we conducted in Asia with 63 centers called EPCOLIS study. EPCOLIS means the Asian Pacific COVID liver injury spectrum study. What was found is cirrhotics are more predisposed. They get decompensated and have higher mortality. Let's look at this data. 408 patients, cirrhotics, compensated or decompensated. What was found that those patients of chronic liver disease without cirrhosis, but compared to them with cirrhosis, are having more severe disease. Decompensated, more severe disease. Incidence of injury means susceptibility. So those who already had cirrhosis are more susceptible. Then mortality. All of us as a medicine person know Child-Pugh score. Somebody who has ascites and high bilirubin or has low prothrombin time index, all of them come into CTP Child, Turcot, Pugh 9 or above. They have high 28-day mortality. 1 in 2 will die. On the other hand, if you have a compensated liver, you may survive well. This is another study to show you, this is another study to show you from Europe. Now, this European North American study known as COVID-HAP and COVID secure studies, cirrhosis studies, it shows that patients who have child Pugh A, B or C, those who have child C, they die much more. They have more invasive ventilation, ICU admissions and death. Overall mortality, those who have cirrhosis versus just chronic liver disease means F3, stage 3 or 4 fibrosis, cirrhotic patients have more mortality than just chronic liver disease patients. Can we do a scoring system? There are scoring systems for COVID pneumonia, for severe COVID, WHO scores, for other COVID disease scores. But for liver disease and severe COVID, there are no scores. So we developed one score, and that score is an EPCOLIS score. Now, 1,000 patients, of those 260 were cirrhosis, those who survived versus those who did not. And we found the predictor models. These were all on the univariate analysis, mortality relations. And based on this, we were able to say platelet count, comorbidities, respiratory failure, acute kidney injury, and development of HE are major players in this. So the EPCOLIS score is based, its score is about 10. It will give you, it is easily calculable, and you can find higher the score, more the patient mortality is. So if the score is 51 to 60, mortality is high. Okay. And this scores better than your other liver disease scores like CTP, MELD, or a reference line. So this is your EPCOLIS score, and it performs much better than the child or the model for end-stage liver disease score. Those who have a score of 30 or above, those patients have higher mortality compared to those who have a lower score. So Epcolis score is the first ever liver-specific model, and it is related to respiratory failure, which reflects in liver, renal failure. A liver-related part is platelet and development of HE, and patient-related is comorbidity. And it has a very high area under the curve, high sensitivity and specificity is there. Then comes a group of patients who have got liver transplants. In India, now every city, every hospital has such patients. So this data comes from Spain, and liver transplant patients were taken, compared them to the general population, and it was found that severe COVID in transplant patients can have increased morbidity, especially if the patient was taking drug like mycophenolate. So remember one thing, mycophenolate has to be removed. These are several studies based on liver transplant patients, and mortality in some studies it is same, in some studies it is higher than the general population. Overall, 1 in 5 or 1 in 6 have got death. But one thing is clear, that MMF or mycophenolate is not to be used. On the other hand, drugs like tacrolimus can be used comfortably. In fact, they can benefit. This is also a large registry where liver injury in the liver transplant recipients was shown. I'll not go into details, but if the patient is on immunosuppressant, he actually may have lower risk, because what do you do in COVID? You give steroids. And if your patient is already on steroids, then the liver injury might be lower. However, in severe COVID, then you have a severe liver injury, which is about 1 in 10 patients. What are the predictors of injury in transplant patients? Younger transplanted guy, metabolic syndrome, vasopressor, antibiotic, and as I said, mycophenolate. Now, what are our options in the liver disease? I do not have time, but just to tell you, and this is a rather old published study from our group, liver disease patients, mildly symptomatic, well, you can give sofosbuvir. Hepatitis C drug can be given. To me, it is safer than giving any other drug. In moderate liver disease and COVID, moderate COVID and liver disease, our choice is convalescent plasma in decompensated and dexamethasone plus minus remdesivir. In severe COVID and liver disease patients, we would rather go for plasma and dexamethasone. I know there are some challenges with plasma, but we have used it extensively. We have papers which have gone through. So our choice, it is safer, it is better than giving remdesivir. In occasional patients, you can use that. And in critical patients, I think it is tailor-made for them. Your best teacher is your last mistake. I would like to emphasize, don't be careless. Continue to follow COVID-appropriate behavior till 2022 end. In summary, and a carry-home message for all my colleagues across the world, liver injury should not be ignored, and it is proportional to the severity of COVID-19 infection in the individual. COVID can precipitate liver failure. You have to exclude other causes of liver failure like hepatitis A or E. Remember, COVID can actually reactivate several viruses. Then the liver failure can be acute liver failure. We had 3 patients with COVID who came with ALF, but we couldn't do transplant because the donors were also infected. Acute on chronic means underlying chronic liver disease, it is precipitated, comes as jaundice, deep bilirubin, high bilirubin. Remember, every obese, diabetic, and NAFLD has a higher and worse outcome with COVID. Our study Epcolis shows patients with cirrhosis and comorbidity get severe COVID and poor outcome. You can manage as anybody else Those on therapy with B and C to continue. I forgot to touch in detail liver cancer patients. They can be treated as others without delay in their tumor behavior and tumor treatment. Autoimmune hepatitis, do not decrease the dose of steroids. Continue with the same dosage of steroids as before. Avoid azathioprine. Post-liver transplant, COVID outcomes can be variable. Depends upon if the patient is on steroid or mycophenolate, which has to be withdrawn. Tacrolimus can be beneficial. That is the message, that you refine your immunosuppressant. All patients with chronic liver disease or with obesity or NAFLD should get vaccinated, whether you are transplanted or no transplanted. I think we have to remember prevention and prophylaxis are still the best methods. We need to be careful in autoimmune hepatitis while we are giving vaccine. Several patients I have observed, those who are autoimmune, after giving vaccination, they got very severe fever because it is immune restitution. He was on steroids, but the moment you give COVID vaccine, it is an immune restitution, flare can occur. So such patients who are on autoimmune hepatitis, vaccination must be monitored. Other than that, every other patient, you can comfortably give vaccine. I hope that we have this COVID pandemic down and out in 2022. My compliments to Dr. Narendra Rungta and his entire team for holding such an important World Congress, maybe the first ever. Thank you for inviting.
नरेंद्र जी, डॉक्टर सरीन उपस्थित है क्या?
I'm there.
Dr. Sareen is there. Dr. Sareen, this
हाँ
is
जी,
Narendra Rungta.
मैंने कहा शिव जी के दर्शन कर लिए जाएं सुबह ही सुबह।
Thank you.
मैंने कहा शिव
Thank
जी
you.
के बहुत आवश्यक है।
Thank you, Dr. Mishra.
एक प्रश्न है शिव, बहुत अच्छा आपने बताया सब लिवर डिजीज और कोविड के विषय में। ये कोमॉर्बिडिटीज बाकी डायबिटीज है या लिवर डिजीज के साथ किडनी डिजीज भी है, इंडिपेंडेंट लिवर डिजीज एंड कोविड, इनमें कोई अंतर था क्या आउटकम्स में? जिसमें लंग नहीं इन्वॉल्व हुआ, लिवर डिजीज के साथ कोविड हुआ, माइल्ड कोविड हुआ, उनमें क्या कुछ फर्क था?
Comorbidities के लिए, this is important that we know 1/3 of the world, including India, has a fatty liver. There are two aspects. Those who have fatty liver have more severe COVID. Two, the vaccine is less effective. If a person has both lung multisystem with liver involvement, the disease is more severe. All high D-dimer, all coagulation anomalies come from liver. Coagulation factors come from liver. So your question that specifically liver is involved without lung involvement, that is less common. People have cholecystitis, people have gallbladder gangrene and others. But other than that, pure liver failure without having lung involvement is rare.
No, there were reports, case reports, where they detected coronavirus in bile, in peritoneal fluid, in biopsies. They have seen the virus. So naturally, it like any other virus. And do you see some pattern in common influenza also at times, or what has been your experience with common influenza or influenza, what we say, and liver disease?
The important part, the bystander concept is extremely important, as if you are going on a road, suddenly something falls. So bystander means sometimes influenza came, involves the lung macrophages. Now these macrophages, now they are hiding in the liver. Next time they get influenza, lung is injured, simultaneously liver is injured. This is bystander because the viral proteins go and affect both liver as well as the lung simultaneously. So same occurs in corona. First time you get lung injury, but in 24 to 48 hours, your liver has all those immune cells. So the next wave of viral production affects both. And therefore, 1 in 2 may have high liver enzymes. And if the COVID is severe, you get severe liver injury.
Thank you very much. So how were there any patients like they went for liver transplant and then they were diagnosed as COVID subsequently?
This is very interesting. Patient for acute liver failure was to be taken up for transplant, and we had done both the donor and the recipient in last 24 hours. Both were negative. When finally the patient was on the table, a repeat second COVID test was done, and it was found that the donor was positive. So it was a challenge. Fortunately, the recipient and donor were not opened up. It so happened that from somewhere the virus had come, the whole team had to be stopped. First is that doing transplant at that time was challenge, although we still did about 100 transplants during COVID. Now, somebody who has COVID and liver failure and has come. So if we know that somebody has liver failure and COVID, can a transplant be done? Yes, maybe 2 patients were done. The whole team had prepared very well, hepatologists, surgeons, anesthetists. 2 transplants were done. Both patients came out well. So as long as the COVID is there and it is not a cause of liver failure, let us say hepatitis A, and then there is COVID infection, it's okay. But if you have no hepatitis A and severe COVID, and COVID is the cause of liver failure, transplant is not indicated. Something else is the cause of liver failure, drugs, autoimmune, Giloy or whatever, then COVID as an additional thing, you can do transplant, no problem.
So the patient whom you say that they were not opened up, so the surgery was abandoned at
Yes,
that point of time. I think
yes,
that's a huge lesson, Dr. Narendra Ongta, for everyone to realize. This is very, very important that once you have had that diagnosis before putting the knife in, because once you put the knife in, then it's a difficult issue, decision making. But I think this is what I say, the retrieval or retracting from that. I always tell people, if there is a problem, even if patient is on the table, you can take the patient out of operation theater if such problems. This is of course related to COVID, but I otherwise also say intubation problem, some other problem, ECG is showing some changes. No, it should not be hurried to do the patient aa gaya hai OT mein to karna hi hai jaise taise usko. That should not be the philosophy. It's a huge lesson for everyone, Dr. Shiv Sareen. Thank you so much, Dr. Narendra Ongta.
Thank you, Dr. Shiv Sareen, sir. And I'm recalling 50 years back, I had looked at you and came to you to file your nomination for Vice Presidentship of Union of Medical Students Union of SMS Medical College. If you can recall, I'm sure you may recall or you may not recall, but what I want to say, we continue to look at you even after 50 years for wisdom, for guidance, for teaching, for views, opinions. So that is the kind of stature you have held for good 50 years, sir. Thank you so much for being here, enlightening our delegates, us, about the very important topic you have elaborated on. Thank you so much, sir. And one last question. Remdesivir sometimes is very difficult to get, and you had been mentioning the role of tenofovir. Can we substitute remdesivir with tenofovir if remdesivir is not available? Should next wave break out?
Clearly, sofosbuvir, it is published Sofosbuvir acts with same speed, much more safer. Even if the patient has no hepatitis C, you can give sofosbuvir. Tenofovir may not be, because sometimes it can increase CPK and can cause rhabdo, but SOF is 100% safe, can be given.
Sir, with your permission, can I ask one last question to Professor Sareen?
Yes.
Sir, there are some case reports and series from liver transplant centers that they found the severity of the disease is less in these patients post-transplant, especially when they are on immunosuppression. Do you have the similar experience, and what's your possible theory? It's related to immunosuppression, which is being used for these patients, or something else?
Yeah, thank you, Dr. Nasa. This is the same what I showed. If the patient is on immunosuppressant like steroids, the disease is milder and patients do not get hurt. If patient has mycophenolate, in addition to steroids, the injury is more. So stop mycophenolate. If patient is on tacrolimus, he is more protected. Fourth, if the patient is post-liver transplant in the first 3 months, and that is our experience, and he gets SARS-CoV-2, the disease is more severe because he is on multiple immunosuppressant. He is on the phase of reduction. However, post 3 months, if anybody gets, he is same or slightly more protected. I think the problems in what we faced in many of our patients were they were having obesity, they were having hypertension, thyroid problems, metabolic syndrome several years after transplant. So as a transplant, they were not bad. But as a post-transplant individual, they become very unsick. They had everything: hypertension, diabetes, obesity. Therefore, in them, the disease was worse. So to say that a post-transplant patient has higher morbidity is not correct. He is generally protected. And thank you for asking this important question.
Good morning, sir. Dr. Rungta, sir, and Dr. Mishra, sir, may I request one question from Dr. Sareen? I'm Dr. Dhruv Chaudhary here, sir.
Hello, Dhruv.
Yes, please go ahead.
Yeah, sir. Sir, my question to you is, which I had discussed sometime way back. What has been your experience or the reports regarding COVID in patients who are on anti-hep drugs, especially anti-hepatitis C drugs? Because a lot of people have used it, particularly in Iran, and then multiple trials are going on.
You're absolutely right. One more time, those who are on sofosbuvir, they are protected. Sofosbuvir has a strong antiviral property. It suppresses, like hepatitis C, the SARS-CoV-2 RNA-dependent RNA polymerase. So the replication of SARS-CoV-2 is markedly reduced. In fact, we have our own cell line here on the hepatoma cell lines and others. We were able to show that HCV replication goes down by nearly tenfold, very rapidly. So sofosbuvir is an effective, probably more than remdesivir for treating SARS-CoV-2. You can give it to liver and non-liver patients. So I have no doubt hepatitis C drug sofosbuvir is safe. One can use it without any difficulty.
Thank you, sir.
Thank you.
Thank you, Dr. Sareen. Thank you.
Thank you, Naren, and congrats to everyone.
Thank you.
Thank you for inviting me. And
Thank you so much, sir, for being with us.
Thank you.
मैं आपकी इजाजत चाहता हूँ.
Thank you so much, sir. Thank you.
Thank you, Malaji. Thank you, Narenji, for wonderful organization. Very
Thank you
meticulous.
so much, sir.
Thank you. Thank you so much.
Our pleasure, our honor, sir.
Thank you, everyone. With this, we conclude this highly informative session. Now, without any further delay, let us move on to the next round, the brainstorming round and table discussion. For that, I'd like to to introduce you all to Dr. Kushav Rajan, Consultant Physician and Intensivist, Department of Medicine and Critical Care, Hinduja Hospital, Mumbai. Sir, I'd like you to take on the panel. Thank you.
As sir is as sir is not available, so can you please introduce the panelist?
The panelists for today are Dr. R.K. Mani, Director of Clinical Services, Pulmonology and Critical Care, Yashoda Hospital, Ghaziabad, Dr. Farhad Kapadia, Consultant Physician and Intensivist, Hinduja Hospital, Mumbai, and Dr. Rupen Arya, Professor of Thrombosis and Hemostasis, Director, King Thrombosis Center. Thank you.
Dr. Kedar Tharaskar, Critical Care Specialist, Wokhart Hospital, Mumbai. Dr. Kiruna Piacevoli, Director Department and Anesthesia and Intensive Care, San Filippo Neri Hospital, Rome, Italy. Dr. Massimo Antonelli, Chair Department of Anesthesiology and Intensive Care Medicine, Catholic University of Rome.
So hello friends, I'm Dr. Kushav Rajan, Consultant Physician and Intensivist at Hinduja Hospital. It gives me immense pleasure to moderate the panel discussion on thrombosis in COVID for the World Conference on COVID and Critical Care. We fondly call it the W4C. And can I introduce the panelists now, please? So I have Dr. R.K. Mani, who's the Director, Clinical Services, Pulmonary and Critical Care, Yashoda Hospital, Ghaziabad. We have Farhad Kapadia, my very good colleague and mentor, from who's a consultant physician and intensivist from Hinduja Hospital, Mumbai. We have Dr. Rupen Arya, the Professor of Thrombosis and Hemostasis, Director, King's Thrombosis Center, and he's an authority in thrombosis. These two words go synonymous, Dr. Rupen and thrombosis. So we always go to him for any doubts and controversies. Dr. Kedar Tharaskar, again, a very, very dear friend and colleague, who's a critical care director at the Wokhart Hospital, Mumbai. Dr. Quirino and Dr. Massimo may try to join us from Italy, but because of time constraints and work constraints, they may not. So let us now begin with a little panel discussion on how COVID has been affected by thrombosis in the last nearly 2 years. So we all know, friends, that the COVID pandemic has been overwhelming for most of us. We have learned more and more what does not work rather than what works. Cloning, oxygenation, steroids, and low molecular weight heparin, which have been the mainstay in the management of COVID, are also fraught with controversies. Over the last few decades, thromboprophylaxis has been a norm rather than an exception practiced in the ICUs globally as part of the Fast Hug BID protocol. COVID has once again renewed our interest in thromboprophylaxis due to its increased association with thrombosis and its various forms that it affects our patients. The controversies of anticoagulation, such as its doses, the intermediate versus the prophylactic versus the therapeutic, the bleeding tendencies, the effectivity, its correlation with the D-dimers, and its effect on mortality are still ongoing. And I would request the panelists now to one by one and all of them together try to lay aside these controversies and give us some final words. So my first question, and anyone can feel free to start the discussion. So the first question would be, how common is COVID and thrombosis? What is the incidence that we have seen in data, and what is your real life experience on the incidence of thrombosis? So Dr. Rupen, you could start.
Thank you, Kushav, and thank you to the organizers for the kind invitation to join today. Because I think without any doubt, the burden of thrombosis in COVID-19 disease is extraordinary. I still think back to March 2020, when initially we were thinking that, yes, thrombosis is quite common in our critical care patients anyway, and that is this anything out of the ordinary? But I think there's no doubt it is extraordinary. And I think the figures published by my group last summer still remain quite representative, in that about 5% of all hospitalized patients with COVID-19 disease have evidence of venous thromboembolism. And in critical care, it depends how hard you look, because the early data indicated approximately about 30% seem to be getting venous thromboembolism despite the use of standard prophylaxis. Our own figure locally at King's in London is about 15-16%. So there's no doubt it's a very large figure, and it's 2 or 3 times what we are accustomed to seeing in critical care patients.
Would the panelists want to differ or agree, Dr. Mani, Farhad, and Siddharth?
The thrombosis despite prophylaxis is another aspect we must look at. Despite prophylaxis, maybe in highly thrombogenic conditions like a fracture neck femur or spinal fracture, maybe about 11%. And this seems to be a little higher with the COVID. Maybe it's 12-13%, pushing 12-13%. And one more thing I must say, that what are we talking about? Microthrombosis or macrothrombosis? Probably we are talking about macrothrombosis, because at autopsy we have a higher incidence of microthrombosis. Anyway, the pneumonia and the lung involvement has a much higher proportion of microthrombosis than met with in the usual ARDS. I don't know what's Dr. Arya's impression of these.
Thank you. My impression is that it's both, because again, this controversy came up very early on in the pandemic. But I think without any doubt, it is both large vessel and small vessel thrombosis. The autopsies, as you mentioned, there's microvascular thrombosis in all the organs in severely affected patients. And I think it is down to the pathogenesis of this so-called thromboinflammation or immunothrombosis, whereby, and again, I've never in my career seen such a thrombogenic infection. Now, as the host defense kicks in response to the SARS coronavirus infection, there's a huge inflammatory surge and cytokine release, and all the different elements of the clotting pathway are affected. And also there's endothelial dysfunction and endothelial damage. So ending up with microvascular thrombosis in that setting. But we know from our data and that of others, about 80-85% of the cases are venous thromboembolism and about 15% arterial thromboembolism. And again, particularly with the first wave, we saw a lot of in-hospital thrombosis with blocked renal circuits, as well as Lyme-related thrombosis. And equally, there's recent descriptions of Palmer digital vein thrombosis and chilblains. So I think it is both large vessel and small vessel thrombosis.
Even retinal artery thrombosis, etc. Yeah. So, Dr. Farhad, why do you think that despite thromboprophylaxis, there is a high risk? Is that something to do with the pathophysiology? And do you really believe in these numbers? Have you seen the same amount of thrombosis in COVID as slated in the literature? Farhad and Kedar wants.
I think this is a difficult question to answer, because the number you generate depends on how you look, right? And we've looked much harder in the COVID epidemic than we've ever looked elsewhere, right? So this is the first problem. So we generate a certain number, but we are comparing it to historical data, which probably was never generated in this degree and this degree of systematism, okay? I'll just give you 2 anecdotes. I don't normally like going by anecdotes. Anecdote number 1 was everyone was measuring D dimers in the beginning of the epidemic. And I got a call from a friend who's saying we're rushing to hospital because the D dimer is high and the doc said you got to get admitted right now. And I just asked for the routine test and the WBC wasn't 15,000. And the urine showed pus cells. And I said, just go home and take this. So this would not have happened in the era before COVID. So again, we have looked hard and maybe we've seen a difference, or maybe we found a difference which anyway was there and we didn't look. Another anecdote, again, as I apologize for anecdote, is many years ago, Dr. Agarwala from my institute wrote a paper on the post-op incidence of DVT when we switched to looking at it in Dopplers before we look at all this complicated. And what was surprising is there was a 3 to 5% incidence of pre-op DVT. Okay, so the harder you look, the more you find, right? So with that problem, I genuinely have no idea whether the COVID thing is more or it's more brought to our attention by the sheer magnitude of the epidemic or pandemic And the fact that we looked so much harder in everyone. I mean, we don't do D-dimers in UTI, we don't do D-dimers in dengue, we don't do DMIs in typhoid, but you do them and they're going to be high, right? So I accept it's a thrombogenic disease, but I think all sepsis is a thrombogenic disease. The second thing is that how often do we see this very, very severe ARDS which requires proning and, maybe 5 to 10 times a year. And here we're having 10 people in the hospital, right? So we are going to see more thrombogenic, and at least I don't have the mental agility to get these two numbers balancing in my mind. On one hand, we have this huge number of patients with a very large denominator and a very large numerator where we've actually looked. And on the other hand, we have got a scattered set of patients over years where we sort of half looked, half didn't look. And at least in Hinduja, though we are very sort of, you might call us a sort of high-tech hospital. And despite years of struggling, this is the first time we've screened everyone's veins when they got admitted, right? We've never even done that before. Every critically ill patient who got an echo and a Doppler in the first 6 hours. So obviously we're going to get more data. So while I don't doubt it might be higher, I am keeping an open mind as to, is the difference in numbers a collection factor or is the difference in numbers real? So that's thought number one. Thought number two is, as was said earlier in evolution, the thrombotic and the inflammatory pathways were the same. They sort of separated out a little later. And it's absolutely nothing surprising that if a person's got a high level of inflammation, then they will have a high level of thrombosis. Once again, is COVID more than the others or is COVID the same and we got different numbers? I can't say. With COVID, unfortunately, we don't have a way of eliminating the virus. So presumably the immune system has to go more in overdrive compared to, say, where you have a definitive therapy like artesunate in malaria or antibiotics in pneumonia. So maybe the trigger for thrombosis or thrombogenesis is going to last longer till the immune system itself clears the virus. So all these thoughts at the back of my mind make me think, yeah, it's a problem. We have to be aware of it. But right now, I don't want to quantify if it's a bigger problem than another disease, or we just weren't aware of the magnitude of the problem. And the last thing I want to say at this point is, what are we looking for? I mean, are we looking for clinical thrombosis? Are we looking for imaging thrombosis? Are we looking for D-dimers? Because again, what we are looking for and what we are treating will reflect in the way we report this thing. So if we look for clinically proven PEs, we'll get one number. If we look for CT proven PEs, we'll get another number. If we look for clinical DVTs, we'll get one number. If we look for clinical DVTs, we'll get another number. It's really, really at least hard in my mind to put everything together. So I just at this particular point say any COVID patient is at risk. I'm going to look for the standard clinical things. And as of now, I'm going to practice the standard clinical stuff. And as the literature evolves, I'll change my mind. That's really where I am today.
So, Kedar, just before I come to you, Dr. Krush, I had a nice discussion right in the beginning where we have mentioned through Dr. Rupen and Dr. Mani that yes, the incidence is huge. And Farhad has given it a little twist by analyzing data in great detail by saying that maybe we are looking for it too much, very hard, and therefore we are probably finding it much more than other diseases. I think both are very valid points and we need to strike a balance between that. Nevertheless, we know that it is very common. We are seeing it in day-to-day practice in COVID, and therefore we have to keep our awareness ready for looking for thrombosis. And nobody better than Kedar to talk about how does he screen his patients in the ICU for COVID using focus and throw some light about the smoky vessels that you always tell us about, Kedar. And all of y'all, I would like to ask y'all, how many arterial thrombosis have you also seen besides the pulmonary embolism and the venous DVT? So the known factors are about 5 to 10% at most for arterial. So that would be the other question. But before that, Kedar, on a little on focus and how the ultrasound can help us in picking up the hypercoagulable state in these COVID patients.
Yes, sir. Good morning to everyone. Piacevoli from Italy. Hello. Can you hear me? Screen the lung, that is lung ultrasound, and see the severity,
yes, sir.
severity score. And we also see the heart. So just echo screening, no dedicated echoes, but echo screening. And most importantly, we started screening the lower limb veins also. Now, what made us do this? When we were calibrating COVID-19 patients with ultrasound, we saw smoky echoes and spontaneous echo contrast in IJVs also, interventricular veins also. So that made us think that why not do a holistic screening like we do for any other focus protocol. And we started screening these. So whenever a patient comes to the ICU, we do this focused COVID-19 protocol. And surprisingly, we saw a lot of smoky echoes or spontaneous echo contrast, which we don't see in routine patients. So those are seen when we have slow flow or when we have a shock state or in some malignancies you can see those. But these were very commonly seen 60 to 65%. And we also saw the literature. So a few centers in the US have reported spontaneous echo contrast. And then we started doing thromboelastographs also. As I totally agree with what Dr. Farad says, it's very difficult to quantify. And since we are doing a lot of tests for these patients, which we would not routinely do for other illnesses, that's why we are picking up more things. But this number of spontaneous echo contrast was huge. But surprisingly, the proven DVTs were just 5 to 6%, whereas the spontaneous echo contrasts were much higher. And we started doing thromboelastographs in the last 10 months for these patients, ICU patients, and we found a hypercoagulable state. Platelet aggregation was high, and all the other parameters in TEG were prothrombotic. So that was really insightful. But the other thing was talking about arterial thrombosis. That is not as much as venous thrombosis, but we have seen peripheral vascular diseases. We have seen stroke, small vessel, large vessel strokes, and of course, more number of acute coronary syndromes in COVID patients who have been affected with active COVID. So focus was really interesting. I would like to ask Dr. Arya whether they are doing any studies on TEG along with thrombosis, or have they seen such a picture? And this is a huge number. So we are doing it since almost 13, 14 months now, and we have got consistent results about this.
Yeah, Kedar, before that, sorry, Dr. Arya. Kedar, you talk about smoky vessels in the echo. How many of them have gone on to develop DVT proven? Or all of these COVID have smoky vessels and then you don't do much about it. So does it make a clinical relevance, one? And two, TEG probably is not very easy to do in across India because it's not available, it's expensive. So we probably can definitely use focus if it helps us in management of these patients.
Yeah, so relevant question, Kushal. We used to anticoagulate them therapeutically. So we used to use initially the intermediate doses when studies were not available, or full doses therapeutic anticoagulation for these subset of patients. And for others, we used to use prophylactic dose. And maybe because we were using therapeutic doses for them, we didn't see a lot of thrombosis, all these patients developing a lot of thrombosis. The number is very, very less. I may say less than 1% for these patients who were on heparin. Maybe the bias was that we were already using a therapeutic or intermediate dose heparin for them. And we moved to TEG because D-dimer is not a standalone test. So it was not used in a proper manner. And initially when we started basing our anticoagulation decisions based on only D-dimer, we used to have a lot of bleeding in these patients. So we have formulated this protocol as to when we have smoky echoes with a prothrombotic TEG and a severe disease, we tend to err on the side of therapeutic anticoagulation. But now the adaptive trial results are so we have to rethink about these things.
We'll talk about that. Yeah. Anyone wants to comment so far on any of the discussion? Any rebuttals or any?
I tend to. Yeah, sorry.
Yes, Dr.
I tend to agree with Farad. We may be overestimating and extrapolating a great deal because we are looking harder, and I don't know whether the smoky findings can be interpreted directly as having the therapeutic implication of increasing the anticoagulation. I'm not sure about that at all. Because we may be on the one hand reducing the incidence of DVT, but increasing the incidence of bleeding. Now, the arterial thrombosis, I have not come across much, to be honest. Peripheral vessel, not any more than any other septic patient where you may have digital gangrene. We do see once in a while, not more frequently than that. But of course, COVID-associated coronary artery disease is common, and strokes are common, and we have seizures, sometimes not amounting to strokes, but we don't know what's the mechanism of that. We have no way of finding out. I think we could be overreacting in the therapeutic sense. No, I don't mean, it's one thing to talk about the incidence and pathophysiology and the propensity, but another thing to sort of translate that into therapeutic antibiotics.
So we are going to come to that in the second part. And I completely agree that we need to be aware of ourselves about the risk of thrombosis in our COVID patients, but not get overwhelmed at the same time and start using therapeutically. Kedar made a valid point that in those days when we were really not sure of what the guidelines were about prophylactic versus therapeutic, we all preferred to err on the side of little higher doses And therefore, many other tools like Focus did help us in looking at smoky vessels and then following them up on a daily or twice a day basis, right, Kedar? And if it increased, then probably you were knowing whether to how to react to that. Dr. Arya, one word, and then we move on to the management and other things.
Yeah. I'll just address that issue about using TEG and ROTEM to identify hypercoagulable state. There were a couple of studies from China right at the outset, which did demonstrate the typical fat kind of appearance of the trace consistent with global hypercoagulability, and which, confirms it's a hypercoagulable state. But I don't think it is being used to guide therapy, because I think we know if someone is severely affected enough to be on critical care, they are going to be hypercoagulable. So certainly we are not using it routinely.
Sure. Farhad, anything to add on?
Just again want to make a point. When we were medical students, we were taught pneumonia has 4 phases, and one phase was red hepatization and one phase was white hepatization. And red hepatization essentially was thrombosis. So again, this is really nothing new. Thrombosis occurs in inflamed areas. So I think we can't, I think what's changed from then till now is our ability to diagnose it. And what hasn't changed is our ability to ask the question, so what if it's there? Does it actually change the clinical outcome, or does intervention change the clinical outcome? Unfortunately, when we found an abnormality, our default position was to treat it rather than to sit back and say, what does this mean? Is it protective? Is it malprotective? Is it bad news? Is it good news? And part 1 and part 2 is, anticoagulation is not a low risk treatment, especially in critically ill. So does the risk benefit match up? So these are the things which have taken a long time to evolve. I don't really think we have much answers right now. Sure, we do have a fair amount of trials which are useful. So that's really all I want to say.
So when we talk about the incidence of thrombosis in COVID, we are actually predominantly talking of venous and arterial. We are talking of proven DVTs, pulmonary embolism, strokes, coronary artery disease, and then some other peripheral arterial disease.
I think you should differentiate clinically significant ones from picked up on this thing. That's really quite important, because that's where the difficulty comes in.
Sure. So all the studies are probably discussing the incidence of these 5-6 things which I mentioned. Nobody is talking about the microvascular or the microthrombi, which are probably adding to the pneumonias, the ARDS, which you mentioned, which was taught to us. So definitely there is a micro, as Dr. Mani said in the beginning, there is macro and there is micro. And what we are putting in literature is mainly the macro. Correct me if I'm wrong. Having said that, we also have enough studies saying that if patients of COVID had thrombosis, the mortality was much higher than those who did not have thrombosis. So yes, we know that clinically picking up thrombosis early would definitely change the picture and the outcome of the patient.
I don't agree with that statement. I don't agree with that statement. It might just be a marker of sickness.
We are not talking of D-dimer. We are talking of a proven DVT. So there are some studies, I can't quote as beautifully as you, but there is a 3-fold increase in the mortality in COVID patients without thrombosis versus COVID with thrombosis.
Sure, but that's true for tachycardia, that's true for oliguria, that's true for anything. Question remains, is it a marker of severity or is it a cause of mortality?
Okay. Anyone else wants to comment on that, or we take Farhad's word on...
No, I'm not saying you're right or wrong. I'm saying we can't comment on it. We shouldn't say that this is the only interpretation. Both interpretations are possible. That it's adding to mortality or it's a marker of mortality.
There was one study which said 13% mortality, earlier study again, 13% without thrombosis and 23% with thrombosis.
Perfect. So this has generated a good hypothesis. It needs to be tested in something.
Yeah. Okay. So we have to keep ourselves aware that thrombosis is on, and whether it increases the mortality is yet to be proven. I take your word. When would anyone can answer this? When in the ICU, a patient who is sick on a ventilator with ARDS, would you want to do a CTPA to just confirm pulmonary embolism? What would be your clinical markers? Because this is going to be reaching out to every strata of intensivists and physicians across the world. So, Kedar, when would you plan to do a CTPA in a patient who's already sick and on a ventilator?
So this is a difficult question because the practicality involved is that you can't shift these patients who are on ventilator or who are prone to the CT scan department. So practicality is very limited. But if you can do that, there are a few things in which if you have optimized treatment, you have some RARB dilatation, obviously pulmonary pressures which were not high, and the DVT screening is not showing anything, and you feel that there is a high probability of pulmonary embolism, and you have done most of the things right for your oxygenation apart from that, then obviously, yes, you can do a CTPA if the patient is fit enough to be shifted down. That's the time when you do it. And obviously, RARB dilatation can be because of ARDS. Around 15 to 20% of these patients may have acute pulmonary because of ARDS also. But obviously, DVT and PE are treatable risk factors. So if you feel that, yes, there is a strong degree of suspicion that this patient may be having embolism, then yes, whatever risk you can take and transport this patient to the CT scanner, you can do it. But conventionally, we do use the focus to a good effect. Of course, we have directed our anticoagulation decision, or in some patients when you had a McConnell sign and obviously we have a DVT, or you see a clot sitting in the RA or the IVC, obviously you can thrombolize these patients if they are hypotensive or they fit the bill for thrombolysis.
So basically an unexplained PF ratio which is worsening and unexplained hemodynamics would probably raise a strong suspicion. As we move on the discussion, we are going to get more and more controversial. Dr. Arya, you can start off with telling us the role of D-dimers, which is probably the most controversial in understanding just the severity and also understanding whether our treatment should be aimed at or targeted at the rising D-dimers and the dose of heparin along with it. We are coming to more questions and more controversies, but to begin with, let's start with D-dimer and you being the batsman for that.
Yeah, so elevated D-dimer is very, very fashionable in COVID circles, and right from the outset, because over half of the hospitalized patients have evidence of a coagulopathy, and they showed correlations with the inflammatory markers with IL-6 and CRP. So a lot of the early Chinese publications linked these very high D-dimers to the prognosis and a higher likelihood of transfer to critical care. And I think as a result, it got too overused. It got used in India, particularly in patients sat at home with mild COVID, who were being started on anticoagulants. It was used to escalate treatment in hospital and to decide on post-discharge anticoagulation. In fact, in some areas of the UK, we ran out of D-dimer kits because the early ISTH guidelines said measure the D-dimer daily. So I think that is all highly inappropriate. I think there's not very much evidence to support such widespread use of D-dimer. There are a few studies now, like the multi-platform DMAP-CAP active that definitely say in thousands of patients that it's not useful as a marker or to direct treatment. With some of the smaller RCTs, the ACTION study, anticoagulated people with high D-dimers hospitalized with COVID. And again, there's no benefit from anticoagulation. The rapid HEP study published this week says the opposite. But I think overall, there's no evidence for the use of D-dimer to guide treatment. My own view is that it's useful to check when the patient is admitted to hospital and, as one of many markers to establish the severity at the outset. And then maybe in critical care to be used on a daily or alternate daily basis. Again, as one bit of the jigsaw to help monitor progress. Because as was mentioned a short while ago, it can be used along with right ventricular strain and a sudden deterioration and an unexplained PF ratio to help reach a diagnosis of pulmonary embolism where you can't get the definitive diagnostic imaging. So really, I think we've far overdone it, particularly in India, and we should rationalize the use. There's no evidence for using it routinely to direct treatment or anticoagulation.
Very valid point, Dr. Rupin. It's not just one marker that we should ever look at. It is a composition of many factors, maybe an echo, the clinical condition, the marker, the severity, the PF ratio, etc. Dr. Kapadia, you might be remembering that initial days when the D-dimer went to 3-4, we were using a little higher dose of heparin, and now we have changed our practice because we learned more and more about it. So can we just write off the D-dimer, or we still do have a role? Any of you all can answer this. Yeah.
I don't think you should write it off, the question, unless your question is write it off as a trigger for therapy. I think clearly it should not be a isolated factor as a trigger for therapy. I mean, just like you don't treat tachycardia, marked tachycardia with a beta blocker, you don't treat a high D-dimer with heparin. You go to the underlying cause and let the underlying pathophysiology resolve itself.
Yeah, but initially we did increase our therapy.
Fair enough. I think we did that, and that was the best we could do at that time. But once the trials came out, we stopped both the enhanced dose and or the therapeutic dose.
Absolutely. So everyone agrees? Yes, Dr.
No,
Mani?
I want to say that we have strangely got into a sort of a reflexive response to these numbers now, as though we had never heard of this before. Now, D-dimer being very non-specific marker of thrombosis, we've always known. In fact, in acute pulmonary thrombosis in the ICU, we don't use D-dimer as a marker, as a very strong marker. But what had happened was in this concept of cytokine storm, as though it's very new to COVID, cytokine storm is what is critical care. Okay, in any critical situation, we have a cytokine storm. So there has been an overwhelming response to higher IL-6 and CRP and D-dimer and these composite values just to drive and scale up our response. Because you want to be seen to be doing something. Okay, you want to be giving immunomodulators. You want to give immunosuppressant doses of steroids. All these were extrapolations, and you scaled up the anticoagulation in the same way. But it didn't seem logical because targeting D-dimer for anticoagulation, I think it is fundamentally wrong. And they put an arbitrary figure of double the normal values, then you must scale it up. I mean, why? You give therapeutic anticoagulation only for significant thromboembolism, isn't it? Now, the question of how to identify pulmonary embolism in a critically ill patient has always been a problem. It is not in the context of COVID. We know our chances of picking up pulmonary thromboembolism ante-mortem, is only 30%. In the best of times. So we have to pull the antenna out as far as it can go. That's all right. And number two, you use ultrasound, compression ultrasound to exclude the 50% who, by identifying it, they won't go for CT pulmonary angiogram. Okay, you can save 50% of patients having genuine thromboembolism by using the compression ultrasound.
So Dr. Mani, something which we were using as a negative predictive value has now become a very positive titer in our practice because COVID has been an unknown devil and an evil, and we are learning along the way. So we are much wiser now about D-dimer.
We justified a much more looser application, loose response to these values than a thoughtful response. But in the face of a pandemic, you wanted to do something really.
Dr. Mani, I agree with you that there was an intervention bias. But the reality is we really didn't know at that point. We were just guessing. I don't think we were necessarily wrong. We were, in the absence of outcome data, we just had to go by some physiological principles. And I don't think what we did was necessarily wrong or right. It was a best guess at that time. And then the trials showed us whether our guess is right or wrong. I mean, in the beginning of the trials, I didn't treat the high IL-6, but after the trials came out, I was quite happy to use IL-6 blockers. So, I mean, you can't really know at the beginning of a pandemic which are going to turn out to the risk benefit will work out and which won't. So you got to just hope that you got it right.
No, we just wanted to keep it open rather than jump to a premature conclusion. That's what I mean.
More and more literature, yes, Dr. Mani. So now the main meat of the discussion, what dose of low molecular weight heparin would you use in these two groups of patients? One is the non-ICU hospitalized moderate COVID, and two, the ICU critically ill patient who is severe or critical COVID. And I know I am alluring to the NEJM article and the ASH guideline. So each one of you all, I would like your comments on that. Dr. Ruben, you can start.
Okay, so this is a topic close to my heart and it's very controversial. And we have frequent arguments in the so-called expert groups. Yeah, so basically, what is the right dose of low molecular weight heparin to use in the ward patients with about maybe 3 or 4% PE rates? And this raises, I think, for me, interesting questions about the natural history of the disease and really what anticoagulation achieves. Do we need to adjust anticoagulation to the degree of inflammation and the bleeding risk? And also, does heparin have effects? Does it have effects that are antiviral or anti-inflammatory? Because all of these things have been claimed. So the multi-platform studies indicate a 4.5% adjusted absolute improvement in the need for organ support and on survival. Again, to me, this is a very novel concept that these are so-called thromboprophylaxis studies, but they're not looking at thrombosis rates as the primary outcome. So we are looking at organ support free days. So the multi-platform studies were highly selective. Only 1 in 6 patients were recruited, and the control arm was decided by the caring physician. So the control arm could be intermediate dose low molecular weight heparin, for example, in the critical care patients. So I think the multi-platform studies have its limitations, and number needed to treat to reduce organ support is 25. Number needed to treat to improve survival is greater than 100. And then you have to trade that 4% against a major bleeding risk, which is significant, particularly in the elderly. So I think in the UK and in Europe and North America, it has created a lot of controversy because 2 recent RCTs have been published, small RCTs, one with 400 odd patients, showing that therapeutic anticoagulation reduces mortality and VTE and reduces bleeding rates, compared to standard anticoagulation, which is interesting result. So that was a rapid study published this week. And the HEP-COVID study showed a 20%.
Which group, the critically ill or the moderate or all across?
No, this is moderate. Moderate. So the HEP-COVID is 250 patients, 20% absolute risk reduction of major thrombosis and death. So I think it depends on how heroic you're feeling. The current ASH guidelines say use standard dose in moderately ill patients. The current NICE guidelines say consider therapeutic dose and coagulation. So it depends on how heroic you're feeling. But frankly, the idea of having wardfuls of COVID, moderately ill COVID patients all on therapeutic dose and coagulation terrifies me.
Kedar, what would you use for a moderately ill and a critically ill COVID? Or you don't care, you use the same?
After these trial results, maybe we are shifting to therapeutic dose in moderate and limiting to, but in the ICU, we still use an individual based approach. So we don't go by a blanket of prophylactic. If we feel that this patient has a high risk of thrombosis, like we have smoky echoes, the TEG is prothrombotic, then we definitely, and there is the VT bleed risk score is low, then we definitely are on the side of giving therapeutic doses even in critically ill patients. But after these studies, we again are having a very close look at how to go about it. It's still very confusing, but at least we have got some good data now with these trials coming up.
So we know that one size does not fit all, and we know that even in the ICU, the patient may be critically ill, but it could be something else, maybe secondary infection, maybe a fungal infection along with the COVID. So therefore, you need to individualize your choices of the doses. Dr. Mani, Dr. Parag on this, and then we just have 2 other questions and we sum up.
Yes, we saw that interesting concept of the moderate disease where we may use therapeutic doses, and in severe disease, it doesn't seem to confer a benefit. I have stuck to the usual standard prophylaxis for all, because I'm not convinced enough that you're going to use it on a large scale, therapeutic anticoagulant. I've never been convinced.
Sure. Farad?
I'm happy I'm not looking after moderate, because that's the one place I don't know what the correct thing to do is. So in a way, I was quite happy that the ICU trials at least said the standard is good enough. Okay, so that's the brief answer to your question. However, I would just like to go a little deeper, because what the COVID research has pointed out to me is I need to understand Bayesian analysis a little better because it's completely uninterpretable. I just have no idea how to go about reading those papers. So I have to presume that those people know exactly what they're saying and I take their word for it. That's not normally the way I read a paper. I generally have an idea of what the paper is trying to say. Having said that, even in our standard papers, we have for decades have settled for a p-value of 0.05 as it's a yes, no. And sometimes we forget the limitations of that. Keeping that in mind, I am more comfortable interpreting papers which look at frequency statistics, though I'm widely aware of their limitations. And I am absolutely struggling to understand what these Bayesian things mean. In the absence of a pre-decided cutoff, the author gets to choose the interpretation the author wants. And this is where I am, as of now, struggling with Bayesian analysis. So I am keeping an open mind where we go. I am saying I don't really understand the nitty-gritty of these papers. But for the moment, I feel that a standard dose prophylaxis is good enough for all ICU patients, and standard indications for therapeutic is good enough for all ICU patients. But I'd just like to take it one step further or one step behind, and I suspect people are not going to agree with me. I am unaware of any severity score in the ICU, which is used to predict PEs or DVTs. I am unaware of any bleeding score in the ICU patients, which is used to prevent bleeding risk for those you are going to anticoagulate, and unaware of any study which has shown that DVT prophylaxis actually changes clinical outcomes as against changing ultrasound-guided DVT. So while I continue to practice DVT prophylaxis and while I continue to recommend it, and we've just, for some years, we've been trying to submit a guidelines to ISCCM, and we've tried to do it a little differently rather than be dogmatic, and the editors and the peer reviewers keep throwing it back. But what we are trying to say is that in each of these guidelines is a degree of uncertainty. And we would like the guidelines to reflect that degree of uncertainty. And it's really hard work to get editors to agree with that because they seem to think that guidelines should be cookbook recipes for people who don't understand medicine or academics. I disagree with that approach. So to summarize, I don't know if DVT prophylaxis works in critically ill patients in terms of outcomes. I don't know how we actually choose them because we choose our criteria based on non-critically ill patients, both for thrombosis and for bleeding. But let's imagine that we are doing it right, okay, with all these limitations. Then we would continue to do the same with COVID, and we would probably stick to prophylactic dose with the understanding that I don't know what these Bayesian analysis actually means. So if someone can explain it in a better way or show something different, I'm willing to change my mind. Frankly, if I was looking after moderate patients, I'd have probably gone with full anticoagulation till something else came up. But luckily, I'm not in a position to make that decision because that I think is a significant intervention, which I don't have faith in. But the trials, ultimately, there's no point doing trials if you're not going to believe it. There's no point doing a trial if it gets the answer you want, you believe it. If it does get the answer you don't want, you don't believe it. So if you decide to go with the trials, then I would probably be using therapeutic anticoagulation in those who met the criteria in those particular trials till such time as something better came out. Yep, thanks.
Just to add to your this thing, Farhad, there is a score called as the SIC, which is called a sepsis-induced coagulopathy score, which takes platelets, PT, INR, and SOFA scoring system. And any score more than 4 is supposed to be higher thrombogenicity. And there is 1 or 2 papers, again, I'm not sure which one, but which did say that there is, if more than 4, then there is an increase in the risk of thrombosis and mortality. So it can be followed if we want to, which we do all the time. We look at the platelets, we look at the INR.
I want to clarify what I was saying. I was not saying there are no scores. I'm saying they're not validated in critically ill patients. That's what I was saying. There are lots of scores. And we have tried to find validation for each of these scores purely in a critically ill cohort and not found it yet.
Sure. There is a discrepancy between the moderate group and the severely ill group. So any comments about why this is happening from the panelists? Why does a higher dose not work in the more severely affected COVID patient?
Well, if you believe the theory that you got a chance to anticoagulate before the microthrombosis set in, I mean, that would be the most plausible explanation. And I mean, many things work in early and not late, right? I mean, there's nothing surprising about that. Antibiotics work earlier. There are many things which work early and many things which don't work early. So this could be one of them.
Any other? So I did a little reading in this, and the 3 limitations or the reasons they have given is, one is that definitely there are 2 different groups of populations. The REMAP cap is from UK and the other 2 studies are from USA and Brazil. And therefore the ethnicity and the population bias is different. Not a very important thing. Again, in the severely ill, as Farhad mentioned, they have lots of clots and lots of microcoagulation happening, and therefore a higher dose will not really work. It works better at a moderate dose. And then they actually brought out a very important point that nearly 20 to 50% of the patients who were in these three trials, the remap, the active and the other one, actually did not get the so-called prophylactic dose as prophylactic, the intermediate as intermediate, and the therapeutic as therapeutic. So there was a discrepancy between the UK, the US, and many other studies. So I think there is a thin margin between using intermediate and prophylactic, and that could be one of the reasons for this limitation or this conclusion. Just two quick questions and then we can sum up here. Anybody wants to, maybe Dr. Arya wants to talk about the extended prophylaxis and the duration of prophylaxis post-discharge in these patients?
Again, very briefly, we published a study last summer in, I think, 2,000-3,000 patients, and we found that post-discharge VT was not a significant problem in our population. And since then, the ACTION study, which gave 30 days of rivaroxaban, including after discharge, found no benefit. The core 19 registry did show a benefit, but my own belief is that there's not the evidence to support it for routine use. That is not to say that in selected high-risk patients, maybe with previous VT or with cancer, or who are particularly immobile with a low performance status at discharge, that we might still consider it, but routinely I would say no.
See, Kushal, I want to mention one thing. You know, if we are giving therapeutic anticoagulation for microthrombosis, I mean, the antecedent studies don't seem to suggest that. There have been studies on heparin, for this microthrombosis and ARDS, and also thrombolysis, and they've all routinely failed. And activated protein C, it's now relegated to history. So you see, there is no precedent of using anticoagulation for ARDS per se, where there's microthrombosis. So moderate disease may be associated with the classical indication for anticoagulation, but not to one who turns up with ARDS. That is what I think it is. That's what suggests to me that in microthrombosis it doesn't work. And there is no DIC either.
Yeah.
COVID is not associated with thrombosis, is not the DIC associated. So I don't see how it will work. It won't work for microthrombosis.
So the pathophysiology for COVID thrombosis is very different from just sepsis. It is supposed to be called as the COVID-associated coagulopathy, which is a mixture of DIC, sepsis-induced coagulopathy. They have come up with newer and newer terms called as pyroptosis, which includes the macrophages and whatnot. So probably we are still in the learning curve. Yeah, Farad, you were saying something?
I just want to add that a paper came out in JAMA, I think this week, saying that even in patients before hospitalization, anticoagulation doesn't work, with the caveat that they just gave up the study because no one was getting thrombotic in the first place. So they planned a large study and gave it up because of the low incident rates.
Yeah. You're talking of pre-hospital, huh, Farad?
Yeah. No, since we were post-hospital, I just added this.
This is Gene Corner's active 4B study.
Yeah.
And in fact, they had a very low incidence in the control arm.
In fact, pre-hospital, definitely it's an absolute no. Post-hospital, we are still not very sure of the duration, 2 weeks, 4 weeks. They recommend in the high-risk group, and therefore we may have to take a call individual based.
Let me ask the question in another way to the panelists. Which COVID patient would you continue to anticoagulation post-hospital, which you wouldn't in a non-COVID critically ill patient? What is special about COVID? Which indication is there? I mean, you have all these post-op patients who are immobilized or they have high risk. So when will you in COVID say, I'm going to continue anticoagulation, but in an identical post-pneumonia or a post-malaria or a post-pancreatitis, you wouldn't? I personally still feel that the standard indications for anticoagulation, which were there in the non-COVID, and there's no indication in COVID.
Agreed. I completely agree. The COVID exceptionalism must be put in the dustbin.
You see the difference
because we have overdone it.
A cytokine storm in a teacup.
Absolutely valid point. Yeah, it's storming all of us here. Farad, the problem here is that patients are on low molecular weight till they are hospitalized. And then do you suddenly stop it, or you do give them NOACs or whatever for 2 more weeks after discharge? So that's still an unanswered question.
My question to you is, what would you do in a non-COVID patient? That was my question to you.
Absolutely.
In a non-COVID, I would probably stop giving low molecular weight in the hospital once they are mobilized.
Yeah, but what if they're not mobilized when they're going home? What will you do?
That's a different bunch.
So that's pretty much the same you should do in COVID. At least that's my view.
Yeah, point taken. I agree.
So extended thromboprophylaxis is meaning it's a hyped up thing again. We should not. And
There are
if you
various
see the guidelines of different societies, it's still confusing. So ISHT, then NICE, then ASH, and the other guidelines, they are totally different in all the recommendations. So
personally, I think
sorry,
continue.
Yeah, yes, Kedar, you can continue.
So I said that's why extended thromboprophylaxis should not be given. Those patients in whom we were giving those, we landed up with big bleeds also, hematomas, and they had to come back. And now I think the guidelines clear-cut say that there is no evidence to it.
Absolutely.
Yeah.
I think we were struck with the deluge of guidelines. And it really was a problem because it just didn't have a scientific base. And as you said, different guidelines giving different things, giving different recommendations was a bit of a disaster. I think that what COVID has taught me is that being scientific is not good enough. You got to look at human nature also. You got to look at the way patients behave, doctors behave, your colleagues behave when they interpret science, because it's not, it would be lovely if everyone read the papers and followed everything. But, you know, we made our own guidelines and they made their own guidelines and someone said 3 and someone said 6. And we got stuck and we had to follow them to a large extent. So I think we had a problem with guidelines also.
I'm glad.
Believe it or not, believe it or not, science is subject to subjectivity.
And I'm very glad he just did say that, because in a pandemic, I think it's an evolution of guidelines and we learn more and more as it passes through. And therefore, what may have been true 6 months ago would not be true now. So yes, thanks Parag for being so open, despite deep diving into literature always. Just one very quick question, and then we can probably, I might take just 4 or 5 minutes to sum it up. Anybody wants to comment on the so-called existent VITT, which is vaccine-induced or associated thrombocytopenic thrombosis? Anyone?
VITT is real. For one thing, VITT is real, although rare. It is devastating when you encounter one. And this is, of course, immunopathologic, and you have a thrombocytopenia. Thrombocytopenic thrombosis should alert you to this possibility. And of course, the temporal relationship with the vaccine.
Right. So,
and you can treat it, of course, with IVIG, and the early detection is what is important, and it's both arterial and venous thrombosis.
So VITT is a very important thing to know, because we are encouraging vaccines obviously all world over. VITT occurs after a vaccine within 2 days to 28 days. The platelets first have to be less than 1.5 lakhs, so it is a thrombocytopenic thrombosis. And the next test to do would be a D-dimer here, which would be at least 4 or 5-fold if you do not have a platelet PF4 antibody ready with you. So if a PF4 is positive antibody, then you don't need a D-dimer. And the treatment is interesting. Obviously, you do not give any low molecular weight heparin here. You would have to give fondaparinux, or you might want to give NOACs here. Steroids indicated only if the platelets are less than 50,000. And plasma exchange only if the platelets are less than 20,000 and there is evidence of thrombosis. So VITT is an important concern, especially when patients come in with strokes and acute coronary syndromes within a month after taking the vaccine. And I think these are the steps that we need to undertake.
Could I ask a few questions about this syndrome, because I haven't really understood it? Is the inciting factor a PF factor 4 or is it something else? And in which case is heparin automatically contraindicated or not? Because I've not really got this part.
Dr. Arya has to answer this.
Yeah, so basically it's triggered by a complex between the PF4 and the vaccine. Again, we don't know what it is in the vaccine, but human or free virus proteins or the EDTA are thought to contribute to the immune response. And then there's a highly pathogenic antibody, which the platelets get activated and you get netosis, the so-called neutrophil extracellular traps, and it's highly prothrombotic. We've had in the UK, I think, amongst tens of millions of recipients of the adenovirus vaccines, we've had about 400 cases. I've looked after about 5. And they present with, about half of them present with a very hemorrhagic cerebral sinus thrombosis. 10% have normal platelet count at presentation. So it is pretty dicey. And our mortality was about 20%. in those 400 patients. And I'm sure it occurs all over the world because I've had emails from South Asia, various countries, with inquiries on managing them. But I think that doesn't answer your question, Farah, as to what it is in the vaccine that is triggering this response. But there's a nice paper from Andreas Greinacher, who first described it in blood in the past week, in which they've looked at it in a mouse model. And they found first 2 days, this so-called immunological danger signal. And then between days 5 and 14, this highly pathogenic antibody, which resembles the HIT antibody.
My question really, but just I really have a little blank about this. If it's not the heparin PF4 factor, but it's XPF4 factor, does the HIT test really prove or disprove it? And is heparin as dangerous as it's in HIT, or is it an association? Or that's my main question.
No, that's a good question. I think the chemoluminescence and the rapid utilizers do not pick up this antibody. You need to do, there's about 3 different platelet factor 4 utilizers that will detect the antibody. And so you need to do the right test, basically. What was the second part of the question?
If heparin is not the trigger, it's clearly contraindicated in HIT. Is it equally contraindicated in this if it's not the trigger?
Yeah, so I think that is a very good question, because there's no rationale then not to use the heparin.
Yes.
But there have been some small studies, one with case reports in giving heparin actually showed some benefit, and other one showed deterioration. And certainly I had my first case in January, whereas it was only formally described on the 20th of March. So those cases that we saw, I saw about 2 cases before the 20th of March, and we gave them heparin and they did not do well. But that could be just coincidental. But really, I agree, there's no rationale as such to withhold heparin, other than the fact that we are treating it like heparin-induced thrombocytopenia. But there's no scientific rationale.
So the postulate is about it being something like HIT, and therefore the PF4 is positive antibody, and also like an Apla syndrome where there is low platelets, but yet they are thrombogenic. So probably contraindicated, but we need more data on this. I think we are running short of time.
My point is that heparin is the trigger there.
Yeah.
Non-heparin factor is the trigger here. That is the thing I have to say.
Yeah, I agree. Yeah.
Very valid point, Farad. Yeah. I think we need more data on that. Thanks, guys. And I think this was a very, very fruitful discussion. One of the best I've had on thrombosis and COVID. And I wouldn't call this a panel discussion. I would probably call this a conference statement guidelines, because all 4 of you all have given us such inputs and such deep diving into data that it's really a learning thing for me today. And I'm sure very many people across the world would have benefited from all the amazing news that you all have bestowed upon this topic. So thank you one and all, and we sign off here. Thank you.
Thank you.
So this was a very fruitful discussion on thrombosis in COVID. And I thank all the panelists for giving us such an informative guidelines and their personal experience for the same. We know that from the beginning of COVID, we've had problems related with thrombosis. We had autopsy guidelines telling us the same, and so on and so forth. And now we know that we can use moderate in the moderately ill patients and intermediate dose, and in the severely ill, we still would go for the standard dose. Having said that, we have Dr. Mani and Dr. Kapadia joining us here, and the questions asked are more or less, one is to Dr. Mani, if we have time. Dr. Mani, when would you do a CTPA in diagnosing a pulmonary embolism?
That's a wonderful question. Of course, we know from past experience that even with those on thromboprophylaxis, there is a significant number of people on mechanical ventilation having pulmonary embolism. It may be as high as 2.6% or so. But in COVID, we expect this to be probably higher. So our index of suspicion has to be high. On the other hand, we can't subject everybody to CTPA since there are logistic problems and economic issues. And then, of course, the risk factors. Therefore, any unexplained fall in PF ratio or that which doesn't match with the X-ray findings, or if there are right heart strain patterns, on echocardiogram, when there's a sudden drop in BP and you have a right heart issue, of course, that is a very strong indicator. Or ECG changes, you have, of course, D-dimer is effective. D-dimer climbs up, and there is a troponin and BNP may also rise, is right heart strain. In those circumstances, in spite of thromboprophylaxis, you would think of PE, and you would do a compression ultrasound. If that shows DVT, then the matter is settled. If it does not show DVT, it does not mean that pulmonary embolism is excluded. So those are the cases which you would subject to CTPA. And pending, of course, doing this CTPA, one should fully anticoagulate. I think that would be my approach.
Yeah. So Dr. Mani, there are again 2 or 3 questions on pulmonary embolism, but I think that is straightforward. When would you lyse somebody? Obviously a massive pulmonary embolism, and sometimes in submassive depending upon the individual. So I think if we stick to the topic of COVID and thrombosis, how closely it is associated, we still need to know more data. And before we wrap up, because we are short of time, Dr. Kapadia, do you want to add any take-home messages?
Can I ask something, Kusha? Can I ask something, Kusha?
Yes,
This
Dr.
is Dr. Daga.
Yes. Please go ahead.
Such a wonderful presentation, and Farad, as usual, was up to the mark. I must compliment him for thinking out of box, and I fully agree. I think we got too much into data and all those triggers, but we have been seeing all those things earlier also with other diseases. My 2 quick questions were, Farad, I know we had deluge of data and all that, but we did find in certain category of these patients who were ventilated for long enough, for weeks on this, so there was something. I know that the virus trigger was still there. We were not able to clear the virus for long, but there was something definitely going on, the microthrombi and all that process, which was little much more in COVID. Maybe I'm wrong. And the second thing was about those arterial thrombosis and all that in CAD or stroke more. I don't think so. This we see in other population as well. And what I saw in a small study done post-COVID in following 30 patients with cardiac injury, there was a lot of myocarditis rather than significant coronary artery disease or something like that. So that's all I wanted to say. Thank you.
Yeah, Kusha. Sandeep here.
Yeah, 1 minute, Sandeep. Let Farad answer this, please. Yeah.
I agree with what you said.
So completely agreed, Dr. Daga. We need more evidence, and we are seeing a lot of thrombosis. But as Farad had mentioned in the panel discussion, we probably are keeping our eyes and mind open, and we are looking for it harder, and therefore we are probably seeing more. Yes, Sandeep,
right.
Please.
Yeah, Kushav, now that we started using Sputnik and we have already data from Covishield, what is the incidence of this TTS or this VITT in Indian population?
No, so the incidence, sorry, we have just a minute to wrap up and time's up. So yes, we still need more data of VITT being more common in each group of patients. But yes, we have got more reports from the Covishield vaccine and a little less from the Covaxin and the Sputnik. But I think the more usage that we would have, that would unveil these questions of yours. So thanks everyone. And it was really a learning experience for me from all the 4 panelists and all the audience. And I thank Dr. Rumta again for giving us the opportunity to discuss this very burning issue on COVID and thrombosis at the W4C. Congrats to all those people who have fought against COVID and saved so many lives, risking their own. And God bless and stay safe. Thank you.
Thank you so much, sir. We will now move on to our next table discussion and brainstorming session. For that, now I'd like to call upon Dr. Yatin Mehta, Chairman, Institute of Critical Care and Anesthesia, Medanta, the Medicity, Gurgaon. I request you, sir, to now introduce our panelists and take this discussion forward.
Can you please introduce the panelists as he's
Yes.
not have joined it?
The panelists for the session are Dr. R.K. Mani, Director Clinical Services, Pulmonology and Critical Care, Yashoda Hospital, Ghaziabad; Dr. Raman Sharma, Senior Professor, Department of Medicine, SMS Medical College, Jaipur; Dr. Ashit Hegde, Consultant in Medicine and Critical Care, PD Hinduja Hospital, Mumbai;
Unmute, ma'am, please. Unmute, ma'am.
Ma'am, your voice is not audible. Let me introduce Dr. Rajesh Pandey, Senior Director and HOD Critical Care Medicine Department, BLK Super Specialty Hospital, New Delhi; Dr. Banamba Ray, HOD Critical Care, Some Ultimate Medicare, Bhubaneswar; Dr. YP Singh, Director Critical Care, Max Healthcare.
Good morning, everybody. It's indeed a pleasure to be here. And we are going to have an interesting an hour or so on the long COVID or acute post-COVID syndrome or disease, whatever you name it as. And we have 4 panelists with us. We have Dr. R.K. Mani, the past president of Indian Society of Critical Care Medicine. Besides the critical care specialty, he's a pulmonologist and is director of the medical services and head of pulmonology at Yashoda Hospital. And everybody knows him in the ISCCM circle. Then we have Ashit Hegde, a dear friend of mine. He is head of the Department of Critical Care Medicine at Hinduja Hospital, again very active, written many guidelines. And then we have Dr. Raman Sharma. Yeah. He is a senior professor of medicine, internal medicine at SMS Medical College, an old renowned medical college. So pleasure to have him. And Dr. Rajesh Pandey, he is senior director of critical care medicine at BL Kapoor Hospital, New Delhi, also past vice chancellor of ISCCM. He is going to join us in a few minutes' time. The other panelists unfortunately could not join, so I'll throw the balls which were not meant to be meant for them. So I'm going to direct the other questions also besides what was already given to them. So I think post-COVID syndrome, now we have got over the 3rd wave, and we are now facing the heat of the acute post-COVID-19 syndrome, or long COVID as it is known. Many patients are getting readmitted. They take long time to recover from the symptoms. They last for months. So anything actually persistence of symptoms or appearance of new symptoms after the acute illness is over, 4 weeks after the illness is over, and it can continue beyond 12 weeks. So that depends on whether you call it subacute or you call it chronic COVID syndrome. And many of them take months and months to recover, to get back to work. They have chronic fatigue syndrome, they have muscle aches, lack of sleep, neurocognitive dysfunction, and virtually affects on any system of the body. I mean, it starts primarily with the respiratory symptoms. So they will remain dyspneic and short of breath, and cough can persist. Then they can have cardiovascular complications. We see a lot of these patients coming with new coronary artery disease and thrombotic events, thromboembolic phenomena, stroke, and neurologically there is neurocognitive dysfunction, lack of sleep, there's post-traumatic stress disorder, and persistent neurological dysfunction. It can affect basically endocrine system, where you can get new onset diabetes, with some of them presenting with diabetic ketoacidosis, hyperthyroidism. They also have thromboembolic peripheral complications. And virtually, as I said, any system can be affected. So I'll begin with Ashit. Ashit, can you just define what is this long COVID or post-COVID acute syndrome?
Well, until recently, there was no consensus. Each paper sort of defined it on its, in its own way. But the most popular definitions, like you said, until recently were what is acute post-COVID means the symptoms persisted beyond 4 weeks. and had no other explanation. So if it lasted beyond 4 to 12 weeks and there was no other explanation for the symptoms, then you called it acute, post-acute COVID. And if it lasted beyond 3 months, you called it long COVID. But that was until recently. But recently, actually, the WHO, at least just as recent as a week ago, they had a kind of a consensus meeting where they tried to get some kind of a consensus or definition of what constitutes a post-COVID syndrome. And I'll just, I'll read it out. It's too long for me to mug up. So they had a consensus definition where more than about 300 experts decided to have some kind of consensus. And they said post-COVID-19 condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months. So within 3 months from the onset, symptoms will last for at least 2 months and cannot be explained by an alternative diagnosis. And the common symptoms, of course, they agreed, and they said the symptoms may fluctuate or relapse or persist. So they may persist from the original symptoms, or they may relapse, or they may fluctuate. So this is what they. So basically, the symptoms should be present for more than 2 months and within 3 months of the diagnosis of COVID. That's what is the so-called most recent WHO definition of long COVID.
What is the incidence in various studies? And
again, see, the prime trouble is that again, obviously we don't know the denominator because clearly we are underestimating the numbers of patients affected with COVID. Obviously, any estimate of the total number of patients suffering from COVID is likely to be an underestimate because we really are not taking enough. We're getting missing. The denominator is bound to be much more than it is. Also, of course, the numerator also is likely to be low because we are not actively looking for post-COVID symptoms in everybody. So both the denominator and the numerator are going to change. But so probably we are overall, I think we are probably underestimating the numbers. But grossly, I mean, most studies seem to think that at 4 weeks, beyond 4 weeks, about 15% of patients continue to have symptoms beyond 4 weeks. And about half that number continue to have symptoms at about 3 months. And over time, that decreases to about 2 or 3%. So at 6 months, roughly 5 to 7% of patients continue to have symptoms. Now, it may not look like a big number, but if you look at 30 million or more affected in our country, 5 or 7% of 30 million is a large number of people getting post-COVID. That is a probably conservative estimate in the case.
And the problem in India is that we have very poor rehab facilities, pulmonary as well as musculoskeletal, very little home support.
Except for the metros, except for the metros, it's probably no other.
Yeah, so that's a problem in India. We are very good at looking after the acute care patients, but for chronic care, particularly rehab and at-home care, we are very poor at it. So that is another problem. What are the risk factors, Ashish?
Again, risk factors. Actually, it has been. I mean, this again, like I said, different studies show different things, but 3 things that clearly show the increases of long COVID. One is, females. Though males have more severe COVID, long COVID is more common in females. A higher BMI is supposed to be associated with more of long COVID. And one study showed that if you had more than 5 symptoms at onset, more than 5 symptoms, headache, say nausea, vomiting, whatever, any 5 symptoms at onset, they were strongly associated with long COVID. Of the, patients requiring admission, obviously you have more incidence of long COVID than patients who are managed at home. But once the patient is admitted, whether he is on oxygen or is on NIV or in the ICU, then the incidence of COVID doesn't mean that patients who are in the ICU tend to have more long COVID than patients who are just admitted on the floors. The incidence is more or less with respect to the severity of the illness. But patients who are admitted for COVID, maybe because they had more symptoms, tend to have more long COVID than patients who are at home. But the severity of the COVID does not really affect the incidence of long COVID. And of the comorbidities, and again, varying reports, most people seem to think, except for asthma, no other, diabetes, hypertension. Some studies say yes, some studies say no, that they're associated. And age, again, is a conflicting, report. Some reports say that the maximum incidence of, long COVID is between the age of 35 to 70. And some reports seem to suggest that the incidence increases with age. But probably, I hope from, what little experience I have, I think I would agree that maybe 40 to 55 is the incidence where it is the most. Maybe these are people who are active, who need to get out into society and probably feel, beyond a certain age, any case of life is restricted, you don't complain that much. But people who need to get back to work, they're the ones who are going to complain.
No, so purely from the socio-economic point of view, that is a matter of serious concern to us. Because 40 to 60,
to get back to work, that is a big
they take a long time to get back to normal functioning. So that is a major problem. Yeah, I'll get back to a bit later after that. But the problem is that the certain risk factors which are there for acute COVID are not there for the long COVID or this thing. So as you rightly pointed out, and there are no absolutes in this. I mean, young people can also get it, and severity of illness is also not really directly proportional to the incidence of long COVID. I mean, you may be mildly affected, or you may be even OPD patient, and you can still get it. I mean, it doesn't have to be a hospitalized patient. Coming to Dr. Mani, so Mani, you are basically from the respiratory point of view, what are normally the things which you see in these patients when they come back to you?
You see, I mostly see long COVID in the context of post-acute pneumonia. All right, it may be usually the hospitalized patients, if not the ICU patients. Those who have had bilateral pneumonia have had some form of respiratory support. Now, I do see a higher incidence of long COVID in them. With respect to respiratory symptoms, they do have persistence of sometimes persistence of fever, beyond 2 or 3 weeks, persistence of hypoxia, of course, beyond several weeks or months, and disability in the form of exertion dyspnea, hypoxia with effort, and vague chest pains, heaviness in the breathing, sometimes even wheezing. But I take care to find out if there is anything reversible in the form of sinusitis. I found frequent post-COVID sinusitis, which is often missed because we are just focused on the chest, and we keep treating with antibiotics or steroids. So I will come to it one by one. First thing I do is to exclude sinusitis. I find in at least 25% of them evidence of sinusitis. So that is reversed with the usual treatment for sinusitis: antibiotics, antihistaminics, and steroid. A small proportion may have undetected pulmonary emboli, and that should also be excluded. So what remains, if these two treatable things are not there, what remains is sometimes an organizing pneumonia, and number two, sometimes progressive fibrosis, or sometimes not a progressive one, a fibrosis which heals over time. So I think the ongoing fibrosis is a small minority. Majority are those that will either persist or remodel over time. And that is why one must not overuse medication. Of course, I do use steroids for persistent hypoxia, but merely for persistent shadowing on CT scan, one must not use steroid, I think. Nor is there a strong case for antifibrotics, because consensus is not in favor of antifibrotics. There are ongoing trials, we have to await the results. So the extrapolation that antifibrotics work for IPF and certain other systemic diseases with progressive fibrosis is not yet proven for COVID.
So if when you use steroids for these patients, if you see fibrotic changes on the CT scan, you would put them on steroids?
Not for fibrotic changes. I would put them on steroids for persistent shadows and hypoxia, because organizing pneumonia is real. That's been proven in autopsy studies. We know that apart from DADs, there is a proportion we have. Apart from the microthrombi and DADs, you have organizing pneumonia. And from previous experience with other viral pneumonias, some of them persist to have organizing pneumonia. It may be useful to do a lavage study, because a proportion of them may have aspergillosis, and of course mucor, fear is always there, or some persistent bacterial infection or TB. Now TB activation also I've seen in this milieu. So a lavage you take off, and if it does not show any infection, placing them on steroids on a presumptive diagnosis of organizing pneumonia is all right. Wherever you can do a biopsy, transbronchial biopsy is also one should do. In case
even the sinuses, you would like to do lavage and rule out the aspergillus and mucor?
I would do the sinus CT as well.
And how frequently will you assess them? And what are the tests you'll do from the pulmonary point of view?
From the pulmonary point of view, of course, resting SpO2 and 6-minute walk test to assess the disability, and PFT and diffusion studies are very important. Diffusion studies are also very useful to assess to monitor the progress. It's easy and less radiation risk. If you use DLCO as a part of the armamentarium, I use 6-minute walk test in DLCO very frequently. If it is stable or it is improving, then I would just allow nature to do the healing process, then interfere.
The saving grace is that most of them will not progress to fibrosis.
Yes.
Once the 2-3 months period is over, most of them will not progress. And that is where the question mark about the antifibrotics also comes in. It is a very empirical, unproven therapy. Okay. Thanks, Dr. Mani. Coming to Dr. Sharma. There is one question which was not earlier told to you, but I think one of the panelists has backed out, so I think you may address it. That what are the cardiovascular issues you face? And then we'll come to the kidneys also.
Yeah, cardiovascular manifestations are very, very important. And in April 2020, there was an article published in NEJM in which they analyzed 14 critically ill patients having bilateral pneumonia. So what they found was that 50% of them had atherosclerotic coronary artery disease, possibly accelerating, and 50% of them had myocardial injury. So it can cause myocardial injury, plus it can hasten the atherosclerotic process. So coronary artery disease is very, very important, though it's a risk factor as well, and a consequence also. And then cardiomyopathy, myocarditis, direct invasion of the muscles, that has been described, and that is very important. Of course, steroid-induced hypertension, diabetes, these are part of this post-COVID and post-COVID syndrome. So that is about the cardiovascular manifestations. And important thing is that there was initially a debate of whether to stop these drugs or not, because patient who already has an established coronary artery disease has to continue with all the medications which he's been prescribed. And after the discharge, he has to continue. So initially there was controversy about the ACE inhibitors or ARBs, whether to continue or not. But that has been solved now, and it has been emphasized that they have to continue with all these drugs.
And aspirin also, if the patient is already taking it, should continue. But just for prevention of cardiovascular disease, you do not need to add aspirin.
Yes, of course. That's very correct statement. That is very relevant. And even if the D dimer is elevated, there is no advocacy for use of aspirin antiplatelet in a person who does not suffer from coronary artery disease. Just having post-COVID illness doesn't mean that he has cardiovascular and he is not to be put on aspirin or antibiotic. This is the NIH guidelines these days, not even anticoagulation. And of course, pulmonary thromboembolism is very, very important. That covers both pulmonary as well as cardiac. And there is a lot of controversy about whether the D-dimer elevation indicates something, whether to continue with oral anticoagulation. These days, NIH guidelines, they have shown that there is no need of continuation of anticoagulation beyond the period of illness. So that is again, many of these prescriptions, they have anticoagulant, oral anticoagulants, they are being prescribed, but that's again a debatable issue. So how long do we continue? I think these markers, these inflammatory markers like D-dimer or other markers, they are not following any kinetics. We don't know what kinetics they follow. I have seen many patients having D-dimer elevated to 1,000 or more after 2 months or 3 months or 4 months. So really, are we going to determine the use of anticoagulation or antiplatelet on the basis of these D-dimers? We really don't know at this point of time. The pharmacokinetics is not understood of these markers. So that is very important. Should we continue or not? That is again debatable, but most of the guidelines which indicate that anticoagulation may not be required for a long term.
So that is correct. Today, actually, a JAMA paper has come out on oral anticoagulation. And they had 4 groups, 2 doses of Aliki, that is apixaban, and aspirin and control in outpatient patients, post-COVID outpatients, and they found no difference. So control also was comparable. In fact, it is lesser complications than the oral anticoagulation. So, I mean, that is questionable. If it is required for a particular pathology, that is different. But just to prevent coronary events, you do not give that. Also, if you have to, the patient has to undergo intervention. Unless it is a life-saving, particularly surgery, it is better to defer it by 2 to 3 months. That's normally the recommendation. Otherwise, they do not do well after surgery. And again, the saving grace is that the myocarditis or cardiomyopathy, whatever you call it, it generally improves over the next few months. So many young patients, the EF has fallen to 20% and they get back to normal.
Yeah, many these young patients have myocardial dysfunction. You are very rightly said that they improve within 2-3 months, and small doses of ACE inhibitors or ARBs may help.
Okay, I'm glad. I welcome Dr. Rajesh Pandey, joined in. I've already introduced you, Rajesh. I don't need to redo it again. Everybody knows you.
Sure, sir. Sure.
In this group. So, let's come to the neurological problems with this. What are the common illnesses or common complications you see in the nervous system?
So a lot of neuropsychiatric sequelae have been reported in post-COVID or COVID-19 survivors. The most common being, post-viral kind of a syndrome, chronic malaise, diffuse myalgia, depression, and then sleep disturbances. And the migraine-like headaches have also been noted quite frequently. And generally, they are refractory to the traditional management. And the late onset headaches, they've been found to be associated with high cytokine levels. And, these may persist, then loss of taste, loss of smell may persist for quite some time. So that has also been reported. Cognitive impairment is another thing that has been noted in those who had a prolonged COVID illness. So there's a term called brain fog, which is used where, they have difficulty in memory, concentration, fine functions, receptive language, etc. So those are the issues that are affected. And of course, whole range of psychiatric illnesses. So I think you have a separate question for that. Or should I continue?
No, continue. And let's come to the neurological events also.
Sure. So the psychiatric symptoms which have been noted, which may appear months after the initial infection, beginning of the infection, are generally PTSD, depression, anxiety, insomnia, then all these disorders are quite common, and the most common being significant depression and anxiety, which have been reported in almost 40% of the patients in the post-COVID period. And but this has been found to be similar to post-SARS illness also. So they say this is following severe other coronavirus infections as well. And even up to 6 months post follow-up, these anxiety, depression, sleep difficulties have been observed. So these are quite common. And PTSD, almost 30% of the patients will experience, especially what we found even when they were hospitalized, there was significant fear of death, among the people, especially in the second surge. So all these problems have been reported there in these patients.
And the stroke incidence also has increased substantially,
Yes, absolutely.
So I suppose this is the same as a thromboembolic phenomena, hypercoagulability, which you see. Probably
Yes. That's what Dr. Sharma was also referring to. We do not know how to react to D-dimer values and how long we should continue, whether we should continue or not this anticoagulation or thromboprophylaxis in the post-discharge period. That again is debatable.
And see, that means that the patient has headache or new neurological signs, you will have to rule out neurological event rather than before you go to a psychiatric diagnosis. No, you'll have to organic cause, you'll have to.
Absolutely, but generally it is recommended that, when they come for follow-up to a post-COVID clinic, then, they should have a neuropsychiatric evaluation as well if they have these symptoms. So that is generally part of it's a multidisciplinary approach in the post-COVID management.
And sleep disorders also common. So probably you need some help there also. No? These patients
yes,
have significant sleep disorders after the.
Yes. That is like in 40%, they are supposed to be quite common. So sleep disturbance, I think the bad memories of the time they spent more so in hospitalized patients, those who were hospitalized with severe COVID-19. Whether it has any relation to the cytokine levels or the biomarkers, we do not know. Late onset headache was found to be associated with high cytokine levels, but again, that's a conjecture maybe.
And even the stroke has been associated with higher cytokine as an inflammatory.
Yes. So that's the higher number of stroke patients that came in the post-COVID time, especially those who had undergone COVID-19 disease. That was common, possibly suggesting a thromboembolic nature of this stroke. So maybe these highly susceptible patients, there is a case for continuing for secondary stroke prophylaxis. So these are the situations where I do not know whether NOACs would be the best agents. Like you said, there was no difference among the different NOACs that were used. But we have to identify. It cannot be one therapy for all the patients who are post-COVID. But those who are highly susceptible, maybe we need to look at the secondary stroke prevention.
Okay. Actually, coming back to you, Dr. Hegde. Now, acute COVID is supposed to be a hypercoagulable state, hyperinflammatory, hypercoagulable, and everybody gives some sort of preventive drugs in these patients, particularly low molecular weight heparin. for these patients, long COVID or post-COVID, acute post-COVID syndrome, are they still remain hypercoagulable? And what sort of precautions you take? What sort of medication?
As everybody's already alluded to, so this is a controversial area. Nobody is really sure what to do. Clearly, I mean, at the moment, most recommendations but seem to suggest that you give you give prophylaxis only to patients who would have merited anyway otherwise also. Like basically, people who continue to remain immobile after recovery from COVID probably need some kind of prophylaxis, at least until they're mobile. Otherwise, obviously, if they had conventional risk factors like past history of DVT, the usual obesity, OC, all the standard risk factors, thrombophilic state, etc., obviously they're required. But for the other patients who have recovered from a COVID illness, no matter how severe, whether you need to continue thromboprophylaxis beyond and how long to continue is a debatable point. I think most people tend to prescribe Novax. Usually, Novax is the most convenient, prophylaxis after discharge for about 15 to 20 days for patients who have been in the ICU and have gone home. Beyond that, if they remain immobile, maybe you would continue, or if they have the conventional risk factors. Otherwise, probably at the moment, there's no recommendation to continue. Clearly, there are some patients who once in a way do develop, in spite of, and you feel guilty that you didn't give them prophylaxis. But then I think that number is quite low, and you really need to weigh that against a higher risk of bleeding in patients who didn't merit, prophylaxis. So I think at the moment, the recommendation would be, except if a patient is clearly immobile or has a risk factor, you probably don't need to continue beyond 2 to 3 weeks after discharge.
See, because unfortunately, I think Novax have been very extensively misused during this pandemic.
Now we have got the generic variants which are cheap also. So
all GPs have been prescribing Novax. Anecdotally, a close friend of mine, his brother discharged from the hospital after 10 days, came back with a massive bleed and died. He was on Novax. So I think one has to, if it is indicated for a particular illness which you would give otherwise, then you continue it. Otherwise, just for COVID-19, you do not post COVID-19, you do not need to continue on this thing. But I have a high degree of suspicion in your mind if they get any symptoms related to the prothrombotic state.
I think D-dimer has made things really, D-dimer is high in so many conditions. Test D-dimer before, so now we finally find out malaria, everybody is high D-dimer. So now everybody is getting anticoagulant prophylaxis for just because the D-dimer is high. That's something that.
So D-dimer is not really going to be the guide in these patients.
Predict the risk of.
Correct. Okay. Dr. Sharma, now coming back to you about the kidneys. What about acute kidney injury? How many patients will require dialysis? Would you like to comment on that?
Yeah, surely. Acute kidney injury itself is a poor prognostic marker at admission. This is one of the important criteria along with elevated cytokines. So it is very important. And there was a study, meta-analysis in which 13,000 patients were studied, and it was found that the incidence of AKI was 17% during hospital stay. And this is important because 50% of those who have been discharged at 28 days persisted to have azotemia. So that is important. So this comes under acute COVID as well as long COVID, or beyond 4 weeks. Now, there are certain risk factors which are associated with acute kidney injury in COVID. These risk factors are the old age, more than 65 years of age, male sex. Cytopenia is very important. So high levels of interleukin-6 have been associated with higher incidence of kidney injury, and the definition of kidney injury is the usual definition. And of course, patients who require vasopressor support, those who have hemodynamic changes already, then again, volume depletion. So these are other contributory factors. And besides the conventional risk factors like diabetes, hypertension, CAD, and all those things, CVA, etc. So patient requiring mechanical ventilation, patient on long-term vasopressor, they tend to have acute kidney injury. And one important thing which I would like to mention is that ATN, acute tubular necrosis, is very important. This is the most important pathological finding. However, some patients, minority, have a glomerular collapse also on histopathologically. And an area of concern is that recently there have been few reports after Moderna and Pfizer vaccine of glomerular involvement. So it could be autoimmune or something like that. So that is of concern, but it is seen only in a minority of patients. So cytokines levels, they are important in acute kidney injury. And as I told you, 50% may remain to have elevated urea creatinine at discharge. And how many of these may require chronic kidney replacement therapy? This is again, the figure varies from center to center. On an average, about 5% of these patients overall may require renal replacement therapy, and about 12 to 15% of those who are critically ill may require continuous renal replacement therapy. And of course, then if the patient has got sepsis during the hospitalization, that's an important factor. Volume depletion is another important factor. Patient is not taking any fluids by mouth prior to admission. That is an important risk contribution to acute kidney injury.
Rajesh, what are the endocrine manifestations of this disease?
The most common endocrine manifestations that we saw here was hyperglycemia. Whether that was purely an endocrine manifestation or that was because of the steroids that we were using. And most of these patients, because of high uncontrolled blood sugar levels, because the emphasis in the initial phase was not on controlling the blood sugar levels, which then in some susceptible patients led to development of mucormycosis also. So we saw the epidemic of mucormycosis also in these patients. So that is one that we have seen, and we have also seen some changes in those who are on anti-thyroid or thyroxine and other medication. We found that they needed to overall of the drugs that they were taking because the levels were fluctuating. And I'm aware about these two things. So
yeah, these are the two main manifestations. That's correct. Yeah. Hyperthyroidism can be precipitated, and diabetic ketoacidosis also has been reported
yes. In fact, many of the patients had a long-standing hyperglycemia problem, so possibly labeled as diabetics now post-COVID. So they had to have sugar control for prolonged period. So I'm sure other people like Ashit would have some idea because he deals with these patients.
One other comment.
Yeah, sure.
Yeah. After the pandemic of H1N1, there was a high incidence of subacute thyroiditis. And similarly, we have seen few cases of subacute thyroiditis. So that is viral induced, and of course, radio assays should be done to know whether the patient has persistent transient hyperthyroid phase. So that was my.
The other point I wanted to make was really about pituitary, and hypothalamic pituitary axis suppression. Quite sometimes, especially patients complain of severe fatigue. One possibly, not all, especially patients who receive prolonged course of steroids, they might have HP axis suppression. So not everybody, but some of the patients who have severe fatigue. Other than hypothyroid, you need to think about HP axis suppression and hypocortisolism, because it's an easily treatable cause. I'm not saying it's very common, but that's the other endocrine manifestation you need to think about in patients who complain of severe fatigue. Don't just dismiss it as post-COVID, especially if they receive long course of steroids.
Right. What about the gastrointestinal? What do you see normally in the patients? See, loss of taste, Rajesh has already mentioned, but I think they can have persistent malnutrition, which can continue from the COVID acute illness to post-COVID syndrome. Intestinal, I think motility can be decreased. They maybe have malabsorption syndrome. These problems can also be, and pancreatic dysfunction can make it probably worse, I think, the malnutrition. Any comments on that?
But fortunately, the gastrointestinal...
Anybody can talk.
Yeah. Gastrointestinal hepatobiliary sequelae have not been reported to that extent like others, neuropsychiatric, respiratory, or cardiovascular or kidney, those issues. And largely, like you said, nutrition would be an issue. But what we have seen during COVID time, the people were eating much more. So everybody, all the patients, they gained weight. In fact, during the illness, but those who were on steroids and other things, those who were severe, they had significant weakness, significant weight loss, and significant loss of muscle mass. So they had difficulty in walking, so you rightly said that they had significant, not only nutritional deficiency, but, it was like a critical care neuromyopathy. So they took a long time to recover. Even standing unsupported took a long time in these patients.
And particularly after use of steroids and antibiotics, antibiotic-associated colitis is an important mechanism where patient can persist to have diarrhea. So antibiotic-associated colitis due to Clostridium difficile should be considered in any patient having gastrointestinal upset.
No, Dr. Sharma, probably that may manifest in the acute COVID illness. It's unlikely to be at home, no? I think after
Excuse me, sir, I'm Dr. YP Singh.
By definition, C. diff could occur even after 3 months. Exposure to antibiotics in the last 3 months. So you can,
yeah, but generally we do not see it patients at home.
But this point is like
it's a nosocomial infection, basically.
No, it's nosocomial, but any patient who
may persist
in the last 3 months, so it doesn't necessarily have to
it
be.
may persist for a longer time.
It doesn't have to be while you're in hospital. You might go home.
I agree with that. No, I want to add that the type 1 diabetes incidence has also increased post-COVID.
Correct. Yeah.
It's not only the ketosis-prone type 2. I just wanted to throw that.
No, that is correct. Yeah, that's reported. Yeah. Also, see this anosmia and loss of taste, ageusia, which you get, that is also going to, make the malnutrition worse. I think,
Sure.
And muscle mass, as Rajesh rightly pointed out, like the muscle tone is reduced, the physical activity is reduced, and the quarantine and isolation do not make it any better. People stationary at home do not exercise as well as what you would be doing if you were going outdoors. So I think that can be a major concern. And the awareness of what exercise they should be doing and also, will be affected by what sort of myopathy they have and what sort of exertional dyspnea they get. That will all, I think, make it worse, these problems. Yeah. Okay. Now, that brings me to the, neuropsychiatric problems. Now, Rajesh, we have discussed that to some degree. Now, what are the additional problems? The neuropsychiatry, you talked about post-traumatic stress disorder, how common it is, and what should we be doing? Should we be giving anything to patients?
So these, like I said, almost 40-50% of patients will have depression, neuropsychiatric illness, PTSD, about 30% of the patients. Now, and headache, all these issues. So what is required is because the etiology, we understand very little about the etiology. So what has been thought is that there is a low level of chronic inflammation that is going on in the brain, which involves the parenchyma, vasculature, etc. So everything is involved. And it could be the result of the viral infection as such invading the brain. But largely when they come to the post-COVID clinic, possibly we need to use tools for screening anxiety, depression, PTSD, and other cognitive impairments. So the psychiatrist will have a major role there for evaluating these disorders there. So in the collaborative multidisciplinary post-COVID-19 or long COVID clinic, I think psychiatrists will have a very important role.
I think probably a multidisciplinary post-COVID clinic does make sense. I think that should be encouraged because multiple specialties are involved in taking care of these patients, which are ignored. I think we are very good with acute illness, as I said, but not when they come from.
By definition, it's a multi-system disease.
Yeah. So we already have here. I think all specialists are there in this. What percentage of patients get readmitted? I'm open to everybody now. Of post-COVID, long COVID or post-COVID.
The figure runs to around 10% of these need readmission, rehospitalization. And basically mechanism is again doubtful whether autoimmunity is playing a part or persistence of low-grade viremia is there. We really don't know that, or cytokine storm. What is going on, we really don't know.
So what are the symptoms? Normally, what symptoms they get admitted with or signs?
I think pulmonary is the most important one, and post-viral cough is the most important thing. Chest pain, this has already been described by Dr. Mani. So respiratory symptoms, I think, are the commonest, plus GI symptoms, and of course, cardiovascular dyspnea may be there, which may be due to a pulmonary origin rather than of cardiac origin, unless the patient is documented to have cardiomyopathy also.
Yatin, I want to say, yes, mostly they've been pulmonary patients. Okay, I would agree at a figure of 10%, it could be a little more. They return. All of them are RT-PCR negative. I must say the persistent viremia I did not find. What we found was it is genuine, aftermath of the illness. And they had persistent hypoxemia, a lot of them went back on a ventilator, and many of them had a prolonged course only towards death. And but some people have returned with seizures, neurological, talking neurological. Okay, there have been a higher incidence of strokes among them, but seizures are, I've seen more frequently than with other critical illness, return with a seizure. And we don't usually find anything much on investigation. On MR, we don't find anything different. Yes, we have also once or twice found hemorrhage. They could be related to prolonged anticoagulant therapy, which is injudicious, as we have discussed. A lot of them have injudicious prolonged anticoagulant and steroid or repeated course of antibiotic therapies. Yes, I think Mucor also has readmission. Okay, a lot of them return 6 weeks, 8 weeks later with Mucor to the ENT. They come via ENT. So some are iatrogenic, clearly, and some are, related to COVID aftermath in the presence of negative COVID report.
See,
sorry, if I may just add.
Yeah, please. Yeah.
If you see the most common, like Dr. Sharma explained, is respiratory, they would come that they are still requiring high amount of oxygen. They will complain of fatigue, decline in quality of life, muscle weakness, and pains, joint pains or other pains. These are in addition to the sleep disturbances or PTSD or anxiety, other things, inability to focus in their work. So these would be the most common things. It's not only they will come with one particular organ symptom. So it's like multiple kind of organs symptoms will be presented to the COVID clinic. Yeah.
See, the strokes and ACS has increased in these patients. I'm seeing quite a few of them.
Strokes have increased. Yeah, ACS is
increased. Yes.
Yeah.
And thromboembolism. Some of them with pulmonary embolism.
Of course,
the level of activity is low. Yeah. So pulmonary embolism also we are seeing much more than what
hair loss has also been reported.
Yes,
among those. Yeah. So that's being.
No, readmission. What triggers readmission are those things that we have mentioned.
Yes. Okay. Yes.
Yeah, dermatology hair loss is what has been reported.
Yeah. In addition to what Dr. Pandey has said, I think anxiety neurosis is very, very important. Neurocognitive disturbances. And coming to Dr. Mani's points, I think RT-PCR is not mandated for diagnosis of post-COVID. Even a mild illness can present with. So viremia may be there. Suppose a kidney sample is taken histopathologically. So that way they have seen something virus particles. So viremia does not mean that the virus is there in the throat. So RT-PCR at this point, post-COVID is not a prerequisite for the diagnosis of long COVID, or a severe illness should be there in diagnosis of post-COVID.
No, I'm sure Dr. Mani did not mean it for diagnosis of post-COVID syndrome.
Yeah.
No, I didn't say
just highlighting this important point.
No, I said there isn't any evidence in the form of RT-PCR, but they are post-COVID syndromes. For temporal relationship, they're very obvious.
See, at the moment, most of us.
I must also mention one case where I saw a lot of pyogenic abscesses on the skin, and it turned out to be aspergillus. Okay, he had a very difficult course. Bilateral pneumonia, very prolonged ventilatory therapy support, but we found aspergillus. What I'm saying is we could be missing many aspergillus infections. There was none in the lung. The lung was clear. It was cutaneous aspergillosis. So I'm sure, in all humility, I must say we must be missing quite a substantial number of treatable intercurrent fungal infections. And we may be missing certain treatable causes. Yeah.
So last but not the least, I welcome Dr. Benavar Ray. I requested him. It was not convenient for him at this time, but unfortunately the others, this was the best time for everybody. So thank you, Dr. Ray, for putting in the effort to join in. He was my senior in All India Institute long time back. So now, Dr. Ray, we have covered most of the aspects of post-COVID syndrome and acute long COVID. But now I think one question which I had originally meant for Dr. Mani, but I think both of you can share it, is that what are the socio-economic considerations in long COVID, and what are the ethical issues which you face?
Well, I think, yeah, okay. Thank you, Yakin. I actually joined late because I saw your message quite late while I was on my way to the hospital. Anyway, that doesn't matter. I think better late than never. Thank you very much for the introduction. The social effects of long COVID are enormous. We see a lot of issues that actually crop up in the society with the families. The son-in-law, daughters, the moment you are branded as COVID, they try to keep a distance. Keeping a distance is one thing, is fine, but that that emotional bondage is also affected, is something which hurts you the most, particularly if you are elderly like us. I think I have gone through that stage, but then I know that it is something which I haven't been able to reconcile to. But I'm sure, I think when I talk to a lot of people, they have the similar feelings, right? Today, the things are a bit better. A year ago, things were utterly worse. Today, I think they have understood the realities and they are trying to patch up what they haven't been able to do it. But certainly, this is one thing which I have seen myself and experienced myself. This is not to criticize anybody, because I see that happening with almost all families, right? And then once you are COVID, then even if you are free of the virus, even if it is months after it, and if you are a doctor particularly, I think the kids don't come near you. And they think that you are working in the hospital, you may be still a carrier, which is even worse. I think the relationship inside the family, if you are affected with COVID, certainly has taken a beating. This is one. And there is always a stigma. In my colony, when I stay, they always point out, here is a COVID patient, here was a COVID patient. So, that kind of a stigma that is really attached. Then the frontliners like us who have been working with the COVID patients, I think they are certainly looked upon as frontliners and very, very good work done. But in the society, people actually try to sort of distance themselves from you. You feel quite bad. You actually are in a very, very disadvantageous situation. And the doctors, nurses, I think they have a psychological breakdown. I interviewed some of these doctors for the intensive care, and they said that my parents and my wife have told us that if you are working in the COVID, don't go, don't join. So that is the kind of stigma that is attached to somebody who is in the COVID areas. And then we have also seen a lot of people having the psychological breakdown, and they have to be treated with the psychiatrist. And of course, they are fully around now, but this is what also has happened in the COVID situation. But I'm sure, I think as the days go by, the things are getting a little better, and that is a very welcome sign. So therefore, the social effects of COVID is enormous. Families have been broken. Societies have been divided, COVID, non-COVID. The houses have been earmarked. So I think all that really happens, and I'm sure all of us have the same experience in our neighborhood.
Dr. Bunny, you wanted to add something?
Yeah, I fully, I think I endorse what Panambar's experience has been. I think it's been, the toll has been enormous, the psychological toll of the society. It's not just the patients, his family also have suffered enormously. But the economic impact, I must address the economic impact. That's been huge. The public health impact has been huge. We know how many people got unemployed and how many people went below the poverty line. It's been estimated to be perhaps 30 million, at least, 30 million have gone below the poverty line. Additionally, we already had 40% below the poverty line. It has only increased post-COVID. And of course, the displacements. I have also seen families getting wiped out in the second wave. I have seen parents gone, only child left, or only siblings left, or entire family gone with just one person left. I've seen it with my own eyes. Young people, breadwinners, and the support from the elderly parents in their 30s have died. Okay, so the toll, the emotional toll, we really haven't measured, so we don't know. That's one aspect, the economic, social aspect. Now, I will come to another, which is the toll it has taken on the healthcare workers. Okay, we were short of hands, we were under threat. Our families were putting pressure on us to either quit or not go or change the line to much behind the front line. So this is there. The healthcare worker burnout and inclination to leave job has been high. So lastly, I must come to the dignity in death issue, which is also huge. Of course, we have come across in the news that people were floating in the Ganges, not out of volition, right? And we have also seen how many people have died absolutely alone, just surrounded by people in PPEs, families literally ostracizing them even during death. Okay, like Banambar mentioned. It is extremely painful. They had only their caregivers in attendance while dying. And they, as a ritual, they died on life support, medicalized death. So one extreme, dignity and good death on one side, this is one about the extreme other side, how badly one can die. Okay. And that comes to the question of how important is end-of-life care and the sensitivity to dignity in death and the quality of dying in death, which has been my subject of advocacy for a long time. And this has only got highlighted. And so we must accelerate our campaign for end-of-life care for two reasons. One is, lot of the people, particularly in long COVID and all that, they've gone through the mill. And it's proved to be futile in many people with a baseline frailty and baseline comorbidities, right? Huge comorbidity. They don't have a chance. But still, the family and themselves, they find themselves, and the caregivers find it obligatory to go on the ritual of piling on more and more. So less is more is a philosophy more relevant in our midst today, in the midst of pandemic, than ever before. It has always been. And surely this should change the way we look at critical care and, for a completeness of critical care in terms of compassionate care has to come to the fore again. So compassion has taken its toll, and then the appropriateness of care has to be revisited and actually seen to be done by the bedside. DNAR is extremely relevant for two reasons. One is most of them, only 5% will have any meaningful outcome of DNR, of CPR, okay? And then it also puts at risk the HCWs in their exposure to infection transmission and to the rest in the hospital, and higher risk of nosocomial COVID to other people, non-COVID patients in the hospital. So we have to revisit these and have a practical solution and SOP for DNAR and withdrawal withholding appropriately. We have enough time, particularly in long COVID, to discuss well and arrive at a reasonable, shared decision making. And therefore, it may improve your dignity of time, may improve the public trust, decrease your economic burdens, and improve the rationality, improve the availability of resources also. That also we faced. We ran short even of oxygen. Let's accept it was real in our midst.
So on that sad note, I think we had a pretty fruitful discussion, but long ignored the long COVID or post-COVID, acute post-COVID syndrome. So, and we covered as much as we could in 1 hour's time. I would like to thank all my panelists, Dr. Mani, Dr. Hegle, Dr. Sharma, Dr. Pandey, and Dr. Binambar Ray. Besides, I would like to thank the organizer of this meeting, World for COVID-19, particularly Dr. Rumta, Dr. Tyagi, and Dr. Diktimala for organizing it, meetings and more, for making it easy for us to record. Thank you very much.
Thank you, Yatin, for such a wonderful moderation. Thank you.
Thank you all.
Colleagues.
Thank you. Bye.
Thank you.
Good morning, everyone. I welcome you to the debate session of World Conference on COVID and Critical Care, for which the topic is separating COVID and regular ICU cannot be a viable option in long run in pandemic times. Our chairperson for the session is Dr. Prashant Kumar, Professor, Department of Anesthesiology and Critical Care, University of Health Science, Rohtak. Sir, I would request you to take the session forward. Thank you.
Namaskar, good morning, and welcome to this very important session. And for this important session, I have with me Dr. Banambar Ray, who's head of the Department of Critical Care, Some Ultimate Medicare, Bhubaneswar. And I also have with me Dr. Subal Dikshit, consultant and ICU in charge, Sanjeevan Hospital, Pune. So let's start. Namaskar, everyone. We have a very interesting and important session now, where I, Dr. Prashant Kumar, welcome you all to the session. And we have with us a session in which we are going to discuss about separating COVID and regular ICU cannot be a viable option in long run in pandemic times. And we have with us Dr. Banambar Ray, sir, head of the Department of Critical Care Medicine, Some Ultimate Medicare, Bhubaneswar, and Dr. Subal Dikshit, consultant and ICU in charge, Sanjeevan Hospital. With that, I request Dr. Ray, sir, to say about separating COVID and regular ICU.
Thank you, chairpersons, for inviting me to speak in favor of the motion. Separating a COVID and regular ICU is not a viable option during a pandemic. What we do, and we are still doing it, we opened up separate hospitals and with ICUs. ICUs became fortresses for people other than healthcare workers. Nobody was allowed, and nobody would be knowing what was happening in the ICU in COVID hospitals. People knew their wards are in and out, or some of them dead. Very little or no information in between. Families, acquaintances in non-COVID hospital are stressed because those who are working in other hospitals, in normal ICUs or normal hospitals, they would always be getting the information from the families that please find out what my patient is doing or how my patient is doing in the COVID hospitals, because they do not have any access. ICUs became completely inaccessible to the families. What happened to hospital staff? There was a reluctance to work in the COVID areas. Pressure from families to keep away from COVID duty. We have had doctors who would very squarely say that my father, my mother has specifically told me not to work in the COVID areas. If you have non-COVID areas, tell us. Otherwise, we will not come. There was inconvenience to work while wearing the personal protective equipment for 6 hours or even for 4 hours. If one would wear those and then it is so hot inside, there was a fear of getting infected even in spite of all that. Developing depressive psychosis, it was seen in quite a few of the healthcare professionals. Not meeting families for days together was a huge, huge issue. How are COVID hospital ICUs managed? Staffing was largely by people who had little or no experience in ICU management. Even IU's doctors, dentists, medical students, non-clinical doctors, anatomists, physiologists, untrained nurses managed ICU. Regular intensivists only at times take rounds, and that too virtually. Spacing between beds compromised, and the infections would nicely spread. Infection control measures and biomedical waste management was mismanaged. What happened to communication? System literally non-existent in the standalone COVID ICUs. Doctors and medical staff in regular hospitals became the via media to get information. Telephones, the only medium, would be unattended in the COVID hospitals. What happened to training? Very few trainers to train because they were all managed with untrained people, and trained people would not often get into those areas. Time constraint was a problem to overcome because there were so many patients that they would not have time to actually even look at the training aspects. Putting up systems in a new area was not easy. Record keeping was poor, is poor, and continues to be poor. Clinical auditing became sparse and almost non-existent. And there was no accountability in the name of a pandemic. Often we say that anything you could do in a pandemic, you are not accountable. Is it right? So what happened to patient care? Patient care suffered. Infections were almost universal. Cross consultations were infrequent because you get you give a consultation to XYZ consultant from across the disciplines, and they would hesitate to even go to those areas. Decisions, therefore, also were delayed, not only because of the cross-consultation issue, but also because the senior intensivist would not be available to take the decisions. Mortality increased. It could be a perceptual. You will never know whether mortality really increased because these figures will never be publicized even in the days to come. But perception is a reality. So therefore, we should go by it. What are the decisions to be taken in the ICU? When to use non-rebreathing mask or high flow nasal cannula? When to use non-invasive ventilation? How much trial of non-invasive methods that we should give? When to intubate? When to prone? When to institute renal replacement therapy? When to change antimicrobials? And when to institute extracorporeal membrane oxygenation, and many other small, big, medium decisions that also we need to take. What is happening in the regular ICUs during this time? The non-COVID patient flow was coming down. Surgical operations were less, routine cases had completely stopped, and emergency cases were being taken. The medical emergencies also, unless somebody was forced to come, they would not come. They cater to only post-COVID complications. Once they are RT-PCR negative, they would come, and then they would be there in the regular ICUs. There was a reluctance on the part of the staff to take COVID patients, even when few hospitals in the initial stages were allowed to take COVID patients. So that was it. Today, of course, a lot of hospitals are allowed to take COVID patients. Scenario at present, public awareness is maturing. People are not panicking as much. Situation of must admit has changed to can I avoid admission? Mild cases are treated at home. Majority of patients needing oxygen therapy are treated in isolation wards in the hospital, in a regular hospital. They do not need to come to the ICU. So there has been some rationalization for ICU admission that has come about. So what is the best way forward? Regular ICUs should manage critically ill COVID patients because personnel are proficient in most challenging situations. These patients are quite challenging, as all of us would agree, that some of them are so challenging they could have had any complications, and it is not easy to manage them in separate areas. And personnel would not hesitate to work in familiar areas, right? And because patients would be better attended in a regular ICU, and decisions would be quite timely in a regular ICU because there are trained people working there. Cross-consultation is not a big issue because the other consultants would not hesitate to come and see even if they have to come with PPEs. So issue still remains transmission of COVID-19 to other patients and healthcare workers if we treat patients in the regular ICU. So solution, treat these patients as isolation patients. Make ICUs, isolation ICUs. Complete ICU needs to be converted to isolation ICUs with the same staff. Make those negative pressure if it is possible, but it's not always possible. The air conditioned ducts should also be separate. That could be done. Staff rotation should be regularly done, and PPE should be used and staff are seen. However, compulsion nowadays that I see, they don't use PPEs. So scenario at present, all hospitals are allowed to take COVID patients. They are still being treated in makeshift ICUs. Regular ICU doctors are reluctant to work in COVID ICUs. Makeshift ICUs are not negative pressure, and laxity is very much seen in the use of PPEs in the ICU. So therefore, this scenario needs to change. And thank you very much for your kind attention.
Thank you so much, sir, for that insight. And now let us listen to Dr. Subal, what he has to say about COVID ICU.
See whether, thank you, Prashant, and thank you, Dr. Runta and Dr. Panambarri and the entire team for the World Congress of COVID Critical Care for inviting me to talk on this interesting debate with a very interesting topic also, that whether should COVID patients be separated from non-COVID patients. And I'm supposed to say that yes, and I'm supposed to defend that yes, they need to be separated out. We know that yes, COVID patients definitely are important. I personally am a strong believer, and what I've been practicing, yes, COVID patients really need to be separated out from non-COVID patients because yes, the infections, it is very virulent. The infections, it has got a very high reproducible index. It is an airborne infections and it can rapidly spread from droplet spread, and also there was also viabilities of spread which can also occur onto certain particles and certain stainless steel medium and patient to patient. Definitely the reproductive index of the SARS-CoV virus, the doubling time is almost about 6 to 7 days. Even in asymptomatic patients and mild patients, definitely there's a very high amount of virus shedding, and certain patients there is a prolonged amount of shedding, and that can also spread the infection not only into the whole ICUs but also into the whole of the hospital. And definitely the reproductive index of the R0 or the multiplication index definitely of COVID virus is much more than any other form of virus which you can see here. And typically, as I said, definitely as you compare it with influenza or SARS or MERS, definitely one patient can infect approximately about 4 to 4.9 patients. That is about 4 to 5 patients can get infected, almost twice as much as any other infections. Secondly, it's a new disease where all of us are not known exactly how the disease is really spreading, how fast it's rapidly spreading. I know that in the initial days, definitely everyone was scared, but definitely over a period of time, we have gathered certain amount of information, knowledge, experience, and confidence of handling. But definitely keeping it separated, much more viable one, because it helps to infection control. Infection control is very important aspect of it because it's a scientific approach. There are more practical solutions which occurs if you mix the patients as compared to keeping them separate, because you can have separate proper infection control techniques which are much more different in COVID as compared to what you really see into the non-COVID zone. Similarly, the patient safety, the healthcare worker safety, the relative safety, all can be taken into consideration. And therefore, this safety is really required for everyone. And as keeping it separated much more better, much more easier, because you protect yourself, you protect your patients, you protect the other patients. And apart from that, you also protect the families, the community, and also the environment of the hospitals. Because the main aim is not only to curtail the infections in pandemic, but also to avoid secondary infections, secondary spreads. There is also fear among all the other patients that who are coming in for non-COVID treatment that will I be infected in case if I get admitted with a patient who is getting admitted with the COVID patients who is admitted into the same areas. So therefore, safety of the patients and the relatives is very important in order to control the hospital work or the hospital burden, which is very, very important. You also have to not only look after the patients, you also need to look after the organization, the hospital, which is important. The risk of spread of infection also needs to be taken care under control. And therefore, we must have definite streamlined assessment, preparedness, plan, policies, developments, and we should participate into recoveries and monitoring systems, which will be very easy to have in an independent COVID area as compared to having a generalized area where we are going to keep a mix and match of patients. Similarly, the protocolized kind of management, every patient of sepsis may be different. Every patient in the ICU may be a surgical patient, there may be a certain ICUs which may be mixed, there may be renal patients, there may be other patients with post-bypass, post-plastic patients. Not all institutions patients have got separate separate ICUs like neurocritical care, renal care, post-operative surgical care, obstetric critical care. Certain hospitals have got a mixed ICUs where all mix and match patients are there, and it's very difficult to keep COVID patients into that kind of area. Therefore, patient monitoring, patient safety, all invasive procedures, chances of secondary infections, the anxiety which is also going to go up among the relatives as well as among the patients is going to go up. Education also can be is very important. As what said, you need to train all these staff, the paramedical staff, the nurses, the mamas, the maushis, all into COVID protocols, which is very important. Vis-a-vis, you don't need a PPE protocol which need to be followed into a non-COVID area as compared to a COVID area. The hand washing is common into both the areas, but the frequency of hand washing really needs to be done much more aggressively into COVID. The surface cleaning also needs to be done much more into COVID as compared to the non-COVID area. And therefore, general contact is, yes, you have to have separate ICUs, separate areas, separate wards, more frequent hand washing, more frequent education, more frequent monitoring of doffing and donning kind of technique, more frequent rigid monitoring of our staff, paramedical staff, nurses, the physiotherapists, who all are working. And therefore, infection control policies will be better implemented if you have got a separate zone as compared to mixing it with all other ICUs. It will also help you to triage. It will also help you to protocolize the treatment, because only one person or one intensivist will be in charge of the patient, and it will not be an open ICU. It will also help you to limit the chances of medical staff and consultants getting exposed to COVID. And similarly, it will also help the administration, not only from the medical supervision for implementation of protocol, and also for keeping good environmental as well as good amount of engineering control. Of course, all standard precautions can be taken. Risk assessment can also be done. Proper hygiene can be implemented. Also, at the same time, safe injection practices also can be implemented. And also, further injury prevention can also be taken care of. And the chain of transmission can also be cut if you have got a separate unit as compared to having all the patients who are kept into a mixed kind of unit where all medical, surgical, post-operative, post-bypass patients, post-plasty patients are also kept. This is a droplet spread of infections. Definitely breaking the link is not going to curtail it. You have to stop the spread of disease. You have to encourage more of respiratory hygiene, give masks to each and every patient who are there, who are coughing, sneezing, virtual aids. Risk assessment also needs to be done. Also, monitoring of the PP protocols with an independent infection control nurse, which will be much more better in a separate unit as compared to if you're keeping it in a mixed unit. It should be done from time to time. They need to be monitored. I know that it's definitely going to be cumbersome, but in order to ensure the safety of the staff, the nurses, the doctors, the physiotherapists, and other patients, and also to make the working atmosphere much more conducive. Safe injection practices, also waste disposals also can be much more better. Cleaning of the environment is also going to be much more better with hypochlorite solution, and proper sterilization techniques like the laundry, the food, the utensils, biomedical waste procedures will be important. Similarly, having separate units will help you to early identification, early triaging of the patients. You can separate these patients separately and therefore reduce the burden on the other healthcare workers and not compromise the treatment of other non-COVID patients who are coming in for non-COVID treatment. We definitely saw that definitely in the COVID areas that yes, there was a big amount of burden. The normal surgical procedures stopped, normal plastic stopped, and definitely all patients were being treated as COVID. But definitely to run it from the ergonomics and the economic point of view, having it separately, I know it's a burden to have a separate unit, but looking into the ergonomics and the economics of the hospital, definitely keeping it separately and having an independent unit which is running is much more viable option. Triaging also will be much more easier. It will avoid the spread of infection. It will help you to screen all patients, doctors, paramedical staff with thermometers, and improve the knowledge, safety. And at the same time, it will help you to ensure and not compromise the treatment for other patients. You can also have dedicated areas, do not disturb areas, and additional precautions of confirmed COVID and non-COVID patients also can be taken. The visitors also can be restricted. Other non-COVID patients can enjoy the company of their relations and the near and loved ones. But of course, even in the non-COVID, in the COVID areas, definitely video counseling can be done. Video approaches can be done in order to improve the attachment with the patients. And it will having a separate areas will not only reduce the burden on everybody, it will also improve the administrative skills. It will improve the surveillance. It will also give better amount of monitoring techniques and better amount of compliance. proper waste management disposal, which can also be done into double-layered bags, and therefore no leakage of infections can occur, and it will help you to spread the infections into other parts of the hospitals. And therefore, I'm a strong believer that yes, despite this, because of the high virulence and the high reproductive index, I still personally believe that you should have a separate independent isolation or a COVID unit into a hospital and not compromising the care of other patients. That's what I feel. I'm open to take questions and discuss it with Dr. Ray. Thank you very much.
Thank you so much, Dr. Subal. And I know you have nearly convinced us about having a separate ICU, but I'll still believe that Dr. Ray also had many points where we need to have a common ICU and the mix of patients. So, Dr. Ray, sir, I'll request you to say what are your comments after Dr. Subal has tried to convince us?
Thank you, Prasant. Thank you, Subal. Now, after Subal's volcanic and high-powered lecture, I am sure, I think I agree with you, Prasant, that audience must have been biased completely in favor of Subal. I have got few points from Subal's viewpoints. And first of all, Subal talked, I think he dwelled too much on the transmission part of it. Transmission, by now, we have come to realize the maximum transmission occurs even before COVID is detected. Right, it is in the incubation period, that's the maximum transmission. By the time it is 10th day into the suffering, the transmission has considerably come down. Dr. Subal talked about the shedding of the virus, but it is not shedding, even continues till about 90 days post infection, and then that doesn't mean that they are actually infective, because it could be a false positive result, and in most of the cases, actually, it is false positive. And moreover, when a patient comes to the ICU, he doesn't come in the first week generally. He generally comes in the second week when it is actually the inflammatory phase and the patient is quite sick. By then, the transmissibility actually has considerably come down. So therefore, what Dr. Subal talked is quite true for the community. One person can infect 2 or 3 or 4, but in the ICU, that transmissibility is theoretically and practically also less, because we haven't seen, we had in our hospital, we were taking right from the beginning these patients, and whenever these patients used to come without any test, we used to keep them in an isolation ICU, and at least 30% of them would prove to be COVID, and they would spend about a day or 2 with us. Not a single ICU doctor or nurse or any of the hospital attendants has been infected by treating those people. So therefore, the transmissibility between the patient and the hospital staff is actually quite less at that stage of the patient when patient comes to the ICU. So therefore, I have my opinion reserved, and I think it is for the audience to understand this. Moreover, by the time we have come to this stage, almost 100 crores of people have been vaccinated. So the vaccination program has been continuing, and I'm sure the vaccination program also will have its positive effect in terms of transmission. Then Dr. Subal talked about safety of the patients. I haven't really seen any of our patients getting infected because there is a COVID patient side by side when we have been taking these patients for a long time now in the ICU. I've never seen one patient who is actually suffering. And in any case, if you see how, I'm sure Dr. Subal knows in his ICU, people have laxed the use of PPEs, touching patients. I have seen so many people touching patients without even gloves. So I think that is not fair. But having said that, now since they have been doing this, I have also not seen so many people actually getting infected. Once in a while, we see that somebody could be getting infected, but it is not really true that they are getting infected in a large number. Then he talked about hand washing, PPE. I think hand washing, PPE, by now this is one of the gains of the COVID pandemic, that each one of us I see is washing his hands too often, whether he is in the COVID area or he is in the normal ICU area. I think that's a very good positive fallout of this COVID pandemic. So that argument also I do not buy. The economic aspects he talked about, and economic aspects, when you separate out things, it is enormous. Until now, the government was funding the standalone COVID hospitals. Now governments, one after the other in our country, is beginning to have cold feet in financing these people. So I think there are a number of areas where government doesn't support nowadays. So imagine if the people have to spend that money, I think it is enormous. If the administrators, health administrators, the corporate hospitals have to spend, it is enormous. So therefore, ultimately, it's the public who will have to actually dish out a lot of finances for treating these patients. Then communication, Dr. Subal talked about video conferencing. Tell me, that is most ideal. I agree with you, Subal. Certainly, this should have been done.
No, I
But let
completely
me
agree
tell
on
you,
that.
has it been done? Has it been done in how many places? Practically, the health administrators have paid a complete deaf ear to this. The communication is the worst affected area in terms of patient management, and I'm certain about it.
Dr. Subal, sir, please.
Yeah. So we were just discussing, I agree with certain points, but as I said, yes, definitely it does put an economic and a certain amount of economical stress onto the system. But definitely, if you really see, the entire hospital was not working into the when it was fully COVID. The other areas, definitely we found that there is a compromise in the treatment for other departments, which is equally important. We should not compromise the care. And that was also one of the bases. Definitely, yes, over a period of time, yes, we have gained knowledge. Over a period of time, we have gained experience. Over a knowledge of time, we have understood how COVID behaves and what are the treatment protocols. Initially, it was everybody was having a shot in the dark, but now certain concepts are clear. Certain infection control, the PPEs, the concepts, guidelines, all have changed. Treatment protocols have changed. And definitely, I think few years down the line, once the definition of changes from pandemic to endemic, which I think the government of India is soon going to do it is going to behave and follow the normal course like H1N1, what everybody has been following. But definitely the anxiety among certain patients, the anxiety among not in the medical fraternity, but definitely the patients and the patients' relative who come for treatment for non-COVID still continues to be on a very much on the higher side, even despite spending 18 months into COVID. And yes, I agree with Dr. Ray that yes, the vaccination is almost in India is touching almost 100 crores. But we also need to say that yes, despite taking vaccinations, there is still a 20-25% chance of getting infected. We still need to continue the social distancing, hand washing, and all these protocols. But yes, further experience and further knowledge may get me and Dr. Ray possibly on the same platform in order to reduce the morbidity as well as the mortality. Thank you very much.
Thank you, Subal sir, so much
Prashant, can I come in?
Us and Dr. Ray also.
Yes, sir.
The audience have got the message from both the sides of having the separate ICUs, the challenges and the challenges of having the same ICU catering for both the patients. And I think we can take a few questions from the chairperson and the audience now, and we'll take up those questions now.
So now I request Dr. Rungta sir to comment on the topic, which is topic of debate for every hospital.
Yeah, both Dr. Ray and Dr. Subal Dikshit have deliberated excellently on the topic. And this topic is at the top of our agenda when we finally send some recommendation about the topic to the people concerned. Now, we have been working for ages into the arena of high voltage, highly virulent organisms in our ICUs. Acinetobacters, fungi, viri, pseudomonas, klebsiellas, rabies, tetanus, polios, choleras, and never such situation has arisen that we have a separate ICU. On the contrary, we have separate ICU for neurology, gastroenterology, trauma, and so on and so forth. Now, is it a situation like this? And formation of separate hospitals, separate areas, have sent a strong fear psychosis wave into everybody's mind. And I was listening to the discussion in the previous, session when they say the families have broken down because of fear psychosis. The sons and the daughters and the spouses don't want to come to each other because we are working in a COVID areas. The patients are harmed, the economy is harmed, the society is harmed. Have we understood from countries and hospitals in areas, particularly villages, where there is no possibility of keeping two separate hospitals, whereas there is none? Has there been any vertical increase in mortality or morbidity because of non-separation? There is entire African subcontinent where there is little health infrastructure and there has been no report of very high morbidity or mortality thus far. Whereas in developed countries where they have done everything, and the best socioeconomic and educated state of India, Kerala, where everything has been done, I understand, the morbidity and mortality continues to be high. Having separated ICUs, having separated buildings, and observing all preventive measures, has it worked? There is a serious need to discuss that, deliberate on that. That is my proposition. And in the long run, how long the parents will continue to send their children, doctors, spouses to areas where there is chance of unwanted deaths and disease, where the doctor himself or herself will continue to visit, the nurses will continue to visit where death or disease is imminent. I'm sure, like before, we have been working in high infected areas. I have been myself in charge of poliovirus during epidemics, rabies ICU when rabies was quite common in Jaipur. I have worked with neonatal tetanus ward, even adult tetanus ward, and we have been unscathed. We will perish if we do not observe infection prevention practices. That is my proposition. Thank you. Dr. Ray can take this question, please.
Well, I think I am of the opinion that we actually should not separate it out. You know, about 4 or 5 years ago, we had a spate of H1N1 infections. And we had some isolation wards, and the numbers were so many that isolation wards, ICUs also got filled up. So we had to keep them in the side of a intensive care unit. You know, one side was reserved for them, but it was more or less in the same hall, right? And once we did, I don't remember anybody who has actually been infected from among the nurses and the healthcare workers or the doctors, because they treated patients along with the other patients. As long as you continue to observe the infection control manners, which of course was at a premium at that stage, but today I think it's not at a premium because COVID has done that goodness to all of us. I am certain you will be able to treat side by side the COVID patients as well, because it actually makes sense to treat these patients along with your regular ICU patients and with the regular ICU staff, and then they will be certainly much better off. Today, what is happening? You find that the isolated standalone hospitals, patients are doing fairly all right yesterday night. Suddenly this morning they have been intubated and they have died. There is no accountability, nothing. And I'm certain the care that was given was suboptimal. I'm not blaming anybody, but This is what has happened with the untrained and suboptimally trained people. You still continue to get a lot of mortalities in such standalone hospitals. And as I said, that the numbers we will never know, because something which there are many factors which govern the numbers for the public eye. So therefore, we should actually be seriously considering what Dr. Rumta said, that this kind of a arrangement cannot be forever, and COVID is not going out in a hurry. So therefore, how long you can sustain this? It is always safer and better and good for the society that we do take patients just like we take a H1N1 patients, just like we take a rabies patient, just like you take a tetanus patient, just like you take a tuberculosis patient. I think how many tuberculosis patients are isolated today, even open tuberculosis. So therefore, I think we should treat corona as another infective disease. Transmissibility is high, and with the vaccination that we have had, and we will be continuing to have it in the next few days, I think we should be completing the whole country. We should not be scared of.
Very rightly said, sir. And what I got from the debate and all the discussions, and with the wisdom of Dr. Rungta sir, that it's all about the infection control practices, and the infection control in terms of little more of having some negative rooms for the ICU, which otherwise also we should have been having in with our ICUs. And if these practices are improved, we can definitely come to the same place where we can treat our COVID patients with the other patients without having a fear of a spread of infection to the staff as well as other patients. So thank you very much, sir, for your words of wisdom and all the discussions we had. Thank you, sir.
Thank you, Prasant. Thank you, Dr. Rumta. Dr. Rumta has been always the promoter of the concepts which are generally off the track. People don't follow, and they will follow it not today but tomorrow. So I think this was an interesting topic that we did discuss, and Subal, of course, we don't see, but Subal's points also were very well taken.
I think this should be a very important heading in the final recommendations. The robust document that we have been talking about, our recommendations for the future to come.
Very good. I think Prasant, Prasant Nasa, not our yes. Prasant Kumar here. We will pass it on to him. Yes, I think he would bring it up.
Please see your mail, sir.
Yeah, that's right. Absolutely. Thank you. Namaste.
Thank you, sir. Thank you so much.
Good afternoon, ladies and gentlemen. It is a great pleasure that I welcome you all for the afternoon session of the World Conference on COVID and Critical Care 2021. I hope you all have had a seamless experience so far and that we're able to continue to provide the same for you. Without further ado, I would like to proceed to our next session, which is the thematic session 1. Our chairpersons for this session would be Dr. Gunjan Chanchalani, who is the Chief Intensivist, Bhatia Hospital, Mumbai, Dr. Aditya Kumar, Anesthesiologist, Rainbow Hospitals, Agra, Dr. P.L. Gautam, Professor and Head, Department of Critical Care Medicine, Dayanand Medical College and Hospital, Ludhiana, and Dr. Harjeet Dumra, Consultant Pulmonologist and Critical Care Specialist, Ashray Associates, Sparsh Chest Disease Center, Ahmedabad. I would like to request the chairpersons to kindly introduce the speakers for this session now. Thank you.
Hello?
Yes, sir, audible. Please continue.
Yes. So I have this privilege to introduce the first speaker, Dr. Sudhir Mehta. And he is a senior professor in the Department of Medicine, SMS Medical College and Tech Hospital, Jaipur. His topic is QTC interval prolongation COVID patient myths and facts. I think it's a very interesting topic. Not taking time, let's have a more discussion on this. Head over to Dr. Sudhir Mehta.
A very warm good afternoon to faculty and delegates of World Congress. I bring warm greetings from my institute, SMS Medical College and the World Heritage City of Jaipur. At the outset, I wish to express my gratitude to Dr. Narendra Runta and the scientific committee for giving me this opportunity to interact with you all. In the early phase of COVID pandemic, it was thought that the combination of hydroxychloroquine and erythromycin may have a favorable effect on the clinical outcomes and viral loads of SARS coronavirus 2 infected patients. This resulted in massive adoption of the regime by clinicians worldwide. Many centers used this combination along with lopinavir, ritonavir with the hope of controlling disease due to coronavirus 2. At the same time, there was a substantial concern regarding the risk of ventricular arrhythmias, and in particular, torsades de pointes, given the frequent use of both hydroxychloroquine and erythromycin, both of which are known to prolong QT interval. Many clinical trials initiated in 2020 evaluated QT prolonging effects of these drugs in COVID-19 and tendency to degenerate to ventricular arrhythmias. The results were conflicting, but hydroxychloroquine had to bear the brunt of a culprit. However, with the better understanding of the pathophysiology of coronavirus 2 disease, it has now become clear that there are other factors which are implicated in QT prolongation in severe and critical COVID-19. In next few minutes, I hope to clarify the myths and facts of QT prolongation in COVID through evidences. In routine clinical practice, QT interval is calculated with respect to the heart rate using the traditional Baz's formula, which is basically a ratio of QT interval by the under root of preceding RR interval. In routine clinical practice, QT interval is corrected with respect to the heart rate using the Baz's formula, which is basically a ratio of QT interval to the underscore of preceding RR interval. There are other formulas for correction of QT interval with respect to heart rate. These are Friederichia and Framingham and Hodgins. Now, clinical studies have shown that the Friedreichia and Framingham correction formula, they show the best heart rate correction. They significantly improve the prediction of mortality at 30 days and 1 year. The classical Bechet's formula, it overestimates the number of patients with potential dangerous QT interval prolongation, which could lead to unnecessary withholding of first choice medication. What is the significance of corrected QT interval prolongation? QT interval prolongation is a measure of delayed ventricular repolarization. Excessive QT interval can predispose the myocardium to the development of early after depolarizations, which in turn can trigger re-entrant tachycardias. And the most lethal one is torsades de pointes, which is a polymorphic ventricular tachycardia. Now, this cartoon shows that with the effect of drug on the myocardial myocyte, the action potential is prolonged, and this is translated electronically to prolongation of QT interval. And when the QT interval exceeds 500 milliseconds, the risk of developing ventricular tachycardia is quite high. Now, there is a validated risk score for determining the drug-associated QT interval prolongation. This is the classical Tisdale score, and the risk factors which have been incorporated in this scoring system include the age more than 68 years, female sex, use of loop diuretic, presence of acute myocardial infarction, QT interval more than 450 milliseconds on admission, hypokalemia, sepsis, heart failure, use of one or more QT prolonging drugs, and the maximum score is 21. If a patient has a score of less than 6 or less, he falls in the low risk category, whereas 11 or high means that patient has a high risk of developing QT interval prolongation. Now, what happens in COVID-19? Although the exact underlying pathophysiology is still elusive, various single-center studies and surveys around the world have reported a spectrum of electrophysiology issues associated with COVID and its therapies. A 58% increase in out-of-hospital cardiac arrest in the Lombardy region of Italy during the initial days of COVID-19 pandemic raised concerns regarding the risk of arrhythmia associated with SARS coronavirus 2 infection. In USA, a single-center study of 700 patients showed that admission to ICU was independently associated with a 10-fold increase in risk of arrhythmia. Although cardiac arrest was associated with in-hospital mortality, most were due to non-shockable rhythms, and incident atrial fibrillation, bradycardia, or non-sustained VT were not associated with mortality. In a worldwide survey of COVID-19 associated arrhythmias, when the data was collected from more than 4,500 patients across 4 continents and 12 countries. In all, 827 patients had arrhythmia as per the definition of the study protocol. Cardiovascular comorbidities like diabetes, hypertension, heart failure, and coronary artery disease were common in patients who had arrhythmia. Most of these patients did not have prior history of arrhythmia. Of those who did develop an arrhythmia, the majority of them had atrial arrhythmias, and only 21% patients developed ventricular arrhythmias. Nearly 43% patients who developed arrhythmias were taken on mechanical ventilator, and more than half of these patients, they survived and they were discharged from the hospital. Among the 67 patients in this study who had ventricular arrhythmias, nearly 45% were specified as having monomorphic VT, and 49% had polymorphic VT or torsades de pointes. Patients with both forms of VT, that is polymorphic as well as monomorphic, were treated with hydroxychloroquine and azithromycin combination. Almost half of these patients with VT were hypoxic with oxygen saturation less than 90%, or were hypotensive with systolic blood pressure less than 90 at the time of development of arrhythmia. 1/3 of these patients were in renal failure or were SRO'd when arrhythmia appeared. Patients with ventricular arrhythmias had prolonged maximum corrected QT interval. However, patients with polymorphic VT did not have significantly longer QT intervals than patients with monomorphic VT. So what did this study add to the current existing knowledge? Patients with COVID-19 infection and cardiac arrhythmia have a high burden of cardiovascular comorbidities. Although treatment with hydroxychloroquine and azithromycin combination may have contributed to the incidence of polymorphic VT in these patients who had severe COVID infection, Majority of these patients were likely at high risk for this arrhythmia due to pre-existing cardiac disease and the critical nature of the illness. Patients with ventricular arrhythmias tend to be critically ill with a high prevalence of mechanical ventilation, renal failure, hypoxia, and severe hypotension at the time when arrhythmia occurred. Among those patients who died, ventricular arrhythmias were rarely noted to be the rhythm at the time of death. Only 2.4% had VT or VF recorded at the time of death. Nearly 24% patients had non-shockable rhythms. This is all suggestive that severe hypoxemia and critical nature of the illness are the primary drivers of cardiac interest in this population rather than the myocardial injury or electrical derangement in terms of prolongation of QT interval. So to summarize, severe COVID-19 is a pro-arrhythmogenic state which is created by direct viral myocardial damage, hypoxia, hypotension, cytokine storm, electrolyte abnormalities, especially hypokalemia, concomitant use of one or more QT prolonging medications, and of course the underlying cardiovascular comorbidities. Another initial study which came from Wuhan, out of 138 patients who were admitted in ICU for pneumonia, COVID-related pneumonia, nearly 44% patients had arrhythmias. And 1/3 of these patients had myocardial injury, which could predispose to conduction abnormalities, including prolonged QT interval. Even though the frequency of arrhythmias in ICU patients was nearly 50%, only half of these patients had acute cardiac injury, which suggests that factors other than myocardial damage are also involved in enhancing the arrhythmic risk in COVID-19. Now, in the initial period when hydroxychloroquine and azithromycin were used in rampant in right and left across the globe, there was a major concern that the high mortality, especially in Europe and America, were attributable to the arrhythmogenicity of hydroxychloroquine. Now, we know that with the better understanding of the pathophysiology, this is a myth. Hydroxychloroquine has been in clinical use for more than 60 years with excellent profile in rheumatoid arthritis and SLE. In fact, the European Medicines Agency reports that the cardiac adverse effects of hydroxychloroquine, including cardiomyopathy and conduction disorders, feature in the category of not known frequency, meaning thereby that its incidence is very, very low. And another study which appeared in the heart rhythm paper of 111 patients who were hospitalized with COVID-19 and who had received 5-day treatment with hydroxychloroquine, it was found that hydroxychloroquine monotherapy was not associated with clinically significant QT interval prolongation in nearly 93% of patients. Drug-induced QT interval prolongation has served as a surrogate indicator for increased risk of drug-associated torsity epipontis, potentially lethal polymorphic ventricular tachycardia. However, the relationship between QT prolongation and the risk of having ventricular tachycardia is imperfect and quite complicated one. It is not a linear function of QT interval nor the extent of damage. There are some drugs which can prolong QT interval, but they are not associated with increased arrhythmic death. So the bottom line is that though initially hydroxychloroquine in combination with azithromycin were seen as the major culprit for high mortality, but now we know that though these drugs do prolong QT interval, but they are not the cause of mortality in COVID patients. Now, there is enough data also which shows that hydroxychloroquine has a very low risk of causing torsity epipontis, and this is a rare event with an estimated annual crude rate of 3 per million population. So what are the determinants of prolonged QT interval in COVID-19 disease? The risk of cardiac adverse effects which are associated with use of hydroxychloroquine are amplified in COVID because of many reasons. Number one, many of these patients who are hospitalized and are in ICU, they have critical disease. The large number of drugs are prescribed to these patients along with hydroxychloroquine and azithromycin. And many of these drugs have minimal effect on QT interval, however, when they are administered individually. But there's a risk of prolonging the QT interval when these are used together because of drug-to-drug interaction with hydroxychloroquine. So other than the cardiovascular comorbidities, the other determinants of QT interval prolongation include the age, gender, ethnic group, and genetic predisposition, evidence of myocardial injury because of virus, use of QT prolonging drugs, especially the antibiotic like piperacillin, painkiller, and such painkillers like opioid painkillers like tramadol, electrolyte imbalance, hypoxia, all these which I mentioned earlier also. Now coming to the most important story of my talk is the cytokine story. We all know that there's an intense cytokine storm in COVID-19 patients. Secondary hemophagocytic lymphohistiocytosis is an under-recognized hyperinflammatory syndrome which is characterized by fulminant and fatal hypercytokainemia with multi-organ failure. And it is triggered by viral infections and occurs nearly in 3.7 to 4.3% patients with sepsis. A similar cytokine profile, it is associated with COVID-19, and we are all aware that there is excess release of pro-inflammatory cytokines, and these cytokines, especially interleukin-1, 6, and TNF-alpha, can prolong ventricular action potential by modulating the expression or function of several cardiomyocyte ion channels, especially the potassium and calcium channels. Now, initially there was apprehension that those patients who had immune-mediated inflammatory disease are at a higher risk of acquiring COVID infection and have higher mortality. But in a study by Haberman, it's shown that those patients of this immune-mediated inflammatory disease who were on anti-cytokine or immunosuppressive therapy, they fared better when they had COVID-19 disease, suggesting that these therapies probably minimize the effect of cytokine release on COVID-19, and thereby many of these patients, the lesser mortality was seen probably because of lesser incidence of cardiac arrhythmias and death. Now, how should we approach the patients who have QT interval prolongation? Now, the basic approach means that at the baseline, we should discontinue and avoid all other non-critical QT prolonging agents. We should assess the baseline ECG along with renal functions, hepatic functions, electrolytes, and serum magnesium. Now, what are the absolute contraindications for the use of drugs? Because right now, we do not have any specific drug for COVID-19. These are all empirical therapies. If patient has long QT interval syndrome, or the baseline QT interval is more than 500 milliseconds, or more than 530 milliseconds, if QRS interval is more than 120 seconds, then these are the conditions where one should avoid using QT prolonging drugs. Now, for monitoring purpose, we should place a telemetry prior to the start of therapy. We should optimize the potassium level, and we should get ECG done 2 to 3 hours after the second dose of hydroxychloroquine and daily thereafter. Now, if the QT interval increases by 60 milliseconds, or the absolute QT interval is more than 500 milliseconds, then if azithromycin is being used, one should stop it, or if it is not being used, then the dose of hydroxychloroquine should be reduced. Even after reduction of dose of hydroxychloroquine, the QT interval remains prolonged by more than 60 milliseconds, or the absolute value is more than 500 milliseconds, then we should reevaluate the risk and benefit of therapy, and we should consider discontinuation of hydroxychloroquine. So to sum up, the carry-home messages are that QT interval prolongation due to hydroxychloroquine, azithromycin in COVID-19 is an over-exaggerated inference. QT prolongation is the result of interplay between cardiovascular comorbidities, hypercytokainemia, use of QT prolonging drugs, hypoxia, hypotension, electrolyte imbalance, and myocardial injury. QT interval prolongation very uncommonly causes fatal PT and mortality in COVID-19. Thank you very much.
So, Dr. Sudhir, we had one patient, I just want to go to more practical. We had one patient, COVID, who had multiple cardiac arrest, and he was found to have, along with hyponatremia and hypoxia, and patient had a steroid deficiency also. Like in ICU, we use a lot of polypharmacy. You are very nicely that although in the COVID patients, it's a less risk, but once the patient has arrhythmia potential, what are the approach we should have in ICU if the prolonged QT is there with the patient who has COVID also, like we had this patient. So safe tips, what antihistamine we can use safely in these patients, and how we should monitor, and what other preparations should be kept ready so that we can bail out these patients nicely.
Yes, yeah, thanks. It's a very good question. In fact, partly I answered in my presentation. We should have a baseline ECG, and if the QT interval, corrected QT interval is less than 450, I think, and if there's an urgency and a strong indication for starting a drug,
which has a QT prolonging effect, then one can always start and monitor the with serial ECG. Yeah. If you're using 2 or more QT prolonging drugs, then one should be more careful. It's simply you have to monitor the ECG at regular intervals, and the moment you find that the QT interval is prolonged by more than absolute 60 milliseconds, or if it exceeds 500 milliseconds, then we should stop one of the drugs which is lesser indicated in the treatment. But the baseline is also very important, that all QT interval prolongation does not lead to ventricular arrhythmias. I think I'm able to.
That's true. That's true. But there are a couple of things in ICU actually we use very commonly, like polypharmacy. Like azithromycin you have mentioned, there are like antifungals are there. Then sometimes we lasuride and prokinetic drugs. All many drugs when in combination they are really troublesome in ICU. It's commonly used. Like we used in our patient this mexilicine because patient was having multiple cardiac arrest. Initially, because it's very difficult in COVID ICU coordinating with the cardiology and all those things. It's really tough. But we use mexilicine in this patient to control because patient required having a repeated cardiac arrest therapy also. Very good. Thank you.
One has to be vigilant and use telemetry to detect.
Yeah. Keeping maybe defibrillator or cardioverter along with the pads. That's another very important, I think, message should go. These patients, because these patients can have cardiac arrest at any time, or the VT or VHF. We can then go ahead with the immediate cardioversion with the pads and things are available.
Yes.
Yeah. Can someone introduce other chairpersons?
Dr. Aditya is online. So please mute your.
Yes. Here Dr. Prashant Nasa will be speaking, and he's head of the critical care medicine at NMC Hospital, Dubai. You are welcome, doctor. Please start your presentation.
Thank you, friends, and thank you, organizing committee, for having me here into this very important Congress. I should start my presentation with due acknowledgement to these two major collaborative groups who have done a remarkable amount of research in last few months and given a lot of evidence which we are practicing these days into management of COVID-19. Starting with this foremost and more important trial of dexamethasone in patients with COVID-19, where recovery group was actually looked at almost 6,500 patients, and almost 75% of these patients were either requiring oxygen or were on invasive mechanical ventilation or ECMO, and only 1/4 of these patients were without oxygen. What they found was there was significant mortality benefit in patients who were on oxygen, and patients, the benefit was even more in the patients subgroup where the patients were already on invasive mechanical ventilation at the time of starting corticosteroids. While in patients who were not on oxygen, there was a tendency towards harm in these patients. And the benefit was much more significant in patients who had symptoms of more than 7 days of the onset, so signifying a role of inflammation and role of corticosteroid in suppressing this and reducing this inflammation. The number needed to treat was significantly more in patients with invasive mechanical ventilation of almost 9. Looking at this particular study, we know that it's a very major, robust trial which was performed very rapidly, and looking at the patients, and majority of these patients were in from the United Kingdom, and the follow-up was almost completely 95% of these patients. The only major limitation is open label, and there was few missing data where DEXA was unavailable, and what were done for these patients. Followed up by this major trial, the most of the ongoing trials had to stop, and World Health Organization actually collaborated with these ongoing trials, and they did this meta-analysis taking out their data, and the 7 RCTs which were performed, which were done on patients with corticosteroids, COVID-19. Dexamethasone was in 3 trials, hydrocortisone was in 3 trials, and methylprednisolone was in 1 trial. They found there was significant difference in the terms of lower mortality in patients who were given systemic corticosteroids. The important point is almost 60% of these patients in the meta-analysis was obviously taken from the recovery group, and that was one of the reason there is still some doubt that if patients for recovery trial were excluded from this meta-analysis, the mortality benefit is not that much significant as compared to when we included the patients of recovery. Another major area, which was also, the sort of controversy from the start of the pandemic, was use of these interleukin-6 antagonists, especially like tocilizumab and these immunomodulators. So there were few conflicting trials which were giving results diametrically opposite on the role of tocilizumab in patients with COVID-19. Almost 4,000 patients were included by the recovery group, and almost 1,900 of these patients were on oxygen. And the primary outcome was mortality, while there were many secondary outcomes which they were looked into this particular trial. The mortality at day 28 was significantly different in the patients who were on tocilizumab, and the number needed to treat was 25. What was also more important was, they did a secondary analysis while patients on invasive mechanical ventilation versus the mortality in these patients and the patients who did not progress to invasive mechanical ventilation. So in all these subgroup analysis where the patients did not progress progression of the disease to requirement of invasive mechanical ventilation or ECMO, there was significantly higher rate of improvement in these patients. What was also noticed that the patients who were already on corticosteroid, the benefit was much more as compared to the patients who were not on corticosteroid. So that led to their recommendation that tocilizumab should be considered only in patients with critical COVID who were already on corticosteroids. Another group, as I discussed before, REMAC group also looked at the tocilizumab or interleukin-6 receptor antagonist. In fact, they added sarilumab, another IL-6 inhibitor, and they used Bayesian analysis where they looked at organ support-free days, which was also significantly higher in patients with tocilizumab or sarilumab as compared to the standard of care. And the posterior probability of survival was almost 99% in patients with tocilizumab and 99.5% in patients with sarilumab. There was also significant difference in the terms of hospital mortality. Followed by these two major meta-analysis, again, World Health Organization through their REACT group did a meta-analysis looking at almost 27 published trials, out of which 18 were unpublished trials, looking at the role of IL-6 antagonist in the management of hospitalized serious critically ill COVID-19 patients. The mortality was significantly supporting the tocilizumab group, and the benefit was much more in patients who were already on corticosteroids. There was no significant benefit, but the mortality benefit was there, but it was non-significant in the patients with sarilumab. Looking at various secondary outcome or subgroup analysis, again, the progression to invasive mechanical ventilation or ECMO or death at 28 days was significantly reduced in patients who were on corticosteroids and were given tocilizumab in patients with critical COVID-19. In this meta-analysis, they could not find any significant increased rate of secondary infection, which is a much more concern with use of these immunomodulators. But the meta-analysis of all the RCTs did not find any increased rate of secondary infections. Also, there was lower progression to the requirement of organ support like cardiovascular vasopressin support, like use of vasopressors or renal replacement therapy. Now, from the start of the pandemic, there was much more media hype on use of convalescent plasma as one of the therapy for management of COVID-19. And this study, which came from India alone, is a very robust trial which was conducted at the difficult time of the pandemic in the first wave and was published in a very reputed journal of BMJ. Almost 465 patients of moderate COVID-19, where 2 doses of convalescent plasma was transfused 24 hours apart. Convalescent plasma in this study did not reduce progression to either severe disease or mortality. Though there were few limitations like open label design, and the study was underpowered to look at the mortality difference. And what was also an important limitation was they did not measure neutralizing antibody in the donor because it was not available in majority of the labs at that time when the study was ongoing. Followed by this, there were many other trials which also had a negative outcome and did not improve survival in patients with COVID-19. Followed by this important trial, which was again done by the recovery group of almost 11,500 patients, where they looked at the role of convalescent plasma in management of COVID-19. Again, they did not find any mortality difference, but also in the subgroup analysis, the difference was not there even in patients who were having negative for antibody, which were supposed to get benefit. Similarly, there was no difference with or without in patients with invasive mechanical ventilation or difference in the terms of hospital discharge. Also, that high titer convalescent plasma, which was again published in one of the paper in New England Journal of Medicine, did not have improved survival looking at in this major RCT, which was done with convalescent plasma. Followed by the meta-analysis, which was published in Lancet again in 2021 August. Of these 10 trials, there was no mortality benefit, there was no outcome benefit with use of convalescent plasma in patients with COVID-19. World Health Organization, had collaborated very rapidly this large global multi-arm adaptive RCT looking at the role of repurposed drugs. So we know that many of the drugs which were started being used in the management of COVID-19 from the start of the pandemic. So there was a lot of debate, how they can improve outcomes. So they look at the core factors, whether they actually reduce hospitalization mortality, because looking at the global platform, it was not a measure to look at the morbidity alone. So what was important was looking at the hard outcomes like mortality and rate of hospitalization. What they found was the popular drugs like hydroxychloroquine, and they actually removed that myth. The hydroxychloroquine or other drugs like remdesivir, lopinavir combination did not have any outcome benefit in terms of reduction of mortality or reduction of hospitalization of these of the patients of COVID-19. Despite being a multi-arm and a global platform, the adherence to the treatment group was very high, and very few crossover happened in this particular group. In the last few months, there has been production of these specific monoclonal antibodies against SARS-CoV-2, which has been a breakthrough in the management of patients with COVID-19, because these were one of the first antiviral therapies which were specifically designed for an infectious disease where antibodies were targeting against SARS-CoV-2. This published in New England Journal of Medicine of patients of almost 2,700 patients looking at this combination of monoclonal antibodies, isariumab and imidivab, looking at 2 doses of 2,400 milligram and 2,200 milligram. They found mortality benefit and reduced rate of hospitalization using either of the 2 doses, 2,400 milligram or 1,200 milligram of combination of 600 plus 600 isariumab and imidivab. Also, there was faster time to resolution of 10 days versus 14 days and faster viral load clearance. The benefit was obviously much more higher in patients with SARS antibody. The negative while these treatments were given, followed by a meta-analysis again by World Health Organization recommended SARS-CoV-2 in patients with non-severe COVID-19, and though the evidence is moderate, there were also preprint papers which are not included in the presentation, on which WHO actually recommended even in patients with severe and critical COVID in subset of patients where antibodies are negative, with their latest evidence which is now published in BMJ. Again, as we know now, COVID-19 is a prothrombotic disease, and there has been use of anticoagulation as a therapeutic management of these patients from the start of the pandemic. So there was a lot of debate to use anticoagulation in a therapeutic measure. So this published paper in New England Journal of Medicine, where they used almost similar type of randomized controlled trials, VMACAP, Active4A, and 8TTACC investigators, where the data was pooled so that to enhance the power of the study. Almost 1,200 patients were enrolled in this particular randomized controlled trial, 591 in the therapeutic anticoagulation group, and Bayesian analysis was done. There was no difference in the terms of organ support with the use of therapeutic coagulation. There was no difference in the terms of survival to discharge. Also, the mortality benefit was also not showing any benefit in terms of using therapeutic anticoagulation. There was tendency towards higher bleeding in patients with therapeutic anticoagulation, and the probability of inferiority and a tendency towards harm was noticed in patients where therapeutic anticoagulation was used in critically ill patients who were being managed in ICU. There are a few more very important trials, which obviously because of the time I cannot include, and I recommend to go through these few trials and many more which are worth reading. Thank you.
Can I ask a question to Dr. Prashant Nasa?
Sir, Dr. Prashant is not online.
Okay.
Yes. May I request chairpersons to introduce the speaker?
Very good.
Yes, ma'am, please continue.
We call upon next Dr. Pradeep Diposta. He is the head of department ICU and consultant intensive care at KEMH Pune. He will be talking on the topic ultrasound and neurocritical care.
Namaskar, everybody. I am Dr. Pradeep Diposta, an intensive care person from the city of Pune. I have been asked to speak about use of ultrasound in neurocritical care. Is there any role? It's a fascinating topic and a vast topic. I have divided my presentation under the following headings. I will, by the end of the lecture, try to open up your minds to the varied applications of neurocritical care ultrasound. I will first look at the orbits, then the optic nerve sheath diameters, a bit on the pupillary reactions. Is it used in stroke protocols? Other applications, some procedures if time permits. Now, when we get a person in the critical care, you can image almost everything from head to toe by the use of bedside ultrasound. The orbit is beautifully seen at the bedside. You can see the anterior chamber, you can see the pupil, you can see the lens, you can see the posterior chamber, and you can make out all artifacts or all pathologies in these particular chambers. Look how beautifully the ultrasound demonstrates what would not have been visible to the naked eye. You can see a traumatic globe. You can see a detached retina. This is possible by the use of the ultrasound at the bedside. Similarly, if you compare the ultrasound on the left-hand side of your screen with a CT image on the right hand of the screen, you will see that the ultrasound scores very, very high over the CT scan. You can see in the CT scan, you will not be able to appreciate any abnormalities in the posterior chamber, while on the ultrasound, you can see clearly a detachment partially of the retina, clearly seen on this particular image. Can the sinuses be seen on the ultrasound? Well, yes, it depends on how full the sinuses are with fluid or other tissue. If you have the sinuses which are full of tissue, you get an ultrasound image which looks like a vase. This particular vase-shaped image is called a complete sinusogram. If you have a sinus which is incompletely filled with fluid material, then because of the ultrasound evaluation by the probe, you would get a semi-vase or an incomplete sinusogram. So if you're a patient with a PO in the ICU, you do not know where the focus of the PO is, don't forget to look at the sinuses. You may well find a complete sinusogram or an incomplete sinusogram there. This is one of the fascinating roles of the ultrasound. The person may have a swollen eyelid. You are struggling to open his eyes to look at the pupils, commonly seen post-traumatic, commonly seen after a post-surgical event. The ultrasound can beautifully show you the size of the pupils, the shape of the pupils, and of course, beautifully the reaction to light of the pupil. This is a slightly different oblique view showing the same thing, beautifully reacting pupils to ultrasound. The optic nerve sheath diameter. This, I think, is one of the most extensively discussed points of neurocritical care. The end results or the take-home messages are still not clear. The optic nerve sheath surrounds the optic nerve. The black strip surrounding the optic nerve and the diameter measured 3 millimeters behind the optic papilla is what we are looking for. Now, does this correlate well with the raised intracranial pressure? Well, there are lots of discussions, lots of debates on that, and the overall impression is that yes, if an optic nerve sheath diameter is probably more than 0.6 centimeters, it correlates reasonably well with a raised intracranial pressure. There have been two signs which have been discussed. One is the crescent sign. I propose to show you a bit about the crescent sign because this has not much prominence as the optic nerve sheath diameter, but it could be an invaluable tool in looking for raised intracranial pressure. And if you look behind the optic nerve, you would find an area of blackness. It is likely to be related secondary to changes in the raised intracranial pressure. This particular sign is called the crescent sign. So if you have a crescent sign, if you have bulging papilla, or you have a dilated sheath, all of these could mean there is a raised intracranial pressure. Now, does the ultrasound compare with the CT scan? Can we measure midline shift on the ultrasound? Well, the answer is yes. Can you see this? The midline is here, beautifully seen by the ultrasound as well. You measure the distance between ipsilateral cranium to the midline and contralateral cranium to the midline, and hence you would be able to measure the midline shift. Now, what next? In our stroke protocols, if you looked at the extracranial carotid arteries, so many times you could pick up ulcerated plaques or thrombi there. This gives you valuable clues in your stroke management. You can pick up pathologies there. This is the division of the carotid arteries, and you can see there's probably some amount of blockage of one of the carotid arteries in that particular segment. Then what about the transcranial Doppler? This, of course, is one of my most favorite topics, and this has changed our management in severely traumatized brains. Visualization of the brain through the transcranial window is indeed an important part of management of severely injured brains. You could see beautifully the full circle of Willis, right from the middle cerebral artery to the anterior cerebral artery to the posterior cerebral artery. Each vessel is identified by its location, volume, and measurements. Bifurcations would have bifid recordings, and flows away from the transducer would have negative recordings. This particular segment of ultrasound is of late been an invaluable tool for us in our identification of the severely traumatized brain and in identification of the person who is probably going in for cerebral circulatory arrest. You can see beautifully just these small peaks in these two segments. Once you see these oscillatory flows, it means that your intracranial pressure has already reached a very, very severe state, and this particular person is likely to be brain dead. Similarly, we use the ultrasound in monitoring for vasospasm, commonly after subarachnoid hemorrhage. You can measure the velocities of the arteries, follow them up over time, and know whether vasospasm has got relieved or continues in these particular patients. Transflap ultrasound. Can you see these images? You can actually see the pathology very, very clearly. Once you see the pathology, you can actually measure the shift of the midline or the increase in the pathology or the occurrence of a new pathology within that segment. The views seen in these particular clips are on par with your CT scan. You can see in this particular clip that the midline has indeed shifted towards this particular side because of some lesion occupying this side of the brain. So remember, you can measure midline shift very, very well by the use of the ultrasound. It correlates excellently with the CT scan if you do simultaneously. Can the ultrasound be used for bedside procedures? Large, obese people, people with edematous backs, you want to do a lumbar puncture. Yes, you can utilize the ultrasound. It helps you identify the anatomy very, very accurately. It helps you in the dynamic guidance of your needle as you try to do the procedures. It is also helpful in your trauma patients. You can identify disruptions in the cervical spine, bony fractures in the cervical spine very, very accurately, as you can see in this particular picture as well. So all in all, it is indeed a fascinating area of critical care. Neurocritical care ultrasound is indeed what may hold the key for us in managing critically ill patients. The applications in the neurocritical care are multiple. It's a very dynamic method. It is cost-effective way of monitoring very, very seriously ill patients. We could possibly evaluate most or almost all structures in the head, neck areas, and more importantly, can do examinations repetitively rather than the scan, which are expensive, and transfer of these patients up and down from your ICU to the scan could indeed be risky to the life of the patient. This improves decision making at the bedside and hence outcomes. I do hope I have managed to convince you about the use of ultrasound in neurocritical care. I will be open for questions at the end of this presentation. Thank you.
Very interesting and topic, and with the futuristic possibilities. I never knew earlier that ultrasound could be used for such applications. Very interesting and very encouraging.
Is Dr. Pradeep around, sir?
No, sir. No, sir. But Prasant sir has logged in. We may take questions from Prasant.
Right. I think this is a very fascinating area. And many times we have limitations of shifting the patient to the radiology department. When he's on ventilator, he's quite bad and he cannot be transported. With this upcoming technology, which is very little practiced in most parts of our country, in fact, most parts of the world, despite hard work of the ultrasonologists around the world. Dr. Prashant, how can we take this technology to every ICU in our country? Can you elaborate?
Sir, sorry, can you come again?
No, I said this is quite a fascinating area. I was elected president of ultrasound technology in ICU in 2014 and I had attended the World Congress, and there it was said CT will disappear after 10 years and 2024 is approaching. So ultrasound technology should be taken to almost every parts of this country in ICUs, where patients cannot be shifted or transported to radiological departments because they are not in good shape to be transported. So how can we achieve this?
I think, sir, more of training, and it should be part of our, the standard training programs of our fellows, which are there. Many good places, they are already being given this training as a part of their fellowships or part of their DNB, FNB, or DM. But I think besides training, it should come into, the guidelines. Even surviving sepsis guidelines still do not mention much about hemodynamic monitoring. Right. And that where, the area needs to work upon. There is still a lot of confusion, like for critically ill patients. I was just looking at the use of ultrasound for COVID patients. It came up as a good diagnostic tool, but to say that it can replace CT, I don't think so. But at the same time, it gives you much more, bedside information, which helps in management of critically ill patients, along with the other tools. So it's a part of our armamentarium. As like any other single hemodynamic monitoring can change outcome, I don't think. It has to be part of the complete armamentarium which we have, and it has improved. Now I always believe that, being a very good fan of money heist, we should have our eyes inside the patient, and ultrasound add to that eye. Whether we are
can we develop a very robust, say half day or 1 day online program?
Ultrasound online alone will not work, sir. People need a hands-on training. Yes, it has to be.
That they can organize this will sensitize them to need.
Exactly. There are very good courses like WinFocus and even IACCM is conducting those things, but ultimately it's a hands-on, and more importantly, the people should continue to use them. Learning at these conferences or workshop, if you're not using it bedside, then you do not develop that skills. The learning curve is short for ultrasound, but again, it has to be developed. Unless you start using it frequently at the bedside,
right,
issue is you will not use it. So it's important to have these trainings, as you rightly said, sir. We should
Thank
have
you.
half day to 1 day, but it should be complemented with the hands-on training too.
Good. Once the people learn all this regarding ultrasound, then it will be very cost effective, because as you said, at times very difficult to shift the patients to CT, to the radiology department. They are in poor shape, poor hemodynamics, or need ventilation difficult. Then it will be definitely much more helpful.
Ultrasound, I think, multiple roles in ICU. I think without now we are using it daily. This thing, it is feeling like we are handicapped without it, because whether it's putting a center line, assessing the hemodynamics, because at times the shock assessment, even echo alone cannot make. You can have multiple things. Even the monitors may not help the way this helps. Learning curve is not that difficult. I think even weaning the patient's diaphragmatic assessment, optic nerve sheath diameter, it's very easy to learn. It hardly takes time. The another hurdle is the P&D Act, because availability, that's the concern actually.
That's really difficult to manage.
My simple suggestion is, if you tell somebody that you start taking this particular pill for 7 days, probably you will live 10 years longer. So if similarly we start telling repeatedly the intensivists that you start doing ultrasound by the bedside, your patient survival increase 2-fold, 3-fold, or your diagnostic abilities will multiply many-fold. So that
much more. It's
yeah, that is the kind of sensitization that we can achieve by online program, and at a very cost-effective manner, we can reach thousands of intensivists, and they can later achieve the final goal with local teaching and bedside handling.
Very true. Very true.
Sure. In fact, what I would say is that during this COVID pandemic, sir, a lot of people, instead of doing the CT scans, they were doing ultrasound. It was encouraged to do ultrasound chest, basically, to find out whether the consolidation is there, and it had actually helped us a lot in rather transferring the unstable patient for CT scan, just do an ultrasound and see where you are. I think you're hello, good morning, sir. Good morning, sir. But in fact, it is. I feel it is, as you said, it is very important nowadays, and lot because of COVID pandemic. A lot of courses in the UK are being done as a online course plus hands-on, so to save the time for regular interaction. So I think it is a very useful suggestion, sir. I think it's a like European diploma in echocardiography is mainly online now. So it is being adjusted, and then you do your own logs, and then you appear for examination. I think it is feasible and doable, and it's a very good suggestion, sir, I would say.
Dr. Aditya?
Yes. Now, Dr. Ruchira Khasane, Head of the Department of Critical Care, Associate Professor in Anesthesia at NASIC, will present her presentation. Dr. Khasane, please.
Hello, everyone. Thanks for W4C organizing committee to give me opportunity to speak on burnout in COVID-19. As we know that burnout is increasingly being recognized globally as a major health concern. It is affecting physical as well as mental health, and especially during COVID-19 pandemic, it has been tremendously increased, especially among healthcare workers. So it is a multidimensional syndrome, a state of physical as well as emotional exhaustion, which is usually associated with reduced sense of personal accomplishment. There is lack of interest, whatever you are doing. There is associated psychological stress, post-traumatic stress, as well as that might lead to complete depersonalization. Now, burnout is not a new entity for us. Even without pandemic or in previous whatever pandemics had happened in last century, burnout used to be a problem. But during COVID-19 pandemic, these dynamics have been tremendously changed, especially among healthcare workers. Now, what is our major concern? Because of these burnout issue, which was significantly increased, that led to a suboptimal patient care as well. In pre-COVID area, it was not that high. As per a few studies, there was a wide range of burnout during pre-COVID era from 16 to 15%. And the usual reason of burnout, common reasons of burnout in pre-COVID era used to be like job dissatisfaction, high working load, feeling of not being appreciated, inadequate remuneration, failure to achieve the goals, poor interpersonal relationship, lack of family time, or competing with the family interest. Now, what happened during COVID-19 pandemic? Apart from these issues causing burnout among us, there were some add-on factors as well, because managing the patients with a disease which is highly contagious in nature was definitely added to a job stress. We used to come frequently in contact with the patient. There was like many times there used to be a forced redeployment also. Then we always used to have a fear of catching infections, carrying that infection to our family members. Then at times when the patient's load used to be very high, then the working environment used to be compromised at many levels. Though there were many online ongoing programs, but still everybody was perceiving that we are getting inadequate training. Then work exhaustion in whenever the PPE is on, especially I would say in the second wave, when the summer was on, working with PPE on was extremely difficult. Work exhaustion, concern with the self and carrying that infection to your family members, even fear of doing unfamiliar work. As we all know, just to improve the manpower, there were many fraternities were involved in patient care who like hardly had come across with the direct patient care since many years. Were also involved in a direct patient care, which was also added to a tremendous stress. And unfortunately, if somebody tested positive, then a prolonged period of quarantine and social stigmata as well. So these were all reasons which added burnout significantly among healthcare workers. The burnout assessment, there were many instruments had come up. The oldest one was published in 1981, which is Maslach burnout inventory, and many publications were based on this Maslach burnout inventory. There were some limitations and drawbacks of this inventory, and so after that, Copenhagen burnout inventory was the latest one, which comprised of 3 domains: personal, work, and client related. So client can be modified. In pre-COVID era, client used to be majority times work and stress related to that. And in COVID era, COVID-19 was the client. So there were few set of questions, and based on those questions, the burnout was prevalence of burnout was calculated by using this CBI. So I'm happy to share, and I'm thankful to the organizing committee to present here on this platform my own work. And so we created a questionnaire based on this CBI. And this last domain, which is a client-related domain, we modified few questions which are related to COVID-19 pandemic, and we calculated this questionnaire, and we got almost more than 2,000 healthcare responses. And we these were the questionnaire, which was a domain 1, which was based on the personal burnout, where 5 questions were there. In domain 2, work-related burnout. And the last domain was a pandemic related domain, where total 13 questions were there. So we circulated these questions, and we got a very good response. So we found that the prevalence of personal as well as work related burnout was also very high. Apart from that, the pandemic related burnout was it was more than 50%, particularly in this survey. The most affected age group was younger age group up to around 21 to 30 years of age. and females and the nurses were majoritarily affected. The doctors were 1.6 times. Compared to that, the staff was like 5 times more, experienced more pandemic-related burnout. Almost half of the respondents, as per our survey, had a fear of contracting COVID-19 infection while serving the patients, and 66.9% of the respondents had fear of carrying that infection to home and infect the family members. Nearly 1/5 of the respondents expressed the fear of death while working, and a quarter of the respondents felt that they are not going to welcome by their community as well. So the result of our studies were really made us restless. So much of the burnout, the healthcare workers were affected when we got to know the results, and we must come up with some resilience technique to overcome this burnout. To support our Indian study, there were few international publications as well, but ours was the first Indian publication. So this was the meta-analysis involving 13 studies, and they observed that females were more prone to develop the anxiety and depression in this COVID-19 pandemic burnout. Nurses had shown a higher incidence of anxiety and depression, probably due to prolonged working hours, job insecurities, undervalued, poor remuneration, and even lack of support by the seniors. Another study has been published in Singapore during this COVID-19 pandemic among healthcare workers, and they also had shown that the prevalence of anxiety, depression, and stress were high among the medical who were directly in contact with the patient. Another multi-center cross-sectional study had come up involving 958 patients, and they observed that history of contact itself is contact with the COVID-19 patient itself is an independent risk factor, which has doubled the risk of anxiety and depression in COVID-19 pandemic, leading to burnout. And one more study which was conducted in Hubei province in China. And what they did is they compared the mental health disturbances among the physicians as well as nurses. And they observed that those who were in direct contact with the patient care had more severe symptoms of anxiety, depression, insomnia, and mental stress. And the severity was more among the females, junior level of doctors, and those who were frontline workers. So what should be the approach to overcome these scary results of burnout and affecting mental health, and as well as it is affecting a physical health of healthcare workers? To prevent and to ameliorate the effects of burnout, there should be a multi-pronged approach which will not only protect the healthcare workers, but it will prevent the collapse of healthcare system. So basically, intervention should be at organization level as well as intervention should be at the individual level. So at organization level, prompting the preemptive resilience strategies, creating working friendly environment. There should be some institutional leadership to create some protective working environment for the employees, frequent updates about the information, instruction, training, and even the technical updates to the healthcare workers. There should be a sense of safety, that they are safe in while dealing with the patient, and their family is also safe if they catch the infection. So these should be some important strategies which should be implemented at the organization level. Even in during first wave, even at many places, the healthcare workers had a fear of getting adequate protective gears also. Those concerns were also there, which was not the case in second wave. But the prolonged working hours, assuring the compensation by the organization, even rehabilitation, curative services, and counseling services should reach to the healthcare workers, so that they should utilize their talent for the patient care. Of course, interventions at the personal level, they are extremely important. One should focus on self-care, on their psychological well-being. Maybe some yoga meditation can help. Distressing yourself by some personalized resilience techniques and attending the workshops or computer assistant resilience training. There are many digital packages are also available. And the best is to vent out your emotions with your close ones, near ones, and friends. And if you need any help, don't be hesitant to open yourself and take the help. So I will end up my presentation. Few points to remember. Burnout is not new among us, even before pre-COVID-19 pandemic era. However, the dynamics have drastically changed during COVID-19 pandemic. burnout was highest among the healthcare workers. Major concern of the burnout are fear of catching infection and infecting family members, and those who were directly involved with the patient care were the most affected one. At the organization level, one should have a prompting preemptive resilience strategies, working friendly environment, which should be proactive at the organization level. Though the long-term effects of current pandemic and burnout-related issues need to be assessed later, but ensuring our own mental health and restoring yourself is the priority at individual level. So, I would like to end up my presentation by this quote by Dalai Lama: "If you feel burnout setting in, if you feel demoralized and exhausted, it is best for the sake of everyone to withdraw and restore yourself." Thank you very much.
Unmute sessions.
This is very, very nice presentation. Good.
Do you want to say something?
I think she was online. I think she just disconnected.
Dr. Ditya?
Thank you. Very, very nice presentation. And she highlighted the important causes of burnout, which was very common in the healthcare workers. And the management was also told by her, very correct and very pointing to that how to restore the efficacy and efficiency and psychological morale of the people. Thank you.
Burnout is a very important aspect. Looking after it increase the complication rate also, and looking yourself and then looking the patient is important. But at times it becomes difficult when the pandemic is there to take rest also. So the duty also becomes very important. Both things balancing is really difficult. But at institute level we have to something make, because coming together it's a very good tool to relieve the tension by sharing the knowledge and this thing, expressing the emotions. So having in between some long, maintaining the social behavior and having some little bit get-togethers, like many of the studies that come from the Sweden, where they have even like they call it the fika, that having a tea together relieves a lot of stress. So small things in ICU, having small, although maintaining the behavior, social behavior, COVID behavior, I would say, but having small parties is, I think it's okay to go ahead with those to relieve tensions.
Yes, very right.
But this is a part that the institutional level should look after, because a lot of fear is one getting the infection, other is losing young patient very quickly. When the failure is there, we take not only one thing that it's a fear, but one is once you are losing the patient, a failure to achieve the success also backfires also.
Yes.
Also very important to share among the others team members. Leaders have to take the call for these things also to maintain the boost morality also.
Right. Very
nice presentation.
Good afternoon, everyone. It is an honor to have you all here for the World COVID Conference on Critical Care 2021. I hope we have been able to make this conference a smooth experience for all of you, even virtually, and it would be our aim to do so in the future. Let me now introduce our chairperson for the next session. It is our chairpersons are Dr. Nirmal Jaiswal, Internal Medicine, Critical Care Medicine and Consultant Physician in Dhantoli, Nagpur. Dr. Amrita Gupta, MD, FIPM, Assistant Professor, Department of Anesthesia, SN Medical College, Agra. Dr. Sadiq Mohammed, Associate Professor, Secretary, IS CCM, Jodhpur City Branch, Assistant Editor, Journal of Anesthesiology and Clinical Pharmacology, and Dr. Nipun Agarwal, Associate Professor, Community Medicine, Bareilly. I would like to request the chairpersons to kindly introduce our speakers for this session. Thank you. Over to you, ma'am.
Good afternoon. I am Dr. Amrita Gupta. I would like to introduce the speaker, Dr. Abhinav Gupta, Consultant ICU, Homerton University Hospital, London. Sir, please continue.
Good morning. First of all, I would like to thank Dr. Rungta and the entire team of W4C for organizing this conference and inviting me to talk on COVID management strategies in NHS. I will be briefly talking about what we did at Homerton University Hospitals because it's a part of National Health Services, where I'm working in intensive care unit. So the total number of COVID cases in the UK was nearly 8 million, and phenomenal number of deaths was 135,000 deaths who had tested positive. The first case was reported in 31st of January 2020, after which the COVID became a notifiable disease in March. The initial strategy was to contain the COVID situation, try to delay the transmission, and do a lot of research and mitigate whatever the effect it had. And slowly, when it reached pandemic level, and it was realized that it has reached a phenomenal level. So the country went into lockdown in March 2020. National Health Services, it began on 5th of July 1948, and by the efforts of then Minister of Health, Mr. Bevan. And it was basically, the aim was to make it more affordable and accessible to everyone. And in its 72 years of history, the scale and degree of adaptation by NHS was unprecedented. It acted swiftly for emergency preparedness and resilience, with this command centralized, which is called the gold for strategic oversight, and silver for local tactical coordination amongst responders. And it was soon seen that there was a rapid deployment of carers to achieve 10,000 home visits a day. There was redeployment of clinicians. There were cross-discipline clinicians, and new protocols were written, new admission criteria were made, and a lot of general practices when patients were going to see their GPCs, a lot of practices were delivered virtually. And it also, there was seen tremendous support from charities along with weekly clubs for NHS, and really helped. And the interventions that were done to increase capacity, because ICU had limited capacity, acute care settings had limited capacity. So what they did was cancel all elective surgeries. And the 7 major field hospitals were set up. They were repurposed. There were arenas that were repurposed into hospitals. Private hospitals were being deployed for emergency surgeries. So COVID patients were being managed in NHS hospitals, and the elective surgeries were being continued in private hospitals. A lot of former healthcare staff that had hitherto been retired, and they came back to help in this crisis. Lot of final year nursing and medical students did voluntary jobs, and they were really helpful. They had their own rota. They were helping out with blood gas machines. Some of them participated in communication team. Some of them were helping out in ICUs, doing a lot of jobs. Even the pediatric beds were converted to treat adult patients. And the remaining staff in the hospitals, they reorganized themselves into different teams. And in my hospital, I remember one of the skin consultant and a bariatric surgeon and a gastro surgeon. They formed a communication team to talk to the families of the patients. The orthopedic surgeons and the maxillofacial surgeons, they combined to form a proning team to prone and deprone patients. A lot of anesthesia consultants and registrars who were not working in ICU, they formed intubation teams. They used to go and see the patients on the ward, intubation done in A&E and wards, and transferring the patients for CT scan from wards to the ICU. And a lot of senior clinicians, like clinical leads, they used to act as bed buddies. So they would help the nursing staff, especially during nights. They had their own rota. They used to offer. I remember a maxillofacial surgeon who, during his night shift, he reviewed all the tracheostomies. There was a radiology consultant who would do ultrasound and interpret X-rays of all the patients. I remember the clinical lead. She was helping the nursing staff with pressure dressing, and she reviewed a lot of pressure dressings. And it was, in fact, I remember an orthopedic lead who was trying to understand the EVGs and how to do suction very enthusiastically, actually, and he still remembers those days. This is one of the buildings in London, in Greenwich. which Excel London, it's a big building, and it was repurposed for converting to acute care settings. And these are the beds. Soon the ventilators were added, and a lot of infrastructure was added. And 7 such temporary hospitals were established throughout the country. Hundreds of NHS staff were redeployed. They had actually retired. They came back to help. They had their own concerns. Lot of redeployed staff. They had fear of becoming infected because they had lost their skills. They were concerned about patient safety and their own skills. And some of the staff that were coming from different other specialties to work in ICU, they had concern regarding their own professional loss. And all these decisions were made in real time, which is very similar to the military principle of mission command. That is freedom of action at all levels to deliver the required outcome instead of a traditional command and control structure. And this was the fastest and most significant repurposing of services, capacity, and staffing in the NHS history. In fact, we were a part of Northeast London, and the sector formation was a very interesting thing that happened. It was a very beneficial thing because the different trusts in the same sector, they used to hold meetings at least thrice a day. In our Northeast London sector, we used to hold meetings thrice a day, 9 o'clock, 1 o'clock, and 4 o'clock. And all the different trusts in the sector, they used to support each other. They used to help each other with decompression and transfer of patients between trusts. And to the extent that we did develop our own nectar, which we popularly called as nectar services, that is the ambulance service, along with the team to help in transferring patients, so that the team actually working in the hospital, in the staff and the doctors, they are not taken out of ICU. So there's a separate team for transfer. To the extent that the transfers were done within sectors, if there's no capacity available in the city of London, if not in London, to nearby areas, if not in nearby areas, sometimes the transfers used to happen over a distance of more than 300 miles, like from London Hospital to Newcastle. Sometimes we transferred a patient to Manchester, which is quite far off. Another landmark thing that happened was extensive research. A lot of legislations and the legalities required for research were done away with because it was priority research to find out the treatment, to find out the management strategies. And some of the famous trials that happened at that point of time was a REMAP CAP trial. Again, it will be very interesting to read through how these trials were actually working. And there was a recovery trial and the genomics trial, basically, which is I'm the PI for this genomic trial. That why do some healthy people, they become seriously ill with COVID, and if that is something to do with the genes. And interestingly, the results came, and some of them were adopted, and there were significant findings. For example, dexamethasone to decrease mortality and morbidity, tocilizumab is considered beneficial. No role of aspirin, convalescent plasma, and a lot of such drugs actually. And on the basis of these, guidelines were revised, and it was an intense effort of a lot of societies, the Faculty of Intensive Care Medicine, Intensive Care Society, all of the Royal College of Anesthesia, anesthetists, and the Royal College of a lot of Royal Colleges, they got together to make these strategies. And vaccination, a lot of work was going on in vaccination, which was the Oxford vaccine was developed by the collaboration of Oxford with AstraZeneca. One of the global breakthrough was the development of Oxford COVID-19 vaccine. And UK, in fact, became the first country in the world, first country to authorize mass vaccination program. And throughout early 2021, it had one of the biggest percentage of patients being vaccinated. And to the extent now that 85.6% have received their first dose, and second dose has been administered to around 78.6%. So basically now, the NHS passed through 4 phases. The first phase, which was started in April 2020, immediately after the pandemic and the lockdown, the main purpose was to free up the acute care beds, create more capacity, stop all non-urgent work, and redeployment. The phase 2 was after the first lockdown, and when services were slowly beginning to improve, to resume all the critical care services, begin the elective work. And phase 3 was to review the positive changes and to tackle the backlog, because there's a tremendous backlog of surgeries. So efforts are all going on to complete that backlog. And now what we're looking at is the winter surge, because what is predicted is more respiratory infection in kids. So the NHS has achieved 33,000 bed capacity, 7 repurposed hospitals known as Nightingale hospitals, local manufacturers for PPE. They were taken in, and NHS increased their lab testing capacity. They had more partnerships now. Ambulance services were escalated. There were community service providers, which the number was increased, and mental health services were provided 24/7. And this was all considering to take care of the well-being of the staff, because the staff had gone through a lot of stress and strain and mental trauma. And I remember we had a well-being hub, a lot of trust at that well-being hub, in which there was coffee, tea, snacks available 24/7, and a lot of charities they were working towards to provide to help the NHS, and to have some quiet moments and to discuss with other people around. Just to the well-being hubs were quite popular, and the well-being support is an essential component at the moment. And NHS wants to retain that workforce, and moving towards more digital consultations now. And though face-to-face is also being encouraged now, because things are slowly getting not normalized, but improving, and integration of all these services. And are we reaching those that pre-COVID era? Yes, different opinions on this, but yes, we are going towards that. And this was what we did in brief. And there were a lot of things that we learned from them, from this pandemic. A lot of lessons to be learned. And thank you, and have a wonderful day, and enjoy the conference, please.
Thanks a lot for listening to this, actually. And this was, in short, what we did. And the pandemic is still continuing. We are preparing for the winter surge, and we are anticipating more number of patients, especially the pediatric patients coming in now. I'm happy to take on any questions and anything that anybody wants to discuss.
What are the manifestations in pediatric group, Abhinav, there?
So what is happening now is there's a announcement, there's a warning that has been issued to all the hospitals now to prepare. And most of the patients are coming now in as bronchiolitis, the small age group, which we think is RSV, and the older age group are basically school-going children. And now the vaccination has started. Interestingly, initially they were thought that the school-going children and children of less than 16 years of age, they don't require vaccination. They would be all right. But now what has been going on is they develop cough, they develop common cold, and they start transferring that to their parents and to the elderly population sitting at home. So the need was felt that, okay, they need to be vaccinated now, because the spread has suddenly increased.
They are COVID positive?
Yeah, COVID positive, sir, and fever, cough and cold, and increased absenteeism from school, to the extent that now we are not going for isolation things, because the rules have changed in the UK that anybody who's positive with vaccination does not need to be isolated per se, actually, no, which is very surprising at the moment. So the not the patient, but the relatives around, the family, they don't need to be isolated now. So yes, the fever, common cold, and cough, it is being increasingly seen now in the UK.
Hospitalization rate has increased for children.
So the problem now is because there's dual thing going on. There's respiratory RSV infection going on, and there's COVID infection going on now.
This is a season for RSV.
There's season for RSV, sir. And
there was an epidemic of RSV in New Zealand,
exactly,
in recent past.
And we have been alerted that the epidemic is going to happen again. So now every trust has been asked to prepare. So what we do when we do on calls from home now, we are asked to now stay in the vicinity of 30 minutes distance, basically, because of anticipated increased number of patients. Maybe RSV, maybe COVID. It is very difficult to distinguish at the moment, sir.
Oh. Yeah. Can I ask question?
Yes, sir. Please.
Yeah. The post-COVID, after the second wave, what sort of presentation you are getting as a chronic presentation, manifestations of the COVID other than the lung?
Right. That is very interesting, because I'm also doing the follow-up clinic as part of ICU, and it initially started as a bereavement clinic now, but now I'm seeing a lot of patients who are presenting as what we call as a long COVID syndrome now. One of my own colleagues in the department, she had COVID, and she's now she had myocarditis now, and prolonged myocarditis to the extent that she can't walk for a long distance because of myocarditis. And one of the patients that I saw had at sciatica pain actually, so she was unable to walk now, and that's prolonged neural involvement as well. We had a few patients of stroke, but they recovered very fast actually. All the stroke patients recovered very fast. All those patients who had thromboembolic phenomena, they recovered very fast. One of the patients had ophthalmology issues actually, so she's still going for her eye appointments actually. And I haven't seen any skin manifestation per se, or I might have missed it, but this has been reported.
Sorry, Abhinav, how do you correlate it to COVID? These patients anyway would have come otherwise also.
I totally agree,
How
sir.
do we relate it to COVID?
I totally agree with that, sir. Basically, the point is that because we try to, by default it is correlated to COVID, but anyway they'll go for a follow-up clinic, and then they go for a follow-up prolonged follow-up clinic. They're booked for appointments with the neurologist, and then the investigation start. But by default, anybody who had been in ICU with some complications, we try to rule it out that it is not because of COVID.
Because today morning we had a very interesting debate on thrombosis. And there was Dr. Rupen Arya from King's College, London. You know him.
Yes, I know him, sir.
And he's sort of authority on thrombosis. He's a thrombosis guy.
Yes.
And there was a huge controversy about that thrombosis is hyped. The incidence of thrombosis is hyped, and we have been having high incidence of thrombosis, thrombogenesis in sepsis. So, are we relating everything to COVID?
Unfortunately, yes, sir. because this is a new thing for us, and any new thing that comes up, is it because of COVID? I totally agree with you, sir. We are trying to correlate everything to COVID, but the only thing is, unless or until proven otherwise that it is not due to COVID, we generally treat it as a COVID manifestation. And so a new sort of clinic has come up in the UK, that is a long COVID clinic, which we refer them to long COVID clinic or other specialties as per the requirement. But you're absolutely right. It is sort of by default we are correlating everything to COVID at the moment. And thrombosis phenomena, I would say we have seen massive thrombosis phenomena, and I totally agree, could have been due to sepsis or COVID, maybe another disease which is causing the same. But yes, we had extensive thrombosis phenomena that we had seen. But having said that, I would like to mention the protocols for management changed. Now in ICU patients, we do not start routinely. We do not go by D-dimer tests. So it has been out now. So it has been strongly recommended. Do not base your anticoagulation based on D-dimer values. There has been an alert issued in all the NHS hospitals. The second thing is about to start the intermediate dose rather than the full treatment dose. And the intermediate dose is double the prophylactic dose. This is the only dose that is recommended at the moment to prevent thrombosis, if we are suspecting that. I don't know if he mentioned that actually in the. I'm sorry, I missed the presentation.
All these issues were discussed.
Yes, I'm sure he must have.
And he was very sure that long-term anticoagulation is not indicated. There is no role of aspirin. There is no role of long-term oral anticoagulation.
So the recovery trial, we were part of that. I'm principal investigator in my hospital. Is yes, no role of aspirin at the moment. And at the moment, what we are doing is after 3 months, we stop all the anticoagulation. This is what is going on at the moment.
He was in fact of the view that after hospital discharge, no anticoagulation. That's what he was recommending.
He's an authority, but the only thing is that I think it's too early to say anything, sir, because COVID is still going on.
Yes,
COVID is still going on.
Yes.
Right. Thank you. I'll have a wonderful day, and thanks for inviting me. It's a lovely conference, wonderful conference. Thank you very much.
Thank you. Thank you.
Now we'll introduce our next speaker, Dr. Tapas Sahu. He is consultant and head, Institute of Critical Care, Medanta Hospital, Ranchi, India. Dr. Tapas.
Hello, everybody. At the outset, I must thank the organizing team of W4C for having me here. Today, I am going to talk about something very interesting and thought-provoking. The outbreak of coronavirus 2019 pandemic, known as COVID-19, has created a global health crisis that has had a deep impact on the practices of all intensivists worldwide. You can see here the major lethal impact of COVID-19 2019 on the total health infrastructure as well as the lives of so many people. You can see the death number is almost more than 4 crores and the recovered are almost, you can see 21,373,5,148. The healthcare systems have definitely suffered a lot, but definitely they have shown remarkable adaptability to the challenges from this COVID-19 pandemic impact. Some of these changes will be transformative and they will impact in future also how we provide critical care even after the pandemic is over. Lessons of this COVID-19 pandemic should be viewed and taken seriously as an opportunity to better prepare for the future so that we will be better handled if there will be any other pandemic in near future. Now, the $1 million question here, why this COVID-19 pandemic is so different? The answers are very simple because the pathogen is different here and also we are dealing with the pathogenesis which is also very much different compared to the previous pandemics. Now, why the pathogen is so different and virulent? Here we are dealing with Delta variant, RO of 3.2 to 8. We are also dealing with the virus which is having increased transmissibility and also the secondary attack rate is also very high. There is also 60% higher rate of household transmission than its predecessors. Here, we are also getting critically ill and immunocompromised patients. Those continue to shed viable virus for a prolonged time so that the infectivity continues to be prevailing for a long time. There is also, most importantly, significant risk of contracting the virus for the healthcare workers. Now, in short, we are dealing with critical care which is having increased chances of unwell. In short, ICU. That's the reason. Now, it's the lungs, which is the most important organ to be affected with S2 receptors in the alveolus, in the epithelium. And finally, we are dealing with severe ARDS if the patient is deteriorating fast. You can see the picture that ARDS is the most prevalent concern for all of the intensive care professionals. Now, coming to the pathogenesis related, yes, it's not only ARDS, which is the more worrisome for all of us. Also, S2 receptors, the presence of S2 receptors in the different other organs can present varied in the patients like dermatologic, neurologic, GI, renal, heart, liver. And finally, we are getting something varied presentation due to COVID-19 disease. Now, let's discuss what are the changes and the effects of COVID-19 in the critical care arena. In the label of the healthcare workers, you can see very interesting article published in International Journal of Infectious Disease 2021. Up to 51% of healthcare workers tested positive taking care of COVID-19 patients. Very worrisome. And the risk ratio of contracting the infection was more than twice for the healthcare workers working in the intensive care setting. And you can also imagine the level of the depression, anxiety, peri-traumatic distress, and also low well-being also higher in the ICU staff compared to the other healthcare workers. Now, here, there is also a very high impact on the healthcare facility along with the healthcare workers. 1 in every 5 COVID-19 patients are expected to require some degree of ICU support, and more than 50% of such patients may require invasive ventilation. So definitely the healthcare facility were also challenged to a great extent due to this COVID-19 pandemic. Now, very worrisome and thought-provoking. What are the effects of like this COVID-19 and the impact on the environment? Now, you can see the majority of the medical waste which is going to be generated from the acute care areas, including ICUs, will have great impact on the environmental, like you can see the future of like the green effects, what we are now going to have. Multiple intensive care societies, they have expressed their concern regarding judicial use of PP and their dumping, how we are dumping this waste. And medical waste management is going to be one of the biggest challenge in this pandemic. Very worrisome. Triage of patients. The current pandemic has definitely posed a significant thought provocation about use of a suitable triage criteria and method for critically ill patients who needs to be admitted to the ICU facility. Definitely, it's not so easy. We are getting so many patients, and how to triage the patients as per their severity, as per their criteria to be taken in the like acute care area, to be taken in the HDU, to be taken in the wards. So there are suggestions to have a coordinated system-wide delivery model. And this can be best achieved through local and regional command centers. That is a centralized approach that can facilitate rapid responses while balancing the competing resources and the pressures. Now, coming to the triage of equipments, yes, as this disease is affecting respiratory system predominantly, so resources should be invested on the equipment and also facility pertinent to the respiratory support, such as different ventilators, maybe it's invasive and non-invasive, high flow oxygen equipments like HFNC, availability of ongoing and increased surge requirement of oxygen, etc. We need to have safe clinical practice because it's ultimately the healthcare workers, their life is so precious. So multiple societies have published their guidelines for safe procedural environment in ICU. And the primary message transmitted is self and co-worker safety. And we should and we must keep the protocol breach to be zero. PP availability, supply and disposal. Yes, the aim is optimal safety of the healthcare workers. So we need to have formulation and following standard protocols and ensuring adequate PP in our healthcare worker facility. There should be anticipation of requirement for PP in case of a surge. There should be continuous supply and storage, as well as we need to have segregation of medical waste at the site of generation. There should be also stringent waste segregation plan from the hospital or healthcare facility should be placed in action rather than only in the papers. Definitely, the surge of telehealth facility has taken place during this COVID-19 pandemic, and it will continue to provide good quality care in case there will be any further future pandemic. The advantages definitely we all know: minimize contacts and limit of spread of infection, major cost saving. There will be also the development of remote ICU concept, and simulation-based learning and education have added value to the surge preparedness of this type of pandemic. We need the rapid and free availability of research data. Definitely after this COVID pandemic or during this COVID pandemic, we got the different the search engines providing us free research data, because the use of large volume retrospective data and the inference done using artificial intelligence systems definitely will help us in making the better care to the patients at the bedside, not at the bedside only. And there will be proactiveness to share the clinical data and enroll into available research opportunities so that we can have robust data and registry and also good clinical guidelines to better prepare the healthcare workers. End of life care, yes, there should be timely end of life care discussion to ensure dignified dying, decrease the family distress, mitigate the workplace burnout among the healthcare workers, and also appropriately allocate the resources. ICU infrastructure and restructuring definitely has a great place in the current COVID pandemic, and that will change the practice of ICU in case there is a surge situation. And we need to have clinical communication in a better way, both non-verbal communication, verbal communication, empathy, reassurance, spiritual support. Be truthful, be consistent, be paced, listen to the family, show empathy, and psychological support for the staffs also. Now, staffing, mental health, staff well-being, burnout, fatigue management, really we need to have a better care of these things, because mental health aspects of the healthcare workers should be of prime consideration, and there should be support groups and measures need to be in place before the future surge. There should be also surge capacity planning and resource allocation. There should be validated mathematical models to estimate the volume of possible surge, and that will equate with the available and expanded resources. The resource consideration should be both at the level of material and manpower, not only material. And definitely there is a great role of epidemiologists to look at the pattern of spread, the infectivity, pathogenicity of different variants of current virus to be able to identify and act early. So it is just the beginning, because the lesson learned from the COVID-19 pandemic should not just be the contingency planning for times of stress, but should also reflect new habits that will stand us in good stead when future disasters hit, whether it's a high-threat pathogen or a non-infectious multi-casualty events. Definitely, we are now better prepared. Maybe in future, there will be proper guidelines that will allow us to practice this type of change of ICU practice in a better way. Thank you. The best is yet to come. Have a good time. Stay safe.
If there is any questions, you can take it. You're muted.
Nice presentation, Dr. Tapas.
Thank you, ma'am. Thank
you. Our next speaker is Dr. Suhasini Tirumana, HOD Critical Care, SNG Hospitals, Hyderabad, ex-professor and HOD Critical Care, NRI Medical College, Guntur. Dr. Suhasini.
Good afternoon, everybody. At the outset, I would like to thank Dr. Rumta and the team of World Conference on COVID Critical Care to have included me in this great meeting, and then I'm very thankful to you all. Integrating COVID and non-COVID care is the most important and very difficult task like Dr. Rumta has given me, and I think I will try to share some of my ideas today for integrating the services provided in COVID and non-COVID ICU care. And introducing the subject, the global outbreak of COVID-19 has been unparalleled in history. Its scale of coverage, the speed of spread, rate of fatality, and varied uncertainties, it has shaken the entire world. The unexpected repercussions of the pandemic is an accentuator of the pre-existing inequalities in the healthcare worldwide. And it also resulted in creation of multi-layered disruptions, inequalities at the structural, societal, and individual levels in the healthcare. So it's a great pandemic which has affected, really shaken the world. And it also had some collateral damage, heavy toll on the non-COVID healthcare. So this is very important, like, the people who are not affected by COVID have been suffering the most. So there was, the claim volumes fell by 64% in the early lockdown period. In all the PMJ utilization has declined by 64%. So the health utilization by the non-COVID patients has also tremendously come down. And also the TB notification was about 85% lower. So the healthcare for the others has been suffering a lot. And the economy in the other sectors also, there's a great drop in the GDP. It has got a great adverse economic impact. And the economic cost of COVID-19 in India has been surpassing even China, where the COVID has gone. So this is a great, problem, like all our GDPs have fallen and the poverty rates have gone up. And also it's impacted education, tourism, hospitality, and trade. And definitely the hospital services catering to the other patients has been affected greatly. And thankfully, we have come back to the non-COVID, the decreasing number of cases and then per se, and we are able to admit patients who are non-COVID in increasing numbers. And so we have to cater to the needs of the non-COVID patients too. And the disruption of healthcare delivery system has been very much challenging in India. And because of the primary focus on COVID-19 patients and the incoherent non-COVID protocols. And here, the outbreak has pulled up the essential services and resources away from preventive activities for regular healthcare services through restructuring of the public health services, reorganization of the hospital facilities, and redeployment of the existing staff, leading to cancellations, delays, and disrupted treatment. So it has impacted also the OPD basis and other services in the hospitals, private nursing homes, and then private clinics with negative consequences on non-COVID patients in India. As the COVID-19 caseload increased, the adverse impact has become very much bigger. And during the initial phases of lockdown, the diversification was great, and then it resulted in all the normal services coming to a halt. And it had a great impact on pregnant women and non-communicable diseases patients who needed immediate services. So health seeking was also deferred because of the social and physical distancing requirements and the community reluctance owing to the perceptions that healthcare facilities may be infected. So this had a great an impact on the patients not coming to the hospitals at all. And later, these deferrals, in the initial periods of the pandemic, this resulted in later increasing in the later hospitalizations requiring higher levels of care, longer lengths of stay, and increasing the hospital readmissions, thereby further straining the hospital inpatient capacity. So therefore, it is critical that now we not only focus on the COVID areas, and we also have to manage the patients with without COVID, and particularly those with time-sensitive and medically complex conditions who are postponing their care. So it's important not only to sustain life and health, but also preserve future hospital capacity. That's our utmost responsibility. And to maintain the people's trust in the health system to deliver essential health care is also very, very important to minimize the increase in mortality and morbidity from other health conditions. It has been shown in the Ebola outbreak that deaths due to other conditions have surpassed than due to Ebola breakdown per se. So interruptions in the healthcare delivery systems were great in some subpopulations, and while ensuring the safety of the healthcare workers, we have to definitely maintain the trust of the people to increase our healthcare facilities for them. And the ICU challenges are simultaneously on multiple fronts, and it is very important that we address them. And as we understand, the resource limitations, improper infection control, protection of the healthcare workers, and adaptation of the services to rapidly evolving pandemic has all had a great impact on the delivery of the effective healthcare for non-COVID patients also. So in the early outbreak, we have seen a lot of deficits, like ventilator deficits, and the ICU resources were down, spiraling, which led to a lot of problems. And maintain sustainable healthcare services is very, very important for all healthcare systems, particularly even during the pandemic and after the pandemic, to sustain services to COVID as well as non-COVID patients. And for this, we need to prepare and implement rapid identification and isolation protocols and be prepared for the surge in the bed capacity. And to provide a sustainable workforce with a focus on the infection control is a major factor, because the workforce, the staff, initially they were very scared of getting the infections for them, and they used to leave the jobs and then go away to their hometowns and then never return back. And some of them, for the fear of getting infection, and apart from them, slowly they started to come into the work. And initially they are greedy for the money, and then so focused on the COVID care, and they were ready to work in the COVID, and nobody was working in the non-COVID. And again, there was a great strain on the non-COVID side. And subsequently, when the workforce, the number of cases of COVID have come down, the workforce started to go slowly dwindle to the non-COVID. But again, with expectations, lot of expectations. And then we have to support them at this time and encourage them to be ready for the pandemic, coming up again. A number of cases are increasing slowly. And adequate supplies to equip the ICUs is very, very important. And not only that, we have to equip the ICUs, and the working condition of the equipment is also very, very important. While ensuring supplies, it has to be very much planned, and the non-availability of the supplies was a great factor during the COVID period. Again, increase the supplies, manufacturing, and then to get by them, again, it costs a lot. We have to see that all the ICUs are equipped properly, and maintain quality clinical management. It is very, very important that we follow effective protocols, and then the quality management for the better delivery of the healthcare, and also as well as effective communication between the patients and amongst the staff working in the ICUs is also very, very important. And apart from that, protection of the healthcare workers, and then the psychological support we give to them is very, very important for them to participate in the healthcare services without any fear, and to give them a big hand, give them support, give them accommodation, and looking after their health, and then the leave patterns is very, very important. Adaptation of the services to rapidly evolving pandemic is a order of the day. So we have to be prepared for the worst scenarios and get there. And this is a MOH that Ministry of Health and Welfare, guidelines which have been followed everywhere, and wherever there is a new case, and then suspected, and then non-suspected, and they are distributed to the COVID facilities. And this is a plan. Most of us follow the 2-zone plan, where the patients are put in standard zone, and then COVID-19 zones the hospitals are divided into 2 zones. And the standard zone caters to the non-COVID patients, and who are do not have COVID symptoms at all, or not high risk for COVID. And COVID-19 zone is the primary mission is to provide a safe care of acutely confirmed or suspected COVID patients, or those with high-risk COVID exposures, whether the condition relates to COVID or not. So this is definitely important, totally the areas are segregated, and the employees usually do not cross over between the units, and the traffic routes will usually separate, and the employees and patients in the standard hospitals must be screened for signs and symptoms of COVID-19 infections, though they are segregated totally. But if symptoms occur, or they become positive, they must be immediately transferred to the COVID-19 unit. And in some instances, a standard unit can be converted to COVID-19 based upon the suspected widespread exposure inside that unit. Could be from an infected healthcare employee. And the visitors should be restricted and encouraged not to use face-to-face methods to communicate with the loved ones. These can spread the infection definitely. And there are some protocols or the suggestions made by different business schools, where the Harvard School is one of the best schools, and they say how to cope up, how the hospitals can meet the need of the non-COVID patients during the academic. And they worked up, and then they said they tried to focus on 4 factors, 4 phases of management. So innovative outpatient management to reduce the demands at the downstream bottlenecks. They said you should be using more telemedicine, and also allow the patients who are at risk for needing inpatients should be admitted, and triage the patients definitely at the EDs and then or emergency and OPD basis. And then future, so use telemedicine as much as possible to screen the patients, and have protocols at the emergency department to screen the patients thoroughly and then admit the only needy ones. And combine essential non-COVID patient services across the hospitals. So this is very important, when we pull up the health scheme, there's location pooling. So cater some hospitals to non-COVID patients and only some hospitals to COVID. We can segregate the cases, as well as the same time utilize the workforce to the maximum. And then group hospitalized COVID-19 patients with underlying clinical condition. So if you group them together, patients COVID with heart conditions or with the trauma or with some other problems, then if the group, they can get the best care, and so that the patients can be the best looked after with the specialists in that particular area. And discharge the patients into post-COVID area based upon the COVID-19 status. Once the patients become COVID negative, or the patients are past more than 15 days, they can come back to non-COVID areas, and then they can be catered to for the long hauls and all that. They take a long time. Maybe this is a good plan, so that they can not spend so much of money, as well as patients can be at the same time best looked after. So this is a conceptual model of operations management suggested by the Harvard Business School, where you can see the emergency department where the screening is done, and then the hospital is again the hospital 1, 2, 3, where they cater to different units, and then the wards are again divided into COVID wards, and then where the COVID patients are grouped into cardiology, geriatric, and then trauma, pulmonary surgery. Subsequently, they discharged according to the COVID-19 status. They're discharged into COVID ICU care, or post-COVID ICU care, or non-post-COVID ICU care. And the challenges to this model is the timely, there's access to the COVID-19 testing, and the rapid test results to guide appropriate routine care. And to prevent discharge delays due to testing constraints, and the hospital needs to implement these policies widely. And the post-acute care facility should designate quarantine areas to receive the care while awaiting the results. And this is very important. We have to have places in the hospital where they can be safely looked after. If suppose a suspected patient turns positive, that's okay, they can stay. If they come negative, and it will be a great mental trauma for the patient. So we have to have separate quarantine areas in the hospital. And the role of telemedicine. Telemedicine has been revolutionary in critical care, and the number of beds versus practitioners are very scanty, both in India and USA. We can see from here. And then the telemedicine has come a big way, to cover up for the physician shortages, where it is very difficult to recruit enough intensivists to staff the ICUs properly. And also the demand is increasing on the ICU, where the aging population is increasing. And then the pandemic has highlighted the need for to protect the providers also, to avoid exposure and to continue to treat patients. And then you can have the high demand, not enough supply, and there's a burnout in the physicians, amongst the physicians, and rapid acceleration with the adoption of technology like mobile phones. And the consumers are also demanding for better healthcare in So even in a hospital where intensivists are present, supplemental tele-ICU coverage can offload some of their work, allowing them to gain visibility into what is happening across the hospital and leverage their own skill set more broadly. So this happens when the senior intensivists are especially present, and they cannot go physically to the ICU where they can immediately cater to the patients, either COVID ICU patients. Then the telemedicine will come up in a big way to give the suggestions and see the patients on the screens and then give them. So it is very useful because only with meager, one intensivist can cater to 50 to 80 patients on multiple locations at a time. So it's a great value when a senior physician is sitting and then advising the juniors, and then it has got great outcome benefit. And these outcomes are depicted in terms of lower mortality, shorter length of stay, and more efficient output, and reduced cost operations, and then reduction in the clinician burnout, and a major margin burnout. And also this Pradhan Mantri Yojanas, the PMJ also has recommended the utility of this telemedicine for being utilized for accessing more number of patients by the intensivists, and then providing best care for the patients when it is possible. And so definitely it is a great recommendation which is made by the PMJ. And then the COVID-19 response, again, this is the Providence telehealth. This also has been proved that they said, they divided the phases of illness into 3, and then the normal phases come, they said investment in models of care and payment models of scale, and a proactive talent strategy, and prepare for future crisis. And there is a flexible and plans which are have to be proposed, and then up and down based upon the need, and then divide the growth through affordability, convenience, and new models of care. So this has been proposed by the pioneers of telehealth. The Providence is supposed to be the pioneer of telehealth, and they have proposed these the models of care. Definitely these would help in the future care. And then in India also, again, we have service delivery innovations, 7 shifts accelerated by COVID-19, where the care should be distributed to all places, including community and patient health care. And then the care should be connected, and it should be continuous and human-centered, decentralized, and then collaborative and responsive. The public-private partnership has been encouraged in these cases, so that we can adopt to more effective healthcare and then help the needy patients. And then in here, these are very important. So, coming to the conclusions and the key points, we cannot deem that only COVID-19 response as essential and treatment for other diseases as non-essential. And equal focus is required for both COVID and non-COVID patients. And the 2-zone plan works definitely for most of us. And then the inclusion of telemedicine is definitely allows the physician to advise on non-ICU physicians in the community hospitals, help to provide better care of the patients. And to function appropriately, intensive care units need space, staff, and then the staff, which is very, very important. To balance between these space, staff, and stuff needs to be maximized if surge occurs. And this is very important. We have to have a protocol-based approach in terms of staff, in terms of beds, and in terms of staff. Everything has to be protocolized and supplied to the needy persons, be it in the COVID or non-COVID, has to be done for proper service provision to both COVID as well as non-COVID patients. And strategies for creating staff capacity, including using physician extenders to provide critical care under the supervision of ICU doctors, and expanding staff through recruitment from outside organizations also is very, very important, for us to cater to the needs of the needy when the surge occurs, suddenly, as we have seen in the second, wave. And in here, slowly in the third wave, the cases are increasing, and hope, we are now in a good position to cater to all the needs. And then the flexibility of the care is adoption, which has been done, and all the flexibility has been done in terms of space, staff, and staff. So thank you all very much for the patient hearing. And this is the way, we think we have to integrate the COVID and non-COVID services so that we can do the best for the non-COVID too. Thank you.
Thanks a lot, Swasni ma'am. You've really spoken very well about how to integrate between COVID and non-COVID care, because in our hospital also non-COVID patients suffered a lot. They brought me also even. Thanks a lot for telling the guidelines for it. Very nice presentation, ma'am.
May I ask a question to Dr. Suhasini? Dr. Suhasini, this is Dr. Rungta. Can you hear me?
Ma'am, please unmute yourself. You're muted.
Yeah. Good afternoon, Dr. Rungta.
Good afternoon.
Namaste.
Namaste.
Yeah. How are you all? Dr. Jaiswal, I can see.
Yeah.
Dr.
Thank you.
Nipun. Thank you very much for the opportunity you gave me.
No, you are most welcome. And
really wonderful. I'm sorry.
Your presentation was outstanding. Do you?
Thank you very much for your.
Have you translated all these recommendations in your hospital and ICU?
Yes, we did it segregation and then flexibility. We send our intensive care people to the COVID ICU also and give them an off so that they can instead of monetary remuneration, we give them an off and then we make them work there also. And sometimes you're getting outsourced.
My question to you is direct, Dr. Suhasini.
Yes.
Do you think that separating COVID ICUs, not only COVID ICU, if we have another pandemic, say, in near future, is it sustainable model to separate ICUs for COVID, separate ICUs for H1N1? Is it sustainable in long
Definitely,
run?
We have to, at least, if not, we have to separate them physically. Definitely, that is must. Otherwise, people, the non-COVID patients are getting scared to get into the ICUs per se, to get admitted. They're asking prior, whether we have COVID cases on board or no, before they get admitted in the first place. So we definitely have to segregate them and show them they are separate for the non-COVID patients to be safe, and as well as for our safety also, doctors' safety also. As much as possible, we have to separate them physically. And maybe in the long run, if all the hospitals come together and we can identify separate hospitals as COVID and then non-COVID hospitals are different. And so we can in unison work together to get over the pandemic. That's one way we can do. But in a hospital, I feel it is a must to separate them physically. We do do it in our hospital. Thank you very much, Dr. Nirma.
Yeah, Suhasini, it was an excellent presentation.
Thank you very much, Dr. Agarwal. Thank you very much. Thank you.
Hi, Nirmal.
Sir, very good afternoon.
Very nice to see you.
You are amazing. Nothing, no word other than that. You are amazing.
Because I am your elder brother, you are saying so.
No, just amazing, just amazing. I am really enjoying.
Thank you. Bye.
Now we will introduce our another speaker, Dr. Mayank Vats. He is interventional pulmonologist, adult pulmonologist, intensivist and sleep physician, Rashid Hospital, Dubai Hospital. He is associate professor in Dubai Medical College. Dr. Mayank.
Good afternoon, all. First of all, I would like to convey my thanks to the organizer of this COVID meeting. I would like to convey my regards to the chairperson, panelists, and all the audience. I'm Dr. Mayank Vats, working as a consultant pulmonologist in Rashid Hospital in Dubai Hospital. I'm going to present UAE model for COVID-19 management, which is a standard model for management of COVID patients. United Arab Emirates, which is called as UAE, is a newly developed countries as compared to other developed European and rest of the world countries. But they did a great job and is doing remarkable great work to combat the infection and contain the death rates attributable to COVID-19 as compared to top 15 worst hit countries globally. The first case of COVID-19 in UAE was detected on January 29, 2020 by Ministry of Health. Since then, UAE government has signaled the high alert for COVID-19 and formulated an effective and practical strategy at maximum pace to mobilize all resources and employed all stringent measures throughout the country to curb the COVID-19. UAE took immediate multimodal approach with synchronized involvement of ministry, government, institutions, health sector, private companies, social organization, and public support. In coordination and as per the directive of all the concerned higher authorities in the countries like Ministry of Health, Dubai Health Authority, Abu Dhabi Health Authority, and took all the necessary precautions in accordance with the scientific evidence, scientific recommendation, and the standards approved by the WHO and recommendation of international and local experts. I'm going to present comparative global data of number of cases as per the Google data, World Infometer. The total number of cases, United States ranked number 1 with 45.3 million cases. India is second, 34.1 million cases, and Brazil is 23rd with 21 million cases. If you see the UAE data, they had only 739,000 of cases. If we see the number of deaths, United States had 733,000 deaths, India had 450,000 deaths, while in UAE only 2,126 deaths were reported. Only 94 new cases detected in last 24 hours, and last 24 hours only 2 deaths have been reported because of chronic those patients who had chronic COVID. If we see the calculation as per the 1 million per million population, United States had 137,000 cases per million population. India had 24,000 cases per million population. UAE had 74,000 cases per million population. However, the death rate was only 215 per million population as compared to death rates of more than 2,000 in United States, around 3,000 in Brazil, and in United Kingdom more than 2,000. The mortality rate due to COVID-19 is very low in UAE compared to global data due to extensively timely efforts taken by the UAE government, which I am going to summarize in the following slides. First of all, governmental strategies. As soon as the COVID outbreak happened, they allocate huge amount of funds, which was around millions of dollars, immediately in order to mobilize and carry out all medical services to the best benefit of the residents, irrespective of expats and citizen status, to save every life, because they believe that every life is precious, equally precious in UAE. They took timely effective lockdown of all the non-essential services like schools, shopping malls, shops, marketing, cinema, public parks, public places, etc. They formulate and implemented functional, effective strategy at all levels and in all ministry departments in order to treat COVID-19 and prevent chain of transmission. This factor was very important to prevent chain of transmission. They started countrywide sanitation and sterilization program on the regular basis. Strict and lawful social distancing, stay home, lockdown protocols, closure of school, online education, and many more standard infection control practices were carried out. All government and private organizations employees were encouraged to do work from home, especially for the non-essential and non-emergency services. Provision of all basic health facilities like food, sanitation, health checkup, COVID screening, and other facilities as needed for the special areas of need. And if there was any outbreak of COVID, then to completely isolate that area and contain and seize to prevent transmission of corona till the time all residents of that particular area were screened and declared free from corona. So this was also a very important step to control the infection in that particular localized area. The main motive of the government was to educate to bring awareness among residents to reduce COVID-19. What were the administrative strategies taken? They made availability of ample number of trained, dedicated doctors and nurses and paramedical forces. They developed a centralized COVID crisis and disaster control committee and command centers to triage patients effectively and smoothly and prompt and efficient response by them. Acquisition of other private hospitals, government hospitals, and their medical manpower to take care of COVID-19 patients. Many tertiary level of care hospitals were taken over by government to provide best standard of care. Immediate arrangement of the most important medicines and equipments like ventilator, PPE, and to make sure their regular uninterrupted supply so that there should not be any delay in the care of the patient. Infrared thermometers and temperature scanners were established at all public entrances, including hospitals. There were continuous amendments and upgradation and implementation of the treatment protocols and policies of the COVID-19 patients based on the global evidence and the emerging new scientific literature in last 2 years about the pathophysiology of COVID, and learning from global experience with the expert opinion of local experts and modification of these policies on time-to-time basis as per the local environment in best care of patients with the target of a lowest morbidity and mortality and lowest transmission. The most important part, they provided free diagnosis and free treatment to all COVID-19 or suspicious COVID-19 patients. They took huge steps for the safety and care of the healthcare professional. Regular screening of healthcare professionals were done who were directly or indirectly involved in the care of COVID-19. So the asymptomatic healthcare professional can be detected earliest in order to avoid hospital spread of infection. Provision of quarantine for all the doctors and nursing staff and paramedical staff in hotels with provision of all facilities and to take care of their families so that their family members do not contract infection from them, and provision of isolation facilities in case any healthcare worker got the infection. Full adequate supply of PPE and all equipments needed by the healthcare professionals are available. They opened a unique, one of its kind, state-of-art, well-equipped 3,000-bedded field hospital within a short period of 7 to 10 days, having all the facilities so that the patient will feel at home, having facilities such as entertainment, indoor sports, so as to keep COVID positive stable patients happy. Apart from this, they deployed robots in field hospital so as to avoid contact of healthcare professionals with a COVID patient. Another 1,200 bedded hospital, including availability of doctors, nurses, and paramedical staff, was developed, and many other hospitals were also taken over by government to exclusively serve for COVID patients. To hire new doctors, nursing staff, medicine from India proactively in order to increase the workforce, and local hiring of nursing staff and medical doctors, anticipating the magnitude of the problem and keeping all the steps ahead of the situation so as to keep the situation under control in case of any worsening of the number of cases. Implementation of telemedicine services, online consultation, temporary suspension of OPD, all elective surgeries. Only emergency surgeries were allowed so as to avoid risk of hospital-acquired COVID infection to non-COVID patients. Early detection and prevention of COVID-19 transmission was the most important step what they took. They carried out widespread screening, mass testing strategies. They developed highly sophisticated quarantine and isolation facilities. UAE recorded highest number of people screened as compared to any country worldwide. either in absolute number or number of tests done per 1 million population, and they carried out immediate management of those who are COVID positive by providing isolation facilities. They established many fever clinic, flu clinic, ILI, ILI clinic in tertiary hospitals, private hospitals, and PHCs in order to screen the patients. Opening up of many national screening centers in UAE at every easily accessible place, drive-through screening centers, so that all the residents, especially those who have history of contact of COVID or have symptoms, could be screened early as possible and can be quarantined or isolated. So this early detection and prevention of COVID-19 patient was the main focus, so as to avoid the transmission in the community. Suspension of flights in and out of the country, sanitation drives in flight and ships, health awareness campaigns through social media and paper media, control of air and ship traffic, and regular screening of the recent travelers who came to UAE at the start of pandemic. They withhold all the international flights and shipping so as to prevent new cases coming from other countries. They developed 24/7 efficient and dedicated support system, hotline number for the people, so they can directly contact the health department to get medical advice. They deployed ambulance services to pick the patient from their home and to drop at the isolation facilities so as to avoid the transmission of infection when the patient is traveling from his home to the hospital. They provided ample moral support for the frontline warrior. The government was very empathetic and emotional, and by time to time they appreciated frontline warriors and honoring them through all channels, including TV, radio, newspapers, mobile, SMS, etc., which gave the frontline warriors a consistent motivation and perseverance to boost their morale, to do their work in best possible way, and also providing them help and guidance at each and every step. They appreciated the efforts of doctors by providing 10-year golden residence visa. Many private companies came forward to support the COVID frontline warriors by offering them benefits as a token of respect on their services. So all cumulatively showed that we all are together in the fight against COVID. And this was the logo, this was the main slogan in the UAE. We all are together in fight against COVID. They provided humanitarian aid by arranging food, clothes, shelter, and other basic need for living. They arranged free video call, opening of free communication channel so that the people can get connected with their family back home. And for the areas which were badly affected and suffered a complete lockdown due to a small outbreak, they provide millions of meals, and many charitable organizations also work with the government to accomplish this goal. A special arrangement of flights as soon as possible was done to repatriate stranded visitors and residents in a full infection control way. A recent survey has revealed that UAE is among the top 10 countries in the world for COVID treatment, according to global ranking. The survey was done by the Deep Knowledge Group, a consortium of technology companies and non-profit organizations. They considered 200 data points, and they declared that UAE is ranked among top 10 countries for the containment of the COVID. The COVID-19 treatment efficiency ranking framework assesses countries based on the sophistication and effectiveness of efforts to monitor the spread of the virus, treatment of patients, in addition to the capacity to develop, test, validate, and deploy experimental vaccine and treatment. The data came from sources including the WHO, Johns Hopkins, in addition to overall economic and technological development. UAE has dealt with the pandemic professionally, demonstrating the country's readiness to deal with such a crisis. This has led to a reduction in the number of persons infected by the virus in the UAE, a state in which more than 200 different nationalities lives. The effectiveness in dealing with the crisis confirms that the UAE achieved high ratings in various fields, not by coincidence, but through determined efforts and careful planning. Another important aspect, UAE has world highest COVID vaccination rate. If we see, 86.7% of the population has been fully vaccinated, and 96.7% of the population has received first dose, at least first dose of the population. If we see the worldwide data, only Maldives has 93.8% coverage of the vaccination, while the overall vaccination coverage worldwide is only 37%. In UAE, 86.7% population has got complete vaccine, and nearly like within a month or so, they are going to complete the 100% accomplishment of the vaccine. So I would like to conclude that UAE has done its best to combat the COVID-19 and the coronavirus prevention. And in fact, UAE succeeded in control of COVID-19 to a significant degree with its multimodal approach, even better than many other developed countries. I recommend that this approach should be adopted by all countries where COVID is still not under control. Thank you very much for patience for listening, and welcome to Dubai.
As he is not available, we can move to the next session.
Good afternoon, everyone. I welcome you all on the third thematic session of the World Conference on the COVID and Critical Care. And the chairpersons for the sessions are Dr. Ruchira Khanse, Consultant Critical Care in Medicover Hospital, Nasik; Dr. Archana Agarwal, Associate Professor of Department Anesthesia, SNMC, Agra; Dr. Mihir Gupta, Anesthesiologist, SVIMS, Agra; Dr. Anurag Yadav, Senior Residency and Teaching, Faculty in MAMC, LNJP Hospital, New Delhi; Attending Consultant, Neuroanesthesia and Critical Care, Medanta, Gurgaon. Now I request the chairpersons to carry the session forward. Thank you.
Dr. Ruchira, can you?
Good afternoon, everyone. So let's begin with today's first, this thematic session 3. We'll begin with bronchoscopy in COVID ICU by Dr. Suresh Kulwal, sir.
Bronchoscopy in COVID ICU. Now, all guidelines suggest bronchoscopy is relatively contraindicated in COVID-19, or it should play a limited role in diagnosis and management. Elective bronchoscopy should be avoided for at least 28 days from onset of infection. But still, there are certain situations where you need bronchoscopy in ICU. Now, it is different than the bronchoscopy in ward or bronchoscopic suite because patients may be unstable hemodynamically and may have one or more unstable organ system. So, high-risk patients for the procedure. Critical care issues are different, like time available is very short, always there is an urgency. ICU are more crowded with other monitoring and therapeutic equipment, so little space for the bronchoscopist, and certain ancillary devices like fluoroscopy is not available. There are more chances of iatrogenic hypoxemia and respiratory failure in critically ill patient. Now, bronchoscopy is one of the highest risk procedures in COVID patients because of aerosol generation and disruption of airway mucosa. There are chances of infection to the medical personnel due to close contact with the patient. Coughing and suction can produce significant amounts of droplets or aerosols, which is contaminating equipment, procedure room, and all personnel present, and even there is higher risk of patient-to-patient cross-infection. What are the therapeutic indications of bronchoscopy? Airway management. When there is difficult intubation, that is, anesthetist has tried for 10 minutes or more than 3 trials he has done, then the endotracheal intubation can be done through bronchoscope and nasal intubation is preferred. You can visualize the distal end of endotracheal tube. You can change or replace the endotracheal tube if the tube is blocked or you want to replace it with a higher number. Placement of the double lumen tube in case of the hemoptysis and monitoring of laryngotracheal injury caused by long-lasting endotracheal tube. Guiding percutaneous direction tracheostomy to avoid injury to the posterior wall. So in this situation of the airway management, bronchoscope can help. Now, emergency intubation should be avoided as far as possible. Awake intubation should also be avoided, and nebulizers for local anesthesia should be avoided as this may aerosolize the virus. Staff should be limited to those essential for the procedure in order to reduce the exposure. Now, most experienced operators should perform the procedure and limit bagging during the pre-oxygenation phase and again after the endotracheal tube is placed. Now, placement confirmation should be done by ETCO2 and observation of the equal chest movements. Auscultation should not be performed and chest access should be avoided if possible. Now, in case of massive hemoptysis, you need bronchoscopic to instill chilled normal saline or adrenaline or hemostatics locally. And for placement of the double lumen endotracheal tube or Fogarty balloon catheter, you need FOB. Endotracheal, endobronchial electrocortical laser therapy or cryocorty in case of the massive hemoptysis can be done through FOB. And also the FOB can localize the site of bleeding before bronchial artery embolization. Now, this is very common indications of fiber optic bronchoscopy in ICU. There is aspiration of mucus plugs and secretions causing volume loss and atelectasis, and hypoxemia is an indication for urgent FOB in these cases when these cases are refractory to the vigorous chest physiotherapy and suctioning. Now, this is especially true in occasional mucus impaction in some COVID-19 patients. Also, it may identify bronchial migration of endotracheal tube as a cause of collapse. Now, sometimes there may be gastric aspiration, and aspiration of the food, even if the pH is more than 2.5, can cause significant pulmonary damage. And with FOB, thick food material can be removed by washing and aspiration. Now, if there is foreign body, then it becomes an urgent indication for FOB, and this foreign body can be removed through bronchoscope using Dormia baskets or rigid bronchoscope. Now, what are the diagnostic indications of bronchoscopy? Bronchoscopy in COVID patients should only be
considered if the nasopharyngeal smear is negative 2 times and clinically there is still diagnostic uncertainty of COVID-19 infection, or other diagnoses are considered that would significantly change clinical management. Associated bacterial, viral, and fungal co-infection can be easily identified by direct sampling, as well as the mycology galactomannan in these samples in these patients by FOB. The ventilator-associated pneumonia occurs in more than 30% of the patients, and accurate sampling can reduce unnecessary antibiotics. Now, in immunocompromised patients who are not responding to empirical antibiotics and are test negative for the COVID-19 and have no other diagnostic means available, then urgent bronchoscopy within 1 to 2 days may be warranted. Now, if the bronchoscopy is performed for diagnostic reason, the BAL only is recommended, and other procedures like transbronchial biopsy or needle aspiration should not be performed in the same time. In cases of suspected lung cancer, bronchoscopy should be performed if delayed diagnosis can cause poor outcome of the cancer, and also if the tumor is responsible for causing lobar collapse. Now, how you do bronchoscopy in ICU? The bronchoscopic should have direct observation of the monitor. You should be monitoring all the equipments. In non-intubated patients, it can transnasal route is preferred with additional use of slotted mouth and nose protector for the patient. If the patient is intubated but not on mechanical ventilation, then FOB can be done through endotracheal tube or tracheostomy tube. If the patient is intubated and on CPAP or SIV, then you can discontinue mechanical ventilation for a short time. And if the patient is on mandatory ventilation, then T-tube connection or CVL three-way adapter is required. Now, only essential personnel should participate in this high-risk procedure, and visitors and students should not be allowed to be present in ICU. Now, staff should wear the full protection, and they should wear the PPE, and general anesthesia with muscle relaxant is recommended in COVID-19 patients to reduce aerosol production, and enough should be tried to reduce the cough as far as possible in these patients by under general anesthesia or by giving dexmedetomidine or other cough suppressants. Now, one should avoid devices that produce aerosol, including nebulizers or atomizers and high-flow nasal oxygen during bronchoscopy. And open tube rigid bronchoscopy and jet ventilation should be avoided, and also avoid repeatedly removing and reintroducing the bronchoscope. Now, certain adjustment has to be done on if the patient is in ICU. Like endotracheal tube should be at least 8 mm for adult fiber optic bronchoscopy, which is having outer diameter of 5.6 mm. Increase FiO to 100% 15 minutes before, during, and 1 hour post FOB. Now, consider increasing tidal volume or inspiratory pressure by 20%. Discontinue PEEP or maintain below 8 cm. Also monitor axial tidal volume and airway pressure, monitor SpO2, monitor hemodynamics, and monitor ECG. Now, if the patient is on veno-venous ECMO support, anticoagulation should have been stopped a few hours before the procedure, and clotting time should be tested before the procedure. Platelet should be at least more than 50,000, and BAL may be performed in these cases. M1 FOB can be done if the patient is NIV and hypoxic patient is there in ICU. Then it can safely undergo bedside diagnostic and simple therapeutic bronchoscopy with NIV support with low complications rate. Now, this is a disposable, one-time use, single-use bronchoscope, and which is new possibility, which eliminates the need for complex clinical procedures and minimize the risk of cross-contamination. With this bronchoscope, the patient can be treated immediately when needed without having to wait for the arrival of a reusable scope and stacking system. Its working channel of 2.8 mm makes it highly suitable for management of tough retained secretions and BAL procedure. So this above scope, which is a single-use scope, is difficult to find and is not present in everywhere. So BAL is the procedure which is commonly performed with the fiber optic bronchoscopy to retrieve the samples. Now, it is originally referred to as liquid lung biopsy, and its samples contents of the millions of alveoli. So the yield is therefore greatest for the alveolar filling procedure. Now, if a patient is in ICU and to take an X-ray and you find new shadows appearing, always these new shadows are not infectious or pneumonia. There can be drug-induced pneumonitis, there can be aspiration of gastric contents, it can be pulmonary emboli, it can be ARDS, it can be lung contusion, it can be cardiogenic pulmonary edema, or lymphangitis carcinomatosis, or it can be atelectasis. So BAL samples will differentiate the infectious lesions with the non-infectious lesion. In COVID, BAL has sensitivity up to 93% compared to 72% in sputum and 63% in nasal swabs in these patients. Now, in ICU patients, if the BAL is done, then IL-8 and IL-6 levels are increased, giving the early diagnosis. And determination of the cytokinin concentration in lavage fluid may be useful for evaluation of severity and course of the ARDS patients. Level of D dimers are also markedly elevated in ARDS as measured by in BAL. Now, protected displacement brush is another procedure which can be performed in these patients through FOB, and it procure uncontaminated low respiratory secretions. More than 10⁻³ colony forming unit per ml on culture is indication of an infection. Now, sensitivity is up to 66%, and the test is specific in up to 90% of the cases. The bronchoscopes are listed as semi-critical devices as they do not enter the vascular system, so as other critical devices do. However, a high level of the disinfection process should be used, and post-procedure sterilization include leak testing, visual inspection, followed by sterilization. Now, specimens should be stored and processed according to the biosafety requirements. All staff must remove personal protective equipment according to the appropriate training and leave the examination area only after ensuring strict hand hygiene. Now, what are the effects of FOB? Now, up to 20 centimeters, the water PEEP increases if the endotracheal tube is of 8 millimeter size with adult bronchoscope, and it increases up to 30 centimeters the water if the endotracheal size tube of size is 7 millimeter. Now, it increases the FRC by 30%, FEV1 decreased by 40%, it reduces the vital capacity, and it significantly reduces the axial tidal volume. Hypoxemia is also common up to 2 hours post procedure, and PO2 drops by 20 to 30 millimeter the mercury in uncomplicated procedure, but it can go up to 30 to 60 millimeter drop in critically ill patients. Suction can further induce 40% fall in the partial pressure of the oxygen, and suction should be applied for short periods like 3 seconds or less at a time. The hypercapnia up to 8 millimeter of the mercury is common in an uncomplicated procedure. There can be increase in the mean arterial pressure, increased heart rate, increase in pulmonary artery pressure, and decrease in the cardiac output up to 50% of the patients. But these all hemodynamic effects returns to the baseline within 15 minutes after the procedure. Now, the complications of FOB are most important is infection to the healthcare workers with bronchoscopy and decreased inhalation pressure, FOB-induced pneumothorax, hypotension, cardiac arrhythmias, bronchospasm, FOB-induced secondary infection, fever due to release of inflammatory mediators, and lidocaine toxicity. Now, the absolute contraindication is bronchoscopy is if inexperienced or team is inexperienced, then bronchoscopy should not be performed. If there are absence of suitable facilities or equipment for protection, then bronchoscopy should not be performed. And if there is inability to maintain proper oxygenation during the procedure should not be performed. Related contraindication includes severe hypoxemia, acute coronary syndrome, uncontrolled arrhythmias, uncontrolled bronchospasm, auto PEEP more than 15 centimeter, bleeding diastasis, severe pulmonary arterial hypertension, increased intracranial tension, and chronic renal failure, pulmonary abscess. So the all these are related contraindications. Thank you very much.
Chairpersons, is there any question?
Now I invite the next speaker, Dr. Gagandeep Kang. She is a professor of microbiology, the Christian Medical College, Vellore. She would be speaking on the COVID vaccinology, all that a doctor must know.
Update. And to start with, we'll look at what are the platforms on which COVID-19 vaccines are available. Broadly, these can be divided into two classes. One is the older versions of vaccines, which are vaccines that we are familiar with, where you have live attenuated or inactivated viruses or virus-like particles like the HPV vaccine, or recombinant DNA like the hepatitis B vaccine. Or we have the new classes of vaccines, vectored vaccines, which first became available for Ebola 2 years ago. DNA vaccines, where Zydus Cadilla's vaccine is the first such vaccine to be used in humans, and the RNA vaccines, where the first vaccine licensed was the one from Pfizer, but there are other vaccines available as well now. So where are we today in the vaccine landscape globally? We have vaccines that are still not in human trials and preclinical testing, continuing to be made, particularly because we think we might need vaccines that have better performance characteristics than the vaccines we have now, such as greater activity against variants or a longer duration of protection. So these continue to be tested and developed. But we also have a lot of vaccines that are in different phases of clinical testing. And for SARS-CoV-2, for the first time, we saw a lot of vaccines being tested in many combined phases, 1 and 2 together, or 2 and 3 together. Where we are today is many vaccines have been through these phases of testing. We have 13 vaccines that are in early or limited use, 8 that are approved for full use globally by WHO, and there are 7 vaccines that have been abandoned after entering clinical testing. In India today, we have 3 vaccines in use. We have Covishield, which is about 88% of all the vaccines used in India, Covaxin, which is about 11.5% of all the vaccines used in India, and Sputnik V, which is less than 1% of the vaccines that have been used in India so far today. In terms of their performance characteristics, all of the vaccines appear to be performing well. Of all of them, we have effectiveness data largely for Covishield, though we expect to see effectiveness data for Covaxin, which is the real world performance of Covaxin, at some point in the near future. We also have Zydus Cadila, which has been approved by the DCGI, but this is not available in the market yet. And we have other vaccines that are in various phases of clinical testing from multiple Indian companies. It's a matter of great pride that India has every platform of vaccines that are available in the country. Now, if we look at vaccinations in India, we recently achieved the 1 billion mark. But in terms of the share of the population that has been vaccinated, we rank just above the global average, as shown in the red circle there. And in terms of the daily number of COVID-19 vaccine doses given per 100 people, we achieved a huge peak in September, but administration has been declining somewhat after that. The 1 billion peak shows that we have done an excellent job with our immunization program, but that doesn't mean that the work is over. We still have a long way to go because much of our population has received only 1 dose at the moment, and a smaller proportion, just over 20%, have received both doses of vaccine. If we look at the COVID platform, that is spelled out very clearly. About 70% of the doses that have been given have been the first dose, and only about 30% of what we have given out so far is the second dose. Nonetheless, this is a phenomenal exercise with nearly 80,000 sites conducting vaccination, and this will continue for a while. Now, what are the issues for doctors? I've just highlighted the key issues to discuss here. First is which vaccine is best, what dosing intervals, should we use boosters or vaccinate children, what are the contraindications for vaccines? There are, of course, many other questions, but we can discuss those at a later time. In terms of which vaccine is best, it depends on what you are asking of the vaccine. Do you want the highest antibodies? Do you want the longest protection? And the answer really is we actually don't know which single vaccine is best. We know some characteristics of some of the vaccines. The mRNA vaccines clearly give the highest antibodies, and in all of the vaccine trials, which you see in the graph here, the mRNA vaccines had the highest antibodies, followed by the adenovirus vectored vaccines, and then by the inactivated vaccines. However, Covaxin did better than the other inactivated vaccines. Now, we don't have a lot of effectiveness data from India, but from international data, most of the vaccines are working reasonably against the Delta variant. And there seems to be emerging evidence that's based largely on immune responses at this time, that we should seriously be considering mix and match strategies where we either give 2 different vaccines initially or we boost with a different vaccine. Lots of questions are asked about what are the dosing intervals, why does India have a longer dosing interval, isn't it time for us to change back? Actually, all the data that is emerging is showing us that a longer gap is better. But the important thing to remember is that the longer gap leaves the person slightly unprotected in the period between the 2 doses. So if there is a lot of infection going around, we might want to shorten the doses. But if there isn't a lot of infection, it makes sense to keep the long doses. Next question is, are boosters needed? Yes, absolutely, for those who are immunocompromised or have comorbidities. But which result in them having definitely a poorer immune response. For others with comorbidities that don't lead to a poorer immune response, or for the elderly or those at risk of high exposure, it's likely that they will also need booster doses, but the question is really when and with what vaccine. High-income countries have made recommendations to give boosters anywhere from 3 to 6 months after the primary series for people who are in long-term care, have comorbidities, or who live or work in high-risk settings. But basically, this is based on data showing that there is an approximately 10% decline in protection with the highest performing vaccines, the mRNA vaccines, over a period of about 11 months. So there's a lot of data that we need to understand, especially given India's high seropositivity rate. And it's likely that at some point in the future, there may be a need for booster doses, but this is an area where we should wait and see. Now, should children be vaccinated? Well, if you're immunocompromised or you have comorbidities, absolutely yes. And preferably with vaccines that have been used in children in other parts of the world, such as mRNA vaccines. But we don't have those vaccines in India at the moment. For other children, I don't think the time is right to immunize them now. I think we should cover high-risk adults first and figure out which vaccine is best for children. And the reason to do that is because your first vaccine is likely to shape your response to future infections and future vaccines. So it's important to have this information before we make decisions that will influence our children's responses to vaccines in the future or to infection in the future. In India, we have the inactivated vaccine, but we have no effectiveness data, even from adults. And other country experience shows us that inactivated vaccines do not work well or don't work for a long time. And we should think about whether this is enough for us to make a decision. For DNA vaccines, this is a new platform. There's limited data on immunogenicity in children. So I think it's really one where we should use it in adults first and then move to children. And adenovirus vector vaccines are not used in children elsewhere. So without studies, it would be hard to make a recommendation for their use in children. What are contraindications and what are side effects of vaccination? The only contraindication is allergic or anaphylactic responses to an earlier dose of the same vaccine. And serious side effects really depend on the vaccine. Anaphylaxis and allergic reactions have been reported with all vaccines, but there are some special side effects with some vaccines. These include myocarditis in the young with mRNA vaccines and thrombosis with thrombocytopenia syndrome with adenovirus vector vaccines. There are also unconfirmed relationships such as with GBS, with Bell's palsy, and with ITP. Now, with vaccines that are developed and used exclusively in India, the monitoring of safety happens through the national AEFI system. And because the level of reporting is very, very low, there are some questions about whether we are really detecting any signals or whether we might be missing something. This is an area that continues to require strengthening. So everyone who has potential AEFIs should be reporting them. So thank you very much for your attention, and I will look forward to interacting with you.
Thank you so much, ma'am, for the nice lecture, actually, for highlighting the need of the booster and at what age we should give the immunize. We have to immunize the children. A very nice presentation, and thank you very much, ma'am.
Doctor, can I come in? This is Dr. Runta. Thank you, Dr. Khan, for a wonderful presentation. This is Dr. Runta. And thank you for being part of our conference, and you have given a lot of insight about vaccination, and because you are one of the top persons to talk about vaccination in India. A couple of questions for you. What is your comment about the discussion going on about the cocktail vaccine?
I think from the data that we have so far, it does look like mixing vaccines gives us better immune responses than using 2 doses or 3 doses of the same vaccine. So we should be thinking about what the consequences of using mixed strategies are. By and large, I think different vaccines have different arms of the immune system that they stimulate. So, for example, with mRNA vaccines, you make a very high antibody response. But with vectored vaccines, you make a better T cell response. So it's possible that combining the two vaccines will give us a broader and longer lasting immune response, but we really need to do the trials to understand before we start using them in people.
My understanding is attenuation is a little different from inactivation.
That's correct.
Right. So why are we not thinking about attenuated vaccine development?
We are actually, both Serum Institute of India and Indian Immunologicals are making attenuated vaccines, but they are making them with a new method. Previously, when we wanted to attenuate vaccines, we used to use either physical, chemical, or biological methods to induce the attenuation, to weaken the infectious agent without necessarily killing it. And both Serum and Indian Immunologicals are using a new approach to attenuation, which is called codon de-optimization, to deliberately induce mutations in the virus so that it replicates less well and therefore cannot cause disease. The phase 1 studies have already started for these vaccines.
One more question. Some of these states have reported seroconversion as high as 76 to 80%, whereas our first dose achievement is nearly close to 55%. What is your comment about it?
I think a lot of the seropositivity that we are seeing is coming from people who were naturally infected. I think one of the consequences of having had a really bad time during the second wave is that levels of exposure to infection were very, very high. Now, we know that a combination of infection and vaccination is what gives the best and broadest protection. So in some ways, some of the suffering that we had in the country in the first half of the year may actually be an advantage for us when we immunize all of our population. We will do better than many other parts of the world where the bulk of the protection will come from only doses of vaccine.
Now, my last question to the microbiologist, Dr. Khan, not about the vaccine. One of the speakers in the morning was talking about introduction of CGG into humanized mice. Humanification of the virus.
Yeah.
He was talking about explosion of COVID virus. And this is probably man-made and humanization and introduction of CGG factor into the mice. Can you comment on this?
So I think there is a lot of speculation about what has been done, what can possibly be done. But until you have well-designed and well-described experiments from which you can see not only what was done, but what the consequences of that were, it's very difficult to say what has happened. The potential, of course, is enormous.
Thank you so much. I will not push into it. I just wanted, I was a little curious. The speaker was quite sure that what has happened. So I wanted to have your comments on it.
I'm not so sure.
Thank you so much. And thank you very much for accepting our invitation to deliver this lecture, which is so important to us.
Thank you.
Now I invite Dr. Devin Juneja, the Associate Professor, Institute of Critical Care Medicine, Max Super Specialty Hospital, Saket, Delhi. He'll be delivering the lecture on the COVID and the secondary opportunistic infections.
Hello, everyone. Today, I'll be talking about secondary opportunistic infection in COVID-19 patients. We really do not have to look at the journals to see what kind of infections we are dealing with in COVID-19 patients. If you look at any newspaper headlines, you will see a lot of secondary infections in patients with COVID-19. And whenever a patient with COVID-19 presents to us, he is always worried that if he is having any secondary infection or not. This is especially true after the second wave when we had a lot of black fungus or the mucormycosis patients with us. This is one of the largest trials published showing the Indian data. This was from the ICMR, and this was published in the month of June this year. They collected data from 10 hospitals of 17,534 patients, and they showed that 3.6% developed a secondary bacterial fungal infection. The rate of developing secondary infection was lower in this particular study because they included patients from OPD and wards also, not only from critical care. But the mortality in the patients who developed secondary infection was very high, 56.7%. If you look at this table over here, and the mortality ranged from 30% and went up to 80% in patients who developed secondary infections, as compared to patients who did not get any secondary infection. Blood and respiratory sites were the most commonly infected sites, and G and B were the predominant organism in respiratory infection, but there was a significantly increased number of GPC infection when patients developed bloodstream infection. And if you look at the distribution of common pathogens, the most commonly isolated organisms were Klebsiella, Acinetobacter, Pseudomonas, followed by E. coli and other GNBs. And if you look at the rate of infections of Aspergillus and Candida, it was very, very low, to the tune of 6% of Candida and 2% or 1.6% for Aspergillus. But we must keep in mind this was before the second wave hit us. And if you look at the susceptibility patterns, you will see more than 80 to 100% of Klebsiella and Acinetobacter infections were resistant to all the commonly employed antibiotics. The rate of ESBL was 83.2% and rate of CRE was 74.2%. And if you look at the takeaway, which was printed by the press, it was that the poor infection control, irrational antibiotic use are killing COVID-19 patients who would otherwise survive. So this was the take-home message which they had printed, and hence we have to be very, very careful whenever we are dealing with secondary infections. And if you look at the data from the ICUs, this was an Italian study of 89 critically ill patients, and they've reported a high rate of secondary infection up to the tune of 76.4% in patients with COVID-19. Again, the most commonly isolated organisms were GMB like E. coli, Acinetobacter, and Klebsiella, with 55.2% of them being MDR. And among the gram-positive infections, Staph aureus and Enterococcus faecalis were commonly isolated, and the rate of MDR was 37.2% in GPC infections. So these are the usual suspects, and these are the organisms which generally cause secondary infection in the patient with COVID-19. And normally we get a lot of infection with Pseudomonas, Klebsiella, Acinetobacter, Staph aureus. Again, these are commonly isolated from COVID-19 patients also. But we have seen, especially after the second wave, a lot of patients getting fungal infections, especially mucormycosis, and a lot of patients developing candidiasis, especially Candida auris. There has been a lot of Candida auris infection. This is a newly recognized Candida, but we have seen a lot of patients developing Candida auris infection. This is a very difficult to treat and isolate infection, and this has caused a lot of havoc. And Aspergillus, Pneumocystis carinii, and cryptococcal infections are again very commonly isolated from COVID-19 patient. Certain viruses have also shown to cause co-infection, like non-COVID coronaviruses, influenza A, H1N1. We usually used to, whenever there was an acute iteration in any patient, we used to look for any of these co-infections. And the reinfection or reactivation of tuberculosis, CMV, has also been commonly reported. And rarely, some parasitic infection like Toxoplasma gondii and strongyloidosis have also been implicated. Why these patients are at increased risk of getting secondary infections? This is basically because COVID-19 can itself cause immunosuppression, and it can lead to persistent lymphopenia, which may be persistent for weeks to months. So the patients with lymphopenia are more prone for getting secondary infections, especially with fungal infections. Use of immunosuppressive agents. We have seen a lot of these patients going into cytokine storm, and corticosteroids have been shown to be a mainstay and can improve outcome in patients with moderate to severe COVID-19. So they have been used rampantly. So they can also lead to increased secondary infection. prolonged ICU and hospital stay, prolonged critical illness, use of invasive mechanical ventilation, lot of catheters and lines, prolonged use of antibiotics, and obviously we have seen a lot of lung destruction and fibrosis, which make these patients prone to secondary bacterial and fungal infections. So if you look at, there have been certain studies which have tried to find out predictors of getting secondary infection, and the usual culprits are older age, underlying neurological disease, use of immunosuppression, and ICU admission have all been identified as a risk factor for developing secondary bacterial or fungal infection. And patients in this particular study, patient who received steroids and tocilizumab progressed to have a more severe ARDS and secondary infection, and mortality rate was also significantly higher, up to 25% as compared to 6.7% in patients who do not develop secondary infections. But again, if you look at IL-6 inhibitors, there is a lot of ambiguity regarding the data, and this is the latest living guideline from WHO, and it shows that use of IL-6 inhibitors may improve patient outcomes, and the chances of secondary bacterial infections are there is low quality of evidence, and it shows that the chances of getting secondary bacterial infection is not significantly increased, or rather they showed that 5 fewer infections per 1,000 cases in which tocilizumab or other IL-6 inhibitors were used. So again, the jury is out, but again, whenever you are using these immunosuppressive agents, you should use them cautiously. Looking at the diagnosis, obviously we have to do the general test, like if the patient is having bacterial infection, the chances are his TLC will be very high or very low, procalcitonin may be high, CRP and IL-6 levels may be on the higher side. Fungal infections will typically show high CRP and TLC, but there are certain biomarkers that like beta-D-glucan and galactomannan, which can also help us in early identification of fungal infection. If the patient is having viral co-infection, then the LDH, CRP, OTPT may be high. Patient may also have lymphopenia. And obviously certain imaging tests, chest X-rays or CT scan may aid us in identifying a particular diagnosis. Then obviously we have to do some specific tests, like we have got PCR based tests like the respiratory panel, in which you do a test of the respiratory secretions. It can help us in early identification of many of these secondary infection. Obviously cultures take a lot of time, but they can again be negative in a large majority of patients. They may be positive in only 30 to 40% of patients, especially if the patient is already on antibiotics or antifungal agents empirically. These cultures may be negative again. Biopsy, again, to make a diagnosis of fungal infection, it is better to have a biopsy of the lung tissue or any other site of infection, and that can help in diagnosing. Gene experts for like tuberculosis, for CMV, we have got specific PCR-based tests or IgM, or ideally we should look at the seroconversion if that the patient was having CMV was negative earlier, now he has become CMV positive, or we can also test for the CMV load, but again, a clear cutoff for CMV load is not there. So you have to take it with a pinch of salt. And then obviously the AFB stains and cultures can help us in making a diagnosis of tuberculosis. But again, it is very difficult to make a diagnosis of any secondary infection in these patients because a lot of overlap is there in from the underlying COVID-19. So if you look at the chest X-ray, it becomes very difficult for you to guess whether there is an acute infection or there is a progression of the underlying COVID-19 disease. So whenever there is acute deterioration in any patient of COVID-19, like acute increase in FiO2 or patient developing multi-organ failure, that would be the right time that you should suspect that this patient might be having a secondary infection, and you should look for a secondary infection doing all those tests which we have discussed earlier. Again, obtaining respiratory samples is very difficult. We try to avoid doing a bronchoscopy in these patients because of the risk of generation of aerosols. So you have to weigh the risk versus benefit whenever you are doing any of these tests, and obtaining respiratory sample may aid in making a diagnosis. Going further, imaging studies also are very, very difficult. Taking these patients out of the ICU, especially if the patient is having a high FiO2 requirement, if the patient is having severe hypoxemia, taking them down will be logistically difficult. Also, there is always a risk of spreading infection to the others when you are taking the patient out of the ICU. So you have to keep that thing also in mind. We are doing a lot of ultrasounds, which can help us in making diagnosis of infection. So that can help us. So looking at the prevention and treatment, the key to early prevention and treatment is early recognition and isolation of these patients. So if these patients are having any particular, specific infection like H1N1, or the patient is having tuberculosis, you have to recognize them and isolate them so that these patients do not spread infection to other patients admitted in your unit. judicious use of immunosuppressive agents. Both these agents, IL-6 inhibitors and corticosteroids, have shown to improve outcome. But what is important is to use them judiciously. Try to use the minimum doses which are required. Try to stop the steroids as early as possible. And especially when you identify that the patient is at high risk of developing a secondary infection, then you have to be more careful of in prescribing these immunosuppressive agents. Again, judicious and appropriate use of anti-infective agents. We did see a lot of antifungals being given because of suspected risk of fungal infection, especially mucormycosis. Amphotericin B was in shortage, and the government had to regulate doses of amphotericin B and other antifungal agents. We should try to avoid such a scenario getting developed again if unfortunately there is another wave of infections. So early use of anti-infective agents, but appropriate and judicious use is what is warranted. And surgical intervention again might be required, especially in cases with aspergilloma or mucormycosis. We did see a lot of patients requiring surgery after initial antifungal therapy. So early intervention may be required in those patients. So to summarize, there is a high incidence of opportunistic infection, especially in high-risk patient populations who are admitted in our ICUs. And these infections are difficult to diagnose. But whenever the patient of COVID-19 infection is showing a sudden acute deterioration, you must keep these secondary infections at the back of your mind, and you should try to find what particular infection your patient is suffering from. These infections are associated with high morbidity and mortality. So the only way forward is to use your anti-infective agents and immunosuppressive agents judiciously. Thank you, and I'll be happy to take any questions which you might have.
Now I invite Dr. Nikhil Kothari, Additional Professor, Department of Anesthesiology and Critical Care, AIIMS, Jodhpur. He'll be speaking on the current NIH guidelines for the COVID management. Dr. Nikhil, please.
Website here. So there is full 360 pages document uploaded by NIH. It's a very extensive document. So those who are interested for further details, they can please visit on this website and go through this document. It's a very beautifully made document. So to begin with, the coronavirus disease or COVID-19 started in December 2019, and it engulfed the entire world and turned into a pandemic disease. And since it was new for everyone, so nobody knew that how to deal with it. So the guidelines are coming from time to time with frequent updates. The recent guideline, which has been uploaded on 29th of September 2021 on the NIH website. So these are the most latest guidelines available. So all the panel of experts, they have said that the vaccination is a key for management of COVID-19 and control of the spread of COVID-19. It not only prevents the spread, but also prevents the severity of disease. So they have laid on stress on extensive vaccination program. Plus, they have laid the stress on the role of monoclonal antibodies. So we'll be seeing that what are these antibodies and how to make use of them. One good thing they have said that there is no role of pre-exposure prophylaxis. They clearly mentioned that they have recommended against the use of pre-exposure prophylaxis. We have seen that there is array of drugs like hydroxychloroquine, ivermectin, or vitamin supplements people have been using in day in and day out. So they said that there is no role of these pre-exposure prophylaxis in any of the COVID-19 patients. And they have divided or they have classified the infection into asymptomatic phase to critically ill patients. The patients who don't have any sign and symptoms but are found positive for COVID-19, they are considered asymptomatic. Then they develop sign and symptoms, and another set of patients develop sign and symptoms of COVID-19, like they develop fever, malaise, body ache, nausea. So, but the saturation is well maintained. They are in a mild form of disease. Then the few set of patients in which the saturation drops on room air, but they're still above 94% room air. They are categorized into a moderate illness, and the patients which saturation drops below 94% on room air are into severe category, and they need hospitalization. And further in the hospital, there are a certain set of patients who develop shock or in multiple organ failure or with increased oxygen requirement. They are critically ill patients. So they are defined different guidelines for different set of patients. First thing is the treatment guidelines for non-hospitalized patients. those patients who are not being hospitalized and they don't need any supplemental oxygen. So these are the patients who most often visit us in outpatient consultation or in OPDs. They said that these have either asymptomatic or a mild form of disease. So they have said that in these patients, if they're not being vaccinated properly or recently being vaccinated, so we can use the monoclonal antibodies like bamlanivimab or etcvimab, casirivimab plus in MDVimab. It's a tongue twister to pronounce these antibodies. Another one is sotrovimab. So these are the few antibodies, monoclonal antibodies, which can be used in a mild to moderate form of disease. And one more thing, that panel has recommended against the use of steroids or other systemic glucocorticoids in the milder form of disease. And then there are certain set of patients who are in the hospital but are discharged from the hospital. So the panel said that there is no need to continue remdesivir in these patients, and it also recommended against the use of dexamethasone in these patients. Then another set of patients who are either discharged from the hospital and require a home oxygen therapy. There are a few patients whom we discharge, but we advise them to continue with supplemental oxygen, or many patients who take discharge themselves and go home. So people generally prescribe them or ask them to continue with remdesivir or steroids. So there is insufficient evidence about use of remdesivir or steroid in these patients. But there is very big set of patients in which they are sick, they come to hospital, but because of resource constraint, we are not been able to admit them in the hospital. So they said that in this certain group of patients, you can ask them to continue on oral steroids and let them be at home with supplemental oxygen, and they can be admitted as and when the bed is available. So in this set of patients who are sick, they can be given steroids even at home. Now, the treatment guidelines for hospitalized patients. So what treatment we need to follow? So the patient who are being hospitalized, who are sick but doesn't require supplemental oxygen, they have again recommended again the use of steroid in this patient. And the patient who are being hospitalized but and are on supplemental oxygen, definitely we have to give steroids in this patient to prevent the further progression of the disease. And another antiviral drug, that is remdesivir. And I would say that remdesivir is the only US FDA approved drug which has to be used in COVID-19. So they started early. Normally they're given for 5 days, but can be continued up to 10 days if the patient is not respond, but should not be continued beyond 10 days in any of this patient. So you can give remdesivir alone, and the patient is worsening, then steroids can be added in this set of patients. Now the patient guidelines in hospital who are rapidly deteriorating. There are certain set of patients who come in the hospital. We start with 1 or 2 liters of oxygen, and we've seen that the oxygen requirement is going up. It goes up to 8 liters, 9 liters, or even 30 liters or 50 liters in 24 hours. So these patients are rapidly deteriorating. So they said that definitely steroid has to be given, and if the disease progression is so rapid that oxygen requirement is tremendously shooting up in 24 hours, so this patient has to be given IL-6 antagonist like tocilizumab can be tried in this patient along with this dexamethasone, but single dose of tocilizumab, that is 8 mg per kg, and maximum is 800 milligram to be given in this set of patients. Probably that is the recommendation. Now, what is the role of anticoagulants and antiplatelet therapy? The people started the anticoagulants, antiplatelet therapy to prevent venous arterial thromboembolism. So they said that there is no role of prophylactic use of antiplatelet, anticoagulant in this oral anticoagulant in this patient. And if the patient are on hospital and they are able to move, so we have to motivate in them to ambulate and to move around rather than starting any antiplatelet therapy. And another practice is to discharge them an oral anticoagulant. So the panel of experts of NIH has recommended against the discharge on oral anticoagulant. Only the few set of patients who have either malignancy or undergone a recent wall replacement or any implant, that is they put in a coronary angioplasty or something like that, they could be asked to continue with their oral anticoagulants when discharged from the hospital. Now, a few words about the monoclonal antibodies. So normally whenever a pathogen or a virus or any other infective organism enters in a body, their surface protein have few, there's on the surface of the cell membrane, they have few proteins. So they serve as an antigen, and in response to these proteins, our body produces several antibodies, so which fights with this pathogen. But it takes some time, at least few weeks, for our body to develop the antibody response. So to buy time or to protect the patients in this period, they can use a monoclonal antibody. So the antigen are introduced into a host, and antibodies are developed, and then they are gathered from this host. So these available antibodies can be introduced in the body in the patient and to protect them from ongoing infection. Now, what are the set of patient in which the monoclonal antibodies to be used? So the patient who are not fully vaccinated or received any single dose or recently being vaccinated, but it is less than 2 weeks time, or the patient who are fully vaccinated but are immunocompromised, they get a COVID-19 infection. The monoclonal antibodies has to be used in this patient, but that to be within 7 days. They should not be used as a last resort. They have to be used early. And in few months back, the use of monoclonal antibodies has gone down because the infection was mainly because of beta and gamma variant, in which it is not found to work as efficiently as it works in delta variant. So these days, the infection is mainly due to delta variant. So in this, it is very effective. The antibodies has to be given. So this is a dose regime of different set of antibodies, and single dose has to be given. And they said that even in pregnancy and lactation, this can be safely given if given risk versus benefit ratio seen. These are the list of drugs. Remdesivir is only FDA recommended drug to be given usually 5 days, but not more than 10 days. And a few slides about care of critically ill adult patients in COVID-19. So whenever these patients are admitted in hospital, we have to minimize the aerosol generating procedure. And if we need to intubate these patients, we have to use a video laryngoscope. For the patient who are hemodynamically unstable, we need to give crystalloid, balanced crystalloid or colloids, and albumin has to be deferred. Then about oxygenation and ventilation, high flow nasal cannula or high flow nasal oxygen concentration is the recommended modality to give an oxygen. In case HFNO or HFNC is not available, then NIV can be tried. And the last word about the proning, the awake proning, though beneficial, but it has been seen that people defer intubation in this patient in view of awake proning. That should not be practiced. If need to intubate them at the proper time so that to prevent crashing of the patients. On a ventilation, low tidal volume with tidal pressure less than 30 has to be maintained. The role of ECMO is not being justified. There is insufficient evidence for using as well as against ECMO. So it's still under trials are going on. About convalescent plasma, definitely no established role has been there. Only patient who are immunocompromised, if we have a convalescent plasma with high titers of antibodies can be given in these patients. Stem cell still on a trial basis, not in a routine use. Different immunomodulators like colchicine, IL-1 inhibitors, or inhaled budesonide, inhaled steroid. No role is there. The recommendations are not in favor because of lack of evidence. Lastly, the vitamin supplement, the role of vitamin C, vitamin D, or zinc. There is no proven benefit. So the panel of experts of NIH recommends against the use of these supplements in management of these patients. Okay, thank you and have a nice day. Thank you very much.
Can we move on to the next session?
Good afternoon to all the esteemed chairpersons and our speakers for this session and all the attendees as well. It is an honor to have you all here with me as we proceed on with all these sessions on day 2 of the World Conference on COVID and Critical Care 2021. I hope the experience so far has been smooth and seamless, and we hope we can do the same for you for the coming sessions. Let us proceed to the 4th session now. Our 4th session has 4 chairpersons as follows. Our first chairperson, Dr. Lalita Gauri Mitra, is Professor and Officer in Charge, Anesthesia, Critical Care Medicine and Pain, Homi Bhabha Cancer Hospital and Research Center, New Chandigarh and Sangur. Our second chairperson is Dr. Sarina Agarwal, Professor, Department of Surgery, ASMCS, Firozabad. Our third chairperson is Dr. Vipul Agarwal, Head of the Department of Orthopedics, Government Medical College, Firozabad. And our fourth chairperson is Dr. Prashant Prakash, Professor and Head Super Speciality, Department of Pulmonary Medicines, SN Medical College, Agra. I would request our chairperson to kindly take over now and introduce all of our speakers. Thank you.
Dr. Mitra, can you please introduce?
Yeah. Good morning. Good afternoon. It gives me immense pleasure to invite Dr. Bhavin Jangaria. He's a consultant radiologist at Picture This by Jangaria. He is a trustee of the Radiological Education Foundation, which is a non-profit organization started in 1996 with the aim to foster radiology education among students and consultants. And so would be speaking on HRCT chest and how do we interpret in COVID. We welcome, sir.
This opportunity to speak on HRCT chest interpretation in COVID as part of the W4C conference. And I will spend the next 12 odd minutes covering the role of CT scan in the diagnosis and follow-up of COVID-19, basically focusing on the signs, classification systems, severity scores, angiopathy, etc. The typical signs are as mentioned here, and I'll discuss them in detail, and then we'll talk about CORADs and then the severity score out of 25. The classic signs of COVID-19 are ground glass, consolidation, and reticular opacities. The ground glass is either perivascular, which is quite typical of COVID, or subpleural. If it is associated with these areas of septal thickening, then we get a crazy paving appearance, which can also be seen with alveolar proteinosis, but the crazy paving of COVID is different. If we have consolidation, which we can see here with air bronchiolograms, the consolidation typically has an organizing pneumonia pattern where it is either subpleural or it is peribronchovascular, as we can see here. And again, here, this is subpleural. Now, obviously, all of these patterns can occur in a mixed manner. So we can have consolidation with a ground glass halo with some crazy paving, or we can have ground glass in the center with consolidation at the periphery, which is the reversed ground glass halo sign or the atoll sign. In the partly resolving phase, we also get these thin and thick bands, and we'll revisit these in a little while and see what the cause of these bands is. With severe disease, we get an ARDS pattern where we see diffuse consolidation, ground glass, we may get pleural effusions, but there is characteristic sparing of the anterior segments of the upper lobes as we see here. And that is a hallmark of any acute lung injury, but especially when it occurs with COVID-19. And we also get volume loss in the lungs, both antero-posteriorly and supero-inferiorly. Histologically, this is a combination of diffuse alveolar damage, AFOP, fibrosis, and OP. Now, one of the things we do in our reports as radiologists is mention the CORAD score. Now, this is a confidence score, where as a radiologist, when I say that a particular scan is CORADS 5, that means I'm 100% confident that it is COVID. And if I say it's CORADS 1, it means it's essentially a normal scan, as we see here. CORADS 2 is when there is an alternate diagnosis, as in this case, we see tuberculosis. CORADS 3 is where I see perivascular ground glass, but it's focal, and I'm not sure whether this could be something else. CORADS 4 generally implies a better than 80-90% chance that this is COVID, and we see these subtle perivascular areas of ground glass, or here we see focal perivascular consolidation. And then CORADS 5 is where we have typical findings. CORADS is to be used in the setting of suspected COVID. So if I'm doing a routine scan in a patient who has interstitial lung disease or lung cancer or lung nodules for follow-up, if it does not show COVID, does not mean I will write that this is CORADS 1 or CORADS 2. CORADS is a confidence system which implies the level of confidence of a radiologist to say whether there is COVID or not in the setting of suspected COVID or during the height of a pandemic when all the scans typically are being done for COVID. How good is CT? This is an evolving process, and every 3 months the Cochrane database updates its reviews. And in July, this was at 88% sensitivity and 80% specificity. The other thing we mention in our reports is the severity score, where we try and determine the extent of involvement. If it's less than 5%, then the score is 1, and so on and so forth. And this is how we look at it. So here I see the right upper lobe in axial, coronal, and sagittal, and it's normal, so the score is 0. The right middle lobe shows subtle perivascular ground glass in the axial, coronal, and sagittal image. It's less than 5%, so the score is 1, and so on and so forth. And here you can see in the left lower lobe that the disease is definitely greater than 25% of the volume of the lung, but less than 50%. So this patient has a score of 8/25. And we know that in most places in India, with a score greater than 15, the patient would be admitted. But basically, it's obvious that the higher the score, the worse is the outcome. The caveat is, and we need to understand this, that it's an extent score, not a severity score. What we are estimating is the extent of disease. We're not even differentiating between ground glass and consolidation. And it's a very crude score because somebody who has 10% involvement will also have a score of 10. Somebody who has 20% involvement in all lobes will also have a score of 10. So as long as we understand all these limitations, it works, because after a long time, or probably in one of the first such instances, this is a scoring system that is used pretty much in all places in the country, and something that is used across the country that has become ubiquitous obviously needs to continue to be used. The other issue is of understanding angiopathy and vasculopathy. And so while we believe that these lung changes are virus involvement of the lungs, etc., we know from histopath studies that most of COVID is an endothelitis or a capillaritis. And we see those signs. For example, we see these proximal dilated vessels or intralesional dilated vessels. We see this vascular tree and bud where we have these budding areas coming out of this vessel because of the microthrombi. We get a target sign. So in the target sign, we have the vessel in the center, the perivascular inflammation or ground glass, the relatively spared area, which is hypodense, and then we have the edematous lung here, which is a ground glass halo. We may see filling defects in the pulmonary arteries, and we can see that here. We can see the target sign here as well. But we can also get perfusion defects without thrombosis. So this patient here, we can see 3 weeks after onset, the pulmonary arteries are normal, but there are large areas of hypoperfusion in the mid zones. And it's when we've used dual energy perfusion maps, we've realized that the reason for the bands is the hypoperfusion in the subtended lung, and these bands are actually hyperemic edematous lung. So this is the summary of all the vasculopathic signs. Lastly, we come to follow-up. And this is now important because now almost 19 or 20 months into the pandemic in India, this has become more important. Now, in the short term, most patients improve. So here we see consolidation, ground glass, crazy paving. 1 week later, we just see some residual bands and reticular opacities. In this patient, and this is also not atypical, 10 days later, we see the so-called resolving phase where the ground glass is gone, but we're left with reticular opacities and a little bit of architectural distortion. Some patients just worsen. So here we have perivascular ground glass, one focus on 23rd April, significant progression 4 days later, and then almost an ARDS pattern. And then see, but in 2 weeks between 3rd and 19th, may the extent of shrinkage of the lung. And seeing this in anterior-posterior dimensions also tells us that the patient is worsening. Medium term sequelae follow this kind of logic. So here is a patient about a month later where we see what looks like traction bronchial ectasis, but we now use the term transient airway or bronchial dilatation. Another patient where there was a lot of pleural retraction, but another month later, so this is 3 months follow-up, the lung is expanding, though there is residual ground glass. We know from the first SARS epidemic of COVID-1 that most patients will resolve over 6 months. There was a paper in 2004 on this. And it's not just about gross lung changes. We also see the vasculopathic changes. So this patient has a thrombus here. You see 5.5 months later, there are significant perfusion defects that are still there. And this has been shown in papers from France as well, where 2/3 of their severely ill patients showed perfusion defects. We've even seen perfusion defects with apparently normal lungs in patients who are still otherwise symptomatic, which has also been shown in functional MRI trials in Britain, where 6 months later, they still have gas exchange problems, and these patients continue to remain symptomatic. But we're also learning that over the long term, patients never deteriorate and either remain static or improve. Most of them improve. So this patient who appeared to perhaps going into fibrosis, 9 months follow-up shows almost 95% improvement. This lady, where we saw that things had improved, has remained reasonably static. So there's improvement over a year from September 20 to July 21, but between March and July 21, there is no significant change. So there's some residual ground glass and reticular opacities, both in the upper and in the lower lobes, a total of 13 months follow-up. The same with vasculopathy. Here we saw these perfusion defects at 5.5 months, but when the patient came back at 9 months, the lung changes are also gradually improving, but all the perfusion defects have gone, and we now have hyperemia here. And we now know from other studies as well that in those who are not mechanically ventilated, and we need to clarify that, most patients improve except for a small subset, and radiological changes persist in about a quarter of patients, but they don't progress. Not a single patient shows definite progression. So we basically know that we shouldn't therefore be using the term fibrosis until we know for sure. And 7 years follow-up of SARS-CoV-1 has shown the same thing. And so that was basically a short snippet of the role of CT chest in COVID-19, where I've talked about the signs, ground glass consolidation, septal thickening, and the signs of angiopathy, vasculopathy with dilated vessels, vascular tree and bud, perfusion defects, thrombi, etc. Then we've talked of the CORAD's confidence system, we've talked about the severity score or the extent score, and we've talked about short, medium, and long-term follow-up. Thank you for giving me this opportunity. I hope you have a great meeting and have fun.
Requesting chairpersons, if there is any question.
So, I'd like to say something, and this is more in terms of being quite upset about the whole thing. Whoever played the video sped up the video by about 15%, probably because you're running late and you wanted to fit it in time. So it made me sound like a racing car running through the lecture, and I don't think that's a done thing. So whoever's done it, you need to apologize and make sure you never do it again. Also tells me that I should not send recorded lectures and just do them live. So I guess it's from the technical team, but this is for you all. And all the doctors who are listening to this, please make sure that they don't do something like this to other speakers. Though I guess your meeting is ending anyway now.
So I think even though it was a very, I mean, I spoke yesterday and I voiced what you said, that our lectures have been speeded up a shade, and in spite of it, I think your images were fantastic. If students,
thank you.
The images were fantastic. I said, even if the students had concentrated on the images, I think it's actually it's a great learning experience for not just students, even for us who have been seeing this through the year. So I can't see any question in the chat, but I would like to ask you something. So in the current scenario, do you think one should still get a CT chest to give a diagnosis if one is kind of in an intermittent phase and maybe they're just not getting the reports right, but the patient is still being symptomatic?
I guess so. It has to be now a clinical judgment call, like with any other disease process, right? If we suspect that the patient has COVID, if the RT-PCR is coming negative, then there is a role for doing a CT scan. But there is no role for doing CT, let's say preoperatively, as it is still done in many hospitals, just because it's become routine. Or just doing CT every time somebody suspects COVID. That doesn't make sense anymore. So now it becomes a clinical diagnostic tool. If you have a problem, you suspect something, like with TB, you suspect TB or sputum, MTB is negative, chest x-rays plus minus, you get a CT scan done. Same thing with COVID.
Okay. So another thing I would like to ask. So Dr. Kapil Zipre came up with a wonderful article on using artificial intelligence in radiology. It was published recently. So where do you see artificial intelligence with respect to CT scans?
In an artificial world, these are all papers. There's no real life utility at this point. It doesn't make any sense. So we know proof of concept that it works to. So these are called narrow AIs. They are asked a specific question, they give answers, and they work only on those data sets that they've been trained on. We've been working with AI for almost 5 to 6 years now, and it's still a long way to go before there's any real life usage as far as CT and diagnostic and scoring and all of that is concerned, way into the future.
Dr. Bhavin, this is Dr. Rumta. Thank you very much for joining us.
How are you?
I'm fine, thank you.
My
My question to you is there any specificity about CT in COVID?
So specificity is in the range of about 80 to 85%. So that's where CORADS comes in. If we say that it's CORADS 4 or 5, then as a radiologist, I'm very confident it's COVID. So my specificity with CORADS 4 and 5 is virtually 99%. Of course, there are situations where we're not sure. There are situations where we overdiagnose, sometimes underdiagnose. All that happens. But overall, CT is a good modality.
Number two question is, what is your experience about when RT-PCR probably is not yielding any results and CT gives a guidance?
That does happen. It happens in quite a few patients, yes. So
do you think that is related to technology or that is related to real pathological outcome?
No, so I think it's related to real pathology. I think we still know that 20-30% of positive patients have negative RT-PCRs, and their CT scans will be positive because they have disease. So that population is, that was the first, in a way, the first question. If you have a patient suspected to have COVID, if RT-PCR is negative, do we do a CT or not if we strongly suspect COVID? And yes, that's where it helps.
Prognostic part you have already explained.
So one quick question, sir. When you look at perfusion scans, how do you know that it's more to do with fibrosis, that it's probably we are not dealing with microthrombi or some thrombi formation?
No, we don't. So if we right now, like I said, unless except in mechanically ventilated patients, we still don't know whether this quote unquote fibrosis is real or not, because after I gave this lecture, 2 new papers have come out on October 5th with 1-year follow-up of CTs. And the standard learning is that nobody progresses, 75% to 80% improve, and 20% to 25% remain static at 1 year. So coming back to the perfusion thing, when we're doing the perfusion scans, when we see those defects, most of them are actually related, therefore, to the microthrombi rather than lung changes, because where you have lung changes, you actually have hyperemia because there is more blood flow going there. And where the defects are, they tell you that's where the microangiopathy was. So we're learning not to use the term fibrosis. We're learning that much more is happening in the lungs beyond just the changes we see on CT scan. But we're also learning that everything seems to improve over the long term, in some fast, in some slow, but eventually it improves.
Last, I want to comment on Sir's lecture. Can I come in?
Please go ahead.
I'm from Jalgaon, Maharashtra, Dr. Leena Patil. I just want to comment on Sir's lecture that HRCT has played a very big role in the beginning when we are learning, where RT-PCR reports used to come after 6 days, 7 days, because it's in periphery, and CT scan is help a lot us to learn and diagnose. So of course there is a big role. Thank you.
This side, Dr. Rhythm Sharma, one of the main reasons in answer to Dr. Rungta's question could be that many times these are new variants, Delta and Delta plus variants, they generally do pass nasopharynx, they do not lodge over there. And they directly get receptor, binds to the ACE2 receptor in the lungs. So most of the time, what you get picture RT-PCR being a negative, but you find that HRCT things are positive.
Thank you so much, sir, for a wonderful talk. Short of time, I request my next chairperson to introduce Dr. Anand Dongre for the next talk, please.
You are muted. Please unmute. Unmute yourself now. You have to unmute yourself. Oh, not audible, ma'am.
Ma'am, we can't hear you.
I'd like to introduce Dr. Anand Dongre. He's the founder and managing director of Clopping Critical Care Council. Clopping has a massive experience over the last 5 years.
We have the video.
Good afternoon, respected chairpersons. At the outset, I must thank Dr. Rungta the organizing chairperson for this World COVID Conference, along with other team members of the organizing committee like Timala, Sudhir, and Ranveer, who have worked hard for this conference. My topic on this is Nagpur experience, COVID striking twice. Yes, COVID struck twice. But before that, I need to tell you about Nagpur. It is centrally located, even geographically, 0-mile marker starts from here. It is also known as Orange City. It has been awarded a Cleanest City Award and as well as Greenest City of India. It has been founded in early half of 18th century by Bundelkhand, and it is also known as winter capital of Maharashtra, where assembly session takes place for 20 days to 30 days per year. So this is how the Nagpur looks like. The metros have started here, and it caters to a population of 4.6 million, which has got 11 districts, 11 talukas. In other words, it is also comes under a region known as Vidarbha, which has got 11 districts and which comprises of Amravati, Akola, Buldana, etc., etc. So Nagpur has got a huge population base, which it covers through 4 medical colleges and a lot of other hospitals, corporate hospitals, nearing to a total bed strength of 3,000 to 3,500 intensive care beds. This is what we came to know during this COVID the pandemic. So let us begin. The first case of COVID-19 pandemic, as you know, Maharashtra was topping the list, so to say. And the first case of pandemic was found in Maharashtra on 9th March 2020. The largest single day spike, 68,000 cases, highest peak in all of India, was reported on April 18. That was the second wave, the brutalist month, or the battle which we fought. It was in April 21, March, April, and May. And the Maharashtra was hotspot that accounted for nearly 22.35% of total cases in India, as well as about 30% of all deaths. So Nagpur, along with Vidarbha region, almost covers 1/3 of Maharashtra. So the situation in Nagpur was not different. First wave, March to September 20, and the first reported cases in Nagpur was on 11th March. And sooner, we had to have a lockdown by 17th March. Second wave again started with that March, April, May were horrible. A lot of surges and lot of patients at one point of time. Almost all medical colleges were full, almost all hospitals were full. And initially, during the first wave, it was thought that the COVID has to be contained within those 4 medical college walls. So only medical colleges were allowed to have COVID patients. But later on, in the second wave, we had to, the authorities have decided to convert each and every available hospital in Nagpur to a COVID hospital. So those centers which has got tertiary care will be declared as dedicated COVID hospitals, and other centers without ICU facilities but with oxygen, they were dedicated. They were known as dedicated COVID centers. And this is how the second wave started. The second wave was more furious, and it has a number of cases. And you can see that almost total number of cases in Maharashtra, which was there in the first 10 months, has increased, was equal to those which we found in second wave on March, April, and May. That is the time of second wave. And this was the news in India today, which says how the second COVID wave has battered Maharashtra. Really, it was a real pandemic, first time situation for all of us, and we have seen lot of panicky, lot of fear, lot of deaths, even, and every single person was every day thinking about COVID and COVID and COVID only. The state has recorded more cases in the first 72 days. Can you imagine that in first 72 days of second wave, what number of cases we had which were not there in first 11 months of first wave of COVID. So in Nagpur was not far behind, and in one day, almost in April, the whole month has witnessed 53,000 cases. Fatality rate was more in first wave because lot of treatment therapies was going on, therapeutic interventions were sought in, plasma therapy was coming in, tocilizumab was there, remdesivir just halfway through first wave. But the second wave, we were prepared very well as far as the therapeutic interventions were concerned. Ventilators were bought, they were distributed, and all hospitals, ICUs were geared up. The second wave, we can see there is a decline in death rates. And the month April was the horrifying month. Nagpur registered the most COVID deaths of any district in the worst hit state of Maharashtra in April. 60 deaths on a single day. Later on, we had oxygen. The problem started along with the second wave. That we had a problem with oxygen. So the oxygen rationing was done. Oxygen committees were made. Oxygen cylinders were in high production from Hyderabad, nearby Telangana, Hyderabad. Oxygen cylinders were brought in, and it was taken in control by district magistrate so that the oxygen rationing can be done appropriately. And you can see even in OPDs, even in IPDs outside the hospital, patient used to come in auto rickshaws, ambulances, and by other means to just keep holding themselves till they get a bed in intensive care unit. I think it was there all over India, and the oxygen deficit was really was a hardening one, because every day you have to have a 6-hourly monitoring of oxygen cylinders. Everyone was on BiPAP, everyone was on ventilator. I mean, most of the patient, almost anyone gets admitted was requiring oxygen. The oxygen was in high demand and short in supply, and those were the horrifying days which we underwent. Then the preparation of all hospitals, because they were not allowed in the first wave to keep a COVID patient. It was started in second wave, and almost everyone has immediately started a preparation of training of nurses, PPE kit, how to wear PPE kit, how to sanitize yourself, how to sanitize the area, how to look for the patients, and intensive cares, video monitoring, video chatting, and all these factors which came into play. All the preparations were gone. Similarly, at hospital levels, training purposes were there, and they were good. There were the people. They came in group as well, like couples. Every patient who gets discharged should have a photograph, and it should be submitted to NMC or Nagpur corporation authorities. So here is some of the photographs I show you of those glimpses. Then new methods and new masks, new innovations, they were all there, and everyone was trained for that. Then along with that, we had an associated disease as well. The burns patient which came, and the central line procedure or tracheostomies, they were done all under PPE kit and with limited supplies. And second thing, HFNS was in high flow nasal cannula was in vogue at that time. So many patients were on BiPAP as well as on HFNS. COVID deaths, it was no wonder that because of lack of beds, because of lack of oxygen, because of lack of drug, we had a lot of deaths during that period as well. And every death has to be reported to Nagpur Municipal Corporation. Body is to be handed over to Nagpur Municipal Corporation so that they can give the body or take the body to the mortuaries. Administration gearing up, yes, Nagpur administration did a very good work. Oxygen rationing was done. District magistrate was in charge. Remdesivir control was done. Every day 6 p.m. the list used to come and distribution of Remdesivir was done. Then there was CCC, that COVID coordinating center, where all patients, everywhere, the public were given the number, patients were given the number, and wherever you need a oxygen bed or a bed, you call CCC, they will distribute it. And that is how it was regulated nicely. Supply of ventilators were there from the NMCs and government authorities. Increasing bed strength, yes, there were almost 1,000 bed strength were added, especially intensive care beds were added. Telecounseling was one of the biggest factor. It was in association with IMA, and Indian Medical Association member helped the patients to check their the admissions or hospitalization or their panic situations. They by telecounseling they were answered. Coordination committees were made, task force committees were in work, citizen forum, and public awareness program on every second day or third day on some aspect of COVID was done. So administration has done a good job. Lockdown continued, but there were chaos on many aspects like mismatch of bodies or victims were not ready to accept, the relatives were not ready to accept that someone has died because of COVID. But there were good news as well. 99-year-old man who got admitted with breathlessness, fever, and weakness was admitted with us, and 3-4 days he became a little better and he defeated Corona. He was in the news as well. Other side of pandemic, we had one of the patient, you can see on the left side, he had a score of 18/25. He thought that he's going to die because he knew about CT scan correct score, but he celebrated his birthday in intensive care because once his oxygen were off. And Dr. Ajay, Commissioner of Ajay Kumar, at that time, Commissioner of Nagpur, was giving awards to all those who participated in telecounseling. There is a short video you can see of patient on HFNAC. There is a score of 17/25 was on FHNSC. But above all, there were a lot of philanthropists, good Samaritans who were working from outside. And when oxygen supply was less, one of these, Pyare Khan, a transporter, had tried, and he also supplied almost over 205 tons of liquid oxygen by 19 tankers from multiple locations. So this is how Nagpur could survive and overcome the death rate. Happy hypoxia is not only found in COVID, but as well at the highest peak of the world, or second highest peak of the world, that is Changla. Thank you very much.
Is there any question?
I don't see any questions in one sec. There's one question. No, let's comment. It's a fantastic talk, sir. We do not have any questions. I think Nagpur fought COVID like any other city or any other state in the country. Serena, ma'am, would you like to ask something?
Your voice is not audible, ma'am.
Ma'am, we cannot hear you. Ma'am, we cannot hear you. We cannot hear you. Can you unmute yourself, please?
Maybe her mic is not working. You can try by earphone or.
No, ma'am, we can't hear you.
We can continue with the next speaker.
I request Dr. Prashant to please introduce our next speaker and thank Dr. Anand for his wonderful talk.
And Dr. Prashant is not online. Can you please introduce? Unmute yourself.
Dr. Vijay?
No, ma'am.
Okay. I take the pleasure of introducing Dr. Leena Patil. She is an intensivist at KD Patil Multi-Speciality Hospital, Jalgaon. She has been a member of the COVID Task Force at Jalgaon and is Secretary of the Critical Care Society at Jalgaon. She will be speaking about the Maharashtra semi-urban experience of about 2,000 patients. This is actually a question I would have asked Dr. Anand as to how do they get to the grassroots level. Probably Dr. Leena will have some answers to that. Dr. Leena, please.
Good afternoon, everybody. My topic is Maharashtra semi-urban experience of 2,000 patients, the data. Before that, I just want to introduce regarding the pandemic situation initially at Jalgaon. Maharashtra State Jalgaon district. It comes in Nasik division, away from 400 kilometers from Pune and Mumbai. What were the initial challenges for us? Lockdown since 22nd of March 2020. In April 2020, there were only few admissions of COVID-19 SARS-CoV-2 virus in Government Medical College Jalgaon. Cases start rising in May and June 2020. No private hospital was ready for COVID cases admission at beginning because the associated staff is not ready to work for COVID patients. Indian Medical Association helped a lot by putting a private medical doctors duties to government colleges to help the government doctor and learn about the virus. Because in India, we know that we are having a highest population, so it is going to increase, the cases are going to increase. What we had with us, 65 ISSM members, we learned COVID from webinars because lockdown period was there like 3 months. So we learned a lot on webinars from USA, China, papers presented by them. What infrastructure we had in Jalgaon? 1 government medical college, 1 private medical college, 3 multi-specialty hospitals above 50 bed and 13 small ICUs. Not sure in the month of April 2020 that Jalgaon is going to be a hotspot or continue to be in the green zone. What we know at the beginning, which drug as an antiviral drug? Hydroxychloroquine, lopinavir, ritonavir, prophylaxis with chloroquine or hydroxychloroquine. What we know is steroid is working when hypoxia is there. The only effective drug that time was oxygen if the patient goes in respiratory distress. There was a task force implementation under the guidance of civil surgeon in Jalgaon. On 4th June, Honorable Health Minister of Maharashtra, Rajesh Tope, visited Jalgaon due to high death rate, which was 11%, and asked about the implementation of a team of 10 doctors dedicated for guidance, especially physician, anesthesiologist, chest physician, and intensivists. Team of 10 doctors with civil surgeon and honorable collector. Ground level visit done on 6 June 2020 to Government Medical College. Till 6 June 2020, no private doctor was ready to give his own hospital for COVID because 80 to 90% of the doctors having their residence on the top floor of their hospital. The task force team with Honorable Collector. There is a group of 10 doctors which is always there to help and to make the team work. Death rate continued to rise. As the death rate was increasing, bed efficiency started. Many NGOs came up with the COVID centers. COVID centers and quarantine centers came up, but those for mild cases. Many private hospitals got permission for COVID hospital at the end of June because society people who took allegation against COVID hospital, their families getting short of bed. So they returned back their complaints and all doctors were working freely and slowly the staff also started working. There is initially a very social stigma regarding we are not getting class 4, class 3 workers to help the patient. So we applied a bed assistant system. The relatives sometimes allowed to feed their own relatives. But still the death rate continued to rise. There was a fear because the relatives had COVID. But still we are on to it. Anyways, we have to manage it. Productive work being in task force. Jalgaon is having a 42 lakh as a district population, 5 to 6 lakh city population, and 15 taluka places. All moderate to severe COVID cases are going to come to Jalgaon for treatment. 8 meetings with Honorable Collector Sir, Government Medical College Municipal Corporation. We are having a teamwork. Productive discussion on availability of bed, drugs, training for ventilators, already been started. We work on testing, tracing contacts, and treating COVID patients. Video conferencing at taluka places level. When we use immunomodulator first time, I specifically want to mention because it was a learning curve for every doctor. In April 2020, one of our physician father, his age was 78 years, day 8 of COVID positive, he was on calcium, zinc supplements, and HCQ. He went into respiratory distress and oxygen requirement increase. As mentioned, steroid was given Solomidrol 40 milligram IVBD, which is mentioned in the guidelines. Patients start deteriorating and put on BiPAP. IL-6 level were not available in Jalgaon, so sent to Pune. Cytokine storm start typically on 9th day of the patient symptom. We have done chest X-ray, ABG, 2D-CO was normal, ABG PO2 FiO2 ratio less than 100. CXR showing increased shadows. We use injection tocilizumab 8 milligram per kg, which was available in our hospital because we read about it in April 2020. Patient symptoms of breathlessness decreases within 2 days of administration of drug. IL-6 level came after 2 days, which were 4,000 picogram per ml. Learning curve from here was timing of drug, timing of diagnosis monitoring is very, very important. Injection remdesivir got available at the end of June. Lot of controversy regarding this drug now also and at the beginning also. But as in COVID, right time, right drug and patient survival. As we start using injection remdesivir, the recovery rate was faster in July than in May and June. Antiviral drug in viral application phase may inhibit the further damage. Death rate also came down from 11% to 2.3% in August and September. More bed available, critical load got distributed, drug availability, oxygen availability was the cause for it. We always worried about the moderate and severe cases. Those required most attention. Otherwise, many survived with their own immunity. This is the diagram which shows how the inflammation and pulmonary phase is simultaneously occurring and the patient is having respiratory distress. That is the early stage and this is the severe stage. If the patient immunity is very good and the patient will not go into the cytokine storm, but if the response from the immunity is very high, then patient land up in severe and moderate cases. Now presenting 2,000 patient admitted data, we manage at tertiary level. Retrospective data from 21st of August 2020 to 21st of May 2021. 75 bedded hospital, 2 oxygen plant, atmospheric oxygen plant, capacity of 65 cylinders. I specifically want to mention because this plant helps us a lot in second wave, where there was oxygen deficiency. Age group of all patients, 23 years to 94 years. Severity of the disease depend on PO to FiO2 ratio. Less than 100 was an ICU admission criteria. In first wave, treated 1,286 patients, 774 were moderate to severe, 450 ward admission and 62 deaths. In first wave, we manage ICU patients with high flow oxygen, non-invasive ventilators and BiPAP. 362 patients were on BiPAP, 289 patients on high flow and intermittent BiPAP, 123 patients on NIV. I specifically want to mention in first wave, each and every patient received standard treatment of injection remdesivir and steroid as indicated. Total deaths in first wave, 62 deaths. Cause of death, 9 died due to sepsis. Average length of stay was 25 days. 5 deaths within 24 hours ICU due to respiratory failure. 10 patients had cardiac cause as a terminal event. Even after thrombolysis, we couldn't save these patients. 2 patients had abdominal distension, suspected abdominal vessel thrombosis, but we couldn't do much for that patient. 36 patients had respiratory failure and intubation and death within 24 hours after intubation. So, death due to respiratory failure were high, 66.1%. First wave almost end till 10th of January 2020. No admission in the month of January. Second wave started in February 2021. On 18th wave, 5 UIDS admission in 1 day. Within 5 days, the hospital flooded with patients. What is the difference between first wave and second wave? In first wave, within a family, 1 or 2 patients were admitted in ICU. But in second wave, we were surprised that sometimes whole family is in the ICU. 714 admissions in second wave in ICU. 714 admissions in second wave. 632 admissions were in ICU. 330 patients on BiPAP. 120 patients on high flow and non-invasive ventilator on admission. 182 patients on non-invasive ventilator on admission. 24 patients on mechanical ventilation. Average mechanical ventilation day is 8 days. Still, 50.3% of patients were managed on BiPAP. Use of immunomodulators. We usually try to use the immunomodulator within 24 hours of ICU admission if the oxygen requirement is very high. Injection tocilizumab, 130 patients, 12 deaths. Injection itolizumab, 45 patients in ICU, 9 deaths. Injection bevacizumab, 16 patients and 13 deaths. Total death in second wave, 79 deaths, 15 had sepsis, 6 patients had pneumothorax, 7 patients had mucormycosis and sepsis within the ICU and they died. 51 had respiratory failure, 3 patients went down. Death in second wave, still 64.6% of patients died due to respiratory failure. Lab parameters of all non-survivors, D-dimer more than 10,000, LDH more than 1,000, serum ferritin more than 500, CRP more than 40. Above 4 parameters can be considered as a mortality indicator in COVID-19. Retrospective analysis of all ICU patients, survivors and non-survivors. We had total 2,000 patients. Out of that, 1,406 ICU admissions. 185 patients received immunomodulator, injection tocilizumab. 149 patients survived out of that, and their length of stay in ICU was 10 to 12 days. Death in that group were 36 patients were non-survivors. Total non-survivor were 138 during that period. And immunomodulator use in non-survivor is very less, like 36 patients. So immunomodulator use was less in non-survivors patient. No patients survived who required intubation. We intubated 24 patients in second wave also, because at that time there was a deficiency of remdesivir, there was a deficiency of immunomodulators, and we have to ventilate, intubate, and oxygen and ventilation and supportive care is the main weapon in our hand. So, but none of our intubated patients survived. So my observation is timing of immunomodulator is very important for a better result. So this is all about the retrospective analysis of all ICU patients, which we manage in semi-urban area. Thank you so much.
Any questions from any of the panelists? Any questions from anybody in the audience?
I think question.
You
just want to hear the experience.
No. How are you now prepared? Should we have a third wave? What have you learned from the second wave, and how are you prepared for the third wave now?
I think We are prepared for third wave, like pediatric wave is going to come. The what ultimately is the patient immunity is saving the patient, and we are having a lot of vaccination, but still we don't know how the virus is mutated. But still we are ready, at least with an equipment. Actually, I want to give credit to our district collector for a fantastic oxygen management, because we have seen being in task force. I really appreciate his work, and I think he'll do the same thing, because the distribution to private and government is through the magistrate. And whenever it comes to and saving lives, there is an equal distribution of oxygen, and we are prepared. Yes, we are prepared for third wave, because we are having lots of centers which is recognized by the government as a DCH. So we are ready.
This is Dr. Rumta, Lina. Gauri, can I come in?
So just I just wanted to make one thing, sir. You
Yeah.
can also say it.
Yeah.
I think it's my observation, and correct me if I'm wrong. So I think for our third wave, I think the private setup will be more receptive in accepting patients with COVID-19 that we struggled in the initial phase when the second wave hit us. That scare, the fear has now gone away. So I think we'll get a lot of support from smaller private setups if we kind of run out of beds in the bigger setups.
My two questions, one to Gauri and one to Lena. Why do you think third wave will come? Gauri?
Sir, can you see the mehndi on my hand?
Yes, yes.
So nobody was wearing a mask in any of the streets of Delhi today. The markets were chock-a-block full. Nobody was wearing a mask. There was no place to sit, no place to stand. Okay. So
and still we go there.
So I don't know what this festival will
because
do.
Tomorrow is Karwa Chauth.
Yes, exactly. So I mean,
right.
I thought I went very early, but I could see.
But you are in Chandigarh or you are in Delhi?
Sir, today I'm in Delhi. Today I'm in Delhi. I'm going back.
So my question goes to Lena. Why do you think children would be affected?
Sir, children's like
people are talking about it, or somebody said it, or you read somewhere, or there is a scientific reason.
There is a little bit. If the schools got open, then only children will get affected. I want to correct myself.
No. It is not question of correction. You see, we just want to know, discuss it out, and we want to know.
I would like to say something, sir.
Yes,
sir,
yes.
I have a daughter who's 17.
Yes.
I have a daughter who's 17, and
don't tell me you have a 17-year-old daughter. Okay.
I'm a semi-relic, sir.
Okay, go ahead.
So now this group of children who are in their 10th, 11th, 12th, so they're almost like an adult, and they're not being vaccinated. And that's one of the big fear I have of trying to send my kid to school, because when if God forbid they get it, they will actually, they'll behave like an adult. The severity might be high. So they're not going to behave like children. They're going to behave more like unvaccinated adults.
Now, my suggestion, I have spoken about it earlier also in the conference, and I talk about it on the social media, on TV also. You know, this, we cannot do if something comes.
Right, sir.
But when we keep saying that third wave will come or children will be affected, the morale within the house, around the house, in the society goes down. People become apprehensive. So I feel that this is duty of all of us to keep the morale up. At the same time, keep people telling to observe COVID appropriate behavior. Force it, enforce it, suggest it, request about it. Do everything possible. Blackmail them, whatever you can, but keeping cheerful and let the society be cheerful for whatever time, that is very, very important. And that is how you can keep your ICU also very cheerful.
Right.
Your nurses, your residents, your patients' relatives, and those patients who are recovering, those also. Now, there is an observation, Dr. Nirmal is there?
Yes, sir.
Nirmal Anand was also there?
Sir.
No, I see lots of Maharashtrian doctors around at the same time. What is the problem?
When the Leena is there,
You had decided or what?
Pardon, sir?
A doctor from Jalgaon, three doctors from Nagpur.
Sir.
Right, sir.
So what is the issue?
No, sir. Andy, the force is Andy.
Okay. So something is, I can sense that there is some force working. So that is exactly what I wanted to know.
So it was like Nagpur, which has Nirmal, who first started a COVID center in the private hospital.
Nirmal,
And everyone
Nirmal does not have time even to pick up telephone from unknown numbers.
No.
So
sorry for the inconvenience to you.
No, he is very busy. No, that's good, not unfair.
But Nagpur was the worst hit, sir.
We cannot afford picking up every call that comes our way. Because I was a bit relaxed, so I thought that we will have a small
But sir,
lighter chat.
I again wanted to say you have absolutely utilized that time to have the best product on this earth today.
No, that's okay, but this has been possible with cooperation of all of you. Small experiences build up the fort. Juhi, all the way from Muscat.
Yes, sir. Yes, sir.
Yes.
Really,
Welcome.
it's been a wonderful experience, sir. Really, congratulations
No, even we have learned a lot.
Yes, of course. I think we learn every day. Yeah.
When I'm
absolutely.
sitting, you see, not seeing patients, I'm sitting across the monitor, listening to everybody, taking notes. And,
some normalcy. So you brought some normalcy, sir.
No, I can see a lot of smiles now.
Absolutely.
Yes. Anyway, thank you so much. I just wanted to make when Leena was talking about pediatric, I have been a pediatrician. I am a pediatrician basically.
Okay.
So I'm MD pediatrics and then I entered critical care medicine. So
Great.
I was a little worried that why COVID should affect. Nowhere in the world children have been affected so far. There have been cases, yes, no population can escape, but the death rate is, it's Kawasaki-like syndrome.
But sir, I still feel, Leena will also agree with me, that thymus is playing the major role in pediatrics.
Yes, because if you do 100 X-rays of children below 1 year, the superior mediastinum will be white. So that is the thymus shadow.
Yes.
And many children cannot withstand that thymus disappearing.
Oh.
Well, as a pediatrician, I do not know what is happening, but yes, every examiner would put that X-ray, wide mediastinum, and if you don't speak the differential diagnosis of thymus, then come after 6 months.
Right.
Sir, I want to comment a little bit upon the first wave and Indian culture than the world culture. Because
I hope we have the permission of the chairpersons and the anchors.
Actually, we were supposed to wind up at
okay, fine.
5. We are already at
No,
6.
not because I am there, so there is no
session.
liberty to me even.
Yeah,
No. So I think we should close this session. We have Dr. and all waiting.
No, after 5 minutes, somebody will blame me.
Oh,
Dr. Rumta was carrying on. So what can we do?
Yes, yes.
That's okay.
So we hand over the session to the next chairperson.
Yes, yes, please.
The next session. Thank you so much.
Thank
you
you.
all speakers. Thank you.
Thank you for the wonderful session. Thank you.
Ma'am, yeah, still one speaker is left. So this is the last speaker of the session.
We have, okay, it's not there on the pan. Okay, it gives me absolute joy to introduce Ashish, Dr. Ashish Khanna. Know him from childhood. He is a son of a very, very, very famous surgeon from PGI. He's an associate professor and vice chair of research, Department of Anesthesia and the section of critical care at Wake Forest University School of Medicine at Winston-Salem, NC, USA. He is the vice chair of the American Society of Anesthesiologists. He's on the Committee of Critical Care Medicine, and he's the program co-chair of SCCM of the Annual Congress 2023. I welcome Dr. Ashish to come and give his next talk.
Just 30 seconds for me, Gauri, before Ashish. I just want to...
Okay, so...
Ashish, thank you very much. You are most welcome. And we are not happy about the fiasco or confusion that was caused, but there is happy ending and you are here. Thank you so much.
Hello, and thank you much to the organizers for this opportunity. I'll be talking to you all today about patient selection for ECMO in COVID-19, a very relevant topic with several connotations, both on the medical, critical care, and ethical fronts. So I want to start by going back in time, and I'm going to go back in time right when the pandemic started, especially for us here in the US. This was about early March 2020, when we first started feeling the pressure in hospital systems and ICUs all over the country. And what I have on screen right now is what we were doing at my 850-bedded tertiary care university hospital that has about 150 to 200 ICU beds, with the ability to put about 5 to 7 patients on ECMO at any one given time. So these were our basic ECMO guidelines going into that time. Patients who were younger than 60 years of age, with a PF ratio less than 150 on 60% FiO2, a PEEP of 5, and any patient that gets prone or paralyzed for oxygenation and or with cardiogenic shock or myocarditis due to COVID-19. These were sort of the broad frameworks for when we would consult the ECMO service, which I am a part of. So when things evolved, we obviously, the way we ran this ECMO service would be based on what I just showed you in the last slide. We would consult the ECMO team. Now, the ECMO team would consider going on ECMO based on these criteria. So in the presence of respiratory failure or cardiac failure, single organ injury, less than 5 days on mechanical ventilation, no major comorbidities, and fully functional prior to mechanical ventilation, which is really important, that the ability to have a good quality of life prior to going on mechanical ventilation or prior to the sickness that's taking the patient to ECMO is really, really essential. And we would really put a lot of emphasis on that one as well. Now, importantly, at least in terms of the logistical plan, everything would require the approval of an adult or pediatric ECMO director. And obviously, as COVID progressed, we also narrowed the age. So while general ECMO was about 60 for COVID patients, 50 or less was sort of that cutoff for going on ECMO. Now, the RESP score is important. I bring this up, although I understand that it is not a prognostication tool per se for screening to go on ECMO, but it is a survival tool to see prognostication for patients who are already on ECMO. However, the other way I use this, or I encourage my trainees to use this, is go ahead, look at the factors on the RESP score, things like age, duration mechanical ventilation, etiology of respiratory failure, underlying CNS disease, neuromuscular blockade, underlying acidosis, and possible cardiac arrest. Factor those in and then see whether your patient is going to be a good candidate or not for ECMO. And it's important because, as we all know, the score itself goes from a negative of 8 to a positive score more than 8, and it classifies on risk categories and in-hospital survival. Things such as age, duration of mechanical ventilation, and also certain etiologies of respiratory disease, along with pre-existent CNS dysfunction, really put a patient all the way down on in-hospital survival. So clearly, those patients are not good patients to consider them as candidates for ECMO in any case. Now, classically, yes, we do look at the Murray lung injury score and clearly set criteria. You look at radiology, look at 4-quadrant involvement, look at how hypoxemic your patient is, look at how much PEEP patient's on, and look at respiratory system compliance. And again, as we all know, after dealing with this pandemic for nearly almost 2 years, respiratory system compliance has become a really important factor when we start looking at putting patients on ECMO. We all know that there's a very fine line between over-ventilating your patient, whether invasively or non-invasively, prior to going on ECMO, and how non-compliant those lungs are when you decide to take the patient on ECMO. Clearly, if the lung injury has reached the point of initiation or onset or progression of fibrosis and a point of irreversibility, then the exercise of putting on ECMO is essentially a bridge to nowhere, which is the biggest thing that we're all worried about. So what does ELSO say? I just wanted to quickly go over this. ELSO does also look at your hospital capacity, right? So this is really, really important as we deal with surge situations. So it goes from conventional capacity to tier 1, tier 2, and crisis capacity, depending where your hospital is within these different tiers. That should also govern your decision to go on ECMO or not go on ECMO. Now, ELSO also has this complicated algorithm. I'm not going to go all the way through it, but it looks at different PAF ratios, need for neuromuscular blockade, whether you've proned your patient or not, whether you've tried inhaled pulmonary vasodilators like Floland, you've tried recruitment maneuvers. So the important thing here being that the ELSO wants to essentially tell you that you have to not just show hypoxemia, you also have to show that you've tried some basic maneuvers prior to going to ECMO, and then further, depending on the grade of hypoxemia and ruling out of other contraindications, would the recommendation of ECMO be made. Again, another similar way of what I just said, important thing is the contraindication side. If you cannot remember anything, just remember irreversible organ system failure is a clear contraindication to ECMO, whether it is neurological failure, whether it is respiratory failure, whether it's a combination of the above, and whether there is sort of a poor quality of life before going on ECMO. All of those things are clear contraindication to ECMO. So I'm gonna, to make this slightly more interesting, I'm going to present to you one of our clinical cases. It was a young 13-year-old boy with a BMI of 73.9. Now, I'm saying a BMI of 73.9, not a body weight. So his body weight close to 500 plus pounds, COVID-19 pneumonia, 3 days history, intubated right away as he got to the ER, was hypoxemic, PEEP of 20, FiO to 100%, paralyzed, sedated. I was on ICU service that night. I was consulted for putting him on ECMO. He also had a possible inferior MI. He was too big to take him to the cath lab, put him on the table. Bedside echo, I picked up a probe and put it down, looking at a subxiphoid view, and it was generally good function. Now, most of you would probably say, well, we're not going to put this candidate on ECMO. It was early days of the pandemic. The guy was young, and I did put this patient on ECMO. And in fact, he turned out and walked out of our hospital 3.5 months later and is now living a great life. and we've now reported this as the largest living survivor of VV ECMO in COVID-19 coming from our center. Some of the things I want to highlight here is sort of the progression of disease, right? So this is how his COVID-19 pneumonia started, very typical, ground glass opacities. This is immediate post-intubation, very typical X-ray that all of us have seen in the last 2 years or so. We had several adventures and misadventures in this patient. We had to transport this patient from one part of the hospital to the other. We lost that airway a few times during transport. We also found him nearly impossible to ventilate. We finally used a 37 or a 32 French crescent bicable double lumen VV ECMO right IJ cannulation for him. It was a massive team effort from a lot of specialties involved. Initially, rest settings on the ventilator, adequate central arterial access in addition, titrated sedation needs, and had a bit of a challenge maintaining ECMO flows with cardiac output. His cardiac output himself was close to 16 to 20 liters per minute all the time. We had to do several things, including a beta blocker drip to drop his own cardiac output down, continuously monitor non-invasive cardiac output with a flow track, and then try and match ECMO flows as much as we could to his cardiac output to prevent shunt hypoxemia. So turned out to be a very interesting case. This is ECMO day 0 with appropriately positioned Avalon. This is sort of the timeline. I encourage you guys to look at our case report. We tried several different things during his whole stay in the hospital with us. This is ECMO day 1, typical lungs of COVID once they've been cannulated. ECMO day 3, similar non-aerated lungs, rest settings. ECMO day 15, 16, lungs have started opening up here a little bit. Aeration is coming back. This is time they're starting to make good volumes on the ventilator. Lots of numbers here, but basically showing his overall blood gases during his entire CVICU or stay with us. Trajectory of improvement all the way through. Vent settings are reasonable, and he's starting to make some own tidal volumes as well as he progresses and over the course of illness. And again, this is all of his inflammatory markers, which clearly didn't show a great pattern. We were very fond of doing inflammatory markers a year and a half ago, but we soon realized that they weren't really telling us a major story. And then coagulation results, as we all know, this was another thing, especially D-dimer, as you can see, typically very high on admission. Stays quite high all the way through, although there's some times when it does go down to about 5,000 to 3,000 right here. This is immediate post-decannulation. So he stayed on ECMO for about 3.5 weeks and then was decannulated. X-ray looks way better. I was again on service that night, and this boy went into severe septic shock. Soon after he was decannulated, had MSSA bacteremia, high spiking fever. The graph at the bottom shows that there is blood pressure. This is the A line in black. It was dropping all the way down to maps of 50s and 40s. He was already on 3 pressors at that time. I did start him on angiotensin II, acted as a good rescue vasopressor for him. And then he stabilized out. This is his ventilatory settings as we were decannulating him. And this is a typical case also, high renin vasodilatory shock, where his renin at that time was about 10 times normal. And clearly angiotensin II right here showed a dramatic response and led to early stabilization along with initiation of antibiotics for his septic shock. So overall, then in the medical ICU and on the floor, this boy made a great recovery. It's a great example of when you should be flexible with your choices in ECMO, and there is an opportunity to intervene and to do well, then it should be done. Now, this is the ELSO dashboard, which is continuously updated with real-time data. So there's about 10,000 COVID-19 confirmed cases on ECMO in the ELSO registry. Clearly, there's more patients than that on ECMO, but because not everyone in the world is reporting to ELSO, but just to give you a ballpark number, ECMO is being done fairly frequently for COVID-19, although in the last 6 months or so, I've seen a general reluctance because of surge pressures and outcomes not being that great. Now, the ELSO does report a in-hospital mortality of nearly 50% of patients on ECMO. And I think that's fairly reasonable. That's exactly about where our center is. And it all depends on, again, on patient selection and several other factors on how your patient's going to do. But again, that in itself is a little bit of a moving target. Obesity, I presented this case to you. Interestingly, obesity has not been clearly associated with poor outcomes in patients on VV ECMO, and especially those with COVID-19. Here is some data that does show that there's a significant amount of obese patients who are already on VV ECMO and are being reported by ELSO. The group from Maryland, Sam Galvano and colleagues have looked at obesity classes all the way through, and they haven't really shown that increased obesity, overweight up to class 3 is associated with poor outcomes at all. And similarly, is another representation of their work. And other work also published in intensive care medicine here showing that the only time obesity starts making a difference is at body weight, 100 kilos or more. And clearly, this is something that we saw as well. So in short, I thank you all for your patience. It was a broad-based discussion along a clinical case of patient selection for going on VV ECMO. I will say that use your clinical judgment. Use the triage scores that are available. Look at patient-specific issues. Every patient is different. Every situation with COVID-19 is different. Use your institutional guidelines and triage strategies as well. Look at your own internal resources, staffing, nursing, patient ratios, and hospital stress situation. Look at the patient's quality of life. Very, very, very important. Don't just put patients on ECMO when there is no chances of survival. So it's a destination to nowhere. It should never be a destination to nowhere. Seek evidence and add to the data. Look at ELSO all the time. They're updating their data. Collaborate with specialties and build up a good, strong multidisciplinary critical care team, because that is really the essence of saving patients on ECMO. Is not just you yourself, but all of those critical care team members who are going to ultimately lead to better patient survival. I thank you all for your patience. I always bring up this. May of 2020, when the US reached 100,000 COVID deaths, I thought that this was very telling at that time. I know that we're way beyond that all over the world, but I wish for you all to stay safe, and thank you all for this opportunity.
Can we have Rumta sir? Are you there, please?
Ma'am, he's not Dr. Sorry. Dr. Assis is not online.
No, Dr. Rumta.
Okay.
I don't see any questions, and Dr. Ashish is not there online. So can we close this session? We are running late by almost 45 minutes. And would like to hand over this session to the next chairpersons to continue the evening plenary session. Thank you.
It's a quiz actually.
Good evening, everyone. It is an honor to have you all here for the World Conference on COVID and Critical Care 2021. And I hope it's been a smooth experience so far. And now we will proceed on for the quiz. The quiz masters of which are as follows: Dr. Anup Kumar, Chief, Critical Care Medicine, Baby Medical Hospital, Kozhikode; Dr. Ritesh Shah, Critical Care Specialist, Sterling Hospital, Baroda; Dr. Ehsan Ahmed, Chief of Critical Care and Emergency Services, KPC Medical College, Calcutta; and Dr. Sharmili Sinha, Critical Care Specialist, Apollo Hospital, Bhubaneswar. Over to the quiz master. Thank you.
So good evening, everyone.
At the W4C2021.
So I request organizers just to confirm that the participants are online.
Yes, sir. Just a minute. 1 or 2 participants joining.
Okay.
I'm on call with him.
Yep.
Yeah, good evening, Dr. Ritesh and
Yeah,
others.
good evening.
I think we have to wait till
that's
sizable
because
of them join. Yeah.
Just one,
hope
just
all-
one more.
No,
No
worries.
problem. No problem. So I request all participants, please open your camera.
So how many have joined so far?
Just a minute, ma'am. Let me check. 1, 2, 3, 4, 6. Ma'am, 12 has joined and one
Okay.
more is joining.
Okay. And
So
I
we
guess
have-
you all have been numbered, right? Or they have been provided a number?
Yes, ma'am. We'll show here also so that they can, it will be reminded them which number is of whom.
Yes. So once the, everyone is there, we'll just narrate the rules and regulations for the same so that everyone should be very clear what to expect.
So Avinash, let us know when all 15 join. So we'll go.
Okay, ma'am.
Okay.
Rest two are also joining. You are saying 13% is joining.
Yes,
Rest two.
ma'am. Sir, just a minute. 13 has joined. One has, I think one is not picking up the call, no response. So it's like, so total maybe 14.
So next 3 minutes, I think we'll
Yes, sir.
start.
Yes, sir. Next 3 minutes.
Exact 5:30.
Yes,
right?
sir. Yes, sir.
So someone has written message that I'm not able to unmute. Yeah, Avinash, can you check this, please?
Yes, sir. Dr. Dinesh, please click on mute and mute option. Dr. Dinesh. Your camera is on, but you have to click on unmute.
So if you cannot unmute, please check, I think log out and log in again.
Dr. Kalpala, you are in panelist. You need to click on join as panelist. I'm promoting in the, okay. Dr. Soeb, please click on, okay. You have also joined.
So all 14, we are waiting for Dr. Dinesh, but otherwise 14 have joined. Avinash?
Yes, sir. Let me take the attendance once.
Yeah.
So I'm just taking their name and please unmute and just say yes. Dr. Srinivas Reddy.
Yeah, yes.
Participant 1. Okay.
So please check your number. You will be number 1. Okay, that is participant or contestant number 1.
Dr. Sabrish.
Yes, sir. Yeah.
Okay. Dr. Raghav Gupta.
Yes, sir. Am I
Dr.
audible? Yeah.
Yes, audible. Dr. Mohammed Soeb. I have just joined Dr. Mohammed. Please unmute.
Yes, sir.
Okay.
Okay.
Dr. Vinay. Dr. Vinay. Dr. Ronak?
No. Dr. Kalpana, you
Dr.
say?
Kalpana is not joined.
Present.
Okay, sorry.
Yeah, he's there. She's there.
Just confused. Which one?
Okay.
Dr. Ronak?
Yes, sir.
Dr. Dinesh?
Dr. Dinesh has rejoined.
He's just joined. Dr. Abhimanyu?
Yes, sir.
Okay. Dr. Santanam? Dr. Santanam?
Yes, sir.
Okay. Dr. Suganya?
Yes, sir.
Dr. Aparna?
Yes, sir.
Dr. Taekwondo? Yes. Dr. Chandamali?
Yes, sir.
Dr. Chirayan?
Yes, sir.
Dr. Mayur Dhwaja?
Yes, present.
Dr. Vinay? Dr. Vinay? And Dr. Dinesh?
So Dr. Dinesh actually had again text, I think, in the chat.
Let me check, sir. Maybe he's in. Dr. Dinesh. No, he's not online, sir. Dr. Vinay. He was online, but I think he's left. Dinesh, there is some connectivity issue from Dinesh. He's continuously logging in, logging out.
Okay. So I think let us give him 1 minute because he already had shown up.
Yes, sir.
Sorry,
Sir,
other contestants, because of a bit delay. Yeah, Dr. Dinesh has rejoined, I think.
Okay.
Yes, sir. Can you hear me, sir?
Yes.
Yes.
Okay,
So Dr. Vinay was also online. I don't know. Dr. Vinay? I just had call with him.
Yeah, please.
Okay.
So all 15 have joined or 14?
14 have joined. He's just confirming with Dr. Vinay. So confirmed or not, Avinash?
I think let's start. Let him join. He can be the, depending on his number, he can join in the middle of the queue or we can take him at the last because you're already late by.
Yeah, 30 minutes, 35 minutes actually.
Yeah.
Okay, any update, Avinash, or should we proceed?
Dr. Vinay, are you joining? Please. Okay. Sir, we can start. He's joining.
Okay. So welcome all contestants in the World Congress on COVID and Critical Care. It's one of the fantastic effort by Dr. Runta sir, Dr. Diptimala, Dr. Anvit Tyagi and their team. So this time we have also, kind of first time this is going to happen, that is online quiz. We have 4 quiz masters, me, I am Dr. Ritesh Shah, Dr. Sharmili Sinha is there, Dr. Anup has joined, and Dr. Hassan has joined. So they might be joining a little later. So I'll just tell the rules and regulations for the quiz. First of all, as I said, each and every one is kind of numbered as a contestant number 1, 2, 3. So I hope all of you have noted your number. Is there any confusion? You just tell us right now. Fine. So everyone is, well aware of their number, contestant number. So what we are going to, there are 3 rounds. Now, first round and second round are going to be the same. So it is going to be kind of MCQ based only. So we are going to narrate a question in the PPT form. There will be 4 options. Sometimes there might be 5 options. Once we read out whole question, and we are going to read out all answers for you. And once we finish the final answer narration, then the clock ticks. You will be having 30 seconds to answer. And just relax because there is no negative marking in first 2 rounds. Okay, so either there will be plus 10 marks with the correct answer and 0 for incorrect answer. But 30 seconds is the time when you need to finish your answer, or you need to say whether A, B, C, D, or E sometimes. Only one statement is correct. There might be 2 correct answers, but you need to go ahead with the best answer which is possible, right? So I hope I'm clear for this. So we will finish up 2 full rounds of question, and this is not a past question. So if I ask contestant number 1 any question, and if he or she cannot answer, that question cannot be passed. Either there is 10 marks or there will be 0 marks. There will be different questions for all contestants, so that the second contestant do not get much time to think, just to be on the fair side. This is first 2 rounds. And later on, the round 3 will be different. So I'm not narrating the rules and regulations for round 3 because there will be filtering out the number of candidates after 2 rounds. So we'll be narrating the rules and regulations for the 3rd round once both the 2 rounds are complete and the contestants are filtered out for the grand finale round. Is that clear? Is that clear? Any confusion, you can just tell us. But 30 seconds is the time when you need to give us answer. All right. And please do not see if anyone is prompting, then it is their loss. I mean, you are creating a loss for rest of the contestants also. So no, just mute yourself, and whosoever's number is there, then and then he or she should be unmuting themselves. Okay, is that clear? Should we go ahead?
Yes, sir.
Yes. Okay, so I'm just sharing the screen. Dr. Sharmili, should we start?
Yeah, we should.
Okay, is it visible? The PPT is visible for everyone. If anyone cannot see the PPT, they can raise their hand. And Avinash, please confirm that is there any, chat box or someone is trying to say, because I won't be able to see all participants at a time.
Okay, sir.
Okay, so let's go ahead. All the best to all contestants. Just enjoy. It's a time to enjoy rather than being on the stress. It's not an exam. It's just for fun. All right. So let us start. Who is contestant number 1?
Yeah, it's me, sir.
Srinivas.
Sorry.
Dr. Srinivas Reddy.
Okay. So
yes.
Are you ready?
Yes,
Dr. Reddy, are you ready?
Yes, sir.
Okay. So here is a question for you. Which biomarker takes its peak late and remains high for longer duration after onset of MI?
The timer should start.
B, sir. It's a B.
No. Timer is not to be started right now.
Yeah, please stop the timer.
Timer once I finish the answer number 5. So your options are myoglobin, B troponin I, C CKMB, D anti-proBNP, and E is BNP. So your time starts now.
It's a B troponin I, sir.
Are you sure? You
Yes,
have time, so you can rethink and just tell us whether you want to lock this answer or not. 15 seconds. So you want to lock the answer? Dr.
Yes, sir.
Reddy?
Yes, sir.
Okay, so troponin I is the answer and it is a correct answer. So big applause for Dr. Reddy, plus 10 marks. Avinash, please note 10
Yes, sir.
marks.
Yes, sir.
Okay. So you have 30 seconds, so think over and then go for the answer. Okay. Should we go to contestant number 2?
So next contestant number 2 is Sabris P. Dr. Sabris P.
Okay, please unmute yourself.
Dr. Sabris, are you there? Yes.
Yes,
Okay.
sir. Yeah.
So question number 2. Following are the criteria for diagnosing cardiogenic shock except systolic blood pressure less than 90, mean arterial pressure less than 65, cardiac index less than 1.8 liter per minute per square meter, left ventricular end diastolic pressure less than 80 millimeter of mercury, or pulmonary capillary wedge pressure more than 80 millimeters of mercury. Your time starts now.
Sir, my option is B. Answer is B. Sorry, D.
So you still have time, just make up your mind.
Yeah, final answer is a D.
Just narrate B or D. Sometimes it is confusing. So just
D,
narrate the
sir.
answer.
Left ventricular end diastolic pressure less than 18 millimeter of mercury.
Should I lock it?
Yes, sir. Yeah.
So answer is D and it is correct answer. So big round of applause for Dr. Sabris. You get plus 10 marks. Avinash, please note plus 10.
Noted, sir.
So is contestant number 3?
Sir, me, sir, Raghav Gupta.
Okay. Are you ready, Dr.
Yes,
Raghav?
sir. Yes, sir.
Okay. Male 45 years suffered polytrauma following a road traffic accident, arrived in ER with altered sensorium with GC scale 6/15, obvious injury and chest injury. Blood pressure is 80 systolic, heart rate 126, SpO2 94% on room air. No obvious visible bleeding. Which one of the following statement is true? Your answers: A, NS is preferred over RL for massive fluid resuscitation in head injury patients. Hypotensive fluid resuscitation is detrimental in polytrauma patients. Central venous access is required for rapid fluid administration. And hypotension is an integral part of lethal triad of trauma patients. Your time starts now.
So answer is B, sir. Hypotensive fluid restriction is detrimental in polytrauma patients, sir.
So where is the clock, Avinash? Okay, so I'll minus 10 seconds from that.
Yes, sir.
Yes, sir.
So still you have 10 seconds. Dr. Raghav, do you want to lock the answer?
Yes, sir. Hypotensive fluid restriction is detrimental in polytrauma.
Is it your final answer?
Yes, sir.
Should I lock it?
Yes, sir.
Okay, so answer is B, hypotensive fluid resuscitation is detrimental in trauma patients, and it is a correct answer. So big round of applause for Dr. Raghav and plus 10 for him.
Noted, sir.
Well done, boys and girls. Come on, any girl is yet to come. So go for contest number 4.
Mohammed Soeb Ahmed.
Yes, sir.
Are you there?
Yes, sir.
Are you ready?
Yeah.
Okay. Which of the following is a sign of effective CPR? Your answers: A, diastolic intra-arterial pressure less than 20, systolic intra-arterial pressure more than 60, EtCO2 more or equal to 10 millimeters of mercury, urine output more than 1 ml per kg per hour, and good ECG complexes while CPR is ongoing. Your time starts now.
Sir, is D. Urine output is more than 1.
So you still have time. You want to lock it?
Sir, is D.
What's your final answer?
D.
Narrate. Which one
Systolic
is that?
Systolic intra-arterial pressure.
So you want to go for B?
Urine, yes, sir, B. Systolic intra-arterial pressure.
Okay, but I'm afraid Dr. Shoaib is a wrong answer. And the best is, the end-tidal CO2, which is more than 10. So I'm sorry, but you won't get any marks. Never mind, there is always a second round, so cheer up. Okay. Contestant number 5.
Yes, sir, I can hear you.
What's your name, please?
I'm Dr. Vinay.
Okay, so you're here. So are you ready, Dr. Vinay?
Yeah, sir, please.
Okay, so your question for the first round is 75-year-old man underwent CABG, post-op day 2, patient developed hypotension, oliguria, tachycardia, PAC, pulmonary artery catheter data shows PAP or 15 by 6 millimeter of mercury, CVP 7 millimeters of mercury, PAWB 5 millimeter of mercury, cardiac index 1.4 liter per minute per square meter, and SVR is 2800 per dyne per second per CM5. And most probable diagnosis is, your answers are A, pulmonary embolism, B, cardiac failure, C, cardiac tamponade, D, sepsis, and E, hypovolemia. Your time starts now.
Hypovolemia, sir. E.
So still 10 seconds to go. You want to lock it?
Yeah, sir.
So please lock E, that is hypovolemia. And actually it is a correct answer. So big round of applause for Dr. Vinay. You get plus 10. Right? So contestant number 6.
Yes, sir.
Dr. Kalpana Maji.
Dr. Kalpana, are you ready?
Yes, sir.
Okay. Which of the following modality of RRT uses all the principles of convection, diffusion, and ultrafiltration? A, CUF, B, CVVH, C, CVVHDF, D, CVVHD, and E is SLED. Your time starts now.
The answer is C, CVVHDF.
So you want to lock the answer?
Yes, sir.
Still 15 seconds to go. You can rethink. Tell me the correct answer now.
Sir, A.
Are you sure? Just tell me the final.
Sir, A.
ASCUF. I'm afraid, Dr. Kalpana, actually you are right on the first time. It is CVVHDF. So you need to be confident, okay? There is no problem. Second round is always there. So that's fine. Contestant number 6, or rather 8.
It's 6, sir. Sorry, 7. Dr. Ronak.
Yes, sir.
Number 7.
Is it 7?
7, sir.
Okay. So how did I? Okay, fine. Question number 7. Yes. So are you ready, Dr. Ronak?
Yes, sir.
So here is a question. Female 70 years, CKG, diabetic, hypertensive with history of repeated UTIs and multiple previous antibiotic exposure. Now admitted with febrile illness with dizziness, heart rate 120, BP 90 systolic, a bit confused. Last 24-hour urine output was only 300 ml. Evaluated WBC 25,000, creatinine in 3.4, which was previously 0.8 before 3 weeks. Sodium 132, potassium 5, bicarbonate 15, diagnosed to have urosepsis. After sample collection for cultures, which of the following is true about loading dose of antibiotic? Your options are A, full dose of antibiotic, B, half dose of antibiotic, C, antibiotic dose as per creatinine clearance, D, 30% dose of antibiotic, or you just wait for the culture and then you will give antibiotic. Your time starts now.
Answer is A, full dose of antibiotic.
So still time to go. Dr. Ronak, you want to think?
A, full dose of antibiotic.
Are you sure? Should I lock it?
Yes, sir.
Okay, so he's locking full dose of antibiotic, and there is a correct answer. So big round of applause for Dr. Ronak. So well done so far. So let's go to contestant number
8. Dr. Dinesh Gontal.
Dr. Dinesh.
Yes, sir.
Okay, are you ready, Dr. Dinesh?
Yes, sir.
Okay, so here is a question for you. for symptomatic severe hyperkalemia, all the following statements are true except your options are A, injection soda bicarbonate significantly reduces hyperkalemia, B, insulin shifts potassium intracellular, C, calcium gluconate prevents arrhythmias temporarily, and D, beta agonist is one of the important therapy.
Option A, sir. Injection soda bicarb significantly reduces hyperkalemia.
You want to lock it?
Yes, sir.
Are you sure?
Sure, sir.
So answer is A, injection soda bicarb significantly reduces hyperkalemia, and it is a correct answer. So plus 10 for Dr. Dinesh.
Yes, sir.
Okay, sir.
So next question. Contestant number 9.
Abhimanyu Kalita.
Are you there, Dr. Abhimanyu? Yeah.
Yes, sir.
Are you ready?
Yes, sir.
The question is, the following parameters are compatible with the diagnosis of cardiogenic shock except SVRI 2800 dynes per square centimeter 5, arterial oxygen content of 15 ml O2 per deciliter, cardiac index of 1.9 liter per minute per square meter, or mixed venous oxygen saturation of 72%. Your time starts now. It's a cardiogenic shock. So time is running out.
My answer will be D. Sir. D. Mixed venous oxygen saturation of 72%.
So you want to lock it?
Yes. Yes, sir.
Okay, so lock D, mixed venous oxygen saturation of 72%, and it is a correct answer. So big round of applause for Dr. Abhimanyu. You get plus 10. Avinash, please note it.
Yes, sir. Noted, sir.
So who is the next one? Contestant number?
Contestant
Yes,
number
sir,
10. Anthanam.
10, na?
Yes, sir.
Yes, sir.
Okay. Are you ready?
Yes, sir.
Okay, just a second. Okay, so here is the question for you. What is the contraindication of administering nitroglycerin in the management of acute coronary syndrome? Heart rate more than 100 per minute, phosphodiesterase inhibitor used 72 hours ago, right ventricular infarction and dysfunction, SBP of 100 millimeter of mercury, or patient already taken 2 tablets of nitrate sublingual. Your time starts now.
Sir, option B, phosphodiesterase inhibitor use of 72 hours ago.
So you still want to think?
Sir, B option.
Are you sure?
Yes.
Should I lock it?
Sure, sir.
So please lock answer B. I am afraid it is actually incorrect answer because if you see carefully, it is phosphodiesterase inhibitor used 72 hours ago. And the obvious is, right ventricular infarction and dysfunction, which is the contraindication for NTG. No worries. There is always a second round. So let's go ahead. Who is the next one?
Next one is contestant number 11, Dr. Suganya.
Are you there, Dr. Suganya?
Yeah, please unmute. You need to unmute.
Yes, sir.
Are you ready, Dr. Suganya?
Ready, sir.
Okay, here is your question. Regarding the mechanics of positive pressure ventilation, all the following statements are true except setting an extrinsic PEEP less than intrinsic PEEP will reduce elastic work of the respiratory system. B, one risk of applying PEEP is a reduction in oxygen delivery. C, a decelerating flow pattern is seen in volume control ventilation. D, the difference between peak and plateau pressures is greater with volume control ventilation than pressure control ventilation. And dynamic compliance equals the tidal volume divided by peak pressure minus positive total end expiratory pressure. Your time starts now.
Answer is B, sir. One of the risks is applying.
So still there is time. You want to think over? So tell me the final answer. Time is running out.
Answer is B.
B is one risk of applying PEEP. Is it?
Yes, sir.
So please lock answer B. I am afraid, Dr. Suganya, it is incorrect answer. The correct answer is C. A decelerating flow pattern is seen in volume control. So never mind. There is always a next round, right? Who is next?
So the next is contestant number 12, Aparna Sahu.
So Dr. Aparna, are you ready?
Yes, sir.
Okay, so here is your question. Just a minute. Consort is a reporting guideline for following. Which one is a true statement? A, meta-analysis, B, diagnostic studies, C, observational studies. Which one is true? And D, randomized control trials. Consort, what is the true? T. Come on.
Sir, D, sir.
So are you sure?
Yes, sir. D, RCT.
Should I lock it?
Yes, sir.
Okay, so lock D, randomized control trial. So it is a correct answer. Well done, Dr. Aparna. You get plus 10.
Thank you, sir.
Who is next?
The next is participant number 13, Dr. Chandramouli.
Dr. Chandramouli, you are there?
Yes, sir, I'm there. Yes, sir, I'm
okay.
here.
So are you ready for the question?
Yes.
Okay, here is a question regarding errors related to the hypothesis testing. Identify the false statement from below options. Type 1 error is usually set at 0.05 for a level of confidence of 95%. B, type 2 error is usually set at 0.1 to 0.2. C, type 2 error is the power of the study and usually set at 80%. And D, when the estimated probability is less than the set alpha error level, that is type 1 error, alternate hypothesis is rejected. Your time starts now. Yes, Dr. Chandramouli.
Yes, sir.
15 seconds left.
Answer is B.
Sorry?
Answer is B. D. D. When the estimated probability is less than set alpha, it is type 1 error.
Are you sure? Should I lock it? It's time gone. Anyway, you said that answer is D. When the estimated probability is less than the set alpha error level, that is type 1. Alternate hypothesis is rejected. And actually, it is a false statement. So it's a correct answer. So plus 10 for the same. Congrats. So who is next?
Next is contestant number 14, Cheria Roy.
Are you there, Dr. Cherian? Yeah.
Yes, sir.
Are you ready?
Yes, sir.
So here is the question for you regarding different severity scoring system. Identify the true statement from below option. For validating the performance of a severity scoring system, model calibration and model discrimination has to be tested. B, model calibration can be done by calculating the area under the curve, that is ROC, receiver operating characteristics. C is typically a severity scoring model, requires an AUC of the ROC curve of 0.50, and lead time bias can make a prognostication model more accurate. Your time starts now. Yeah, Dr. Cherian.
Yes. Sir, model calibration can be done by calculating the area under curve, the receiver operating curve. B.
That is B. You are saying B?
Yes.
So you want to lock it?
Yes.
Should I lock it final?
Yes.
So please lock answer B, but I'm afraid that's incorrect answer. So 0 for this. Maybe next round.
Yes.
You can just lead. And who is the last contestant?
It's Mayur Dhwajarath, Dr. Mayur Dhwajarath.
Are you there, Dr. Mayur?
Yes, sir. Yes, sir.
Okay. Are you ready for the question?
Yes, sir.
So here is a question regarding albumin best statement. 5% albumin can be used in resuscitation in hypovolemic shock. 20% albumin in sepsis can be used for building volume. 20% albumin with furosemide can be used in AKI as a challenge test, and albumin is contraindicated in low EF cases. Your time starts now.
Sir, it's option D. Albumin is contraindicated in low EF cases.
Still 15 seconds left. You want to relook? Please tell me the final answer, please.
It's D, sir.
D. So albumin is contraindicated in low EF cases, and actually is the correct answer. So plus 10 for Dr. Mayur Dwaj. So here ends the first round. So everyone has done wonderfully well. Those who could not make it, that's fine. There is always a second round, right? So Dr. Sharmili, are you ready for second round?
Yes, yes. I was watching them all through, and I think it has been almost like a rapid fire run, but nevertheless, they've done well. A couple who missed it. Actually, it is not only about the knowledge. So take it easy. It's nothing an exam that you're appearing or of your courses, etc. Take it easy. So I think it's not only the knowledge, about also your integrity, your steadiness. Because when the quiz master is tickling you that you have time left, it's not necessarily that you're wrong or right, right? You just consolidate what is right, what do you do in practice, that's it. And some of this will be theoretical questions. Sometimes you will encounter those scenarios. So just think and stick to your answer. I think 30 seconds is good enough time. You want 1 minute, 2 minutes break? Or we straight go to second round?
No, I think let's go to second round.
Okay, okay. I'll share screen. Yeah.
Yeah.
Yeah, they are eager to answer your questions.
Oh, Dr. Hassan is here. Welcome, Dr. Hassan.
Yes.
Hope it is visible. It is visible?
Yes.
Put it on slideshow mode.
Put
Okay.
in the slideshow mode. Put in the slideshow.
Oh, yeah, I will. So, everyone, we have covered till, there are 15 candidates, right? So 15 questions you had in round 1. Similar rules as Dr. Ritesh narrated will also apply to the round 2. Each one of you will get one question. So the first questions for candidate 1. Who is the first candidate?
Dr.
Dr. Sharmili, I would say that just go reverse if possible, so that the random is maintained.
Okay. Yeah. So the candidate 15.
Avinash, please take a note of it. It's a bit, a bit more work for
But
you.
you should not make mistakes, Avinash. You take.
Yes, yes. So it's a contestant number 15. That is Mayur.
Yeah. So we'll start from 15 and we'll end in
1.
Candidate number 1. Okay. So accordingly, you mark. No question.
Yeah.
Is that clear, Abhinash?
Time like you right, Vishnu?
Please, Dr. Abhimanyu, please mute.
Yeah. Those who are not being questioned,
Sorry,
please
sir.
keep yourself muted. Yeah. Please make sure that. And Abhinash, please make sure you mark them accordingly.
Yes,
So candidate number 15.
Yes, ma'am. I'll announce the
Your name?
Also.
Yes, ma'am. Mayur Dwaj.
Dr. Mayur Dwaj. Right. So here is your question. Please go through. It's a clinical
Dr. Sharmili,
scenario.
please narrate. Please narrate.
Okay. So, a 56-year-old gentleman with pancreatic malignancy stage 4 on palliative chemotherapy presents with mild pain in the left calf. He is a diabetic and hypertensive on regular medications. Examination shows a conscious oriented and he is comfortable. SpO2 on room air is 99%. His blood pressure is good, 134/72 with a pulse rate of 102. There is a left lower limb swelling, which reveals a DVT of left popliteal vein by bedside ultrasound 4-point compression test. Echo is normal. A peripheral smear done, which shows presence of cystocytes, helmet cells, and microspherocytes. The investigations are as follows. Take a close look at this, Dr. Mayur. I'm not going to read this. So this is, maybe I read it for you. TLC is 10,000. Hemoglobin is 8.1 gram. Platelet is 1,56,000.
1,56,000.
Yeah, this is your coagulation, fibrinogen, and D-dimer.
Yes, ma'am.
Normal ranges here. Sorry. So what is the underlying diagnosis in this patient?
Can I have the timer?
Yeah, timer can start now. Is the timer on? Oh, yeah.
Yes.
What is the underlying diagnosis in this patient?
Five seconds left.
It's A, acute thrombotic pulmonary embolism.
Your time is up. Right. So you said acute thrombotic pulmonary embolism. Why did you think it is acute? Was there any acute signs? I think it was a lengthy questions, but we gave you time, right? And the scenario was quite, descriptive of the clinical situations. I'm afraid your answer is wrong. The answer is chronic disseminated intravascular coagulation, because this patient did not have any signs of acute respiratory
Failure.
distress or any decompensation of the respiratory parameters. He was comfortable. He was not tachypneic. Saturation was good, but obviously he had a chronic malignancy and a DVT presence. So these parameters are suggestive of a chronic disseminated intravascular coagulation. That is quite pathognomonic of this chronic DICs, right? So we go to the next questions for candidate number 14.
14, that is.
Avinash, note down for candidate number 14.
Dr. Cherian, go ahead.
Dr. Cherian. Yeah. So next question 17. Is it okay if I read it, or you would be comfortable reading by yourself?
Dr. Shamili, please read it. It is better.
No, I would let the candidate, Dr. Cherian, is it okay?
Yes, ma'am.
Okay, I'll read it for you. Yeah. So 27-year-old man was diagnosed to have meningococcal meningitis based on clinical and CSF study. His past history was unremarkable except for the history of splenectomy following an accident. He continues to be feverish and is currently now hypotensive. Also noticed to have developed a large purpuric rash over chest, abdomen, anterior thighs, and limb extremities. His blood picture shows the following. This is the blood picture. TLC is high, 17,000. Platelet is 94,000. APTT, 67 seconds. INR is 2.1. Fibrinogen is 180 milligram percent. FDP and D-dimer both are high. So what is the likely diagnostic consideration in this patient?
Your time starts now. Is a round 2.
Option C, acute infectious purpura fulminans.
Yes, that was a quick response. You want to review or you want to stick? It's up to you, but I'll declare only after 30 seconds are over. You can go through the options and the investigations and think about the answer. So answer is?
Option C.
Option C. Yeah. Great. Congratulations. That is a correct response. So it is an acute infectious purpura fulminans. So this patient has splenectomy that indicates they usually tend to be infected by capsulated organisms. And in rare scenarios, they can have this kind of purpuric rashes over different parts of the body. So this is quite a fulminant condition as well. Right. So this is for candidate 14, I believe. So we move to candidate number 13, 1313.
Dr. Chandramouli.
Ready? Dr. Chandramouli. Yeah. So this is a bigger question for you. Nevertheless, I'll read it for you. So it's an obstetric question. 28-year-old primary gravida had undergone a LACS, cesarean section at a local hospital. Just 12 hours before. Post-surgery, the patient was found to have persistent vaginal bleeding associated with progressive hypotension and flaunulin hemoglobin. She was referred to a tertiary center where an urgent uterine ultrasound was done, which was normal. She was conscious, oriented, and pale with clammy peripheries. She underwent a CCT abdomen and pelvis, which shows active bleeding from left uterine artery, which was embolized by an interventional radiologist. Now, the patient was subsequently shifted to ICU and was noticed to have bleeding from the caesarean site as well as from the arterial sheath. So, what is her investigations are as follows. Her blood parameters. TLC is 8,900. Hemoglobin is just 5 gram percent. Platelets are 120,000. APTT is 78. INR is 1.9 and fibrinogen is 90 mg/%. Both FDP and D-dimer are high. So what is the best response among all this for her? I think your time can start.
Started.
Okay. I cannot see actually. Yeah, okay.
15 seconds.
Yeah.
10 seconds. 5 seconds. Please say something.
All statements are correct, sir. E. All statements are correct.
Okay.
Okay, your time is up. What?
He said E.
E.
Last one. All the
Yeah,
statements are correct.
so that is unfortunately wrong. The best response is transfuse FFPs, PRBCs, and you have to give platelets in this case. So answer is B. Dr. Chandramouli does not get any marks for this. This is a very common clinical scenarios. And when you are giving massive transfusions, usually they have to given in the proportions. The best response in this scenario is B. This option D, obviously, this cannot be all not done or not recommended in this kind of patients at the first go. So the best statement or the best next step is option B. So with that, we go to next candidate. I think candidate number 12.
Yes. Dr.
Okay.
Aparna Sahu.
Dr.
Yes,
Aparna.
ma'am.
Yeah. You ready? So here comes your question. Hold a moment. So this is your question. Which of the following statement about DIC is incorrect? In chronic DIC, plasma factors 5 and 8 are normal, whereas in acute DIC, they are decreased. Acute promyelocytic leukemia causes acute DIC. Unlike liver failure, the plasma level of factor 8 and 111 antigen are reduced in DIC. In general, chronic DIC causes bleeding, whereas acute DIC causes thrombosis. So which is the incorrect statement, Dr. Aparna?
Ma'am, D.
20 seconds more to go.
So that was really a quick response.
10 seconds to go.
You want me to freeze there, Dr. Aparna?
Yes, ma'am. D.
Option?
D. In general, chronic DIC causes bleeding, whereas acute DIC causes thrombosis.
Yeah, correct. So Dr. Aparna has responded correctly. So this is an incorrect statement. So you get 10 marks for that.
Thank you, ma'am.
Good going. So we'll go to next candidate number 11, I believe, right?
Dr. Suganya.
Yeah. Dr. Suganya?
Yes, sir. Yes, ma'am.
Yeah, good. So we will move to the next question, which is question number 20. The Japanese Society of Thrombosis and Hemostasis divides the patients into categories as follows. A, basics, B, hematopoietic, C, infectious. All the above are wrong. A, B are correct or A, B, C are correct.
Twenty seconds.
A and B are correct. Option E.
Option?
E.
Option? Okay. Right. Actually, both A, B, C are correct. So it is the option F, which is the correct answer. So Japanese society actually very commonly we do not quote these societies, but lately because of different causes, depending on the etiologies of this thrombosis hemostasis, these also have been come into limelight now, and these are the broad categories into which they have divided: basic, hematopoietic, and infectious. So all three are there. So our correct response is F. So Dr. Suganya will not get any marks for her attempt. Never mind, we still have, we'll see the scoreboard card at the end of this round. So next we go to candidate number 10, I believe.
Dr. Santanam.
Santanu. Right, Dr. Santanu, ready? Okay. So here is your
Hey,
question.
just a minute. Is there?
Dr. Santanam?
Yes,
Is he
ma'am.
there?
Yeah. Okay. Okay.
Is there? Okay.
Yeah.
So, Dr. Santanu, here is your question. Which among the following is not a part of routine treatment of DIC? Option A, tranexamic acid or epsilon aminocaproic acid or aprotinine. FFP is cryoprecipitated SDP. Option C, platelet factor 4 or the RDPs or PRBCs. Not a routine part of DIC.
$20 seconds.
Platelet factor 4.
Sure.
10 seconds.
Yes, ma'am.
You want to lock?
Yes, ma'am.
This time is up.
Okay. So your response was C, PF4. Actually, the answer is A. It is not a routine part of treatment of DIC, tranexamic acid. Because DICs can have both hypercoagulable or hypercoagulable or hypercoagulable factors or situations accordingly. So tranexamic acid is not routinely given in its treatment. The answer is option A. So he'll not get any marks for this response.
Next.
Next contestant number
candidate
9.
is
Abhimanyu Kalita.
okay.
Yes, sir.
Here is a question. Which of the following failed to show any benefit in mitigating sepsis-induced DIC as per available evidence? You can read the options. Heparin, antithrombin C, 3, thrombomodulin, protein C, or A and D, all are inefficient.
$20 seconds.
I'll go for F. All are inefficient.
Okay. So you think both all heparin, antithrombin 3, thrombomodulin C, all are inefficient. So
Time is up.
that is a
Anyways.
correct response. Well done.
So
You get 10 marks for that. That's a
F
correct
is correct,
response.
right?
Yeah.
F is correct.
F is correct. Yeah.
Okay.
F is correct. That's a correct response. So you get 10 marks for that.
Thank you.
Right. Good. So we move to the next candidate. Who is the next candidate?
Next and Dr. Dinesh Gontla.
Dr. Dinesh. Good. So here is your question. A medical emergency team was called to attend a 50-year-old man who has a sudden generalized tonic-clonic seizures in the ward. He was diagnosed to have a small right MC infarct last night and had received RTPA as thrombolysis in the as he was in the window period. He was due for check CT next 2 hours or so. So an urgent CT brain was done, which showed a 2 into 1.2 centimeter hemorrhagic transformation in the infarct area without any midline shape. He was given 12 units of cryoprecipitate and 6 units of FFPs. His blood parameters sent at ICU were as follows. So TLC 8.9 thousand, hemoglobin is 8.8, platelets 260,000, APTT 48 seconds, INR is 1.1, fibrinogen 250 mg%. FDP and D-dimer are high. Creatinine slightly raised 1.9 and LFT is normal. So this is a thromboelastogram. Now this is just a normal thromboelastogram for your reference, and this is the patient's thromboelastogram. It was run because he was given thrombolysis and now he has this kind of mild deranged parameters. So this was the thromboelastogram. So what will be the next best step? Your time starts now. Time up, yeah.
To give it's option A to provide more FFPs.
15 seconds.
Yeah, you have time. Just review. It may
5 seconds.
should we lock at option A? Option?
A.
Okay, time is up. He was given thrombolysis just a couple of hours ago. He has a bleed. So the right answer here is option B, to give tranexamic acid. So it's a wrong answer, and unfortunately you will not get any marks for this. So you go to next candidate. Who is the next candidate?
Dr. Chandrakant Patel. Ronak Chandrakant Patel.
Doctor?
Ronak
Oh, you're
Chandrakant
there?
Patel.
Okay. Right. So I'll just see. Dr. Ronak Patel. Okay. So here is your question. Which of the following about Rotem component is correct? Intemp represents, no, here his time doesn't start now. Let me read.
No, yeah.
Let me read. Intemp represents intrinsic pathway and is equivalent to APTT. Extem represents extrinsic pathway and is equivalent to PT, that is prothrombin type. APTM excludes fibrinolysis. FibTem isolates fibrinogen function. HepTem and ECATem are optional extras. All of the above are true. Only A and B are true. So now time starts now.
Twenty seconds.
Only A and B are true. E. Only A and B are true.
So you go for option G.
Yes, ma'am.
Option G you want to lock?
Yes, ma'am.
Right. So your time is up and you have gone for option G, which is unfortunately a wrong answer. The answer is F. All of the above are true. Rotem is for studying different part of the coagulation parameters, and it gives you instant results. So these are different actually parts of the machine and which have got different functions to indicate which part of the coagulation cascade is defective. So correct option is F, where all of the above are true. So he doesn't get any marks for the wrong response. We proceed to the next candidate.
So Dr. Ronak didn't get any marks now?
No.
Yeah.
Okay. So next candidate is Dr. Kalpana Maji.
Okay. Dr. Kalpana, get ready. Here is your question. I'll read it. A 60-year-old farmer has been bitten by a snake and has been rushed to the hospital. Examination reveals he is anxious but are comfortable with an oxygen saturation of 98% on room air. BP is 148/90. Pulse rate is 122. Has severe pain and mild swelling of the right foot with visible bite marks. He has been undergoing thorough monitoring and neurological evaluation since admission, which were normal. Coagulation parameters closely monitored. He started having bleeding from gum, nose, injection sites, and also oozing from the wound side over next 12 hours. So these are the lab parameters. PLC is 10,900, hemoglobin 9 gram%, platelets are 1 lakh. APTT is 100, INR is 1.9, and fibrinogen is 80 milligram%. Now, the whole blood clot test at 20 minutes, the clot test was at 26 minutes. And FDP and D-dimer were high. Now, which are the clinical types? Which are the clinical types of this disorder? It's a bleeding type, massive bleeding type, asymptomatic type, organ failure type, A and B, or all the above.
Twenty seconds.
It's E, A and B type. A and B.
10 seconds to go.
E.
So you want to lock option E, that is A and B.
B.
Time is up, and I'm glad to say this is a correct response. So Dr. Kalpana gets 10 marks.
Thank you.
So who is the next?
Let's see Dr. Vinay.
Doctor?
Vinay.
Vinay is there. Yeah.
Is there? Okay. Go to Dr. Vinay. Question number 26. So I'll read it for him. A 72-year-old lady, morbidly obese, around 90 kgs, with rheumatoid arthritis, and had undergone bilateral TKR 1 year ago, hypothyroid, having diabetes mellitus and hypertensive, on ventilator for COVID-related ARDS, on 70 to 80% FiO2, creatinine is normal, no bleeding history, D-dimer is 2.58. What dose of low molecular heparin will you use? So what is the best response? 60 milligrams subcutaneous OD, 40 milligrams subcutaneous BD, 60 milligrams subcutaneous BD, or 60 milligrams subcutaneous OD plus aspirin 150 milligram. So what is the best response?
milligrams subcutaneous OD, ma'am.
15 more seconds to go.
So you can think about the clinical scenario. I have 5-6 seconds.
I'll go for B, ma'am. 40 BD. Yeah.
40 BD. So your time is up and you have revised your answer to your benefit. And I'm glad to say that is a correct response. So
Just
I
save.
think
Just
that is
save, Dr.
yeah. You just,
But yeah,
yes, clinical, based on the clinical scenario, this is the best response. There is no consensus guidelines as of yet, with so many papers recently released and some of the interim results are in the pipeline. But according to the current practices and according to the scenario of this patient, 1 milligram per kg, because she is morbidly obese, even if you exclude her fat around 70 to 80 kgs. So 1 milligram per kg, around 80 milligrams per day will be sufficient. So that's a correct answer and you get 10 marks for that. Good. So next candidate is there.
Next candidate is Mohammed Sohail Ahmed. Dr. Mohammed Sohail Ahmed.
You're there. Avinash, should I go to the next question?
Yes, ma'am.
Okay.
Yes, sir.
Right. So here is your question. It is a road traffic accident case. 42-year-old man has rib fractures, 3rd to 7th rib on the right side with fracture clavicle on the same side. Now day 3, he comes from another hospital to your hospital. Pain score is 7/10. It is high. Started on analgesics. He was given IV nalbuphine, tramadol. He was given a ketorolac patch. On day 5, pain persists. It has actually increased to 8/10 now score. So what will be the best possible way to handle him now? Option A, continue conservative pain management. Number 2, option B is consider surgical fixation by open method. Option C, consider percutaneous fixation of the ribs. Option D is put a thoracic epidural. So what is the best possible intervention at this point of time?
It's D. Consider surgical fixation of the method.
Say that again, be loud.
It's D. Consider surgical fixation of the method.
Open method. You say B for Bombay.
Time is up.
Okay, so your answer or response is option B, that is consider surgical fixation open method. Unfortunately, this is a wrong response. On day 5, with no mention of a flail chest or any other severe bone injuries or underlying lung contusion, there is no indication for surgery at all in this case. We can augment the pain management. We should continue to conservatively manage the pain in this case. You can augment the analgesic packages. And if at all surgical option is given, the best
Dr.
is...
Sharmili, we need to finish this round quickly because we need to go to hall B later on.
We will. So if at all for surgery, this will be a percutaneous fixation, but not at this stage. So best option at this point is option A. So you will not unfortunately get any marks for this. We proceed to the next candidate.
Yes, ma'am. Raghav Gupta, ma'am.
Okay, Raghav. Dr. Raghav, your question is here. Regarding osmotic therapy in traumatic brain injury, what is the best statement? 3% saline is superior to mannitol for control of intracranial tension in first 24 hours. 7% saline is better than 3% saline. Option C is once mannitol is stopped, or oral osmotic agents can be used. Option D is sodium target of 145 to 150 milliequivalent per liter is desirable in these patients. So, which is the best statement? Your time starts now.
$20.
Ma'am, A, 3% saline is superior to mannitol for control of ICT in first 24 hours.
You want to freeze that?
Yes, ma'am.
Sure.
Yes, ma'am.
You have 5 seconds. So you want to go for option A, saying that 3% saline is superior
Time
to
is up.
mannitol for control.
Anyway, time is up.
And time is up. And that is not a correct response, unfortunately. It is an alternative for mannitol, but not proven superior in control of intracranial tension. Among the 4 choices, the best will be to have the sodium little on the higher side, that is 145 to 155. So next candidate, so he does not get any marks for this. Dr. Raghav, I'm sorry.
Next
We'll
is
proceed
Dr.
to the
Sabrish.
next question. Dr. Sabrish, here is your question. Prone in ARDS, what is the best statement? Has proven mortality benefit in ARDS up to 30%. Prone can be done if low dose noradrenaline is on. Dialysis can be conducted in prone position. Duration of 36 hours has superior results compared to 12 hours of proning. What is the best statement?
My answer would be A. Prone in ARDS has proven mortality benefit up to 30%.
You sure?
Yes, ma'am.
15 more seconds to go.
15 more seconds. Yes.
My answer is A.
Okay, so Dr. Sabrish wants to freeze option A, is mortality benefit up to 30%. Unfortunately, it has definitely got mortality benefit, but it is not up to the mark of 30%. So that was the catch point there. So prone position actually is better, early the better. Among the 4 statements, this is option B is the best one. Prone can be done if low dose noradrenaline is on. Dialysis nevertheless can be done in prone position, but yet not tested in many centers. Very, very few centers across the globe have tried it, mostly in the Latin American countries. So best option among these 4 is option B. So unfortunately, Dr. Sabrish will not get any marks for this. The last question of the round 2, and this is for our last doctor.
Yes.
Yeah. So this is on acute pancreatitis nutrition. So again, what is the best statement? Post-pyloric feed is better tolerated than pre-pyloric feed. Option B, partial parenteral nutrition with enteral feed is superior to enteral feed alone in terms of meeting calories and protein goals. Option C, trace elements are essential for these patients. Option D, in case of feed intolerance, partially digested polypeptides are better tolerated than intact formula feeds in pancreatitis patients, though not any outcome benefit has been proven. So your time starts now.
$20 seconds to go.
So I'll go with A.
Say that again, sorry.
A post-pyloric feed is better tolerated.
So you have 5 seconds. You want to go for option A. You just want to say post-pyloric feed is better tolerated than pre-pyloric feed.
Anyway.
Time is up. And I'm sorry to say that is a wrong response, because there is nothing which has proven that pre or post-pyloric feeds are comparable or one is superior to the other. Among the 4 choices, again, partially digested polypeptides will be better tolerated than intact formula feeds, because these are already partially digested. But of course, there is no outcome benefit has been proven. So unfortunately, Dr. Srinivas will not get any marks for his questions. I think these were a bit tougher round than the round 1, but all attempted well, and that's the spirit. It's not about winning, it's about participation.
Great round of applause for everyone.
And so for all of you, because you have participated, we are so glad that you are here. And this, on a Saturday evening, we are here.
Yes, sir.
Avinash, can you project the scores, please?
Yes, please do that. And my co-panelists, Dr. Ahsan Ahmed and Dr. Anup, if they're there, please show up also. They all have contributed to this quiz. We have been planning this for all of you last 10-15 days. So here is the score.
Okay. So that was tough one. All right. So what we'll do that because in Hall A there is something else. International session is about to start.
Okay.
So I think just Avinash, can we have a 1 minute, please?
Yes, sir.
Okay. So Dr. Sharmi will just discuss on phone.
Yeah, all of you
All
please
of you,
wait. Sir.
please be here. Be here.
There is.
For a minute. For a minute. Just 1 minute.
Okay. Okay, sir. Okay.
All of you, please log out from this hall and log in into Hall B. Avinash, I think you had sent the link for Hall B, na?
Yes, sir.
Yes, sir.
The hall
Avinash, you also join. Okay, I will
Yes, sir.
handle the hall A.
Okay. So here is the link in the chat box. Have you all got it?
Have you got the link of hall B? I have mentioned in the chat box.
Chat box, it is there. You can just take a photo and
Then I just have to click or just copy paste.
Leave and join कर सकते हैं ना? वहीं पे click कर लो, सारे Hall B में आ जाओगे. ठीक है?
हाँ. Just click on हाँ.
Thank you, everyone. Sorry for the delay. We will now begin the last session for this evening, the plenary session. For that, I'd like to introduce the chairperson. Dr. Shubhal Dikshit, consultant and ICU in charge, Sanjeevan Hospital, Pune. Dr. Vinod Singh, consultant, critical care director, ECMO program for Gangaram Hospital, New Delhi. Dr. Susruto Bandyopadhyay, director, critical care and AMRI Hospitals, Kolkata. Dr. Vivek Gupta, pulmonologist, sleep medicine and critical care consultant, Criticare Hospital and Research Institute, Nagpur. And Dr. Lakhan Koswal, principal and controller, Senior Professor Pediatrics, R&D Medical College, Rajasthan. I would now request the chairperson to introduce our speakers and carry this session forward. Thank you so much.
Thank you very much. I would not wasting time. We already are running behind time. I would like to introduce the first speaker. I'm Dr. Subal Dikshit. The first speaker is going to be Dr. Yunsuk Kong. He's the Department of Pulmonary and Critical Care Medicine at the Assam Medical Center. the University of the Ulsan Medical College in Seoul and South Korea. And he'll be talking upon the resource allocation and the ICU triage and the COVID-19 pandemic in the Asian ICUs. And he's got tremendous experience on it. So I request Professor Yong to please take his talk forward.
Hello, everyone. I'm talking about the medical resource allocation under pandemic COVID-19. I'm a pulmonary critical care physician in Asan Medical Center, Seoul, Korea. I have no conflict of interest to disclose associated with this topic. As you know, the level of social and the structural inequality in critical care healthcare system is high in Asia. A shortage of intensivists, and as shown in this figure, ICU bed in many Asian countries still remains. This ceaseless COVID-19 pandemic, longer than 1 year, have brought global challenges of scarce medical resource to the healthcare systems. Health resource limitation is partly managed by medical resource allocation and by patient triage to hospital admission. Medical resource allocation is a sharing limited medical resource between hospital, regions, and countries. It aims to reduce a situation in which critical ill patient do not have unfair access to care. It is a matter of opportunity for diagnosis and treatment under ethical principle of equality and equity in care. I did a simple survey on 14 intensivist perception to resource allocation and triage in 12 countries and Hong Kong. All respondents replied their countries had the experience of a problematic COVID-19 outbreak. However, level of a shortage of personal protective equipment or medical equipment during the surgery were different. A country had experienced a serious level of shortage of personal protection equipment. Respondents said that national allocation of medical resource well done in 5 countries and Hong Kong and somewhat helpful in 6 countries. This figure shows the efficacy of a bundle intervention for consumption management and the monitoring of personal protection equipment of a local 5 hospitals in Hong Kong. The intervention included cutting down non-essential service, implementing telecare, monitoring personal protection equipment consumption at unit level, and the PPE stock at the cluster central distribution center, and forming mobile infection teams. The authors show the overall consumption reduction by 64% through this bundle intervention. Triage is a shift of a priority in critical care decisions when surging patient put an intolerable load on hospital. Priority in care decision shift from respecting individual patient autonomy to benefit maximization under the surgery. This figure shows the patient triage over phone using a brief severity scoring system in a local epidemic in South Korea. The authors reported that less than 3% among more than 3,000 admission to therapeutic living centers were transferred to the hospital through the patient triage over phone. Under the surgery, a proper governance for the triage is crucial to facilitate the decision-making process alleviating caregivers' moral burden, and to ensure equal treatment opportunity of a patient to scarce medical resource. Medical and ethical experts, together with the government authorities, should prepare transparent and well-defined triage guidance, which are openly accessible to the public. As shown in this table, common ethical values of triage for critical ills issued from many medical societies are benefit maximization and justice. Two major practical issues are how to maximize benefit and how to address proportionality of care. Whether to focus on most life years by saving younger patients or saving more lives of all age is a sensitive issue to maximize benefit. Removing a patient from a ventilator or an ICU bed to provide it to others in need is justifiable. Prioritization guidelines should differ by intervention and should respond to changing scientific evidence. As shown in this figure, globally elders were more susceptible to COVID-19 than youngers. Therefore, older persons' priority after healthcare workers for vaccination has a scientific evidence. In such a sensitive period, clinicians should carefully consider the issues of a vulnerable patient group, such as racism, nationalism, or ageism. This figure shows the gradation criteria for prioritizing of ICU admission issued by Korean Society of Critical Care Medicine. This guideline recommended to consider patient clinical condition and patient performance status together with the presence of a severe comorbidity when to decide priority for ICU admission. However, this guideline did not show a clear guidance for the tie break with the same priority. Triage plans should contain different levels depending on the level of resource constraint to avoid inappropriate denial of care. In contingency, basic standard of care maintained, but alterations from standard operating procedures to conserve scarce resources. In crisis, there is a major shift for the ordinary care. Substantial alteration to the delivery of care when demand outstrips supply of scarce medical resources. Therefore, the authors recommended the clinicians must resist the tendency to anticipate crisis when still in contingency to avoid inappropriate denial of care. For the priority instructions to work properly, it needs medical and ethical validation on what basis the priority selection variables was decided. It needs obtaining the consent of the society. It also needs consistency to perform the guidelines to avoid any issue of discrimination. The respondent said that 8 countries and Hong Kong had the triage shared by intensivists. And in 6 countries, medical specialties had prepared with the healthcare authorities the triage guideline. Medical ethicists involved in the preparation of the guideline in the 4 countries. However, except Vietnam, triage notice to the public did not seem to be well performed. The respondents thought that the triage actually worked to the real world well in 5 countries and Hong Kong, and in partly in 2 countries. Then how to prepare for another surge? It may be different depending on regional situations and their society cultures. It is difficult to adequately shift from intensive care to comfort care, even if the patient is about to die in many Asian countries under familism. According to our previous investigation on end-of-life care in Asian intensive care unit, withholding or withdrawing of life-sustaining treatment level is widely different in patients with no chance of recovering and a meaningful life. These difficulties lead to moral and physical distress of healthcare professionals. To cope with the limited medical resource, open communication on resource allocation and triage between healthcare professionals and the public, sharing transparent and accurate information. Preparedness and drill of critical care pandemic plans based on the current medical capacities in individual society should not be delayed even now. And reallocation of available medical staff is needed, as shown in this figure, to increase critical care capabilities in individual hospital. Considering the shortage of intensivists in most of Asian intensive care unit, tiered step strategy for pandemic is really needed. I would like to disclose my talk by saying that the countries with well-performed medical resource allocation did not seem to suffer from the resource shortage during the surge of COVID-19 in Asia. Except Vietnam, even in the countries with the triage guidelines, the triage was not well advertised to the public. Lastly, preparedness and drill of the medical resource allocation plan is urgently needed under resurging patients with variant COVID-19 in many Asian countries. Thank you for your attention.
Dr. Yonchuk, this is Dr. Rumta. You are muted. Can you unmute yourself?
I can hear you.
Yeah. Hello, good evening. Thank you very much for being part of this conference and supporting us all throughout. My question to you, you are muted again. Yeah. What is the best way you kept the morale of your nursing resources up and high, prevented burnout?
It is a real issue, especially in a nursing side, because the intensive care nurses, although they working in front of the patient, however, their voice is not well addressed, even in the policymaker or the triage. So to alleviate their the burnout or moral distress of the intensive care nurses or young intensivists, the senior intensivists should surely try to more communicate with their stress and seek to provide their rest time, adjusting their rotating schedule. So and as I had told, the tiering step, meaning that including non-intensive, care nurses or non-intensive care doctors should be retrieved with the short-term intensive care management education is another the option to relieve their stress.
And what was the worst resource crunch that you experienced? The worst resource crunch.
In fact, in South Korea, there is not much, the big problem in medical resource shortage, although there was a local epidemics happen. During the local epidemic happened, the medical staff, gathered there to relieve their, the shortage of intensive care personnel. In the brief, survey in Asian intensivist, the most common shortage was medical resource. Many countries deported the intensivist, especially in China. The intensivist gathered in the Wuhan the area to overcome the medical staff shortage for the brief time. However, the medical and also the technicians, lab technicians also deported to overcome their shortage. However, they said that the actual shortage of medical resource such as personal protective equipment was not well addressed.
Thank you very much. So I'm happy to introduce Dr. Arun Alok Chakravarti. He is the president of International Society of Human and Animal Mycology, president and head department of medical microbiology, in charge Center Advanced Research in Medical Mycology and WHO Collaborating Center, PGI Institute of Medicine and Research, Chandigarh. Dr. Arun Alok is one microbiologist who is known all over not only in India, but all around the world. His research work is very well recognized. Dr. Arun Alok Chakravarti on the topic, the post-COVID fungal deluge, the microbiologist vision.
At the outset, I'd like to thank the organizer for inviting me to discuss post-COVID fungal deluge, the microbiologist's vision. As microbiologist, my vision for last 35 years is to make everyone aware of fungal infection before it is too late. Nature Microbiology in 2017 mentioned stop neglecting fungi because it kills nearly 1.6 million people every year and 300 million suffer from serious fungal infection. Even the Nature Journal in 2013, they mentioned it could happen in one night. Of the planetary disasters, out of the 4, one is fungal epidemic. And very recently in June 2021, Scientific American mentions the new deadly plague that is from the growing worldwide threat of fungal disease. And friends, this threat had come first with the Candida auris, now with COVID-associated mucormycosis. In Candida auris, we know that this is a big problem because it is developing resistance very fast, easily transmitted, already spread to 43 countries, cause severe infection and mortality, contaminates the environment fast, and not easily identified. And it's a resilient pathogen. Whereas in mucormycosis, this is the first time any fungal disease has been made notifiable in India. Until August 3rd, government portal mentions nearly 50,000 cases. And I would say that even in that portal, mentioned, it is very likely that actual figures are considerably higher than this. Question is, why fungal infection in COVID-19? In any respiratory viral infection, there is damage in the epithelium and hampers ciliary clearance, and that's main issue. Beyond that, we also see immune dysregulation, which have been shown very clearly in case of the COVID-19. And in COVID-19, another important fact which we have come to know is that they play through this danger-associated molecular pattern. This is an endogenous signal exacerbating inflammatory response, and that also plays an important central role in the pathogenesis of fungal disease. Beyond this, we also have seen that corticosteroid and anti-IL-6 antibody, which is being used in case of these patients of COVID-19, helps in fungal invasion. But in case of Candida, the issue is not so much with COVID, rather our practices, infection control practice, giving more antibiotics and steroids. So fungal infection in COVID, whenever we discuss the three topics which come to us, candidiasis, aspergillosis, mucormycosis. But here still the problem of diagnosis of fungal infection persists. Whenever we say sepsis, whether it is bacteria or fungus, that's $1 million question sometimes. Pulmonary mycosis, there is another problem. COVID itself produced certain clinical features as well as imaging, which is similar to pulmonary mycosis. And when we have to discuss the COVID-associated pulmonary aspergillosis and mucormycosis, it's so difficult to distinguish. Coming first to the COVID-19 associated candidiasis. These are the two hospitals in Brazil, March to August 2020. It had shown that from the start of the COVID, there is tenfold increase in case of the candidemia. And another important fact which have been shown that mortality has gone multiple times, 17 to 22%, it had gone to 72.7%. But when I say that this issue is linked with our practices, this has been proven by this university hospital at Spain. They have got good antimicrobial stewardship program. Even during this pandemic period, you can see their antibiotic consumption has not increased much. And you can see also this hospital-acquired candemia and multi-drug resistant bacterial infection has also not gone up so much. Compared to this, University Hospital Italy, where they have compared the COVID-19 and non-COVID patient, this is prospective study. It showed that, again, antibiotic use, ICU stay, immune suppressions are important. Here also there is almost tenfold increase which have been there. So if you see the country-wise, there is variation amongst the incidence in case of COVID-associated candidiasis. Spain very low, to China up to 23.5%, which is there. And here again, I like to say that indiscriminate use of antibiotics, glucocorticoids, and infection control practice is important. You see here, it is USA study which has shown very clearly compared to COVID-19, without COVID-19 or pre-pandemic period, you see this candemia rate goes up when the patients acquire COVID-19 after some period. That means it is more healthcare associated, 50 to 80%. And here, again, the emergence of multi-drug resistance, Candida auris is a worry. It had shown now in many countries where this spade is there. But in challenge, in case of candemia, still is there. Whatever the procedure we try, still our success rate in antemortem diagnosis is not crossing 50 to 60%. There is dilemma interpretation of beta-D-glucan. So we need certainly molecular tests which really can work as a point of care. Coming to the COVID-19 associated pulmonary aspergillosis, it was being recognized since last year, mainly in case of the Europe, maximum studies were there. Of course, there are studies in Latin America, USA, and even in case of the Pakistan, which shows that in case of the hospitalized COVID, it's around 0.4% incidence, ICU 6.9%, whereas in mechanically ventilated patient, even up to 10.3%. But even in the country, different hospital, the rate varies. So there is problem still about the diagnosis. When it had been compared with the influenza, we understand the NADPH oxidase, immune suppression, that's very important. It is caused either by influenza itself or even certain people have genetically susceptible to it. Whereas we still don't know the immunotherapy. So the angioinvasive threshold model is still to be worked out. And if I compare the influenza versus COVID-associated pulmonary aspergillosis, we see tracheobronchitis in COVID-associated pulmonary aspergillosis quite less compared to influenza. More important point is, as we are not going for much of the respiratory sample collection, we are depending more on serum galactomannan. Serum galactomannan positivity rate is also poor. So the classification which had been tried by Verivich in case of influenza, that would not be used. Even in case of the imaging, it's like chameleon, because you see that whether it is aspergillosis or without aspergillosis, imaging cannot distinguish. Rather, it is multiple pulmonary nodule or lung cavitation is important. Refractory fever for more than 3 days, even after antibiotics, think about it. Hemoptysis, blood rub of chest pain, think about this condition. And if you look into this particular disease, you have to rule out mucormycosis and abscess and lung cancer and metastasis from the imaging. But if you look into the mortality-wise, the mortality in case of the probable kappa is much higher compared to without kappa. And they have also tried to look into this when exactly the angioinvasion occurs. When there is angioinvasion, there would be galactomannan would be positive. But it comes almost close to the mortality status. So from our European Confederation of Medical Microbiology, as well as International Society of Human Animal Mycology, together we formulated this guideline. This guideline tried to say, as people are a bit scared of collection of the bronchial lavage or doing the bronchoscopy, we suggested that we can go for non-bronchoscopic lavage sample. It should have the galactomannan index, which should be much higher. That is to be there. So that has been classified as the possible goal. But I would still say it is better to do bronchoscopy, because that would really help us in case of diagnosis. So 28 international experts recommended that diagnostic workup is required for kappa. CT imaging is not helping. They have mentioned that serum beta-D-glucan or serum galactomannan is not recommended. It cannot help. Rather, detection of the aspergillosis sputum and tracheal aspirate, which is being suggested by some people, it is also considered to be insufficient evidence. So they recommend to do the bronchoscopy. That is very important. So my take is, despite reservation doing bronchoscopy during the first COVID-19, we may perform bronchoscopy if the procedure is done safely, using the WHO style checklist, safety precaution with adequate PPE. And day by day, we are seeing increasing evidence for infections risk associated with bronchoscopy and which can be managed. We still need to have the galactomannan cutoff, that to be decided. And we also need to decide the cutoff if you are not doing bronchoscopy, and in case of non-bronchoscopy lavage, what should be done. And we also need to really validate this particular recommendation in India's scenario. Coming to this third topic of COVID-19 associated mucormycosis. Friends, the story started last year at the beginning. We used to see occasional cases. Then there was the 18 cases which have been reported from Bangalore, from one city, from 3 centers. So from European Confederation of Medical Mycology and from our International Society, we tried to look into where from these cases of COVID-associated mucormycosis are coming. What we found is that more than 50% are coming from India. So we planned this study in India last year, September to December 2020, 16 center. And this study already showed there is a twofold rise of COVID-associated mucormycosis in 2020 compared to 2019. And we also have seen very important facts is that the population is that it is the male, older male who suffer, and prevalence is 0.27% amongst the patients who have been treated in the hospital and 1.6% who have been treated in ICU. Majority of them have nasoorbital mucormycosis, but patients are coming late. You see that 1 quarter by that time his brain is involved. Yes, diabetes and steroid are the 2 important risk factors, but in 1/3 of the cases, there is no diabetes, only COVID-19 is the risk factor. Of course, majority of them have got also steroid. And if you see when they acquired the infection, it is median 18 days after the COVID diagnosis. That means by that time they are already discharged from home. So they are coming back from home with this COVID-associated mucormycosis. And when we try to do the multivariate analysis, we found that the hypoxia and inappropriate steroid is the most important factor. Friends, this whole scenario changed in next year when we saw in 2021, especially in the month of June and July, or even from April it started, there is a rise in number of black fungus or mucormycosis which have been there. And this rise is so phenomenal that people started really worrying what is happening in this country. Myriad hypotheses came. Some said it is the garbage, some said it is the construction, some said it is the contamination of the industrial oxygen, some said of the humidifier water, some said it is the zinc supplement or use mask. These are the important factors. So, but they none tried to prove. So it came out on us to look into this, whether these are important or not. First, we published this in case of zinc supplement. We looked at 50% of the Rhizopus aerugea. Yes, in vitro, they can grow profusely in case of zinc and risk medium. But when we tried to look into the patients, we found there is no rise compared to the control. So the study did not support the speculation that zinc supplementation really helps. Next, we look into the iron. Iron indices, when we looked into case 5 control, we found that yes, mean serum iron is significantly lower. Also, the total iron binding capacity is significantly lower in cases than control. Then we looked into the environmental study. This study is still continuing, but this has brought out very important facts already. We found that oxygen port, cylinder, humidifier, these are not important. Important is the spore in the ear of the hospital as well as outside. We found most of them are Rhizopus aerugea, which is also isolated from the patient. This is not the first time. Earlier also we have shown that environment of the hospital and outside in India, there is high spore count in case of mucorales. So friends, if we have to say that what we can learn, in our study we have shown diabetes and steroid are the most important risk factor, along with possibly the environmental mucorales which is there in here. So if I have to narrate what happened in the second wave, I would say that besides steroid and diabetes, what happened is that the patients came that time in so huge in number that doctors were not sending only patients in the ward. They are seeing in the corridor, they are seeing the patient in the pavement, and they had no time. And because of that, what it happened is that they really went on giving steroid because there is an oxygen crisis to compensate that. Both this problem has together created such a situation, blood sugar has gone to the roof. You know, if you give dexamethasone instead of 6 milligram, 40 milligram dexa, which is more than 200 milligram of prednisolone per day, what would happen about the blood sugar? And blood sugar control was not there. And this particular, our hypothesis is proven from this particular study from Mumbai. You know that in case of the Mumbai, in Maharashtra, there was very high number of mucormycosis. But this tertiary care center, what they have done, they have shown that they studied nearly or more than 1,000 cases of COVID in the intensive care unit. And majority of them have received steroids and 50% of them have diabetes. But most important thing is that they have this steroid which have been given only up to 6 days. They didn't exceed the dose more than 40 milligram of prednisolone. And what else they have done is that they have nurse-driven strict glycemic control they have done. And because of that, there was no case of mucormycosis reported during the stay in the hospital and during immediate outpatient department follow-up. So this indirectly proves this theory that diabetes, steroid, and if you see environmental layer is important. So what we have seen is that in case of this COVID, that there is a hyperglycemia which is being produced by diabetes, COVID-19, steroid, and of course the stress, COVID-related stress. And this hyperglycemia is producing an inflammatory state. And this inflammatory state potentiates further hyperproteinic syndrome, which is being there, and this causing extra intracellular iron. So there is oxygen radical is being released, causing damage, and free iron comes in the circulation, which is a very good food for mucorals. Further, there is endothelitis. This has been proven by the autopsies. And this endothelitis really upregulate the endothelial receptor glucose regulated protein, GRP78. By this cartoon, I'd like to explain that high glucose and free iron causing endoplasmic reticulum stress, and this is causing GRP78 upregulated. And GRP78, which is the COTH3, the receptor in the fungus, which gets adhered, which ultimately causes cellular damage, and then there is endothelial penetration, and it enters the blood vessel, causing the ischemia and hypoxia. So friends, we have a high spore count, but healthy people don't suffer because of our innate immunity. But here in case of these patients of COVID-19, steroid, even COVID-19 itself and blood glucose, that's playing important role. So how to diagnose these cases? If I have to say, in case of rhinocerebral, it is much easier. You have to just collect proper sample by the ENT people, and you can see that there is presence of easily accepted high P. And even if you do the culture, you can get the culture very soon, and there is no problem. But there is problem in case of the pulmonary mucormycosis. Pulmonary mucormycosis has got clinically similar, imaging is not helping, and here the problem is we have to also distinguish from COVID-associated pulmonary aspergillosis. Generally, we can say if you are getting large cavity and if the patient is galactomannan, beta-glucan or PCR negative or aspergillus, it can suggest come. But you may feel still googly very frequently. That's why we are developing a guideline for it. Summarizing the whole discussion which I wanted to say, think of fungus in your patient. That is very important thing which is required. Second important thing is that we need to have distinction from the sepsis. Need to improve candemia diagnosis. In case of kappa and mucormycosis, there is diagnosis difficult, so we need further standardization of it. But you should try for bronchoscopy, that is very important. Biomarker test needs standardization in this patient. But what we have learned in case of COVID-associated pulmonary mucormycosis, that strict glycemic control and appropriate steroid therapy will bring down the rate. Further, we generally is suggesting that post-COVID patient has the immune dysregulation almost for 1 month, even 2 months. So during this period, you should use universal masking because it's not only outside, inside your house, there is large number of spores. So any diabetic patient, there is a chance of getting this infection. So at least for 1 month, use this mask, that is very important. But we need some point of care test and fungal diagnosis to improve. That is very important in this. Finally, I just like to highlight that we have now developed our fungal infection study from Fungal India Registry. And this is a registry of 3 types. One is for aspergillus, second is mucor, and third is for rare fungi and endemic fungal disease. Finally, I invite you all for this particular conference, which is going to held next year. This is the World Congress of Fungal Disease from 28th to 24th September 2022. Thank you for your kind attention.
Thank you, Dr. Chakravarti, for a wonderful presentation and for being with us. I hand over to Dr. Subal Dikshit. I have a question before that. As you have noted from the Bombay study, that there was no case between September 2020 to May 2021. And then there is a flurry of cases from the same area. I think the behavior of medical fraternity towards use of steroids and control of diabetes, blood sugar must have been the same in 20 or 21.